present your history, and then we will interrupt you at that stage, and then we will ask you to go on to examination. Start, please. Dr. Krishna, you can hear me?
So am I audible?
Yeah.
Yes, please start.
A 48-year-old female resident of Jaunpur, housewife, came to the OPD with chief complaints of pain in the right upper abdomen for 12 months and lump over the right upper abdomen for 3 months. Patient was history of presenting illness. Patient was apparently normal before 12 months when she developed off and on colicky pain in the right upper abdomen, which was insidious in onset, progressive in nature, and for the last 4 months, the pain is continuous, dull aching, moderate in severity, non-radiating, aggravated after taking meals, relief on taking over-the-counter medication. The patient noticed a lump over the right upper abdomen 3 months back, which was insidious in onset, progressive in size, initially of size of about 2 into 2 centimeters, and has increased in size 3 times the initial size, according to the patient. The patient also has a history of loss of appetite and significant weight loss. There is no history of nausea, vomiting. There is no history of fever, yellowish discoloration of sclera of skin. There is no history of itching. There is no history suggestive of any GI bleed. There is no history of early satiety. There is no history of any altered bowel habits. There is no history of any sleep disturbances. Past history. There is no history of any tuberculosis, diabetes mellitus, hypertension, asthma, or any other chronic illness. There is no history of any surgical intervention in the past. Menstrual history. Patient attained menopause 3 years back. She has 6 children and all were full-term normal, born by full-term normal delivery. Last was female child, 13 years. Personal history. Patient takes a mixed diet and she's a non-smoker and non-alcoholic and a non-tobacco chewer. Family history is non-significant. Summary. A 48-year-old female with no comorbidities came with the chief complaint of the pain in the right upper abdomen for 12 months and lump in the right upper abdomen for 3 months, associated with rapid increase in size and significant weight loss and loss of appetite without any jaundice or altered bowel habits.
Okay. Dr. Shabi?
Yes, sir. I have 5 minutes. Krishna, you are supposed to answer to me. Now, let's get down to your chief complaints. What does the pain signify?
Sir, the pain
signify regarding the organ of origin or the site where the disease may be.
So the pain originates in the right hypochondrium region. So the organ of origin will be either a gallbladder or
There are 3 broad categories: pain in the upper abdomen, pain in the mid part of the abdomen, pain in the lower abdomen. The upper abdomen corresponds to the foregut, mid abdomen corresponds to the midgut, and the lower abdomen corresponds to the hindgut. So now you have a disease. See, you are taking a history without knowing what the patient is having. Okay? So answering that part, then I'll ask the sub part of pain, which is very important. So it could be a foregut, and more so it is on the right side. So what could be the organ which may be causing this pain?
So gallbladder, liver, or a duodenum.
Okay. And then you say it is colicky pain. What does this signify?
So colicky pain signifies that the patient is having either a hollow viscous viscous or a
biliary colic. The tubular or hollow viscous, they have a tendency that whether it is a gut or ureter or a bile duct, they cause this thing colicky pain. And then you have a change in nature of the pain. What does this signify?
That the colicky pain has now changed to a continuous pain, meaning the etiology of the pain has changed.
What are the causes of this colicky pain in the right upper quadrant? The common causes.
Sir, cholecystitis is the most common cause
Yes.
for the right.
And
And sir, any duodenal obstruction may cause as well as chronic cholecystitis.
so gallbladder is one organ which can lead to, and bile duct, which can lead to colicky pain in the right upper quadrant. Of course, some duodenal pathology, but most of the duodenal pathology are not going to cause colicky pain like an ulcer. They cause dull pain. Stomach pathology which might cause a colicky pain there. So, the change in nature, what does this signify? Again, I ask you. Is it signifying some change in pathology? Let's give an analogy. Let's say the pain of hernia, initially its pain is different. Once it gets strangulated, the pain is different. There are certain organs where you have this thing. So what, regarding the disease process, colicky might be due to stone cell. Now, a dull aching pain might be due to something else. Yeah.
Yes, sir. The dull aching pain may be due to due to any metastasis to the organ.
Cut that down. Now, lump. Since you're just 5 minutes. Lump. Causes of lump in the right upper quadrant. This type of lump. Let's not talk about all the lumps. You have given a small lump, progressively increasing and associated with certain other features which you bring it out. So, causes of lump, relevant lump in the right upper quadrant.
Sir, it could be a benign pathology or a malignant pathology. A benign pathology like a mucosal empyema gallbladder or a malignant like periampullary carcinoma.
कुछ है खाने
Yeah, go on.
Periampullary carcinoma or a CA gallbladder, or it could be any liver malignancy which comes as an exophytic growth.
Yeah. Okay. So, the lump could be several. Now, what else you would like to differentiate based on your history? A benign disease versus a malignant disease. Which part of the history signifies this is might be a malignant disease?
The history of loss of appetite and significant weight loss will signify that it is, and also rapid increase in the size.
Okay. How do you define anorexia?
That it is the loss of appetite of the patient, either by qualitative or quantitative. So, like the patient tells that the patient was first able to eat 6 chapatis, but now she's able to eat only 4 chapatis.
Okay, fine. Now, another important thing about vomiting. Supposing if the vomiting, what does this signify? And what is the characteristic of vomiting?
Vomiting signifies either an obstruction or a gastric outlet obstruction in this type of patient.
So a patient who doesn't give a history of vomiting practically rules out a gut pathology, that means stomach, duodenum, obstruction, etc. But remember this thing that vomiting can also be associated with most of the pain originating in the rectoperitoneum or the abdomen. Now, last jaundice. The last question about jaundice. What does jaundice signify if it is present?
Sir, it signifies that there is obstruction in the biliary tract.
So, what does your history signify? What the problem the patient is having?
So the lump is in the right upper abdomen, and there is no jaundice and any
organ of origin, probable organ of origin, and the disease process.
Gallbladder, sir.
Okay. Why can't it be liver?
Sir, because there is no jaundice, there is no history of any chronic liver disease.
Okay, fine. Dr. Kapoor has to say something.
Okay.
Sir.
So go to your next slide.
Yes, sir.
Just 1 or 2 points. When you talk of jaundice, so you are saying no yellowish discoloration of sclera or skin. You should have mentioned the color of the urine and stool also.
Okay.
Go to the next. Next. Now, in the summary, the change in the nature of pain is important. So that should have become a part of the summary because there is a distinct change in the nature of pain.
Okay.
Because earlier she was having biliary colic and now it is a dull continuous pain.
Okay.
And second, why do you mention altered bowel habits in the summary?
So altered bowel, whether sir, it could be any malignancy which is CA colon, which could have metastasized to the right hypochondrium. Sir.
So why metastasize? Primary malignancy of the colon cannot give rise to a lump in the right upper abdomen?
Sir, it could give, sir.
Can. So even the primary malignancy.
Like the right hepatic section.
Okay, let us proceed with the examination.
Okay. General examination. Patient was examined in a well-lit room after obtaining consent in front of the female attendant. Patient is conscious, cooperative, well-oriented to time, place, and person. Patient is thin-built, well-hydrated. Her Karnofsky performance status is 80%. BMI 17.1. Pallor is present. No icterus, no clubbing, no cyanosis, no generalized lymphadenopathy and edema. No signs of chronic liver disease. Vitals, temperature is 98 degrees Fahrenheit. Pulse rate is 86 per minute in right radial artery, normal in volume and rhythm. BP is 112/68 millimeters of mercury in right arm supine. Respiratory rate is 14 per minute. Systemic examination, CVS, S1, S2 heard, no murmurs. RS bilateral, air entry equal. CNS, no focal neurological deficit. This is the photo of the inspection. Abdomen, local examination inspection. Abdomen is scaphoid in shape. Umbilicus is central in position and inverted. All quadrants move equally with respiration. A lump of 5 into 3 centimeters is seen in the right hypochondrium, extending partly in the umbilical region and right lumbar region. And shape is globular. Surface appears to be smooth. Skin over the swelling is normal. No visible pulsations or peristalsis seen. There is no scar, no sinus, no dilated veins. Thermal orifices are normal. No swelling seen in any other quadrant. The abdomen is soft, non-tender, and the local temperature is not raised. An intraperitoneal lump of 7 into 5 centimeters is palpated in the right hypochondrium, extending partly in the umbilical and the right lumbar region. Shape is globular, surface is nodular. All the margins are well defined except superior margin, which is in continuation deep to the right subcostal margin. The swelling, the lump is hard in consistency. It moves well with respiration. The finger could not be insinuated between the subcostal margin and the lump. No other lumps are palpable. No hepatosplenomegaly. Left supraclavicular fossa is normal. Thermal orifices are normal. Percussion. Dull knot is present over the lump. Tympanic knot is present over the rest of the abdomen. The liver span was 12 cm in the midclavicular line. There is no shifting dullness or fluid auscultation. The bowel sound is present. There is no brewing heard. So the per vaginal examination was normal and there was no mass felt in the rectovaginal pouch. Distal rectal examination, perianal region was normal. No sinus, no fistula, no fissure in anal. Anal tone was normal. No fecal staining was present. No mass felt. No hemorrhoid seen on proctoscopy. Spine was normal. Summary. A 48-year-old female with no comorbidities came with the chief complaint of right upper abdomen pain, which was first colicky in nature and then changed to dull aching for the last 4 months, and the lump in the right upper abdomen for 3 months associated with weight loss and anorexia without any jaundice or altered bowel habits. A lump of 7 into 5 centimeters was palpable in the right hypochondrium, extending partly in the umbilical and right lumbar region. Shape was nodular, hard in consistency, which moves with respiration, and finger could not be insinuated between the subcostal margin and the lump, which is dull on percussion without any ascites, organomegaly, or features of metastasis.
Dr. Pradeep, please.
So, Dr. Krishna, you have a case where a female patient of 48 years of age is having started with colicky pain in right upper abdomen,
Yes.
which later on went on to become dull aching pain.
Yes.
and is now associated with a lump in right hypochondrium
Yes, sir.
without jaundice, right?
Yes, sir. Yes, sir.
So, what are the possibilities that come to your mind?
Sir, based on the history and the examination, sir, it could be.
Obviously, you will speak only on the basis of history and examination.
Yes, sir. It could be a gallbladder malignancy, sir.
Okay, that is one.
Sir, it could also be liver malignancy, which is coming as an exophytic growth.
Liver malignancy, primary or secondary?
So primary, sir, as an exophytic growth from the 4B would be as a, but the consistency won't be hard.
Okay, what else? See, if there is a lump in right hypochondrium, forget about the case. There is a lump in right hypochondrium. You have to, what are the possibilities that come to your mind?
Sir,
a lump in right hypochondrium can come from
a liver, gallbladder, duodenum, or right hepatic flexion.
Right hepatic flexion, right? So, what are the possibilities in liver?
Liver, sir, it could be a primary malignancy or a secondary from an occult.
So, your examination does not reveal enlargement of liver.
No, sir.
Right?
Yes.
So, the possibility of a hepatoma or secondary, the surface of secondary liver is nodular, that you cannot miss. Right?
Yes. Yes.
So, the primary and secondary liver malignancy is ruled out. How about hydatid of tense hydatid cyst projecting from inferior surface of liver?
Sir, it could come, sir, but it would be associated with fever and chills, sir.
Not always. Hydatid cyst.
And sir, the consistency will be, sir, cystic in the consistency, sir.
Or a tensely cystic lump sometimes imparts hard consistency. Now, what are the point in your examination which rules out the possibility of a hydatid cyst?
Sir, first it is according in the examination in the history, sir. It is a colicky pain which has now come to the which has now changed to dull pain. Also, there is history of loss of weight and anorexia, and there is a lump which is rapidly increasing in size. And
see, you already said on palpation that the lump is nodular.
Yes, sir.
Right?
Yes,
the surface is nodular.
Yes, sir.
So that you won't find in hydatid cyst. That is the only one point. While making a diagnosis, I'll ask you to lay more emphasis on the objective things like physical findings rather than history. I don't mean to say that history is least important, but preference should be laid on the objective things. So you have already said the surface is nodular.
Yes,
so that rules out the possibility of hydatid. Now we come to gallbladder.
Yes.
Again, same thing, a tensely cystic swelling can impart hard consistency. What are the possibilities from gallbladder?
So gallbladder, it could be benign like mucosal.
Okay.
And malignant gallbladder carcinoma.
So it could be an empyema, it could be mucosal, it could be empyema, it could be carcinoma gallbladder.
Yes, sir.
Okay. So why not mucosal or empyema?
Sir, the
I've already shown
the shape is nodular, and also there will be a side-to-side mobility.
Dr. Krishna, shape is never nodular. Shape is pyriform. You said in one of the slides.
Yes, sir.
Shape is pyriform.
Yes.
That's what pyriform shape makes you to conclude that this lump is of gallbladder. My point is, this gallbladder lump, why can't it be mucosal or empyema?
There will be a side-to-side mobility, sir, benign like mucosal or empyema, sir. Also, empyema will be associated with fever and chills.
Chills and rigors, and again surfaces. You have said it is a nodular surface, is exhibiting nodular surface.
Yes.
So that rules out the possibility of mucocele or empyema.
Yes.
Okay, so it's hard inconsistency, nodularity. Why not hepatic flexure malignancy?
Yes, sir.
Your case, why not hepatic flexure malignancy?
Sir, there is no
Malignancy from hepatic flexure.
There is no
Hard
GID
Yes.
or any obstructive features, sir.
Like
Abdominal distension or vomiting.
you hardly find this kind of a presentation. What are the common presentations of a right-sided lump?
Sir, and
Right-sided
anemia,
chronic. Yes.
anemia, asthenia,
What else?
melena.
Yeah. So, what are the points that favor that this could be a right hepatic flexure malignancy?
Dr. Garg, one last question, please.
Yes, sir. So your possibility of carcinoma gallbladder comes into the mind, and a differential. You see the pyriform shape itself suggests that this could not be a hepatic flexure malignancy,
Yes.
right?
Yes.
Dr. Kapoor, sir.
Okay, so just a few points. One point I missed in history when Dr. Shabi was asking you about colicky pain in the upper abdomen, especially right side. In addition to gallstone, you should have mentioned CBD stone also because the pain would be same. Now, in the examination, I know many students mention the supraclavicular nodes as part of abdominal examination, but I personally would suggest that you should mention it as a part of general physical examination.
Okay.
Here you mentioned generalized lymphadenopathy. At the same point, you should have said that there is no left supraclavicular lymphadenopathy. Otherwise, some examiner may interrupt you and ask, why did you not examine the left supraclavicular node? Again, as a general principle, you should mention the abdominal examination first and the other systemic examinations later. You started with cardiac, respiratory and other examinations. And please do not use non-standard abbreviations. Don't say RS, say respiratory system. And one student also has asked, and I also wanted to ask that globular. You said this lump is globular. Now, globular term is used only to describe a distended gallbladder, like what we feel in a mucocele or as we were discussing in an empyema. So when you say hard nodular lump, it cannot be globular. It should not be described as globular. Actually, that's how we differentiate between a distended gallbladder, which could be either mucocele due to a stone impacted in the cystic duct, or a lower end CBD block like in carcinoma head pancreas or periampullary carcinoma, versus a hard nodular lump, which is either in gallbladder cancer or in liver primary. Now you did a proctoscopy also. Why did you do a proctoscopy?
To see for any internal hemorrhoids.
Why did you want to see for internal hemorrhoids?
Sir, for portal hypertension.
In this case, see, at this level, the examination has to be targeted. So since she does not have any history of bleeding per rectum, I don't think a proctoscopy is indicated. Per rectal examination, yes. Per vaginal examination, yes. But proctoscopy, I personally would not prefer to do. Now, liver, when Dr. Garg was asking you, you kept on saying primary. Which is the commonest liver tumor?
Sir, secondary liver.
Why this could not be a metastasis in the region or near the gallbladder fossa in the liver, hard nodular lump in the liver, metastasis from some primary which is not clinically manifest. So if you have a mass in the liver and you are thinking of malignancy, metastases are much more common than primary tumor. And then one of the students has asked, how can we comment on liver span in the right hypochondrium mass where superior margin is not palpable? Dr. Kunal Singla, superior margin is never palpable. It is always percussed. So when you talk of liver span, it is a combination of percussion and palpation. Okay. Now Dr. Harsh has joined. I think he's still not there.
उस
Puneet,
कमरे
you would
में
like
जो
to
दो
take
पैंट उतारी है मैंने
investigations or you want me to go ahead with investigations?
क्योंकि अभी थोड़ी सूसू की मुंह में गिर गई
पैंट है दोनों
Or maybe Dr. Sanjay Kala
तो मैं
is there.
नहीं
पक्का
हाँ
think he
Sorry,
Okay,
sorry, sir. I was not listening the whole history and
Already.
Sorry,
examination.
sorry.
I think I was.
I will carry on.
Yeah.
Do you want to carry on with investigations maybe?
yes.
नहीं वो
Please,
पेंड
please go ahead.
Come on.
पानी निकालना है
Let's
उसका
see
भी
what
कुछ नहीं है।
investigation you're going to do. Now here in the patient, where the possibility of a gallbladder lump versus a liver lump is there, and we have ruled out the hepatic flexure and other problems, right?
Yes, sir.
History and examination. So how would you proceed with the patient?
Sir, I would like to do an investigation to determine the disease, stage it and treat it. Sir, for that, as an extension of the clinical examination, I would like to do an ultrasound of the abdomen.
What will you see in your ultrasound?
Sir, in the ultrasound, I will see the origin of the swelling, the CBD status, the pericholecystic edema, the liver, whether the intrahepatic biliary radicals, any satellite nodules,
दिखाओ
any ascites, and whether there is involvement of any port hepatitis or
Lymph nodes.
Dr. Harsh has joined, sir. Yeah.
Okay, then maybe you can carry.
Sir Harsh, would you like to join in?
No, he is not in a connection, probably. I think, sir, you should proceed. Yeah.
Yeah, Dr. Shabi, please carry on.
So an ultrasound is going to tell you about number one.
Of course, now it has become an extension of the clinical examination, as we say.
And it will show you the site of origin, which means the organ. Now with a good ultrasound, see the gallbladder, the liver, lymph nodes, and what you are mentioned. Now, what is the next investigation you're going to have?
the next investigation I will like to do is the CECT abdomen, sir.
Why straight away CECT? You're not going to have the biochemical blood investigation?
Sir, blood investigations if the patient is if the tumor is resectable, then we will do the blood.
Based on an ultrasound, you do not decide resectable or not. You are just finding out the organ of origin. So, what would be the next investigation which is going to help you out in the diagnosis?
CECT abdomen, sir, for the diagnosis.
What biochemical test?
Sir, biochemical test, sir, liver function test. And see,
Liver function, what liver function test?
You just enumerate fast.
sir, see, whether the serum bilirubins are increased or not, serum SGOT, SGPT are deranged or not, they will be deranged in hepatic and alkaline phosphatase will be deranged in the biliary obstruction.
What is the association? How many times alkaline phosphatase should be raised before you designate it as obstruction?
3 times, sir.
Okay, more than 3 times. But is there an association between the alkaline phosphatase and the malignancy, especially carcinoma gallbladder or a liver tumor?
No.
Some papers, they have said that maybe it's about more than 10 times the association between the alkaline phosphatase and the carcinoma gallbladder. Okay, so you want to have what else? You have mentioned the liver function. What else?
Sir, I will like to do a PTINR,
The coagulation profile.
coagulation profile of the patient. And
Supposing if there is a jaundice, what happens to the PT and why?
sir, the prothrombin time will be increased.
Why does it increase? What is the cause? Why the PT increases in obstructive jaundice?
Due to the obstruction, sir, there will be decreased production of thrombin, which will increase there will derange the liver function.
What are the vitamin K dependent factors?
Sir, 2, 7, 9, 10.
What happens in obstructive jaundice? Why they
So there is decreased gamma carboxylation of the clotting factors.
bile does got to do anything with their absorption? Okay. Now tell me what next. What is the role of tumor markers? Would you like to have some tumor markers at this stage or you don't want?
Yes, sir. Tumor markers, sir, CA 19-9 and CEA used as a tumor marker. Recently, sir, CA242 has also been used to determine the lymph node metastasis.
Okay, let's talk practically. What tumor markers would you like?
Sir, CA99 and CEA.
Between, yeah.
CA99 and CEA, sir.
Are they mandatory?
No, sir.
They are not mandatory. Fine. Now what next? Would you go for an FNAC? What is the role of FNAC in this?
No, sir. I would not do an FNAC, sir.
Why you
Because
want to have a FNAC?
sir, because it will upstage the disease due to needling and needle seedling, sir.
How does it upstages the disease?
Sir, because it causes the needle peritoneal metastasis in the peritoneal cavity as well as from the percutaneous.
Needle seedling, fine. But what exactly is the pathology that it upstages? If you are putting a needle in a
The bile.
malignancy, what you are doing is a breach of the peritoneum. So basically, how much care you are going to take, you will bring the cells on the peritoneal surface and possibly a metastatic disease then, feeling it as such. Now, come to the CT part. What CT scan and what is use of CT scan?
Sir, I will do a contrast enhanced CT scan for the patient, sir.
Just last question I'll ask. Yeah, to complete this,
Contrast enhanced CT scan, sir.
tell quickly what for.
Sir, to find out the
One word.
metastasis.
To stage the disease.
Gestating.
Yes, you want to stage the disease to assess the resectability. Last question, role of PET scan. Would you get a PET scan?
Yes, sir. PET scan is being done in some places, sir, but it is not mandatory because but it helps in determining whether the malignancy is whether the lump is malignant or a benign one.
Yeah, most of the guidelines do not mention PET scan as mandatory, but many centers are doing it mandatory. So PET scan helps to also assess the distant metastasis. Yes, sir.
Okay, there are one or two questions in the chat box. So, what is the difference in the characteristic of pain and carcinoma head of pancreas versus distal CBD malignancy versus stone? Now, here we are not considering carcinoma head of the pancreas because there is no jaundice. Very rarely you will have a carcinoma of the head of the pancreas without jaundice. If at all you have a mass in the head of pancreas and no jaundice, you think of other neoplasms like cystic neoplasm rather than carcinoma head of the pancreas. Distal CBD malignancy, which means one of the periampullary cancers, are usually painless progressive jaundice. And CBD stone, as we discussed earlier, patient will have jaundice with or without cholangitis. Second question is how to differentiate between hepatic flexure carcinoma and carcinoma gallbladder. As Dr. Garg earlier pointed out, yes, it could be a colonic mass, but then if there are no bowel symptoms, if there is no bleed, GI bleed, or if there is no anemia, it is very unlikely. Although we have to remember that carcinoma of the transverse colon or hepatic flexure, like carcinoma stomach, can have very non-specific symptoms. These patients can just present with anorexia, weight loss, and anemia and symptoms of anemia. At the same time, you have to remember that one can involve the other. It is not uncommon for carcinoma of the gallbladder to infiltrate the hepatic flexure and then cause bowel symptoms. So that is why the history becomes important. And the change in pain, we have already discussed that it looks from Krishna's description that initially the pain was like biliary colic, probably due to stones, and it has probably become malignancy now. So that's it. Do we have the actual reports of the investigations before we go on to management, Krishna?
No, sir, I don't have that.
Okay. Another question? Yeah.
So just I want to say that delegates who are raising hands, they should put their questions in the chat box.
Yeah,
So
I am
the
reading
question
from there.
and answer-
I'm reading from
Yeah,
there.
we won't be entertaining as such, so there's no need to raise the hands. They can put their questions there in the chat box. Thank you.
So CA and CA99 are not mandatory questions. As Dr. Shabi said,
No.
that if the levels are high, they support a diagnosis of malignancy, but it's not necessary to diagnose. If you see a mass, if you see focal, irregular, non-uniform thickening of the gallbladder wall, or if you see an intraluminal polypoidal lesion, these are all suspicions of malignancy. And at least in North India, if you see one of these findings on imaging, you should treat it like carcinoma of the gallbladder. CT scan, Dr. Shabi said that when he kept asking you that say in one word, you should have actually said, as he told you, staging and resectability. That is the aim of CT scan. PET scan is not to differentiate between benign and malignant in this situation. PET scan is to look at distant metastasis, either in the abdomen, distant lymph nodes, or outside the abdomen, because if that is there, then there is no point in operating or resecting. Can CHG be present with jaundice? Yes. Jaundice is one of the common presentations in patients with CHG, especially those with neck tumor. And the other could be that if you have a tumor in the body and fundus, there could be enlarged lymph nodes. We now move on to management because we have only 8 minutes left. Dr. Kate, please. So let us give him a hypothetical finding that ultrasound shows a mass in the gallbladder. CT confirms that there is a mass in the fundus and body with minimum liver infiltration. There are few nodes in the hepatoduodenal ligament. There are no distant metastasis. There is no ascites. Dr. Kate, please.
Yes, this is the first scenario. Dr. Krishna, so how will you proceed? I will give you another scenario if you complete this little early.
Sir, I will do an extended cholecystectomy in this patient, sir.
Would you like to do any other investigation before we go on further?
Yes, sir. A diagnostic laparoscopy, sir, I will do to rule out any peritoneal mass, sir.
Fine, yes. So that is what I feel that you should go ahead with that, and then now you can tell me what do you mean by what you said.
Sir, extended cholecystectomy in this, sir, we first start by the cauterization, sir, and we send the aortic cable nodes for the frozen section. And then after that we go deep till the retropancreatic nodes and the retropancreatic nodes, and then we clear the nodes around the portal vein and hepatic artery till the hepatic hilum, sir, from below upwards, sir.
What intraoperative findings will make it inoperable? You see, investigations wise, you already heard what has been told. So what are the intraoperative findings? If you find them on table, you may not proceed with what you said.
Sir, intraoperatively, sir, if the aortocaval lymph nodes are involved, sir, any peritoneal metastasis, sir,
Aortocaval node, you'll send it for section, is it not? But I'm asking you the intraoperative findings which the surgeons will detect if they find on examination. What will preclude the radical resection?
Sir, if the mass is adhered to the portal vein.
Please carry on.
Portal vein or superior mesenteric arteries. And
suppose the gallbladder mass is infiltrating the duodenum. How will you proceed?
Sir, if the mass is
let me interrupt you. Can this finding be missed on the cross-sectional imaging?
Yes, sir, it could be missed.
How?
Sir, if the malignancy is in the walls of duodenum, sir, then it could be missed as it will not be causing any symptoms.
Yeah, sometimes on cross-sectional imaging, you may not be sure whether it is abutting or it is infiltrating. If you have a doubt like that, what additional investigation will you carry?
Sir, endoscopic ultrasound.
Endoscopy, is it not? Before endoscopic ultrasound, okay, if it is infiltrating the duodenum, you like to carry out an upper GI scope. Fine. So you have this finding. Now somehow you thought that it is abutting, but now it appears to be infiltrating. So how will you proceed?
Sir, I will, sir, then do a resection of the.
Sorry to interrupt, Krishna. Please unshare. Stop sharing your slide because then everybody will be seen. That's a request from Dr. Khanna. Just yes. Thank you. Carry on, please.
Yes, sir. If then I will do a resection of the duodenum and do a hepatodiagnosis along with the common bile duct.
Is it a universal acceptance to uniformly resect the duodenum and infiltrating the duodenum?
No, sir.
I'm just asking you, I'm not saying what you said is wrong. What is the indication for resecting 4B and segment 5?
Sorry, sir?
4B segment 5 of the liver resection.
Sir,
Indication.
sir, if the infiltration is beyond 2 centimeters of the gallbladder bed, sir, then we'll do a 4B and 4A resection.
4B and segment 5. Now suppose the scenario shows that the gallbladder is fine and it looks like a liver mass. And on the cross-section imaging, the CT is suggestive of HCC, hepatocellular carcinoma. Okay, that what nodular mass you have felt actually is arising from the liver, and it's a liver mass, and it is suggestive of hepatocellular carcinoma. How will you proceed?
मम्मा संध्या बोलो वो अभी अब ला रही है
If it is a hepatocellular carcinoma, sir, then I will either if it is either I will do a radio frequency ablation, sir, or resection of the involved lobes, sir.
What is the indication for RFA? The liver mass is around 5 centimeter in size. That's what you see. No other liver nodules present. And you have done a liver volumetry, and the FLR is 40%. No underlying cirrhosis. No, I'm asking this question because principally in examination, okay, one of the points that happens is that many times it's a classical presentation of the disease like what you're seeing in this patient. You are from North India and it's a 48-year-old female patient, and it looks like a clinical examination, a patient of carcinoma gallbladder. Investigation is also suggestive of that. So usually focus on one disorder, one disease. An examiner can shift from one to the other disorder. So you should be prepared for something else also. It is not that you have to go into one focus mode and then you know everything about gallbladder cancer. That's why I changed the scenario. So how will you do it? Because it can be that also.
So, then if it is a 5 centimeter, then sir, I will do a radio frequency ablation, sir, which uses a high probe, sir, which results in the coagulation of the.
Is radio frequency ablation a good method for treating 5 centimeter tumor? It's a good method for treating around 2 centimeters tumor. So if you feel that, why not resection of the tumor? I said there is no cirrhosis. Liver resection.
Then resection could be done if sir the functional FLR is more than 50 and Child-Pugh score is K. It is Child-Pugh score, if it is grade A, then we can do a resection. Sir.
No, what do you think is the CTP score in this patient? On the investigations, what have been provided to you prior and your examination?
Sir, it will be around 6.
Five
So
or
it will be
6?
grade A, sir.
Is it not? Everything has to be fine. So the CTP score is fine. Performance status you already told. What is the principal difference when there is underlying cirrhosis? Because most of the time it will depend on, it will happen on a cirrhotic patient. So what is the principal difference in the management of a cirrhotic vis-a-vis non-cirrhotic patient?
Sir, in cirrhotic patients, the compensatory hypertrophy will be decreased in the if we do the resection, sir. So resection
let me interrupt you. When we are looking at the functional liver reserve, okay, FLR, so how much should it be for a cirrhotic patient versus a non-cirrhotic patient? What you said is correct. Yes. The liver function is definitely
less than
subdued in the patient.
40% for.
Yeah, please carry on.
Sir, sorry, sir, I didn't get you, sir.
My question is, if you are operating on a cirrhotic patient with HCC and a non-cirrhotic patient with HCC, when you're looking at the FLR, what will you look for there? What will you look at?
Sir, if the FLR is less than 30 or 40%, sir, then we can do the resection, sir.
Suppose you find the FLR is not optimum.
Sir, and Dr.
And-
Vikram Bhaskar, I think
Yeah.
you should answer it because I think he's talking for the postgraduate to answer it. I think then we'll sum up.
It's around 40% for cirrhotics and around 20% for a normal liver with the non-cirrhotics. Now my last question to you is, if you find the FLR is suboptimum, okay, what is one of the methods that is commonly used to increase the
Pre-operative
portal vein embolization? So just an additional question on the same thing. How long it takes for the hypertrophy to occur? Following this.
चाहो तो हेडफोन ढूंढ देना
Sir,
दो indicate
2
करेगा।
to 3 weeks, sir. 2 to 3 weeks.
Little more than that, around 6 to 8 weeks. Is there absolutely last question, is there any other method by which you can accentuate the FLR in a shorter period of time, what you told?
चला लो
About
ठंड लग
2
रही है।
weeks. That's the last question.
गर्मी कहाँ हो रही है?
Have you heard of something called as ALPS?
Sorry, sir.
ALPS. Associating portal vein embolization with stage hepatic control. Okay, I think I'll transfer to Dr. Kapoor.
Okay, so I will just give a brief summary because we've already finished our time. So when you say the treatment of gallbladder cancer, you should say both terms, extended or radical cholecystectomy, because some groups say extended, some groups say radical. Extended or radical cholecystectomy also, some groups excise only a 2 centimeter non-anatomical wedge of liver, and some people, as Dr. Kate was trying to ask you, remove formal segment 4 and B, so 4B and 5. Duodenum, involvement of duodenum is a very controversial area in gallbladder cancer. It could range from a sleeve resection of the duodenum, segmental resection of the duodenum, and then pancreatoduodenectomy. It's a very controversial point. HCC. Now you see, you should try to catch the hints which the examiner is dropping. Dr. Kate was trying to take you towards resection. Now 5 centimeter HCC in a young, she's only 48-year-old, well-preserved liver function, no clinical or otherwise suspicion of cirrhosis. He was telling you also non-cirrhotic liver, and again you were repeating RFA. So some good examiners give you hints which you should be willing and ready to take in the exam. Now, there are 1 or 2 questions, how to differentiate between hepatic flexure mass and gallbladder. Yes, if the mass is truly in the hepatic flexure, it will probably be fixed. But if it is in the proximal part of the transverse colon in the gallbladder area, then the clinical findings could be like a gallbladder mass. Although, if the transverse colon is kind of hanging down and redundant, you could feel all margins separate from the liver or the costal margin, which would not be the case in gallbladder, but yes, sometimes it can be difficult. And then you go back to the history, as I said earlier. Could there be jaundice in gallstone disease with normal CBD and normal liver? Yes, you can have a large stone in the neck of the gallbladder, which is compressing the CBD, what is known as a Mirizzi syndrome. But then there will be IHBRD, there will be dilatation of proximal CBD while the distal CBD is normal, and there will be some derangement of the liver function test. So just to summarize, when you get a patient with right upper abdomen pain or right upper abdomen mass, you, as the earlier examiners were asking, you have to think of common things first, which are gallbladder, liver, head of the pancreas, colon, and you should not forget retroperitoneal tumor, which can be present in any quadrant. Points which suggest gallbladder, history of pain and jaundice. But then the lump is palpable. If you have a gallbladder lump palpable, you should be able to differentiate between a distended gallbladder and a gallbladder mass, which suggests malignancy. Liver, as we discussed earlier, as Dr. Garg was trying to ask you, if it is a large, smooth, tense cystic lump, you obviously think of hydrated, but if it is a mass, solid mass, then secondaries followed by primary tumor of the liver. Head of the pancreas without jaundice, do not make a clinical diagnosis. colon, bowel symptoms and GI bleed. And if it is a largely asymptomatic lump, with just diffuse pain and no other symptom, keep in mind a retroperitoneal tumor. So I am going to put my email address in the chat box. Students, please email me. Just write right upper abdomen lump in the subject of the email, and all the emails which I received till today midnight, I will send you a copy of the chapter on right upper abdomen lump from my book. I would like to thank Krishna for presenting the case and all the examiners. Thank you, Puneet, for asking me.
Thank you.
Thank you, sir. I thank Dr. P. Kapoor for moderating this session. I think and also the examiners for this session. And move on to the next event. What we have it is the laparoscopic cholecystectomy, and it will be presented by Dr. Devarshi Sharma from New Delhi. And I request Dr. Pradeep Garg and Dr. M.A. Ansari to moderate the session. I request Dr. Pradeep Garg, sir, to take over that.
Okay.
Can I share my screen?
Yeah. Hello, Dr. Devashish.
Hello, sir. Good morning to you.
I didn't know that you are Dr. D. Sharma. Okay.
Actually, I worked in Varanasi at that time when Shashi was a undergraduate student at that time, and I often used to be called as D. Sharma at that time. Probably he wrote it as D. Sharma. It occurred to me also at one time, but I thought that he has written it, let me not change it.
Long association with BHU, that means. Can you?
Right, I was
do you have this video? Do you have video or only presentation?
Good morning, Dr. Garg.
I have a video, short clips of 8, 10, 15 in between all my presentations. So I have a whole video of 7 minutes. Do I need to show that, or presentation with the steps, and that way I can go whatever way.
Okay, you go ahead in whatever manner you want. Dr. Ansari, is it okay?
Hello, Dr.
This is fine. Then we will. Good morning, Dr. Devarshi, to see you. And we will moderate the session after you finish your presentation. Thank you, Dr. Devarshi.
Sure. Okay, right. Should I change? I have a video 8 minutes also. It's an old video which I can show you.
You start.
Okay.
Let us start with
this is a little history of laparoscopic cholecystectomy, starting with the open cholecystectomy done.
Yes, it would be fine. All right. Yes.
Eric Mouet was the person who did the first laparoscopic cholecystectomy. It's a very common disease. We all know that. We don't have our own data in our country, but the United States in 2016 reported 1.4 million cases, and 96% of them were done by minimal invasive surgery. Laparoscopic cholecystectomy for laparoscopy is regarded as the foundation. It is the surgery which promoted laparoscopy all around the world, and for other organs also. Initially, it was organ based, then came the reconstructive bowel surgeries also. It was regarded as a benchmark, which is it's a gold standard procedure, and people compare new procedures with laparoscopic cholecystectomy, and is also said the flexible procedure. Indications, very commonly done procedure, but reiterating the indications: the symptomatic cholelithiasis, acute cholecystitis, biliary pain, the dyskinesia, patient coming with gallstone pancreatitis. Last line probably regarding the asymptomatic cholelithiasis has not been written. Yes, asymptomatic cholelithiasis with other procedures, including bariatric, kidney transplants, all these things are being done. Gallbladder polyps, less than 1 centimeter, we don't do anything. More than 1 centimeter, we do a laparoscopy. More than 2 centimeter, we try to treat it as a malignancy. So this are the common indication. Contraindication, malignancy, when you know preoperatively that this is malignancy, then you don't do a lap col. You can go ahead doing a rectal cholecystectomy laparoscopically, but you don't do a laparoscopic cholecystectomy only. Relative contraindications are mild altered coagulations. Patient who is unfit for general anesthesia, but there are reports being done under spinal anesthesia. We in an institution don't do it under spinal anesthesia, but it is reported in the literature. A patient with a significant portal hypertension, all these things can be corrected, and then patient can be taken up for laparoscopic cholecystectomy. So they are relative contraindications. We have got two techniques. I think the American technique and the French technique. In one, you stand between the legs, but most commonly we stand on the left side of the patient with a monitor on the right shoulder. Instruments, the common instruments which are required very basic, you require a dissector, you require a grasper, and a toothed grasper if possible to hold the fundus of the gallbladder. And beyond that, you require the clip applicator to apply clips. You can suture the duct also if required. And ultimately, you require a 10 mm instrument to take the gallbladder out through the port. The basic 4 steps of laparoscopic cholecystectomy is creating a pneumoperitoneum like any other laparoscopic procedure. Put in the trocars, release the adhesions if there are any, dissect the callos, occlusion and division of the cystic artery and the duct, and then finally separation of the gallbladder from the liver bed and extraction of the gallbladder with closure of the port. These are the 4 steps which we can move into. The ports, the commonly used ports are the 4-port technique. People do with the 3-port technique. I think Professor V.K. Shukla, under whom we work, I worked under, he has got probably the largest series in the country of doing it in a 3-port technique. Must have done 20,000 of them, I think, by now. So, the 4-port technique, the first port is in the umbilicus. The supraumbilicus is preferred just because the anatomy, the peritoneum is attached to the umbilicus at that time. Intra-umbilical, you can go into the into the space created, which is reserved for the bladder actually. Then the second port is another 10 mm, which is at the highest point of the epigastrium, to the right of the midline. Then you have the other 2 ports, one in the mid-clavicular line, below the subcostal margin, and another is the lumbar region, which is in the anterior axillary line. These are 2 5 mm ports. Coming to see that the first release of the adhesions, adequate traction has to be given at the gallbladder fundus, which and need to dissect the plane between these omental adhesions and the gallbladder. We should never ever cut between the omentum because that leads to bleeding and makes the field dirty. So these adhesions are very, very common, but at the same time, one should remember it very carefully that the gallbladder should be reflected towards the right axilla. There can be adhesions which can be of different types. This is the case which I had pancreatitis before, and you can see that these adhesions are there, and these are flimsy adhesions which can be taken care of by a sharp instrument, which you don't require an ultrasonic scissor also to do this. This can be done with a cold scissor kind of a thing. But if you don't do it, you're not able to flip the liver above the flip the gallbladder above the liver, and you will not be able to open up the clot. That is the main thing. Once that is true, this is how the gallbladder is retracted up. The lumbar instrument holds the gallbladder fundus, puts it towards the axilla, right axilla. The fundus grows cranially, the Hartmann comes laterally. What it does is that it opens up the clot. In the peritoneum, if required, somebody then put in a little bit of pause there and retract it down medially. We stretch the peritoneal hole at that time and start dissecting at the gallbladder neck. We don't come to the cystic duct CBD junction. The dissection to start at the gallbladder cystic duct junction. That is a cystic duct junction. You can see the cystic duct gallbladder junction section is being started. First, the idea is to do a posterior dissection. You, keeping in mind the ruveus sulcus, go towards the gallbladder gallbladder bed, staying in front of the ruveus sulcus. The sulcus, you can take a hook, you can take a dissector, and create this posterior window. This posterior window gives you a good anatomical delineation in front of the gallbladder where the cystic duct or the CBD is. You can follow this up with a interior dissection. Just anterior dissection means that the peritoneal covering which covers the interior structure can be peeled off. Gradually, you need to move medially. The cystic artery and the duct are identified, and you create the critical view of safety where you see only 2 structures going into the gallbladder, cystic duct and cystic artery, and you also remove the lower 1/3 of the gallbladder attachment to the liver. So once this is done, you get to those two structures, you can ligate, occlude, and cut the common cystic duct and the artery. Each one to be done first. There will be a lot of people talking that you do the first structure which you see first. But if you have a cystic artery there with the duct there, the cystic artery acts as a bowstring. And once you cut that cystic artery, the duct gets released. And you can very clearly see the elephant head at that time. Very clearly, the Lord Ganesha sign or the elephant head sign. You can see that is the trunk there of the elephant with the elephant head, the infundibulum of the elephant head. So this needs to be clipped about 5 to 6 mm from the polycystic duct CBD junction. And 3 clips, 2 proximally and 1 distally. These are the titanium clips, which are 9 mm clips, LT300. And you should mark clips and should not come proximal to the first clip. The first clip should be something which should be marked, and then that one should not. You can cut it beyond that with a cold scissor. And see that the golden bile trickles out from the cystic duct. And following this, the gallbladder needs to be taken out from the liver bed, hooking the infundibulum, pulling it up superiorlaterally, hook the peritoneum interior and posterior. This peritoneum, the posterior one, generally contains vessels, veins, which can bleed. One has to be very careful that you don't prick the gallbladder, don't spill the bile, and along with the bile there can be spillage of the stones. You don't need to enter a deep plane, stay under vision, and slowly remove the gallbladder from the bed. Once you come to this position where only it is attached at the fundus, you try to look down and look for any bleeding, if there is any bleeding there from the liver bed. Following this, the gall needs to be extracted. People talk about an endobag. We generally don't use the endobag. It looks like normal looking gallbladder. It's taken out from the epigastric port. People do take out from the umbilical port. After that, the area is irrigated with little saline, and the whole Hartmann's pouch area is clean and dry. You can use a little bit piece of gauze also to mop the area dry, and close all the 10 mm ports which were created. General problems are short cystic duct, the calculi in the neck can have. There is a fistula between the gallbladder and the duodenum, polycystic fistula, thick gallbladder, aberrant cystic arteries, and these are some problems which one can face. But the biggest problem one can face is an overconfident surgeon. If the surgeon is overconfident, a simple kind of a gallbladder is the most dangerous one where you can hear the gallbladder. Complications intraoperatively can be hemorrhage, which we know from many sides, to occur into the vessels which do not have support. And from the calot, one has to be very careful. Liver bleed is something which can happen while you're taking out the gallbladder. It can be leakage, there can be duct injury, cystic duct, or there can be a accessory duct there, which can leak. Recognition of these problems are very important. Once you recognize that, you can take care of it. You can call for help if required. There are different concepts coming out, as I mentioned, the 2-port, single port, 2-port, 3-port cholecystectomies. These are there for a long time, but this is not really established. Robotic is one which has taken over many things. Clips and versus sutures, whether you put in a clip, people talk about a clip getting into the CPD after 15 years, how relevant it is, how we should stop using clips. I don't think so. Sutures are something, yes, you can suture it, but this is not the place to practice your suturing. Partial cholecystectomy is an issue because how much partial it is. People take out the fundus, people take out the stones, and then say that they have done a partial cholecystectomy. It is not right to be done, where you cannot define the callots, where it's absolutely frozen. You can go up to the infundibulum. That amounts to a partial cholecystectomy. Intraoperative cholangiogram, I think, is lost its way. Associated surgery, whether you can do a hernia with the cholecystectomy or not, that is again debated. Dome down approach is another approach, doing fundus first approach. Clipless cholecystectomy, not using a clip, using ultrasonic scissor to close the cystic duct, and putting. I can understand your pathology will teach you that you're doing it in the vessel intima inverts on its own and then closes on its own. But doing it after, but I've seen one surgeon doing it in my institute. He had a few complications, but complications were not very marked. So this is something I don't know. I have never done it, but literature to talk about. Daycare, yes, we have also done it. Daycare can be done before 12 in the afternoon and discharge the patient in the evening. But India is a stage where patient might not be able to come back. Natural orifice transluminal endoscopic surgery. I think it has again lost its way. Summarizing, ladies and gentlemen, it's a very common and a simple surgery, but the complications can be very disastrous. So one needs to look after that. Thank you all very much. I think I finished in time, Punit.
Thank you, Dr. Deboshi, for a nice and elaborate, quick discussion on a common procedure which is done at every nook and corner of the country. Now, I was always saying that lap chole and lap hernia of course came little later, but lap chole became so popular within short time. The lap hernia has not been able to achieve that popularity. Even now, a lot of centers are doing open. The reason being that open anatomy of cholecystectomy or laparoscopic anatomy remains the same, whereas in hernia, the anatomy of open hernia surgery and lap hernia surgery is totally different. I recommended to MCI also that the teaching of anatomy for lap hernia should be included in the curriculum in first year itself. Anyway, I have made 3 quick observations. One is that when we do laparoscopic cholecystectomy, we always create a critical view of safety and the dissection starts posteriorly. Whereas in open surgery, the dissection in the Callet's angle starts anteriorly. Second is, when you come across sessile gallbladder, it's very difficult to create a critical view of safety this way. And I always recommend and suggest that fundus first is the best option, and partial cholecystectomy should be the way out. Never close a lap chole operation. I mean, never close the pores until even a single drop of bile is seen in the area. Every effort should be made to see from where it is coming and should be seen. Just trickling of a single drop does not entail a surgeon to close the pores and put a drain and come out. That can be very disastrous. That's all I think I have to make about this. And portal hypertension is a contraindication. He already said some of the ultrasonography reports do show portal cavernoma, and they are also the contraindication of lap chole. I'll add to that. Dr. Ansari, please.
Yes, thank you, Dr. Deboshi, for a very, very good presentation. And this is one of the procedure which is taken as the first procedure for any postgraduate to practice in after finishing the training. So every postgraduate has to learn the laparoscopic cholecystectomy from A to Z, because this actually may take you high, and it may even totally destroy your career, because in the beginning only when you commit lot of complications, then you are gone. So that is why every step has to be followed, what Dr. Deboshi has rightly said. One remark I would make, if there are dangerous stones, the small stones which is collected in the Hartmann's pouch and trickling down into the cystic duct, then milking may be done of the cystic duct so as to prevent the migration of small stones into the common bile duct. That is one. And the other thing is, when you come across any anatomical disparity or discrepancy, then you need to be very judicious and slow. You should never do this procedure as a fast, because the fast is slow and slow is fast. If you try to do laparoscopic cholecystectomy very fast, saying that अरे lap chole तो है, फट से कर देते हैं 15 मिनट में, then you are gone, because
उनकी बेटी को दवाई देने के लिए बुलाया था, मैंने तो अभी बोल दिया मैम क्लास है अभी।
Dr. Garg has very rightly commented, if you see a small
मैं उनको वो दे
golden,
देता हूँ, जगह का वो
small amount
भेज
of the
देता हूँ
golden bite into the peritoneum.
मैप पे ना, मैप पे
Just
अपने आप गाड़ी चला के चली जाएगी।
take a deep breath and try to see every part of the common bile duct and the liver that you have not injured or inadvertently you have not perforated the common bile duct, which is not seen because your cameraman which is showing the camera may not be able to focus on that part of the common bile duct, and you may land up having
बैठते नहीं
you
ना
know
वो।
large glioma in post-operative period. So you have to do this
मंडे को
very
जा सकते हैं, फिर ये
cautiously.
कहते हैं, फिर तो मंडे को जा सकते हैं।
And postgraduate has to learn it very properly. Thank you very much, everyone.
I'd like to retaliate Dr. Ansari's statement that slow is fast. That should be the golden principle, and every postgraduate must lay emphasis that there is no necessity to be unduly hurried while performing laparoscopic cholecystectomy. Slow is fast. I think that's an accepted word over. Am I right?
Thank you.
Dr. Lisa.
Yeah, and thank you, Dr. Pradeep Garg and Dr. M.A. Ansari for moderating the session. I thank also Dr. Devashi for wonderful presentations, and we move on to the next session. Here is a case capsule on obstructive jaundice, and for this, the presentation is Shruti from Jodhpur, and the moderator for this session is Dr. Abhay Dalvi, sir, and Dr. V.K. Kapoor, Dr. Marwa, Dr. Amit Gupta, Dr. Mahavir Singh, and Dr. Lakshman Agarwal. They are the examiners for this session. So over to Dr. Abhay Dalvi, sir. He has joined. Dr. Abhay Dalvi, sir.
Yeah, I am very much there. Only thing, I am traveling right now. I've just got down from an aircraft and I'm moving out. So I am asking who is presenting the case?
Dr.
Hello?
Shruti, are you there?
Who is presenting the case?
Hello, can you hear me, sir?
Yes, madam.
Yeah.
Go ahead. All the best.
Thank you.
As said, Dr. Abhay Dalvi sir is traveling, so I request Dr. V.K. Kapoor to intervene in between if he goes out of the network. So Dr. V.K. Kapoor will be there. He will be moderating it in between if Dr. Abhay Dalvi goes out of the network. So it is all
Thank you
okay,
so much.
and we
Yeah.
go ahead with the presentation. Thank you. You share, sir. You share your screen.
Yeah. Good morning, everyone. Sir, should I start with the presentation?
Yeah, please start.
Right. Hello, I am Dr. Shruti, coming from AIMS Jodhpur, and my moderator is Dr. Ramkaran Chaudhary. And I would like to present the case of obstructive jaundice. A 60-year-old lady, homemaker by occupation, coming from Jalore in Rajasthan. She came with the chief complaints of pain abdomen for the last 1 year, with LOH discoloration of urine and eyes for the last 10 days. In history of presenting illness, the patient was apparently normal 1 year back. Then she had history of abdominal pain for last 1 year, which was more over the upper abdomen. It was insidious in onset, intermittent type of pain. Initially mild in intensity, now it has become a little bit higher, that is moderate in intensity for the past 10 days. It is dull aching in nature, radiating to the back. There is no referred pain, and it is aggravated following food intake and relieved with medications. There is also a history of LOH discoloration in urine for the past 10 days, which was noticed initially, following which she noticed LOH discoloration of her eyes also. It was insidious in onset, and it is progressing in nature and associated with itching. However, there are no history of any prodromal symptoms like fever. There is no history of any altered color of stools. There are no aggravating or relieving factors for jaundice. She also has a history of vomiting for the past 10 days, which is intermittent, and she gets about 1 to 2 episodes per day. It is non-BS and not blood stain, non-projectile, and it occurs immediately after food intake and is relieved with medications. There is also a history of constipation for the past 4 days. However, she is passing
तो
playlist.
मैम ऐसा करेंगे या
There
तो
is a
मंडे में
history
चल
of
लेते
loss
हैं
of weight. It's
और
not measured actually, but she is
हाँ
giving history
नहीं
of
तो कोई
eating
बात
of
नहीं
her
मैं
foods.
चल लेता हूँ कोई
And there
दिक्कत
is a
नहीं है
history of
इसको उस पर
loss
लगा
of
दूंगा फिर
appetite.
रिकॉर्डिंग पे
However,
थोड़ी
there
देर
is
में
no
बाद में
history of
देख
any
लूंगा फिर
abdominal distension or lump in the abdomen or elsewhere. There is no history of hematemesis or melena.
नहीं मैं कर
No
सकता हूँ
history of any
लैपटॉप में
bleeding. No history of
वैसे तो
increased
नहीं है
urine
लेकिन
output.
मैं अपना लगा
She
के
does
चला
not
जाता
have
हूँ
any history of cough or hemoptysis or headache or any bone pains.
वो BHU
Coming to the
का
past
चल
history,
रहा
she
है
does
फॉर
not have any
PGs के
history
लिए
of
2 दिन का
comorbidities such as
लगातार है
diabetes,
केस
hypertension,
केस प्रेजेंटेशन
pulmonary
है अलग अलग
tuberculosis, asthma,
डॉक्टर मतलब पूरा सर
coronary artery
लीजिए
disease or thyroid disorders.
चालू
And
हो
she
चुका है
has a previous history of open tubal ligation done 40 years back. She does not give any history of previous blood
हाँ
transfusion. There
हाँ
is no history of any
जी
oral contraceptive use.
जी
Coming to personal history, she has no history of any addiction or substance abuse.
जी
She consumes vegetarian diet and has normal bladder habits, and she complains of on and off constipation. Her sleep and appetite are sleep is normal. However, she gives a history of recent loss of appetite. There are no known allergies.
जी
And in family history, there is no history of any jaundice or other malignancies like
जी
pancreatic, colon, breast, or gonadal cancers in the
जी
family. Menstrual history, she is
हाँ अगर हम शुरुआत में
postmenopausal.
आएंगे
She
तो कोई
attained
दिक्कत नहीं है
menopause
इसमें
10
तो
years back. And
पहले ही देख लेंगे वो
she attained menarche at 12 years of
भीड़
age
भी वही
and
12
had
बजे के
restless
बाद
sleeping
आती
during
है
her menstrual phase, 4 days in 4 out of 30 days. She is a mother of 2 children. Both of them were
जी
delivered through full-term normal vaginal delivery, and both of them were breastfed for 2 years. So summarizing my history, this is a 60-year-old postmenopausal lady who presented with complaint of a dull aching pain over upper abdomen for the past 1 year, which is radiating to the back, and progressive jaundice associated with itching for the past 10 days. And she also has a history of multiple episodes of non-bilious vomiting for 10 days, along with history of loss of weight and loss of appetite. So my provisional diagnosis at the end of history would be a case of obstructive jaundice and probably due to a carcinoma head of pancreas.
कहाँ ले जा रही हो उधर इधर ले आओ नहीं गिरेगी
Dr. Marwa, would you like to ask some questions on history?
Sir, you said that the pain is radiating to the back and it is not referred. What do you want to derive from it? This statement.
Sir, actually, radiating pain is because of local irritation of the nerve plexus. Whereas referral could be because of involvement of nerve cells. There is no referred pain as such, but there is a radiation pain.
So, can some pathology in the right upper abdomen lead to referred pain?
Yes, sir. If there is a gallbladder pathology, then it can refer to the right shoulder.
What is the mechanism like? How it happens?
Sir, it is because of the irritation of the diaphragm that it gets
How?
and also because they share a dermatome.
Yeah, which dermatome?
So that I know, sir.
Okay. Okay, right. Then you said it is progressive jaundice,
Yes, sir.
right? So, what does that mean?
Sir, initially she had noticed only discoloration of urine, and later she noticed the discoloration of her eyes also, and actually as per the patient.
And suppose it is intermittent jaundice then?
Sir, if it is intermittent jaundice, then there is more possibility of periambular carcinoma because there is a waxing and waning of jaundice associated with the necrosis of tumor. And another possibility could be that of a polydopolithiasis also, which will also cause an intermittent diagnosis.
Right, sir. What do you say, Dr. Kapoor?
So, you said that she also has vomiting for last 10 days.
Yes, sir.
Do you not think that to be important enough to be included in the chief complaints?
Sir, she gives a history of like only 1 or 2 episodes, sir, for the past 10 days. I mean, initially when I asked the patient what her complaints were, she just told me. And later on when I inquired about vomiting and other things, that is when she had told me about it.
Yeah, but if somebody who was not having any upper abdominal symptoms earlier starts having vomiting, non-bilious, in this setting, it probably becomes important. And then go to the next slide. Next. Most of the students ask these metastatic history. So cough and hemoptysis, I know that you are talking of pulmonary metastasis. But what is more common than that?
So breathlessness would be more common than that.
Yeah, so pleural effusion, malignant pleural effusion, which causes breathlessness or exertion. So that is more important rather than cough and hemoptysis. And past history. Again, now since there is every possibility that your exam will be online and you will be presenting like this, please avoid using non-conventional, non-standard abbreviations like BA. So say bronchial asthma. And then when Dr. Marwa was asking you about the referral of pain, you said diaphragm, but you didn't mention the word phrenic nerve. You should have mentioned. See, these are questions where you should show your knowledge. I'm sure you know, but you have to show. Nothing is understood in the exam. Okay? Now go to your summary. Okay. So why do you say obstructive jaundice? Why do you say obstructive jaundice?
The obstructive jaundice is because the jaundice is associated with itching, sir.
Can you not have itching with jaundice in non-obstructive, non-surgical jaundice?
Sir, it is still possible when there are excessive bile salts.
So viral hepatitis, can you have jaundice with itching?
Yes, sir, we can have it during the cholestatic.
Suppose I tell you that her pain and jaundice are unrelated and this is an episode of viral hepatitis, what is against it?
Sir, there is a history of loss of weight and loss of appetite, and she is also giving history of vomiting, which is...
Has she lost weight in 10 days?
No, sir, she has been gradually losing weight. Like for the last 1 year, she has come.
That should have come out in your history very clearly that she has lost her appetite and weight even before she started having this jaundice. Okay? Yes. And what is the commonest cause of surgical obstructive jaundice?
Sir, commonest cause would be benign causes, like polytherapy.
So CBD stone is still the commonest cause of surgical obstructive jaundice. Why is this not CBD stone, pain and jaundice?
Sir, one thing is because of the age, older age is pointing more towards the malignant cause rather than a benign cause. And other supportive factors would be that she's having a progressive jaundice rather than an intermittent jaundice, and she's also having an associated history of loss of weight and appetite. So all of these are pointing more towards malignancy than a benign cause.
Many of you do mention age as a point in support of diagnosis of malignancy, but we should keep in mind that even 60-year-old, if you take 100 patients with surgical obstructive jaundice, probably CBD stone will still be common. So what your answer should be that if a 60-year-old patient presents with obstructive jaundice, I would like to keep the possibility of malignancy in mind, and the point in favor is the history of loss of weight and appetite. Also, when patients with CBD stone have jaundice, they have pain and jaundice combined, and they are more likely to have cholangitis as opposed to malignant obstructive jaundice, which means history of high-grade fever with chills and dry. Okay. Let's proceed with the examination.
General examination, the patient is conscious, oriented, moderately built and nourished, lying comfortably in supine position. She has a Konofsky performance index of 90, her GM is 21, addition status is there. There is no evidence of pallor, there is effect present, and no clubbing, cyanosis, generalized significant lymphadenopathy or phlegma. There are no signs of liver cell failure. And
तो इसने बोला टर्न ऑफ स्काई परफॉर्मेंस इंडेक्स 90, ये क्या होता है पता ही नहीं.
Blood pressure of 128 by 70
तुम्हें पता है?
measured in right upper limb at the level of heart. Respiratory rate of 18 per minute, and temperature is febrile. Coming to the examination of abdomen, the patient is lying supine with legs semi-flexed and arms by the side and exposed from neck to thigh. And on inspection, the abdomen appears flat except for a visible lump in the right hypochondrium, which moves with respiration, appearing biform in shape, and margins are not well defined. All quadrants move equally with respiration. Umbilicus is in midline and inverted in shape. Scratch marks are present over the abdomen. There are no sinuses, dilated veins, or any visible peristalsis. Flanks appear free. Hernial orifices are free. And there are no visible peristalsis. Renal angle appears normal. External genitalia appears normal, and left supraclavicular foci is also normal. Coming to palpation, there is no local rise of temperature, no tenderness, and gallbladder is palpable, which is of around 2 cross 3 centimeter in size with well-defined margins, except superiorly, having a smooth surface, soft, firm, and consistency. It moves with respiration and is mobile side to side, and extends up to 3 centimeter below the right costal margin in hyperclavicular line. There are no other lump palpable, no hepatosplenomegaly, Fluid is negative and left supraclavicular fossa is normal. Coming to percussion, there is a dull note over the gallbladder, whereas rest of the abdomen has a tympanic node. There is no shifting dullness. Liver span is normal of 11 centimeters and renal angle is resident. Coming to auscultation, the bowel sounds are normal. There are no added sounds like rub or murmur. I've also done a pervaginal examination which is normal and a digital rectal examination which shows that the anal tone was normal with no evidence of any mass or tissue of fistula with normal fecal stain. Examination of spine was also normal. Coming to the other system examination, cardiovascular system, respiratory and the central nervous system all did not have any. So summarizing my history and examination, she is a 60-year-old postmenopausal lady who presented with complaint of dilating pain over upper abdomen for the past 1 year, which was radiating to back, with progressive jaundice associated with itching for the last 10 days. And she has a history of multiple episodes of non-bilious vomitings, along with history of gradual loss of weight and loss of appetite. And on examination, patient has egress with scratch marks over the abdomen and a gallbladder which is palpable about 3 centimeters below the right costal margin. In the mid-clavicular line, which is soft to firm in consistency and mobile side to side. However, there is no evidence of any other lump or free fluid or hyperosmolality.
Dr. Amit, no. Dr. Amit, questions on examination, please. Dr. Amit Gupta. Dr. Amit, please unmute yourself.
Yes. So am I audible now?
Yes, please go ahead. Questions on examination.
Suruchi, you mentioned that patient is having history of jaundice only for the last 10 days.
Yes, sir.
Right? And with this history, Dr. Kapoor also mentioned that she is having history of, you said that patient is having 1 episode or 2 episodes of vomiting per day. Still, you will like to go ahead with the diagnosis of head of the pancreas, or will you like to keep another diagnosis as your first diagnosis? Some other question in your mind?
Sir, actually, because there is a chronic history of loss of weight and loss of appetite, I would still stick to a malignancy. And probably
the malignancy may be a distal cholangiocarcinoma, it may be a paraneoplastic carcinoma, or it may be a GD carcinoma. So still, you will like to keep carcinoma head of the pancreas as a first diagnosis.
Yes.
So what is the commonest symptom in carcinoma head of the pancreas? That is progressively increasing pain as jaundice in most of the patients. Right? But here you have described that patient is having pain for the last 1 year.
Yes.
Right?
Yes, sir. There could
still you will like to keep.
Sir, there could be 2-3 reasons.
And then you are on top of that, the patient is also having features of gastric outlet partial maybe, right? So by this presentation, can you describe the cause of vomiting?
Sir, the cause of vomiting, common cause, there would be that of a gastrointestinal obstruction. Because the carcinoma head of pancreas had progressed and it's affecting all the. She is also having multiple episodes of non-bilious vomiting.
But in that, okay, but in that scenario, will you see that patient will be having only a 10 days duration jaundice?
No, sir, it would be longer, sir. I would expect a longer duration jaundice. But the reason here could be that the patient noticed only 10 days back, sir.
So, in that context, though it is now not management point of view, it is not very important, but do you know about Benjamin classification of jaundice?
Yes, sir.
Type 1, type 2, type 3, type 4?
Yes, sir. There are totally types. Type 1 is for complete obstruction, which could malignancy.
Very good.
Head of pancreas or because of heating of kidney. Type 2 is intermittent obstruction, sir. It could be because of polydocolichiasis or any worm infestation of kidney. And type 3 is chronic.
Or you can see in periampullary tumor.
In periampullary tumors also, even in capillary lesions in and
yes, type 3.
Type 3 is
एक नहीं बड़ी लाते ना और नंबर है ना
And like you see in chronic pancreatitis, or you when you have done a video entry anastomosis, which has undergone, it's a not right? So type 4.
Sir, type
segmental obstruction.
segmental obstruction. Segmental obstruction, which could be traumatic, or it could be because of any intrahepatic.
Or you see in skull.
Sorry, sir.
अब जाके चैनल पे वीडियो डाल दिया वो
तो वो दोनों वीडियो बैक पे डाली है?
एक
Yes, please.
ये वाला लेके पे डाल
So there are some questions in the box. Why did you ask about gum bleeding history?
Sir, gum bleeding history is because the coagulation profile can get changed even in case of obstructive jaundice. So, and the manifestation can be in forms of gum bleeding.
What else could you have asked in addition to gum bleeding? What other manifestations could be there of coagulopathy?
Any rectal bleeding can be present, or
More common?
bloodstains, vomitus.
Bruises, spontaneous bruises, or bruises on minor trauma. And if it is a young female, then history of pneumo and metrorrhagia.
Yes.
Then there is a comment that can we comment on pallor in presence of icterus? If the
Sir,
patient
if
is
there is
weak.
deep jaundice, then in case of deep jaundice, then we may not be able to comment on pallor from the eyes. In that case, we can even look at the main bits, but still it would be difficult.
किससे बोलते हैं ना
And then
मुझसे तो कभी ना बोला जाए मुनीश की तरह बोल
is it important to know swelling of the lower limbs in this case? Somebody wants.
One thing would be that it can comment on the nutritional status, albumin status of the patient, because that is ultimately going to affect our clinical outcomes.
That should be a routine that in all patients in whom you are suspecting a malignancy, you must carefully look for and comment on bilateral fetal edema. Then, the
As
other
you mentioned about
information
fetal edema, there is no fetal edema.
Yes. So, obstructive jaundice, two things are very important. One, history of pain, and other is whether the gallbladder is palpable or not. If there is history of pain, then the common diagnosis would be gallbladder and pancreas, because almost 50 to 60% of patients with carcinoma gallbladder have pain, and almost 60 to 70% of patients with carcinoma of the head of the pancreas have pain. On the other hand, if it is painless progressive jaundice, then periampullary carcinomas and cholangiocarcinoma, hilar cholangiocarcinoma is more likely. If the gallbladder is distended, palpable, then hilar cholangiocarcinoma is ruled out. Could be periampullary. We have to remember that gallbladder can be distended in a gallbladder neck cancer also. So you have to differentiate between a distended palpable gallbladder and a gallbladder lump. Like in the previous case, if it is a gallbladder lump, then it is likely to be gallbladder cancer. If it is distended gallbladder cancer, painless jaundice, more likely that it is a periampullary carcinoma or a PBC neck. And why did you mention splenomegaly? Any specific reason?
Because of sometimes there can be secondary biliary cirrhosis, which can lead to portal hypertension, causing a splenomegaly.
Is it possible in this case? When does secondary biliary cirrhosis occur?
Sir, if there is any hepatic metastasis, it can occur.
It is usually a complication of long-standing recurrent biliary obstruction with recurrent episodes of cholangitis. So if you have a 10-day history of jaundice, very, very unlikely that you will have biliary cirrhosis. Now, 10 sperm gallbladder with jaundice malignancy without this we have already discussed. Yes. So as I said earlier, pain means head of pancreas or gallbladder. Painless means more likely periampullary and hilar cholangiocarcinoma. Now going back to the history again, she has 1 year history of pain and jaundice for 10 days. Is there any remote possibility that this could be a benign pathology?
Sir, there is still a remote possibility, but the only thing which are going, the two things which are going against is loss of weight and loss of appetite.
Suppose those symptoms were not there, or it was only loss of weight, no loss of appetite. He has good appetite, but still he has lost weight. Could there be any other possibility?
कुछ ही बोलना है इनका
Pancreatic pain, loss of weight, recent jaundice.
चीज तो मेरी तो चलती है
Sir, it could be a biliary pancreatitis. Like there could be a cholelithiasis associated with pancreatitis.
What kind of pancreatitis does cholelithiasis cause?
Biliary
Cholelithiasis causes recurrent acute pancreatitis. What I am hinting towards is whether it is chronic pancreatitis which was responsible for pancreatic pain, and now as a complication of chronic pancreatitis she has developed biliary obstruction which is causing jaundice. And we know that chronic pancreatitis is one of the conditions which can result in significant weight loss even in presence of a normal appetite, primarily because of bile absorption. So there is malnutrition but there is no anorexia. Okay, I think we will proceed. So now, Doctor.
And many times, Shruti, these patients actually tend to lose weight because they are fearful of eating, right? Because the moment they eat, it aggravates the pain. So that can also lead to malnutrition and weight loss.
See, if you have nothing more to show, you can stop sharing your slides so that we can have a full screen view of the panel.
सब related है ऐसा भी नहीं है
Dr.
कि related नहीं है.
So, can you enumerate the possibilities which you want to keep after this discussion? 1, 2, 3, 4.
Sir, my first diagnosis would be that of a carcinoma head of pancreas.
फिर उसके बाद आएगा epigastric
And but there could still be a possibility of a periampullary carcinoma. And I mean, second possibility would be that of a carcinoma gallbladder also.
Which part?
South की लड़की तो है.
Which part of gallbladder? Having malignancy, likely malignancy.
एम्स जोधपुर में
Sir, it could be a neck of gallbladder malignancy.
Right.
जॉन्डिस कर रही तो पीला पीला कर
Another possibility?
Third possibility would be that of chronic pancreatitis, which is complicated with
How do you explain gallbladder palpable in a chronic pancreatitis?
कपूर है लखनऊ से
yes, sir, that goes against.
सफेद दाढ़ी.
And sir, third would be that of a periampullary carcinoma.
That you already told.
Yes. And cholelithiasis can be ruled out in this patient, sir, because of loss of weight and loss of appetite, which is not going to be that person. I would still stick to a malignant cause.
Can cholelithiasis have palpable gallbladder?
No, sir, that also goes against the weight.
Are you sure it can't have? No, what is double infection?
It can have exceptions include if there is any double impaction of the stone, or if there is an infection of cystic duct. Sir, if there is an infection of stone at the cystic duct and at the CBD. So if there is a double impaction, then there can be a palpable gallbladder. Or if there is Greeley syndrome also, there can be a palpable gallbladder. Sir. And in case of a primary CBD stone without any stone in the gallbladder, that is also an exception. Or if there are worms in CBD, worm infestations such as Clonopsis sinensis, that can also be an exception.
Right. So from history, like you are saying, she had pancreas and periampullary carcinoma. So how will you differentiate from history?
Sir, from the history, yes, sir. If there is a waxing and waning of jaundice which is present, then it is more towards periampullary carcinoma because there is intermittent sloughing of the tumor, and at that time there can also be a history of melena which is associated, sir, whenever there is a waning of jaundice. However, then it is pointing more towards the CA head of pancreas.
Right. Another important thing Dr. Kapoor has just now said that painful jaundice is more likely to be CA head pancreas and painless periampullary. Right, sir.
Dr. Mahavir, are you there? Would you like to ask some questions on investigations? Dr. Mahavir Singh? Dr. Lakshman, maybe you can ask questions on investigations. Before Dr. Lakshman comes in, Shruti, did I hear you correct that you said in Miritzky syndrome, gallbladder can be palpable? No.
Yes, sir, that is okay.
No. Miritzky syndrome, usually the gallbladder is contracted, fibrous, thickened. Usually it is
Miritzky syndrome.
Only double infection is the exception which Dr. Marva was trying to ask. Dr. Lakshman, please, investigations.
So before I go to investigation, I would like to ask Shruti. She had said that there is itching, but she did not mention in her chief complaint that patient was having itching. She had only mentioned two things. One, and what is the cause of itching?
Sir, the cause of itching is because of jaundice, which is causing increased deposition of bile salts in the skin. So,
बताया तो
What
पहली बार
happens? If there is a deposition of bile salts, what happens?
There is a systemic release because of excessive systemic release.
It is the nerve endings which get irritated and they release some neurochemicals. That is why patient is very itchy. And what is the classical itching that the patient has which is different from pruritus of other causes?
Sir, here it will be associated with petechial spots. Sir. If you observe the scratch mark, it will be associated with petechial spots and it will be all over the body. Sir. Like even chest, abdomen, it can be associated. Whereas if it is the pruritus of other cause, it is mostly peripheral cause.
So because of cholangiopathy which is there, you can have bleeding along with the itching. Alright, now I move on to the investigation part as I have been asked. So what investigation you would like to do in this particular case?
Sir, I would like to do investigations to confirm my diagnosis and also to plan my treatment. So to confirm my diagnosis, first investigation I would do is that of a liver function test, followed by an ultrasound of both abdomen. In liver function test,
What abnormality you expect in liver function test, in particular your case?
Sir, in liver function test, firstly there will be a conjugated bilirubemia. That is more than 15% of total bilirubin will be conjugated. And there can be an increase in ALP, sir, which is usually associated with obstructive jaundice. Also, the PTINR, that is prothrombin time, and INR can also be deranged. It's usually deranged in obstructive jaundice.
What else? Something about urobilinogen?
Yes, sir. Urobilinogen is usually absent or decreased in case of obstructive jaundice, sir. Because the conjugated bilirubin is not able to reach the colon, so not able to reach the intestine.
हर चीज
You
मतलब
talked
बता
about
दिया
alkaline
तो
phosphatase.
100 कैरी हुई है
You
कितने
think
दिनों
is
से
now
क्लियर हो जाता है ना, इतने दिनों से इसी की तैयारी करनी है. हाँ
the level where you should think yes,
शाम
this
को
may be a surgical cause of jaundice.
Sir, if there is more than 3 times
शाम को
elevation
चलना.
of the normal value, then we consider that it is more towards it.
ऊपर से एम्स की है, ऊपर से लड़की है, वो तो वैसे ही चाटी रहती
Deeper
है.
aspect of the
ये तो है.
jaundice and
और
the
ये
going towards liver failure, then what abnormality you expect in your liver function test?
Sir, if there is a liver failure happening, then albumin levels can start decreasing. Sir. Because in chronic liver failure, albumin.
लेकिन जब हम लोग थे अपनी उसमें
Also,
हम लोगों को भी काफी अच्छा आता था लड़कियों में स्पेशली.
So what next after liver function test?
So after liver function test as an initial screening modality, I will do an ultrasound whole abdomen. In ultrasound abdomen, I would like to see what is the diameter of the CTD, where is the level of obstruction of the CTD, if there is any presence of stones, and what is the echo texture of the liver, and about the status of the gallbladder, if there are any stones in the gallbladder or if it is contracted or distended, and also, sir, regarding the presence of any ascites. And the status of other organs like
ascites.
Suppose you have ascites, what do you infer?
So if the patient has ascites, then it could be because of a malignant ascites also. Also, it can be because of liver cell failure, which is causing ascites.
Okay. What next after ultrasonography?
So after ultrasound, I would prefer doing a triphasic contrast in pancreatic protocol.
What do you expect in that?
Sir, in CT, I would be able to visualize the pancreas better, sir. So, I can comment about the mark on the pancreas, about its relation to other structures such as celiac or celiac or portal. And apart from that, I would be able to comment on the nodal status, peripancreatic nodes or if there is any paralytic node involved.
You have kept your first diagnosis as probably C head of pancreas. Alright. So, what type of CT scan you would order? A simple CT or something else?
Pancreatic protocol, will we call it, sir. Wherein there is an arterial phase, portal venous phase, and a delayed venous phase. And in the venous phase, you will be able to visualize the pancreatic tumor better. Whereas in the arterial phase, if it is a neuroendocrine tumor, then it will be better than an arterial.
Right. So, what? Suppose it is not C head of pancreas. You have commented that there was pain in the abdomen for almost a year, and then she had jaundice.
Yes, sir.
Suppose she had history of biliary colic also. What investigation you would order?
Sir, in such a case, I would order the FCT also. In order to in order to look at the CBD status, sir. If there is no stone as such visualized on ultrasound or on CT, then it would be better that I do an MRCT to know what the luminal status if there are any stones.
Suppose you find a stone over there, what you will ask?
Sir, if there is a stone present, then I would proceed with an ERCP, sir. ERCP with sphincterotomy and stenting to remove the stone, sir.
Suppose there is a big stone.
If the stone size is more than 1 or 1.5 centimeters, then I would prefer doing a I would prefer doing a lab CBD exploration, sir.
Yeah.
For the
आपका फोटो नहीं आ रहा इसमें.
and if the CBD, I can even go with the Kolytopo diagnostic.
What is the complication of Kolytopo disease?
So there could be a delayed complication could be that of the stricture formation.
You prefer doing a faticogestomy rather than choroidopodystrophy. So there is some syndrome. There is the deposition of the food which comes in the, because food is coming in direct contact with the duodenum and it is a very close. So there could be some syndrome and you would have a different problems. So that is why you avoid doing it, but some people still do it. So that is Dr. Kapoor, you can take over.
Dr. Mahavir there, Dr. Mahavir Singh.
Yes, sir. Good morning, sir. Shruti, one question. How you differentiate the medical jaundice with the surgical jaundice in the clinical exam?
So in clinical examination, that will be associated
पुराने
in
उठने
case of medical jaundice. There will be more commonly there can be seen in obstetric jaundice. Second thing is the patient will have prodromal symptoms such as
कृष्णा
fever
भी
and
आया था
chest
उससे
and
पहले है ना.
associated with medical jaundice, whereas that may not be present in obstetric jaundice. And the color of the stools is also important. There will be pale colored stools in obstetric jaundice, whereas the stool color may be normal or high color in case of medical jaundice.
Okay. Thank you, sir.
Okay.
Awesome.
I would just like to summarize for the students. As I said earlier, if you have obstructive jaundice and you make a diagnosis of surgical obstructive jaundice and malignant surgical obstructive jaundice, based on history examination and ultrasound, in large majority of cases, you can arrive at a diagnosis. I'll tell you how. So if you have painless progressive jaundice, as I said, it is either periampullary or cholangiocarcinoma. In cholangiocarcinoma, you will have IHBRD. Confluence may or may not be forming, but below that you don't see bile duct. So it is a high biliary obstruction. So painless progressive jaundice with high biliary obstruction, hilar cholangiocarcinoma. If you see CBD dilated till lower end, it is periampullary carcinoma, painless progressive jaundice. If you have pain with jaundice and you see CBD dilated till lower end, it is more likely to be carcinoma head of the pancreas, where an ultrasound may even show a mass in the head of the pancreas. On the other hand, if you see a mass in the gallbladder, then it is gallbladder cancer. But remember that a small mass in the neck of the gallbladder may not be seen, and therefore it may be very difficult to differentiate between hilar cholangiocarcinoma and a small tumor in the neck of the gallbladder, which is causing biliary obstruction. Now, there is a little bit of confusion in some textbooks and some articles about these terms, pancreatic head cancer and periampullary carcinoma. What we tend to follow is that if you see a mass in the head of the pancreas, either on imaging or at surgery, it is pancreatic head cancer, which is ductal adenocarcinoma of the pancreas. On the other hand, periampullary cancer is a group of cancers. It includes lower end cholangiocarcinoma, that means intrapancreatic part of the CBD, a true ampullary carcinoma. Ampulla is the common channel formed by the common bile duct and the pancreatic duct. A papillary carcinoma. Papilla is the nipple-like projection on the medial wall of the second part of duodenum, which you see when you do a side viewing endoscopy. Or it could be a peripapillary duodenal carcinoma, which is in close vicinity of the papilla. Or it could be a small pancreatic head cancer, which is not producing a mass lesion. So these four tumors as a group are known as periampullary carcinoma because they are situated around the ampulla. Some say 1 centimeter, some people say 2 centimeters. So in periampullary carcinoma, especially true ampullary carcinoma and pancreatic head cancer, even the pancreatic duct will be dilated. So you have what is known as a double duct sign. When you have a double duct sign and the two ducts are meeting each other with no mass lesion, it is a periampullary carcinoma. When the two ducts are separated from each other and there is a mass lesion inside which ducts are not seen, it is pancreatic head cancer. I think Dr. Puneet is trying to hint to me that the time is over, so I will stop there. Thank you, Shruti, for presenting the case and to all the panelists. If Dr. Abhay Dalvi is there, maybe he would like to make a comment.
Yes, sir. Thank you. Thank you, Shruti, for a wonderful presentation. Thank you, sir.
Thank you, sir.
There are one or two questions which have remained unanswered, but I think Puneet, since you are trying to hint to me that we should close, I will stop here.
Sir, I request the panelists to answer the questions in the chat box. So even the panelists can answer which are there, the questions which are there in the chat box or in the question answer sessions. So they can do so. And I thank Dr. VK Kapoor sir along with the other examiners for this session. We have a next sessions there on CBD exploration, and Dr. Rahul is there. Do you join? Dr. Rahul? Rahul, are you there?
Good morning, sir.
Dr. Manas Ranjan Sahu is going to be the moderator for this session, and I request Dr. Manas Ranjan Sahu to take over.
Okay, thank you everybody. Am I audible? Is it audible?
Yes, sir, you are very much audible.
I think the next session will be going to be pretty interesting, and we'll be just switching from Valrada now to Common Builder. And could I now request Dr. Rahul to go ahead with his presentation on CBD exploration?
Thank you, sir. Thank you so much. I thank the organizing committee to invite me for this session. So quickly, I will go to the introduction part, followed by the surgical steps. So coming to CBD exploration, the most common indication being the CBD stone. So there are various treatment options which are available in today's scenario for CBD stones, which includes single-stage open cholecystectomy with CBD exploration, or a preoperative ERC clearance followed by laparoscopic cholecystectomy, or a single-stage laparoscopic cholecystectomy with CBD exploration. So coming to the treatment options, I'll discuss one by one the various options which are available and the comparison between two. Comparing the open cholecystectomy with CBD exploration with the preoperative ERCP and open cholecystectomy, there was a meta-analysis which was published in 2013, which included 8 RCPs, and they showed that there was no difference in morbidity, mortality, and hospital stay when comparing the two groups. Where the efficacy of CBD clearance with open surgery and single-stage procedure was 93%. While with ERCP, it was 80%, and usually it required 2 episodes of ERCP, which nowadays has increased from 80% to nearly 85 to 90%. But the validity of this study is questionable in today's era, where it is mostly decided by the patient through counseling, and the laparoscopic CBD exploration has taken way from open CBD exploration. So when we compare preoperative ERCP with CBD clearance and followed by laparoscopic cholecystectomy versus single-stage lap surgery, the comparison shows that the morbidity and mortality are almost comparable. Even the retained stone rate in single-stage surgery is a bit less than preoperative ERCP followed by laparoscopic cholecystectomy, but the difference is not very significant. Yes, there is a difference in the failure of the procedure, where the CBD laparoscopic surgery scores over the preoperative ERCP followed by laparoscopic cholecystectomy. Now, again, there was another comparison, another meta-analysis which also was in favor of single-stage laparoscopic cholecystectomy with CBD exploration for CBD stones in terms of cost and in terms of hospital stay. Now, but there are indications where you would not consider for ERCP, and you will directly counsel a patient for surgery, and they were laid down by the American Society of Gastrointestinal Endoscopy, which includes stones greater than 15 mm. But some gastroenterologists will question that even they can tackle stones more than 15 mm. But for students, I think stones more than 15 mm amounts to laparoscopic or surgical indication for CBD exploration. Other indications include stones associated with biliary stricture, stones associated with hepatolithiasis, that is proximal stones in the proximal duct. The surgical altered gut anatomy in which ERCP is not feasible, like in cases of Roux en Y gastric bypass or of Billrod 2 EJ, in presence of Milby syndrome, and in patients with difficult or inaccessible papilla of Witter. Now, comparing the success rate of the
procedures when it is, there are three options available. Either you do a CBD exploration through the cystic duct or you go for direct CBD exploration. I will come to the details later on. Laparoscopic transcystic duct extraction success rate is around 70 to 95%, while direct CBD exploration it amounts to 90 to 100%. And coming to CBD exploration, what we have to look for before venturing to the surgery? The first and foremost important thing is the patient's condition, that he should be fit enough to undergo a major procedure. Another important thing is the portal hypertension. Presence of BHPO will amount to an open surgery, and that to a very careful surgery. You may not be able to do a surgery straight away. Maybe we will have to plan for a shunt surgery followed by CBD exploration in cases of CBD stone, in presence of BHPO. Other indications which need to be thought are the indications which need conversion usually, and it is a difficult anatomy in acute cholecystitis or Migli syndrome. In patients with situations needing biliary diversion, the surgeon may not be comfortable with laparoscopic biliary anastomosis, then you may have to go for open surgery. And if there are extensive upper abdominal adhesions which amount to an open surgery. Then other things which include a tissue status, if the CBD is too friable, or the anatomy of the cystic duct, its length, its size, and its insertion point, they matter whether you can go for CBD exploration through cystic duct or not. Then the CBD size, of course, and the CBD stone the number, which will be coming in the next slide. So these are the indications for transcystic CBD exploration. If the patient, the subject should be skilled in endoscopy, the stone number should be less than 8, the stone size should be less than 8 mm preferably, and stone location should be distal to the cystic duct. And CBD diameter doesn't matter in this case. While if you are going for laparoscopic CBD exploration straight away, then the surgeon should be skilled in laparoscopic suturing skills, and the CBD diameter should be more than 10 mm. Then after CBD exploration, whether you should put a T-tube or not. So there was a RCT, there was a meta-analysis which suggested that there are few indications left for T-tube nowadays. Recent history of acute pancreatitis, which may amount to a friable CBD or a inflammation in the papilla of the duct. So in those cases, you may consider for placing a T-tube. Now, coming to the various surgical options, we have three options which I already enumerated. So it is a multidisciplinary approach. We have to take help of the gastroenterologist along with the gastrosurgeon or a general surgeon. Then, most important thing is that all the choices should be discussed with the patient, and you should look for the feasibility of the availability of the options around you. Now, coming to the surgery, so most important preoperative imaging is ultrasound, and most of the surgeons or the gastroenterologists do prefer to and subject the patient to MRI before venturing into the procedure. So in MRI, you can see most of the time you will find a filling effect or a signal void in the CBD with proximal dilatation of the ducts. So these signal voids are usually filling defects which suggest CBD stones. There may be worms also, there may be centrolytics also, but that comes. Those images I have not produced yet. Now, coming to preoperative preparation, the most important thing is that you have to optimize the INR in all these jaundice patients if it is deranged. Even if it is not deranged, then surgeons do prefer to inject vitamin K prior to the surgery. Second is preferably rule out or manage cholangitis prior to venturing into surgery. And the patient should be adequately hydrated. He should receive fluids prior to the day of surgery. Check USG should always be done to look for the presence of or they have passed out. And preoperative antibiotic prophylaxis should be given. Usually gram-negative cover is given in the form of ceftriaxone or cefoperazone sulbactam. Then sign-in and time-out is important step for every surgery, and so is it for CBD exploration. Now I'll explain this open CBD exploration first. The surgical steps include a supine position with a slightly head up position. Now there are two incisions which the surgeons prefer, either a right subcostal incision or an upper midline incision. The right subcostal incision goes 2 to 3 centimeters below the costal margin, from the maybe from the midline to the lateral part of the lateral aspect of the anterior axillary line maybe, or the mid, in between the mid and the lateral axillary line. And and another incision which usually a left-handed surgeons prefer is an upper midline incision, or when the subcostal margin is not too wide. Then you go, there should be adequate retraction on both the sides, on the left and right, so that exposure is good. And next is the division of the ligament of teres. Then hepatic flexor mobilization is the next step. And third is cauterization of the duodenum. So cauterization of the duodenum is important in terms of palpating the stones in the lower part of the CBD, as well as if the patient requires a choledochal diagnostic, then you may be able to do it straight away. Third is the left lobe of the liver is retracted, and this is followed by the dissection at the callus. It was very well explained by Dr. D. Sharma in laparoscopic qualification. You have to dissect the callus, you have to delineate the anatomy, and the gallbladder is taken down by the fundus first method. Then we palpate for the stones, and intraoperative CBD assessment is done to the cystic. So we put the scope to the we do a cholangiogram to the cystic duct and look for the presence of the stone. You will see filling defects, and you have to differentiate these filling defects from bubbles, because the bubbles tend to rise, while the filling defects, because of stone, will tend to stay there. You can do a direct choledocoscopy also to look for the stones in the lower part of the in the CBD or in the proximal part of the duct. Now, if we are not doing it through the cystic duct, the cystic duct is too small to allow introduction of the choledocoscope, or the stone is too large to be taken out to the cystic duct, then you do a choledochrotomy. For doing choledochrotomy, actually you have to locate the duct first, CBD first. To localize the CBD, you have to follow the cystic duct till its end. So you have to localize it. Hopefully I am audible. Am I audible there?
You are audible, Dr. Rao. Please go ahead.
Yes, thank you. So you have to first localize the CBD. So to localize the CBD, you have to follow the cystic duct, and then the structure with which it is meeting will be the CBD. Another way is that it is anterior and lateral to the portal vein, and definitely you have to feel for stones and stents to even confirm that. The third most important thing is that you introduce a needle into the CBD and aspirate bile, and that gives the final confirmation that it is CBD. Then you take traction sutures on by CO or Coro PDS or Vicryl, and then you open the CBD in between these traction sutures. Then once you open, either it can be done with a knife or a 40. Usually the surgeons prefer 40 nowadays. And you do around 1 to 1.5 centimeters, and it is just above in the supraduodenal area, and preferably at the level of below the level of the cystic duct joining, if it is joining at the correct place. Then followed by
Dr. Rahul, we are given only 15 minutes time.
Yeah, I'm just finishing, sir. The slide is not moving on. Yeah. So then followed by we'll sample the vial for culture. We'll take out the stem and send the proximal end of the stem for culture. We flush the CBD, and we try to clear the CBD using various methods, like we can milk the stones to the opening. We can take out the stones through saline flush or pressure flushing. And other methods to take out the stones are through Desjardins forceps, the endobasket, or a Fogarty catheter, and all these can be used in tandem or simultaneously to remove the stone. Now, confirmation of success of CBD clearance is done by a cholangiogram or a choledocoscope again, and once it is confirmed, the CBD is clear, we can primarily close the CBD with interrupted sutures using Vicryl or PDS. Now, what other options are available for the CBD closure? Other options include a CDD, that is the choledochal diagnosis, which is usually done when the CBD is more than 2 centimeters and there are proximal stones, or there is a distal picture, or the patient has history of recurrent choledochal ichthysis. Second is placement of T-tube, which I already said that it is done if the CBD is friable. There is history of recurrent pancreatitis and there is inflammation in the papilla because of an impacted stone. In this case, we put a 14-cent T-tube, which is cut on both sides and opened on the back, and then it is placed into the CBD with proximal end a bit short and the distal end bit long, and the closure of the CBD over the T-tube is done from proximal part to the distal part. And the tenets of T-tube placement is that it's taken out from the abdomen at the with the shortest route, and cholangiogram is done on 10 to 14 days, and it can be removed if CBD is clear after 3 weeks. The complications of this procedure include bile leak, which is around 2 to 3% with CBD exploration, presence of bilioma, which is which is similar to the occurrence of bile leak. Hemoperitoneum can occur, which can occur in any surgery, and it is around 1 to 2%, and a retained stone of 5%. Similarly, lap CBD exploration, it is a similar procedure which is nowadays preferred, and this is the actual port position for the laparoscopic CBD exploration. So it is similar to the laparoscopic cholecystectomy, except for another port which is placed in the lateral to the epigastrium for retraction or place or putting in the endoscope. Then it is similar. These steps are similar in transcystic approach also and the transcoloptical approach also. So I will not go into the details of this. One more important thing that you may need mechanical effectively in terms of Orlean lasers or graspers for transcoloptical CBD exploration in patients who are undergoing laparoscopic surgery. Thank you.
Thank you, Dr. Rahul, for that wonderful presentation. So, just to sum up things, when a patient presents with CBD stones, the first thing that we need to do is to diagnose that he is suffering from CBD stone. And for that, ultrasonography is surely, though it's the basic investigation that we do and come to know, but there are definite restrictions where ultrasonography doesn't play a good role to diagnose distal CBD stones. That's just because duodenal gas acts as an acoustic barrier. So ultrasonography is, trans-abdominal ultrasonography is not an ideal investigation, and those kind of scenario, it is better to take up a MRCP or an endo-ultrasonography to diagnose that there are distal CBD stones. So once we diagnose that there are CBD stones, then the next thing is how do we proceed and approach these patients. There is a cafeteria choice. We have got open surgery, you have got endoscopic approach, you have got laparoscopic approach. But I'll just sum up that the entire thing sums up into 3 P's. The person dealing the patient, the place where it is being done, and the pocket of the patient, the 3 P's. That's probably decide most of the things. But still, most of the scenarios and most of the time when you have a CBD stone, which is CBD is not dilated, single or small stones, the ideal preference will be an endoscopic approach. If the CBD is dilated more than 10 millimeters, you have larger stones, the best approach is to go for a laparoscopic CBD exploration. Okay, endoscopic approach can also deal with larger stones with the presence of mechanical lithotripsy, but more so than not, that sometimes creates a difficulty even for the endoscopist. So it is on an average taken that it is ideal that if you have a non-dilated system, endoscopic approach is better. If you have a dilated system, laparoscopic one-step approach is always better. Then it comes whether you are going for one-step approach or two-step approach. You go for a pre-operative ERCP, clearance of stones from the CBD, following 48 to 72 hours with a laparoscopic cholecystectomy, or you plan to do a single-step approach with the laparoscopic CBD exploration and laparoscopic cholecystectomy on the same go. And vis-a-vis, you have another technique which is called as the rendezvous technique, where you can go for a ERCP and laparoscopic cholecystectomy in the same go. So, with all this spectrum, I mean, we have to decide that which one will be ideal for an existing patient and for an existing condition. Then as regards the T-tube and no T-tube, yes, the world is for no T-tube now. It's much better to go for an antegrade stenting. If at all you consider putting a stent, But if you have a ERCP backup, nothing to worry at all. You can just simply go for a primary closure, do a laparoscopic CVD exploration, do a primary closure and just come out. Nothing is going to befallen on that. But if you are choosing a transcystic and choledochal approach, yes, quite often than not, we always prefer a choledochal approach. Even though we describe that transcystic approach is good, it is better in non-dilated duct, it is better in stones situated distal to the cystic duct CVD junction. So there are many caveats in that, which I think we can much better do it in a trans-choledochal approach. So more often than not, in the minimal invasive era, CVD stones are mostly managed either by ERCP or by laparoscopy. But open surgery is not done out of the paper book. So you can always have at the backup. Then as regards doing a bilioenteric diversion, if you have got multiple stones, you have got intrahepatolithiasis, hepatolithiasis, you have got stones in the ISD. So naturally, those are the situations where it is always better to go add on a bilioenteric diversion, and that will absolutely take care of the patient in the future aspect as well. And as regards following a bilioenteric diversion regarding SAM syndrome, that's probably not a much of a problem. If you have a ERCP, just a papulotomy will solve and shut out your issues. So anything more you want to add on to this spectrum that we have discussed, Dr. Rahul?
I think it was
Because there is a question there from the postgraduate.
Yeah.
Rahul, where to take out the tissue? Means where to put a tissue there, the CBD, that the upper part of the incision, or mid part of the incision, or lower part of the incision, and which is to be preferred?
Sir, I showed on the diagram that we put the T-tube in the lower part of the incision and goes from the upper to proximal to distal. So that when you take out the T-tube, the whole of the traction is on the distal part of the CBD, which is totally intact. So because these sutures will hold the CBD, but they will not hold the traction of the when you take out the T-tube. So funda is to take out the T-tube from the lower part of the incision.
I request Dr. Manas to see any questions there in the chat box. You can ask and moderate.
I think there are none.
There are none.
Somebody has just kindly summarized that. Probably I have summarized it all.
I think
no needs to be managed.
Questions are in Q&A session also.
Is it? No, there are questions on there also.
I think we are running short of time also. So I think that I thanks Rahul for a wonderful presentation, and also thanks Dr. Manas Ranjan Sahu for moderating the session. So we move on to the next case presentation, that is on the epigastric lump. Can I see Dr. Akansha? Akansha is there? Oh, you are there. So you keep on sharing your slides so that, and I request the examiners to join. I think most of them they have joined. Dr. Manas Ranjan Sahu is already there. Dr. Makanlal Shah is there. Dr. Geet Yadav, Dr. Sumesh Chakrabarti, and Dr. Manoj Atli. So I request all moderators, which means examiners, to join. I think most of them they have joined. So we go ahead with the presentations.
Good morning, Dr. Puneet.
Good morning. Good morning. Good morning. I request Akansha to go ahead with the presentation.
Sir, am I audible?
Yeah, you are very much audible. Your slide is also with me.
Good morning, respected teachers. Myself Dr. Akansha Sawan, and I'm presenting the case over epigastric lump. There is a 52-year male from Rajipur, Unnao, farmer by occupation.
Yeah, you can go ahead with the presentation. Yes. There's some issues?
Okay, sir. There was a 62-year male from Rajipur, Unnao, farmer by occupation, belonging to lower middle socioeconomic class, presented to the surgery OPD with chief complaints of feeling of sensation of fullness following meals for 2 months, nauseous vomiting following meals for 2 months, and decreased appetite for last 6 weeks. History of presenting illness. Patient was apparently asymptomatic. 2 months back, when he started experiencing sensation of fullness after meal, which was incident in onset more towards the end of the day and associated with the abdominal discomfort. This was associated with complaint of rolling mass in the abdomen, moving from left to right. It was not associated with pain. Pain also, patient also complains of vomiting after 4 hours of ingestion of meal, which was initially 1 to 2 episodes per day. Later, frequency increased up to 3 to 4 episodes per day. It was projectile, copious in amount, non-bilious in nature, foul-smelling, containing partially digested food particles. It was more common after taking solids than liquids. For last 6 weeks, patient also had significant decrease in appetite with early satiety. There was no history of fever, hematomasis, heartburn, black-colored stool, altered bowel habits, yellowish discoloration of eyes and urine, clay-colored stool, breathlessness, cough or chest pain, significant weight loss, and trauma. There was no past history of similar complaint in past. There was no history of accidental ingestion of any corrosive substance. There was no history of diabetes mellitus, hypertension, tuberculosis, asthma, or any other chronic illness. Treatment history, no history of any surgical intervention in the past. Medical history, no history of intake of any medication for prolonged duration. Family history, there is no history of any cancer-related death in family or first-degree relative. Personal history, he consumes a vegetarian diet, BD smoker, he smoked 8 to 10 per day, and tobacco chewer for last 20 years. Not alcoholic, normal sleep habit, appetite is reduced, bowel and bladder habits normal. Summary of history, 62 a male with feeling of sensation of fullness and ball rolling movements from left to right side of abdomen and vomiting after intake of meal for last 2 months, which was 3 to 4 hours after meal, which was gradually progressive in frequency, containing partially digested food particles and decreased appetite for the last 6 weeks with early satiety.
I think I request Dr. Manas Ranjan Sahu to ask anything there in the history which is left out. Hello.
I think Dr. Akanksha has more or less, you are presenting a 62-year-old male who is sensation of fullness, nausea, and decreased appetite. Was the vomiting for last 2 months?
Yes, sir.
It was a projectile vomiting or regurgitant vomiting?
It was a projectile vomiting.
Okay. And it was foul smelling, containing partially digested food. That's fine. And regarding the history of any pain, periodicity, anything is there?
No, sir. It was only associated with abdominal discomfort. There was no pain association or there was no periodicity of pain.
Okay. Was there any history of melena?
No, sir.
No history of melena. Okay. Fine.
Any other examiner want to add on or comment there?
You have presented everything within 2 months, but I presume that it's a virtual case. The patient is not in front of me, but most of the time you will find that this sensation of fullness started earlier, and then as the time progresses, patient comes up with vomiting. But I find everything is 2 months, and you say patient is vomiting for last 2 months with 3 to 4 episodes, and he has also lost of appetite. So I'm presuming how he has lost weight. So there should be some.
There was not significant weight loss history.
That you should try to find out in your weight loss. And you have maybe just a column of negative history. But I would prefer to go through the other GI symptoms and the other systemic symptoms in a chronological order. So that is an observation from a history point of view.
Akanksha,
Dr. Manoj Adle, sir.
Akanksha, can you tell me, was there any past history suggestive of peptic ulcer disease in this patient?
No, sir, there was no past history suggestive of peptic ulcer.
Any history suggestive of some biliary colics or acute cholecystitis in the past?
No, sir.
No. And what was the timing of vomiting? After how much time after meals he used to have this vomiting?
Sir, around 3 to 4 hours after ingestion of meal.
So,
Dr. Akansha, Dr. Puneet, can I interrupt?
yeah. JD, you can go ahead.
Dr. Akansha, is there any importance of, good morning. Is there any importance? You didn't ask for any night sweats. Is the history of night sweats important in this patient? And another history, tetany. Did you ask for history of tetany in this patient?
I didn't ask for technique, but technique can be there.
Yes. How can we there? What is the explanation?
Sir, due to as patient is obtaining or vomiting from last 2 months, so there will be sir, electrolyte disbalance and loss of hydrogen ion in vomiting. So there's there will be calcium ionized form less in patient. So it can lead to tetany in the patient.
So there is a hypochloremic, hypokalemic, that is the cause behind the lowering of ionized calcium level in the blood. That can be the presentation of the patient in the gastric outlet obstruction. If they are having the multiple sources of vomiting. And the night sweats is important for purpose. Maybe nowadays we can say it can be one of the differential diagnosis of gastric outlet obstruction as a lymphoma. Because the non-Hodgkin's lymphoma is also a site in the stomach. So you I agree with your recommendation that there is no fever, no loss of weight, but night sweat they also have importance.
Yeah. Can you?
Yeah. I have one question, Dr. Akanksha.
Yes,
You told in the negative history regarding yellowish discoloration of eyes and clay colored stool. How do you correlate with all this history with these two negative histories?
Sir, as patient, from my history, I'm providing diagnosis to the case of gastric. So, sir, I'm ruling out jaundice history in this patient because this could be the case of the gastric outlet obstruction, and that can be due to the in case of malignancy to the liver secondary, or there could be the obstructive jaundice that can lead to your gastric outlet obstruction.
No, actually, sometimes this history is important because sometimes in cases of malignancy, there is duodenal obstruction as well as CBD obstruction. Okay. So this history is important. I think everything is covered.
Yeah, I think we'll go ahead. And the only thing which is a miss, Akansha, in my opinion, is like treatment history. You have not mentioned about the present treatment because the patient is vomiting for last 2 months. It is important to mention any form of treatment which patient has received in last 2 months. So, okay, it is important because by this time the patient might have developed electrolyte imbalance and have other problems. So patient was admitted somewhere or been investigated somewhere, that is to be mentioned there in the treatment history. That is important, and the history of allergy is to be mentioned in each and every case. So although we have covered all the expected questions which are to be asked there in the examination. History of melena, you have said there is no history of melena or the peptic ulcer disease as such. We should go ahead with the examination now.
Okay. General physical examination. The patient was examined.
You can go ahead.
Yes, sir. Patient was examined in a well-lit room after obtaining proper informed consent. He was conscious, cooperative, and well-oriented according to time, place, and person. ECOG performance status was 2. BMI of the patient was 20.6 kg per meter square. He was of average weight, lying comfortably on bed. Hydration, he was dehydrated. Vital temperature was 19.6 degrees Fahrenheit in maxilla. Pulse was 80 beats per minute, regular rhythm and normal volume in right radial artery. BP was 130/70 mmHg in right arm supine position. Respiratory was 16 per minute. Failure present, no instrument, cyanosis, clubbing, generalized lymphadenopathy, fetal edema, was there. There was no fullness in supraclavicular fossa bilaterally. Abdominal examination. On inspection, fullness seen in epigastrium extending to umbilical region and left hypochondrium with central and inverted umbilical. There was visible flesh charges seen in epigastric region from left upper abdomen directed downwards and towards to the umbilical region. There was all quadrants moving symmetrically with respiration. Hernia sites are intact. No scars, sinuses, engorged vein and umbilical nodules were present. No visible pulsations and no visible renal angle fullness. On palpation, finding of inspection confirmed on palpation. On superficial palpation, no local rise of temperature, no superficial tenderness was there. On deep palpation, abdomen is soft, non-tender, a single mass of size 8 cm to 5 cm. Palpable in the epigastric region from 6 cm below the exit sternum to 5 cm above the umbilicus, from left mid-clavicular line to 2 cm medial to the right mid-clavicular line. Skin over the swelling is normal, surface is smooth, form consistency, margins are ill-defined, single simulation possible, upper border palpable, able to insinuate fingers between the mass and subcostal margin, mobile in horizontal and vertical direction, moves with the respiration, no pulsation over mass. Mass becomes less prominent on a straight legging raised chest. It was in the abdomen. Liver, spleen, kidneys could not be palpable. Hernial sites intact. External genitalia within normal limits. It was the patient. Perfection, no evidence of leak fluid. Tympanic note over whole abdomen. Impaired resonant note over lump. Liver dullness present up to the right 6 intercostal space. Liver span 12 cm. Auscultation, normal bowel sound heard per minute. Kitchen flesh was present. On ausculto percussion, a distended stomach is present with majority of greater curvature lying 2 cm below the umbilical. On digital rectal examination, perianal area normal, normal anal tone with fecal stains. There was no blood stains, no pelvic deposits, grade 1 prostate enlargement was there. Supraclavicular fossa normal, examination of back and might within normal limits. Other systemic examination, previous examination, S1 and S2 normally heard, no murmur heard. On respiratory examination, normal respiratory sounds were there, air entry was bilaterally equal. Skin examination, no neurological defect. Summary of case, meal, of fullness and bowel-drooling movement from left to right, vomiting after intake of meal for last 2 months after 3 to 4 hours after meal, which was gradually progressive in frequency, containing partially digested food particles and decreased appetite for last 6 weeks with IV satiety. On examination, fullness noted in epigastric region, a single papillaceous mass present which is mobile, no tender, with impaired resonance, moving with respiration, upper border palpable with single inclination possible, less prominence on leg region, impaired sufficient stress present, and distended stomach with greater curvature lying below umbilical. Visible peristalsis from left upper abdomen directly downwards and towards to the umbilical region.
Akansha, just I want to give few comments and then I will ask the examiners. First thing is, patient is a 62-year male, so you must have mentioned about the GBP and the beaded edema in the patient. It is an important component of the examination. The next is what you have said is the abdomen is moving symmetrically with the respirations. See what happens, like although they move symmetrically, but it's not like they all quadrants they move proportionately with respiration. Upper quadrants they move much more with respiration in comparison to the lower abdomen. And you have said the kidney is not palpable. So do you expect the kidney is palpable in a normal individual?
No, sir, generally it is not.
So you don't have to comment about the kidney because unless in a very little patients you may palpate the right lower border of the right kidney as such, but normally the kidneys are non-palpable. So unless until it is a large, it never be a palpable. So never say that the kidney is not palpable. Okay. And I can go in with the examiners. Dr. Manas, you want to go in with the comments?
I think Dr. Akansha, you presented very nicely. I just wanted to know, you gave emphasis on both supraclavicular foci. Is there any reason that you think could it be suppose a carcinoma stomach? Do you expect both the supraclavicular foci to be involved?
No, sir, but this is a part of general examination, so I just commented over it. Basically, I wanted to look for the left supraclavicular lymph node.
Okay, left supraclavicular lymph node. Where actually exactly do you examine the left supraclavicular lymph nodes?
Between two heads of the sternocleidomastoid.
That's good. So you need to examine between the two heads of the sternocleidomastoid. Why is it so? Why you examine that area only?
Sir, there's a thoracic duct drainage. So that's why.
Where exactly the thoracic duct drains?
Lateral to the sternal notch. So
thoracic duct drains to the left jugular subclavian angle, and that's exactly situated between these two heads of the sternocleidomastoid. That's why you need to examine the varicose veins there. My second point is, you told that you palpated a mass that was intra-abdominal because the Carnet's test that you did for the leg raising test was negative. Am I right? Yeah, because the mass was less palpable on leg raising. Could you just clarify when actually you decide in an intra-abdominal lump or a mass to be ruled out whether it is parietal or intra-abdominal? When it is centrally located, we perform either a head raising or a leg raising test clinically. So when actually you prefer a head raising or a leg raising test to be done, or is it just for every case you do the leg raising test only? Is my question clear to you, Dr. Ashan?
No, sir. I think
you didn't get my question. My question is,
Whenever a mass is palpable in the central part of the abdomen from
xiphoid process till pubic symphysis, if a mass, as in this case, it is palpable in the epigastric region, but you did a leg raising test, how actually you decide which case palpable in the central quadrant of the abdomen, in the central region, when to do a head raising test and when to do a leg raising test?
Sure.
Okay. So if you are palpating a mass in the upper abdomen, the ideal test is to do a head raising test. If the central part of the abdomen, lower part you palpate a mass, better is to do a leg raising test. Am I clear on that? And if beyond this, if you are palpating a mass in the lateral flanks of the abdomen, then probably both these tests will not going to give you any kind of a good impression whether it is intra-abdominal or parietal. The better test at that situation will be a Valsalva manning. If you do a Valsalva, the lateral flank muscles when they get short, the mass is less palpable, surely it is intra-abdominal.
Am I right? Am I clear?
Okay, sir.
Yeah, please.
Yeah. In procedural level, you have described that there is visible peristaltic wave. I would prefer to hear that these are visible gastric peristaltic waves. Okay, so you have a description. And secondly, you have said you have palpated a lump and described the dimension of the lump. Sometimes, if you have a gastric outlet obstruction, you can feel it. You can palpate the distended stomach under your finger because two things are different. If you have a lump which is coming up under your finger disappearing, it is a distended stomach. If you have a fixed lump which you have described, is likely to be the lump from which organ usually it is in this patient. You say there is a lump. What likely the organ of origin of this lump?
Stomach.
Mentioned that's why it is a solid mass. Apart from this, you can palpate the distended stomach sometimes. Okay? Otherwise, you describe this infection and palpitation.
I think we
Yeah, just a quick question. You mentioned about suction splash. Can you tell us how do you elicit this sign?
There's some audio disturbance. Sir, hello?
No, it is clear. You can go ahead.
Can you tell us how do you elicit this sign of suction splash?
Sir, suction splash.
Yeah, suggestion.
Hello.
Yes,
For suggesting a splash, first patient needs to be in per for about 3 to 4 hours, and then we place the bell of the stethoscope in the mid-epigastrium, and with the both the thumbs we hold the diaphragm of the stethoscope, and our both hand fingers cover the subcostal margin of the patient, and then we try to sedate the patient. Then we can hear the just stretch sound over there if gastric outlet of
You mentioned about something impaired, or it is not there.
Sir, I didn't mention impaired persistence.
It is there.
It's okay. I think you can go into the Akansha can go into the differential diagnosis in this patient. What you feel like? What are the differential diagnosis?
Sir, my provisional working diagnosis is gastric outlet obstruction due to the carcinoma stomach, and differential diagnosis would to the pancreas.
It's okay. I request Dr. Giri Yadav to go into any comments or questions.
So first differential diagnosis is gastric outlet obstruction. Dr. Akansha?
Yes, sir.
Yes. So after that, the cause is carcinoma of stomach. What are the points in favor of the carcinoma of stomach? And what are the risk factors of carcinoma of stomach which you get in the history of this patient?
Sir, from the studying from the history, particular patient is 62 and me, as clear stomach is most commonly present in the 6th period of the life, and he is a male patient. Male predominantly is there in the clear stomach. Second thing, sir, there's a 2 months history. So patients are 2 months history is a very short duration history, so it is towards the malignancy. Then on the basis of this history, I am making the diagnosis of the gastric outlet obstruction. On the basis of negative history, I am ruling out the reason for the gastric outlet obstruction that could also be there. Any other reasons are there? Sir, or on the examination basis, sir.
Akansha, before we proceed, I think you have explained exactly what the reason why you have kept a diagnosis of carcinoma of the stomach as a first diagnosis. I couldn't get it why you have kept a pseudopancreatic cyst as one of the differential diagnoses, because none of the features which suggest that the patient have a pseudopancreatic cyst. So do the patient have a history of acute pancreatitis which has led to a lump on the first thing? And the second thing is, like, you feel like this lump is a pseudopancreatic cyst, because can we see a mobility in the patient with a pseudopancreatic cyst? You have said it is moving in both horizontal and vertical directions, and it is also moving with respiration. So you have these findings which suggest that the patient have a pseudopancreatic cyst. So it never comes in a differential diagnosis. I don't know why you have kept a pseudopancreatic cyst. Just explain exactly what are the reasons why you have kept a pseudopancreatic cyst as one of the differential diagnoses.
It's due to the age of the patient, location of the mass.
Yeah?
Age and location doesn't suggest that the patient have pseudopancreatic cyst. I think
क्लास आने वाली है आपकी
anyhow, so maybe we can go with any other question.
Yeah.
कपड़े पहन
We
लिए
never come to another. So you can go ahead.
So, continuing with that, pseudopancreatic cyst cannot be there in the differential diagnosis in this type of findings, the history and examination. The only thing which can be discussed whether it is a benign or a malignant. Okay. So, Dr. Akansha, you said it is secondary to the malignant obstruction. So why do you say, what are the pathognomic signs which are saying that this is the malignant obstruction of the pylorus?
Sir, one second. Second is, sir, short duration of the history, and on the finding of examination, the lump, lump examination, sir.
Actually, what happens in malignant obstruction, gastric outlet obstruction, there is anemia, asthenia, and anorexia.
Yes, sir. So there is patient with presenting with anemia, sir.
So with all these findings, you can
I'll be coming to Dr. Mathilan, sir. I think Dr. Manoj Jetli wants to say something. And then Dr. Manoj Jetli, sir, can
It
you
should
go
be
into
very
the
clear
questions
in
and
your mind how does a mass or a lump due to pseudomacratic cyst behaves. It does not behave like this as this particular lump in this particular patient. So plus this patient does not have any past history suggestive of any it would be better if you rather not keep pseudocyst as one of the differential diagnosis. Only as Dr. Sumit has rightly pointed out, it is gastric outlet obstruction, no doubt, but let us go ahead and talk about a malignant obstruction or a benign obstruction, and then proceed with our further investigations. Yeah.
Yeah. Akanksha, can you tell us some more relevant differential diagnosis? Yes. Apart from carcinoma stomach, can you think of any other pathology which can produce a lump and outer obstruction?
Especially head of pancreas, periampulary carcinoma, we look for the any lightning condition.
That will come lower down. Anything into the stomach itself?
Suggest tumors and lymphoma.
You should count with that. The next possible diagnosis may be a large lump, palpable outer obstruction, may be a GIST. HME form of the stomach to talk of more relevant differential diagnosis rather than saying stuff because a cerebral carcinoma with such lump is not very usual. In carcinoma, the body of the pancreas will diagnose. Okay,
so, thank you, sir. So we all agree that in this patient, we want to have a diagnosis with the carcinoma stomach as the first diagnosis, and of course the lymphoma may always consider the other differential diagnosis. But they never keep clear-head pancreas as one of the differential diagnoses of periampulary cancer. It never comes into the differential one. It may be a rare entity, it may be anything which is leading to an obstruction of a duodenum as such, but it never be a differential diagnosis in this patient. So can we go ahead with the investigation part, how we are going to investigate this patient, Dr. Manoj, how we can go ahead with that?
Sir, for the investigation, I would like to go for the CBC, LFT, liver function test, kidney function test, and serum electrolyte.
I want to interrupt you here, and why it is so because as soon as you see a patient in the OPD, the first investigation what we do is the diagnostic investigation. We never go ahead with the routine investigation as such. Of course, if the patient present there in the emergency setting, then you can say we can investigate the patient in a different way. But as such, any patient present to us, we always go ahead with the diagnostic investigation first.
Yeah.
As for the diagnostic procedure, I will go for the GI endoscopy of the patient.
Dr. Manav, this is how you can take over and.
Yes, Akansha, when you see a patient with this kind of presentation who is having vomiting for 2 months, you are palpating a mobile lump in the epigastrium, and your diagnosis is literally coning down onto carcinoma stomach or a malignant gastric outlet obstruction of some kind, then probably your most rational first investigation of choice when you advise is to go for a OGD. Am I right? Am I right?
Yes, sir, can you go into the full form rather than doing more of the...
Okay. So upper GI endoscopy that you have already told. Okay, so when you are doing the upper GI endoscopy, Akansha, what actually you are expecting to see or what are you expecting to do? Or is it feasible that right from the OPD, you can go and get an upper GI endoscopy done in a patient who has got gastric outlet obstruction? Okay, are you online? I think we have
Akansha, this is some issue. Even you can say you can unshare your screen and then go ahead with your presentation because your audio is. Hello, Akansha, yeah, you can unshare your screen and go ahead with the audio, yeah. Yeah, you can answer the questions, yeah. Akansha, you may unshare your
You
screen and
stop
go
sharing
into
your
the
screen.
discussion part.
Akansha,
Yes,
you stop
sir,
sharing.
yes, sir, I will.
Yeah, fine. So the question was, if you are getting a patient with gastric outlet obstruction in your outpatient department, do you straight away can go ahead and do an upper GI endoscopy for this patient?
So first we have to prepare the patient for the upper GI endoscopy.
Exactly. So how you do prepare and when you do this upper GI?
On in blood investigation, two mandatory requirements are viral markers and the cognitive profile of the patient. And second thing, we have to do the gastric lavage of the patient, and we have to keep him or her on liquid diet for say milparolol for a time.
Okay. So if you do an upper GI endoscopy, what you are expecting to see and what you are expecting to do?
Sir, on upper GI endoscopy, we look for the mucosa of the stomach. If there is any content, what kind of content it is, if there is any juice,
Please hold on. Akansha. Once you get your endoscope into the stomach, the first thing that you should note that non-distensibility of the stomach. The stomach in a malignant obstruction usually is not distensible, that distensible, as you find it in a benign outlet obstruction. Am I right? Am I right, Akansha?
Yes, sir. I think you can go with your comments, sir, because we are
Yeah,
running
please.
out of time. You can go
I
ahead.
think there are issues coming up. Okay, fine. So once you have a non-distensible stomach, then you go ahead and see the growth that is there either in the distal part of the stomach or the antrum or the outlet is obstructed. You might find a pencil passage there. Then you try taking a biopsy. Akansha, I think you are online now.
Yes, sir.
You want to go ahead for that? Yes, please.
Akansha, there is a question from where you are going to prefer a biopsy patient. Akansha,
Yes,
there is
sir.
a question that where you prefer to have a biopsy patients.
Sir, from the margin.
From the margin. Why from the margin? Why not from the center of the mass? Why not from the center of the growth? You are more likely to get malignant tissues there.
No, I think you can go
Sir,
with
we
that.
have to take not only one sample. We would like to take 6 to 8 samples from all the circumstances of the growth. So that's why.
What you get there in the center, are you going to get a malignant tissue or you are going to get a necrotic tissue there?
The necrotic tissue will be there in the center
So when you have got necrotic tissue, you have got slough there, so you are least likely to get any evidence of malignancy there. So it is always better to take from the edge. And you might go for a burrowing biopsy as well, because quite sometime it might so happen. Your biopsy may come out as no evidence of malignancy as well, even if you see the growth in your eyes. Okay, so the next investigation you want to plan is after this.
If there's the growth and we are performing upper GI endoscopy and there's possibility of ultrasound, endoscopic ultrasound is available, then I would like to perform endoscopic ultrasound there.
Okay. How is going to happen? I mean, it will help you. This is a palpable growth. It is an advanced gastric cancer if it is so. How is it going to help you?
Akansha, do you feel like it is going to alter your management because what you are going to get there on endoscopic ultrasound is for the early gastric cancers to detect, to know the depth of the lesion. So already the lump which is palpable, what you are going to achieve by doing the US in these patients. The endoscopic ultrasound is advisable or indicated in the patients where they have a early gastric cancers, even T2 lesions where you want to have a depth of the lesion at the same time you want to assess the lymph nodes which are there adjacent to the stomach which is there. So those things can be be detected there on US rather than doing the US in a patient where the lump is palpable. The better I can say answer is to have a CT in these patients rather than having a US in these patients. So I think Dr. Manas, if you can go ahead with the Dr. Makanlal Shah, you can go ahead with the CT report. Few things I want to add it. What is important in these patients? You must know what is the proximal and the distal extent of the growth, because this is to be mentioned there on endoscopy, and any other lesion if it is present there or detected there on endoscopy, that is to be mentioned. And if in the cases with the lanitis plastica where there the mucosa appears closely thickened, you have to take a deeper biopsy or a jumbo biopsy, what we call it as, to have a deeper biopsy to have a positive report for the malignancy. I think Dr. Makanlal Shah sir, you can take away with the CT scan.
Okay. Actually, Akanka, we prefer to listen from the candidate that when you ask for investigation, the proper way of answering is, I like to do investigation to confirm my diagnosis, I like to do investigation to stage the disease, and some investigation to assess its fitness for anesthesia and surgery. So this is a broad outline we prefer to listen from the candidate. So the first part you are talking of, there is no harm in asking for a ultrasonography, which is the basic investigation and extension of a clinical examination. Once you have a lump in the abdomen, if you do ultrasonography, you can have some idea about the lump. But sometimes difficult to pick up a intrinsic gastric lump. But once the lump is palpable, you insinuate the liver. If there is large lymph nodes, you can pick up the lymph nodes. So ultrasound is part of extension clinical examination. No examiner will object why you ask for ultrasound. Ultrasound is part of clinical examination. Next is upper endoscopy discussed. And you ask for CT scan. What are the things you are trying to look at CT scan? How CT scan is important in evaluation of patient with carcinoma stomach? Just give me salient points.
Staging of the tumor, liver metastasis, nodal staging, sir.
What else? Nodal setup. What else can be picked up in CT scan? Good for CT scan. In advanced disease, this patient has got very advanced disease, large lump. Can you pick up large momentum nodules? Can you pick up a pelvic deposit?
Yes, sir.
So, yes. So distant metastasis can be picked up. And how you assess the tumor in the stomach based on the CT scan? Can CT scan help you in staging the tumor?
Yes, sir.
I think I request the other participant to or the panelists to mute themselves. We are getting a lot of disturbances. Akansha, you can go ahead and answer.
Hello? Yes, sir.
इसके मैं इसकी हम
no primary tumor category zero. There is no primary tumor. T1 would be T1A and T1 in this. So there is a
Sorry to interrupt you. What Dr. Makanlal Shah is asking, what you are able to see there on CT scan?
क्या करना है
In relation to M. So what you are going to see there was
invasion of the throat in the layers of the stomach. And in N stage, number of nodes we will go for, and in M is distance metastasis or no metastasis.
What do you think in this patient? When the lump is palpable, what do you think likely is the T stage in this patient?
Sir, Firoza must be involved if patient I am able to palpate the lump.
So it is likely to be either a T3 or T4 tumor.
Yes, sir.
Okay, fine. So assume we are giving a scenario in this patient that this patient does not have a liver metastasis. There is multiple nodes around the perigastric area, and the lump is extending up to the serosa. What should be your next approach?
Perigastric nodes and segmenting what you said, sir?
Perigastric nodes are seen enlarged in the CT scan. What should be your plan for this?
I will report
There is any outer obstruction, and these are the findings. I want to say that these are locally advanced disease. I am today
इधर को
what
खोलो
your
हो
plan?
जाएगा इधर को नहीं
I think, sir, we have
दोबारा बनाना
completed our task. So I want to summarize you what we want to say,
छोड़ो
and then we
पढ़
can
रहे
have a
हैं
comment them the other exam because
बाद में कर दूंगा
I
क्लास
must
करो
never
so
class
Dr. Mahalal sir, you want to say something about
So, no, once you have it very advanced disease, our aim is now
इसे इतना कर सकते हैं रसोई में रख सकते हैं
so here the patient was candidate for neoadjuvant chemotherapy, but he is having a constant TB. So you can either
तो
try
आवाज
for
तो कम रिकॉर्ड
scheduling or you can
लैपटॉप की
go
आवाज
for
से रिकॉर्ड
scheduling
करना है
and then send the patient
आवाज
for
लैपटॉप का
neoadjuvant
स्क्रीन रिकॉर्ड कर रहा
chemotherapy
हूँ
review, and if the mass regresses, we can go for a palliative resection.
हाँ तो उसमें
So that is the plan for a patient having locally advanced cancer.
Dr. Manoj Atlee sir, you want to give a comment?
I think just nicely presented. Akanksha, you should also know if you have decided to operate this patient, how do you prepare this patient for surgery?
Sir, I think we are running out of time. We have completed our time. So can you summarize in the last minute? I request Dr. Manoj, please
Hello?
Can I request? Yeah, you can put. Akansha, I think I request Dr. Manoj Atlee to just summarize and sum up so that we can end our session here. Of course, he is not available as such. Dr. Manoj Atlee, are you there?
Yeah. Can you hear me? Yeah. The only thing you should be careful about was your differential diagnosis. You should consider a gastric outlet obstruction with malignant etiology as well as benign etiology. And as far as investigations are concerned, I would say sir has rightly pointed out, you should have said first thing I would do is an ultrasound abdomen. That can tell you a lot of things. And it is just an extension of the clinical examination. And this, yes, CT scan, contrast and CT will help you to stage the disease and decide whether this is operable or a non-operable disease. If you want palliation, then obviously you have endoscopic stenting available with you, or maybe at times not available, then you can go ahead with surgical bypass gastrojejunostomy. And as sir has rightly pointed out, nowadays there is a lot of importance given to systemic neoadjuvant chemotherapy in such cases. So I would once again say nicely presented. Thank you, Dr. Puneet.
Akansha, just to sum up already.
Puneet, you are not audible.
Just to summarize here, like what you see there on CT scan, also I think can summarize with Dr. Manoj Atlee and also give a summary that what we see there on CT scan is the T and M.
What is important is T is basically the layer of the stomach which is involved. M is
not the number which is important, what is the size of the nodes which are involved there to the tumor. At the same time, we want to see whether they are the reciprocal nodes or the non-reciprocal nodes or the conglomerated nodes. The conglomerated nodes are the indications for using a radiotherapy in these patients. So it is important to mention exactly what are the different nodes which are involved and are they conglomerated or they are individually, what is the size, are they reciprocal or non-reciprocal, depending upon that. And then the metastasis, which is not only the
तारक मेहता
which is important at the same time as the ganglion metastasis, mental metastasis, pelvic deposits. It is important in these patients that the ascites you must see there on CT scan because the management depends upon what is the stage of the tumor and then we can proceed further. I think we can end up our session here. I thank all the examiners and I can go into the next session on delivery fistula. Thank you, sir. Thanks all for joining here, Dr. Manas, Dr. Makalal Shah, Dr. GT, Dr. Sumit, and Dr. Manoj. So, thank you very much, sir. We can go into the next ward round that is on delivery fistula and Dr. Veda is going to present from our department.
Dr. Sanjay Gupta, he has joined.
Yes, I am here. Good afternoon.
Good afternoon, sir. And I request you to take over and we have Other examiners along with you, Dr. Tapan Gopal is here, Dr. K. Bansal, Dr. Mahalal Shah, and Dr. Gyan. So I request all examiners to join him, and Dr. Sanjay, you can go ahead with the moderation. Veda, are you there?
Yes, sir.
Yeah, Dr. Sanjay.
Okay, welcome to the examiners. Dr. Veda, you can start sharing the screen.
Yes. Good morning, everyone. I'll be presenting a case of biliary fistula. I'm myself Dr. Veda from IMS BHU. My patient, a 42-year lady, housewife, resident of Jaunpur, UP, came to CPD emergency with complaints of abdominal distension and right upper abdominal pain for past 3 years. She underwent open cholecystectomy for chronic alveolar cholecystitis on 23rd of January in Jaunpur. On POD1, she was stable and she was allowed OT. The drain was placed and the drain output was 100 ml. And on POD2, the drain output was 50 ml zero sanguinus. And on POD3, the drain was removed and the patient was discharged under satisfactory conditions.
Dr. Veda,
Yes, sir.
can you just go back to the previous slide?
Yes.
So I would request the examiners if they would at this stage ask any questions from Dr. Veda based on whatever she has shared so far, any questions, so that we proceed with the case in the real life scenario.
How do you feel? Do you feel that this is a normal progression of a post-op patient calling open question, or there is something wrong?
The patient is having normal post-operative course till date. Drain output was a bit on higher side, but otherwise she is having normal post-operative course.
Yes,
She is tolerating orally on the POD1 and she does not have any complaints of significant pain or discomfort.
You're right. So
Up to this, it appears that patient is having a normal road to recovery.
Yes.
Up to this point,
we are satisfied. Yes.
So any other examiners, anyone else would like to ask something at this point?
Yes, sir. Dr. Veda, I just have one question. Do you think that the fact that drain has been put raises some alarm in your mind at this point of time?
Yes, so maybe he might have, the surgeon might be suspecting some injury or he might have had difficult surgery.
Okay. So the fact that drain has been put must raise suspicion in your mind that surgeon must have had some difficulty during the procedure and he expected something out of it. Elsewhere, the routinely in cholecystectomy, whether it's open or lab, drains are usually not.
Okay. Dr. Veda, I am Dr. Rajgopal Shrey. My question to you is that you have operated on chronic cholecystitis. So, what probably are the difficulties which you encounter for which there could be a drain has been put? Can you quickly summarize? 1, 2, 3, 4.
There might be any, he might have encountered any adhesions or there could have been any anomalous anatomy.
So what I want you to understand is there could have been a difficulty in identifying the Carrot's triangle, or maybe it may be removal of the gallbladder from the liver bed itself might have been a problem. He might not have expected a bile leak during this surgery. Probably he thought there is some blood maybe collection there. So what may be the reason why he would have put the drain. This is what I understand, because if it is bile, you would have easily seen on table little bit of stains of whatever green color. He thought there could have been some blood loss, so he might have. That's my thinking. Okay.
चलो कॉल आ रही
On
है
POD 10, she went back to the same surgeon with complaints of fever, abdominal distension, and abdominal pain. And an ultrasound was done, and the ultrasound showed a empty gallbladder fossa with gross amount of fluid seen in the potential spaces of abdomen. And then an abdominal drain was placed under local anesthesia, which drained 600 ml bilious content. And the patient was admitted and was managed conservatively with IV antibiotics and IV fluids for 2 days and was then referred to BHU. So should I continue?
This is a ward round. You can continue with your presentation. Then only at the end you can
हाँ
General examination, patient was
आया
conscious,
था अभी
cooperating, related to time, place in person, and was lying comfortably on bed. And she was febrile and her pulse rate was 104 per minute with a blood pressure of 114 by 70 mm of Hg and a respiratory rate of 22 per minute. She appears dehydrated and there was no pallor, cyanosis, clubbing or pleural edema or genital lymphadenopathy and the BMI was 25.4. On abdominal examination, the abdomen was distended, the supraumbilical right
अगर
parabiliary
उसमें नहीं आएगी
was
तो मेरे फोन से कर लेना ठीक है
and an intraumbilical
अभी
malignation
आ
of
नहीं रही,
previous
आप ही
cesarean
को भी
section
आती है।
was seen. And an ADK drain was seen in the right hypochondrium with
ले लेना
biliary
फिर
zone
चार्ज कर
dressing
लूँ
around it.
बेटा अव्या वो चार्जर उठाना वहां से
Palpation, there was no local rise of temperature and abdominals was soft and
अव्या वहां से
non-tender.
चार्जर
There was
उठाना
no organomegaly or palpable lumps. There was no evidence of free fluid and bowel
पूजा
sound was
स्टार्टेड
present.
है कॉल
Digital rectal examination,
Skype.
co-vaginal examination was within normal
पूछी
limit. And the other specific examination was also within normal limit. And then EGD was
आ
done
गई
at
क्या
presentation and her pH was 7.405 and her potassium was 3.25 and her lactate
लो
was
फिर
0.8.
I think you can stop. You can stop. I can start discussing from this point. Beta, go back. Go back to the second sonography. If you are the surgeon, would you have done the same procedure? Abdominal drain placed under relay?
Yes, sir. I would like to place a drain and drain the contents.
You just tell me. Would you have done the same that is written? Abdominal drain placed under relay?
Sir, I would like to place a USG guided tailings.
Try to understand. Your finding is gross amount of fluid seen in superficial spaces of abdomen. Soft training, caracolic gutter, pelvis, everywhere there is bite and abdomen distended and in pain. So that is what not should be done. You cannot blindly put drain
Under
in
USG.
a situation like this. That has to be either ultrasound guided or you are having a situation like this. What should be your preferred way of draining? Do you think this is the situation?
So we can go for a laparoscopic drainage also. Or a
So what do you
USG
prefer? If the collection, see, the situation is either a localized biliary collection or it's a generalized biliary collection, the scenario is different. Your ultrasound is saying that there is generalized biliary collection. In that case, the preferable should be a laparoscopic drainage, or if not possible, an open drainage. Good. Done. Next.
So I just want to add that, sir, that since this patient was, I think, operated elsewhere, I think that is why I think that surgeon put that kind of a drain and then refer to higher center. But the question will be, if it is a patient is coming directly to you, directly, because you might not have facility, I want you to understand that patient septic removal, the septic part removal is the key here. Whether you are done by this ultrasound guided method or a laparoscopic method, you are trying to reduce the sepsis. So say antibiotics, dehydration correction, and that septic. Yes. Please go ahead.
And EBG was done at presentation and her pH was 7.405 and her potassium was 3.25 millimoles and her lactate was 0.8 millimoles per deciliter. And the CBC was done and hemoglobin was 9 and total counts were 14,600. And creatinine renal function test was within normal limits and liver function test was also within normal limits. And a repeat ultrasound was done at our institute which showed post-cholecystectomy status with minimal collection present in the subhepatic space and drain was seen in the peritoneal cavity and moderate dense non-aspirable collection was present in the pelvic cavity. And today morning, the patient was febrile with a pulse rate of 84 per minute and blood pressure of 124 by 70 mm of Hg and respiratory rate of 14 per minute. And she was passing fluorescent stool. Our urine output was adequate and drain output was 200 ml. Bilious.
I just want to ask you, Dr. Veda, just go back to that slide on the investigations and say that, yeah, that correct. So pH, don't the pH slide, pH is there, no? Yeah. So what is your impression at this stage now?
So at this stage, patient is having mild hypokalemia, but she did not develop any acidosis. She said, and that she was not in any septic shock or some metabolic acidosis.
Can you go to the next slide? Yeah. So what does this slide tell you?
So she has sepsis. She is in sepsis, but she did not develop any organ dysfunction yet.
Coagulation profile.
Coagulation profile is coagulation. Using coagulation.
So why it's important?
So in this patient, the coagulopathy might be due to the bile not reaching the intestines.
Then I'm not talking about why. What I'm trying to tell is, you may have to intervene this patient in whichever form, whether you can do, let us say, stone in the CBD, endoscope, episiotomy, or whatever it is. You need to be careful about this whenever you are doing a episiotomy or maybe a PGBD, whatever it is. So coagulopathy, that is one important point we need to keep it in mind. Do you feel your bilirubin is normal?
The bilirubin is raised due to
Absorption from the peritoneum.
Probably it's absorption from the peritoneum. That is one possibility is there. Her alkaline phosphatase, do you think it's normal? Look at the
This is normal for the scale in our institutes. Our normal value is from 110 to 10.
Why it's important to know alkaline phosphatase?
Sir, if there is any associated cholestasis.
No. Especially in case of gallstone disease, you have done cholecystectomy. If the stone has going blocked the CBD, that could have been also the cause of the leak. And if that is the situation, if there's no major vascular or a hepatic duct injury, surgeon is confident, but still it is leaking. Where do you think the leak is from? If there's a stone in the CBD.
Sir, it may be due to slipped cystic artery ligatures.
Cystic duct ligate. Yes. In fact, cystic duct ligation is one of the common features. If you are
Mira, how to explain the scenario? Patient has a brain which is more of the public art, but there is no bile collection. He came back after 10 days. How do you explain this scenario?
This might be due to slipped ligatures.
Slipped ligatures is occurring at the public art. Slipped ligatures are occurring in the immediate post period. How do you explain what might have happened with the brain?
Brain might have been blocked or.
That is the only possibility here. 100 ml, 50 ml, no drain. You know the drain, he came back with a biliary collection. It's like a stone, that is a problem with the drain. We should not rely 100% on drain. Before you discharge the patient, you should do it evaluation. And if there is suspicion, you should at least do ultrasonography. So tell me, what are the likely causes of such biliary collection in the post-op period? What are the different things which can go wrong and you may have such biliary collection?
मिल गया हेडफोन
Maybe due to slipping
मेरा भी
the
मिल गया
ligature
तुम्हारा
of the cystic duct, or if there is any ducts from the draining the gallbladder into the liver bed directly.
Yes.
Or any lateral injuries to the CBD.
Anything else?
Spilled collection.
Which got collected.
Spill bile collected means? What other injury can cause such biliary collection?
So any vascular injury
Can
can
any
cause
sectoral duct be injured? Sectoral duct?
right posterior sectoral duct injury can also cause collection.
And don't forget duodenum. Okay, duodenum, that will be very close there. So you need to know also whenever a bile comes, in addition to the biliary tree, extra biliary organ is duodenum. Always, small cautery burns in the duodenum can manifest even after 3 to 4 days later. Small ones
some biliary ischemia may undergo necrosis. It can manifest a little later. Okay, just keep it in mind. And sometimes, if there's a chronic cholecystitis, hepatic flexion would have gone and stuck there. So we would like to know from the surgeon exactly what were the difficulties which he has encountered during the cholecystectomy, which forms the very, very important thing. Take a phone, call the surgeon. He may tell that colon was stuck there, so we would have tried to release that. Duodenum was difficulty. So please talk to the concerned surgeon and proceed. That's all, sir. I said. Proceed.
So now you have more than 200 ml of bile coming down. What should you do? On this day, he is having a discharge of 200 ml of bile. So what should be your plan?
So this is a low output fistula and patient is doing fine, so we can wait and watch in this case.
How long you should wait?
So we should wait for 4 to 6 weeks and then we should go for an imaging study, mostly about 4 weeks.
You have not done any investigation to ascertain the type of injury. You cannot discharge the patient to home for 6 weeks with a brain output being 200 ml. That is not the strategy for biliary fistula.
Dr. Veda, just a question. Will you like to qualify this as a low output fistula? We are talking about post cholecystectomy. What's the definition to quantify low and high output when we are talking about post cholecystectomy patient? Remember, we are not talking about normal endocardial fistula.
कौन सा है कैपिटल low output fistula?
The majority of the standard textbooks say less than 100 ml per day is low output. Above 100 ml is considered as high output. For post cholecystectomy we are talking about.
ठीक है और ये CAT क्या होता है कैट है ना ये कैप है कैप पे सेटिंग करना
Whenever you have such a cases in board round, always start management and assessment with proper airway breathing. In none of your slide, you have made a wonderful presentation, Veda, but nowhere did I see SpO2 of this patient. The patient might be hypoxic because of sepsis. So your basic assessment is basic things. I would like to know SpO2 this patient. I would like to know if at all this patient is having less SpO2. Of course, you did mention about respiratory chest and auscultations. We are dealing with a patient who could probably have sepsis. And then there have been a lot of collection inside as such for around 10 days. So always have your virtual work and then keep progressing. We all know what ultimately we have to do in this patient. Okay? So just wanted to add this.
Would you consider ERCP in this patient? Would you consider ERCP in this patient?
Yes, sir. ERCP with stenting ERCP can be done if it is a lateral injury or if it's due to cyst. If we identify any cystic duct leak, we can do stenting.
This patient is ecteric. What does it suggest?
Fan kind ऊपर इसमें याद रखना
patient is ecteric. Almost 1.6 billion is not high billion.
I have my fan.
It is unlikely that patient has got a complete occlusion. It is unlikely. So here is the indication. On 10th and 11th post-op day, patient having persistent biliary drainage. This is the ideal place for doing ERCP. Okay.
Yes.
So what in ERCP you like to see?
So we'd like to see the site of injury.
Yes.
Yes, and the type of injury and whether it is complete or partial injury. Complete connection or partial connection.
If feasible, what we add in diagnostic ERCP?
Stenting.
I give a scenario that ERCP has shown that it's partial injury to the biliary tree and stenting has failed. What to do now?
Partial injury to the CBD and stenting has failed. We can do a sphincterotomy and we should place a drain and we should make it a controlled external biliary fistula and we should wait for 4 to 6 weeks and then we should operate the patient.
Okay, next you have to go CA and CAN.
Drain is already put, so you should wait till the biliary fistula closes. How do you classify a bile duct injury? What is the standard classification?
It's a Strasbourg classification.
Strasbourg.
अब देखो बैग ठीक है B
Hello.
Yes, Strasbourg A stands for what?
So Strasbourg is due to leak from the cystic duct or minor leaks from the gallbladder bed with no loss of continuity of the CBD, with continuity with CBD.
Okay, yes.
So,
So what are the principles?
what things you cannot, what are not mentioned in Strasbourg classification, more applicable during laparoscopic surgery? Any other classification?
Stewart way classification is used for laparoscopic CBD injuries.
Yes, yes.
Dr. Sanjay, please can I intervene?
Yes, yes.
और ये क्या है कैट है ना तो यहाँ पे सी ए टी ये भी कैट
Hello.
Dr. Veda,
ये क्या है
now you
कैट
have a
टी
patient
ए
in
टी
your
कैट
ward who has undergone a stent drain placement outside.
Yes.
Okay. Now the patient is fairly stable.
Yes.
Maybe in some sepsis at the most. Counts are 14,000. There is some mild coagulopathy. So, and the ultrasound you said showed some collection in the pelvis.
Yes, sir.
Did it show some collection in the pelvis, the repeat ultrasound at your institute?
Yes, sir. Yes, sir.
Okay, so now you are the resident in charge of the patient. Your consultant has come for the round. So what are the things which you are worried about at this point of time? Apart from the biliary injury, you know that he has got a biliary injury. That's all right. Now what are the things which are important in the management of this patient on the 10th day?
Hello.
Cat की spelling.
Is she taking orally?
Yes, sir. She is taking orally. She is tolerating orally.
She's taking full oral now, right?
ये भी बैग है ना ये क्या है rat rat की spelling क्या है R A
So what else are you worried about?
R A
Sir, about the peritoneal collection.
Okay, so you are worried about the peritoneal collection
And the output, sir.
and the output from the drain.
Drain
As Dr.
output.
Gyan said, that although 200 ml is not a very large amount of drainage per day, but still it is still coming. So what will you do for this collection now? What should be your plan for this collection now?
This collection based on USG, it was non-aspirable. So we will not be able to drain it by drain insertion, percutaneous drain insertion. But at the same time, the patient is not in severe sepsis and she is not deteriorating, so we need not drain it surgically. We can wait and watch for the collection.
So you initially the patient had fluid in whole of the peritoneal cavity in all these spaces. Then with one drain in the flank on the left side or the right side, you think that the whole fluid has been drained from all the components of the abdomen?
Sir, on repeat USG, sir, there was only pelvic collection, sir.
So there comes the question. So is ultrasound a dependable investigation for ruling out
जो सर्किल करना था जो सर्किल पॉइंट है ना उसको सर्किल करना था हाँ अभी क्या है कैट है ना ये क्या है C A T कैट अब कैट की स्पेलिंग होती है C A P होती है C A P कैट ये क्या है फैन ये क्या था P A N फैन होता है फैन तो तबा होता है ना ये क्या फैन है
before you submit the patient to ERCP or anything else?
Yes, sir. Yes, I would like to do a CECP.
Yeah, so it always should not depend on only the ultrasound. And once the ultrasound is shown,
ऐसी रैट की स्पेलिंग क्या होती है रैट की
good idea
R-E-T रैट ये आपका नाम ठीक है
and to look for collection in all the areas of the abdomen. CT is a good investigation for telling you whether
पेंसिल देना रख दी सब
required in the
अरे बेटा मैंने हिंदी का फॉर्म दिया थी
whether the drain is required in the left subdiaphragmatic space or the pelvic space. So CT is the better investigation. You should always get a CT to look at this, and then nutritional status of this patient is very important. Because the recovery is very dependent upon that. So these two things you should keep in mind. So I think you should plan for a CT scan first rather than doing any other investigation.
Okay, Dr. Veda, I have a question to you. Drain is only draining 200 ml, but creatinine is raising up and total count is 18,000. What does it mean?
So we should reposition the drain, or we should repeat an imaging study to look for any intra-abdominal collection, which
So
is not
as it has been told earlier, don't depend too much upon the drain, and it's the gram-negative sepsis, which is the most organ to suffer in the gram-negative sepsis.
said the kidneys.
Yes. So you need to know that patient is going for a renal failure. So you need to be careful about. Now tell me, antibiotics you are not mentioned at all. So what antibiotics are preferred?
So we can give third generation cephalosporin, second generation, third generation cephalosporin, along with an anaerobic coverage.
And if the patient has got a real sepsis,
We can add an aminoglycoside also.
aminoglycosides may not be good here if there's a renal component. What is the good one for enterococcus? You heard of enterococcus in addition to E. coli, etc. That is one of the important organisms in the gram-negative sepsis. One other organism. This may not be applicable here, but you may have to consider carbapenems. Okay, just to keep it in mind. So in this patient, you need to have 4 principles ready always. 4 D's will train. One is the drain. Drainage of this fluid, it has to be kept in mind first. Then delineating the anatomy. Deadly organisms such as all these things. And lastly, of course, the duct mucosa, whatever that rest of this, whatever we talk. What happened to your patient? Please proceed.
Beda, if you talk of a bile duct injury, you have detected a bile duct injury on table. While present in the callus angle area, there is a lateral tear in the bile duct. You could identify in the table.
Yes.
What should you do?
Sir, as I am not experienced, I will get a drain and I will send the patient to higher center.
You are in IMS, BHU.
I will call for help.
Yes.
Ask my senior colleague.
Correct.
So, and help comes. What should be the ideal procedure in such situation? Your senior has come for rescue, and what you think should be the procedure done in such situation?
So if it is just a lateral injury, we can close it over T2.
Should you do a intracolangiogram?
Yes, sir. If facility is available, we can do an intracolangiogram to delineate the anatomy. So it delineates the anatomy better. We can identify the site of injury better.
Yes. So it is feasible once you go for intracolangiogram such situation. And what is the management for a lateral tear?
So if it is less than 1 centimeter, we can close it primarily. If it is more than 1 centimeter, we can close it over a T2.
Okay. We have done a complete transaction.
Yes.
There has been a complete transaction of the bile duct. What should be the ideal procedure?
Sir, if there is complete transaction without tissue loss, it can be repaired primarily. But if there is tissue loss, we should wait for 6 weeks and we should prefer a delayed repair. Or we can go for an hepaticojejunostomy also.
Sir is talking about
The
intraoperative.
primary repair is not a good option in complete transaction.
There
Because
will be
there is some thermal.
injury also.
Yeah.
I think Dr. Veda, in a situation where you have intraoperatively diagnosed a complete transaction of CBD or hepatic duct, and if you have a skill available for repair hepaticojejunostomy then and there itself, we are talking about intraoperatively. So you can go in for, provided as Sir said, there is no thermal damage. I know intraoperatively transaction had happened. So that is the time when, if a special care is available, a skilled person is available, you should go in for hepaticojejunostomy. That should be your answer. After 48 hours, there is no indication of going in for a bilioenteric anastomosis. Then your answer prevailed very well that you should wait for at least 6 to 8 weeks. So a postgraduate should answer like this. Okay, you have to play very smart here.
Veda, now you have a patient where you have done a CT scan and it showed a collection in the pelvis and in the left subabdominal space. So you have put two drains. Yeah, sorry, please.
Yes, sir. You should wind up, sir. We are running short of time and directly
Just last
cultivating.
question.
Maybe little last two questions may be entertained, sir. Thank you.
So now you have put two drains. The drains are draining 100 ml, 200 ml initially. Then the drain stop, and the drain in your in the right space is still draining around 100 200 ml bile per day. So how are you going to manage this patient, say, after 10 days from today? Patient is now stable, no TLC range, nothing, no fever, nothing now.
So we'll repeat the imaging and we'll confirm that there is no further any more collection in the left subdiaphragmatic space and pelvic
Okay,
space.
so you will do ultrasound abdomen to see if there is any residual collection. That's all right. Okay.
Yes.
Okay.
If there is no collection, we can remove those two drains, pelvic one and pelvic one.
Now the question will come as Dr. Saha was asking. Now you have to know what is the site of injury, where this bile is coming from, 100 200 ml, whatever bile is coming. So now at this point of time, definitive what is this definitive investigation which should be helpful at this point of time?
So MRCP. MRCP. Yes.
So why would you not do MRCP initially when you did a CT scan?
I said there is collection. The MRCP cannot delineate the anatomy in the presence of collection. So the collection will be overlapping the CVD and the
MRI picks up the fluid in the biliary tract or the bowel. So the collection will not let that biliary tract be delineated because it will overlap with that fluid, because MRI will pick up the signals of that fluid from wherever it is coming.
Yes.
So MRCP is not a good investigation in the beginning, but once the collections have been trained, then MRCP is the first investigation of choice. Or some would argue you can do a ERCP also at this point of time, as was discussed previously also, so that you can. What is the advantage of ERCP over MRCP?
So the ERCP can be therapeutic also. We can go for stenting if there
It
is
can be both diagnostic as well as therapeutic. So if it is a cystic duct stump leak, or there is a minor lateral CVD wall tear, or there is a accessory duct, all those things, the ERCP will take care. MRCP will only be giving the diagnosis.
I request the examiner and moderator to please summarize as we are running short of time. We'll go
Can I just say, Dr. Veda, prevention of the injuries is more important than treating. So most important thing is identify critical view of Strasberg, and another thing called a be safe. Do you know what is be safe method? Be safe. Be safe means it's some kind of a mnemonic. Easy to remember. B is nothing but the bile duct, right? Say S. What do you mean by S here? You heard of any sulcus of Bouvier? A is hepatic artery, F is umbilical fissure, and E is entry. That means a surgeon who is doing a cholecystectomy, who is able to get this overall view. So you know where is hepatic artery, where is cystic artery, where is umbilical fissure, where is venous sulcus, where is duodenum. That will reduce the complications. Right? That's all from my side.
To summarize, one is you identify bile duct injury on table. So either you repair or call for help and do a HJ. You diagnose the bile duct injury in the immediate post-op period, and patient has got biliary collection. If patient has got evidence of biliary peritonitis, you should do re-laparoscopy, drain the peritoneal collection, and put another drain. If you recognize the bile duct injury in the post-op period in the form of excessive drainage of bile, you wait for 5 to 7 days. If the bile injury is persistent, go for ERCP. This injury can be happened in late post-op period. In that case, if the patient has got biliary collection, again the drainage of collection and reassessment of the bile duct injury. These patients can come quite late after 2-3 months.
मुझे लग रहा है
with slow development of biliary stricture because of
मणिपाल की बुक है ना,
in that case,
उसका ऑथर भी है
by doing an
बैठा हुआ।
on MRCP And if there is a different structure, you go for HG. So that is the outline for management of billiard injury. Thank you.
I thanks all the examiners and moderators for having this session. And since we are running short of time, so if any comments there from any of the examiners or moderator.
Dr. Puneet, can you hear me?
Yes,
Dr.
sir.
Puneet, am I audible?
Yeah, yes, sir. You are very much audible, sir.
Sorry, I'm sorry. There was some loss of audio, so I could. But I think it's been done well, and
Yes,
I just wish to thank the analyst and also to you. And the student has done well. I think it's a complicated problem, but it needs to be handled well. Thank you so much.
I thank you very much, sir, and we'll go to the next function. We have an inaugural function for 15 minutes. So we have a director with us, and Dr. Shashi Prakash Mishra is going to conduct the inaugural ceremony. So over to Dr. Shashi.
Thank you, sir.
Very good afternoon to all participants here. Respected Director of the Institute of Medical Sciences, eminent faculty for the PG Master Class 2021, the office bearers of the UP chapter of ASI, President and all the EC members of UP ASI, senior teachers of the department, residents, all the participants of this PG Master Class 2021, staff members of department, and ladies and gentlemen, I welcome you all for this online plus offline inaugural session of the virtual PG Master Class 2021. So to start with, I will request Honorable Director Sir, Professor Sanjeev Gupta, and Head of the Department to give floral regards to our founder, Bharat Ratna Pandit Madan Malviya.
कव्या कह रही है, कव्या कह रही है।
I request you all for the lighting the lamp of the knowledge.
और अभी यहाँ पे भी करना है ब्लू, ठीक है।
सर्व विद्या की राजधानी नए नहीं है ईंट पत्थर विश्वकर्मा का कार्य सुंदर रचे है विद्या के भव्य मंदिर ये सर्व सृष्टि की राजधानी मधुर मनोहर अति
I'll also request our head sir to felicitate the senior most faculty member of the department, Professor A.K. Khanna, with the floral wishes. Now I will request our head of the department to deliver his welcome address.
Respected Director, Professor B.R. Mittal, senior faculty from our department, Dr. A.K. Khanna, Dr. S.K. Gupta,
Dr. Rahul Khanna, Dr. Seema, Dr. Anil Ansari, and other professors and colleagues of the Department of Surgery, the faculty members, the residents and delegates. I would also want to welcome Dr. Vinod Jain, the President, UPSI, Dr. Nikhil Singh, Secretary, UPSI. I welcome you all there for this PG Master Classes. This year we are doing on a virtual platform because of the COVID pandemic. We have started this PG classes from 2013 and we are doing it on an annual basis. Normally we used to have an attendance of 200 PGs which used to join in person when we do it in the department. But this time when we are doing on a virtual platform, we have more than 500 registrations. So I thanks all delegates, candidates, the PG students, those who have shown their trust, and we hope that Department of Surgery is going to provide a good academic feast in 2 days' time, where we are discussing the case capsules, ward rounds, and the operative steps in a similar way. Exactly, it happened there in MS and DNP surgery exit exam. I want to thank our esteemed director for his kind encouragement and his guidance. Thanks to all the from our department. I thanks the UPSI.
Always conducted UP chapter of ASI, and we have the president of UPSI with us, Professor Vinod Jain. Is the you to give us some words of encouragement. Vinod Jain, sir, please. Sir, you are muted.
Good morning and thank you to all of you, respected directors and other dignitaries on the platform. I am really delighted that BHU, in association with UP chapter of Associations of Surgeons of India, is organizing its first 2 days virtual PG master classes in surgery. This is for the first time in the history, and that's CME for residents and the young surgeons. My dear friends, learning is a lifelong process. UPSI, under dynamic leadership of Dr. Director Academics of UPSI, has always been instrumental for academic upliftment of the association. I thank through bottom of my heart as President UPSI for his continuous endeavor for this cause. My all best wishes of success of this academic program. Thank you very much.
Thank you, sir. Now I will request our Honorable Director, Professor B.R. Mittal, sir, to give us his blessings to us.
Good afternoon, everyone. A very warm welcome to this NECRO program. And I am really pleased to be part of this NECRO program. Another faculty members of the Department of General Surgery, very senior person, Professor Khanna, and Dr. Vinod Jain, from the President of UP Chapter of Association of Surgeons of India, under the aegis of which this master classes in surgery, this series is being organized. Professor Panil told and I made aware of this, that this is the 8th in series. It started in 2013 and it is very popular among the students. It's basically for the students who has to undergo the exit examination. And I must congratulate all of the department and the faculty who organized such a wonderful program, which includes the case capsules, jar wounds, and operative procedures also. So this will go a long way in knowing the surgical skills and creating best class persons that's able to inculcate the surgical skills in the students. So really appreciable. And this time being the virtual course, again I am told that about almost 500 students have enrolled in this. Though when it was physical, usually 200 students used to enroll in this. It's really appreciable. And once again, I congratulate all of the faculty from BHU IMS as well as the faculty across India who have joined this program and who are examiners and teachers to so many students and so many teachers also. So with these words, I once again thank each and everyone for inviting me.
Page number 9 line का
Thank you, sir. Thanks a lot. Now I'm privileged to hand over the responsibility to Dr. Arun Meena, organizing secretary of this event, to deliver the vote of thanks. Thanks, Sasi.
Through it in the vein,
Never let us say you are. The head of the department of the surgery, the teachers, and my colleagues.
be respectful, and be respectful and
First of all, I thanks for guiding on day-to-day basis on progressive words to thanks our esteemed faculty from the various parts of the country, so who have accepted the invitation on a single phone and make the events to happen on the and I wish to express my thanks to the President, Professor Vinojan sir, and Secretary of the UP chapter of the SI for consistent support to organize this event. And I thank our dynamic head of the department, Professor Puneet sir, for his consistent supervisions and support even in the middle of the night. Thank you, sir, for supporting us, guiding us. And I am very thankful to our senior teachers, Professor Ajay Kumar sir, and other senior teachers, Professor Sanjay sir, Rautana sir, Sumit and other colleagues, and who supported me, especially the Dr. Tiwari, Dr. Dubey, and the Sasi, who supported these events, and beloved department, Hemant and Akshay and the other staff members of the departments who helping me to organize this event. I sincerely thank the participating residents from the various colleges who have been the real driving force to conduct this program on a virtual platform. And I am also thanks to Olympus team for taking the task to conduct this program on virtual platforms. And at the end, thanks all those who have helped me to organize this program on the inaugural function comes to its end, and now we'll be starting the sessions thereafter. And the next session we have on the portal application, in which presenter is Dr. Nikhil Dimori from the Medical College, Mumbai. And the moderator of the session is Dr. Sunil Kumar from Jamshedpur. So, Sunil sir, if you are online with us, I wish to hand over to you.
Yeah, okay, thank you very much. Good afternoon. It's Dr. Sunil from Jamshedpur. Greetings. And may I request all the examiners to please log in and I'll request the candidate to start presentation. The way we have been given the guideline is that we will not interrupt the candidate till he finishes the cases, and then I'll request all the examiner one by one so that the candidate gets the flair of each examiner formally, and then I will sum up the case at the end. So I request the candidate, please present your case.
Good afternoon, sir. My case is of a 30-year-old gentleman who is a resident of Raigad who presented to the emergency department with chief complaints of lump in his abdomen since 6 months, vomiting blood since 2 days, and patches of dark-colored stool since 1 day. The patient was apparently all right 6 months back when he first noticed a lump in his abdomen, which was initially small in size and present in the left upper part. It is progressively increasing in size and it is not associated with any pain. It was also not associated with any postural variations. The patient was apparently all right 2 days back when he experienced episodes of vomiting of blood, which was painless and spontaneous, containing about half a cup of blood without any clots at that time and contained fresh, dried red blood without any food particles. Following this, the patient did not have any episode of loss of consciousness. For these complaints, the patient was taken to a nearby doctor who administered intravenous fluids and injections and thereafter referred the patient. The patient also had history of passing dark-colored, tarry, foul-smelling loose stools. There is no history of burning pain in the upper abdomen, which was relieved by intake of antacids. There is no history of long-term ingestion of painkillers. There is no history of repeated episodes of vomiting or retching prior to the blood in vomitus. There is no history of loss of weight or appetite. There is no history of generalized distension of abdomen. The patient has no history of alcohol intake, no history of yellowish discoloration of the white of eyes or skin in the past, no history of chronic pain in upper abdomen radiating to back. The patient was born at full term by a normal vaginal delivery, having had an uncomplicated neonatal period. No history of multiple episodes of upper respiratory tract infections, spontaneous bleeding, fatigue, malaise, or multiple blood transfusions. No history of multiple episodes of high-grade fever with chills, with lump in abdomen and bleeding from tongue. No history of breathlessness or chest pain associated with exertion. No history of blunt trauma to the abdomen. The patient has no history of malaise, edema over feet, yellowish discoloration of skin, loss of axillary or pubic hair. No history of confusion, excessive daytime sleepiness, and nighttime waking. No history of similar complaints in the past, and no history of past surgical or medical intervention done. For these complaints, the patient was referred to the he was admitted blood tests, injections, and was taken up for endoscopy where some intervention was done. Past history, he has not an old case of diverticulitis, hypertension, tuberculosis, or bronchial asthma. There are no known medical comorbidities or prior history of any surgery or endoscopy prior to this admission. His appetite and bladder habits are unaltered as before. Bowel habits are altered as previously described. Family history, there is no history of similar illness in the family members. To summarize my case, he is a 30-year-old gentleman with chief complaints of profuse blood and vomiting since 2 days, which was painless, spontaneous, and bright red in color, with a lump in upper abdomen and passage of dark-colored tarry stools. Coming over to general examination, the patient was examined after taking due informed consent in daylight. He is conscious, cooperative, and
I
well-oriented
think
in
Nikhil, you
time,
have to
place.
stop at this point. We have to discuss about the history part.
Okay, so Dr. Khanna, I'll request you to please ask few questions on history.
Nikhil, tell what do you understand by melena?
So melena is a symptom in which there is passage of dark colored tarry stools which are foul smelling. It is a manifestation of upper gastrointestinal tract bleeding. It can also be present in lower gastrointestinal tract bleeding if the transit time in the gut is more. The dark
What are the other causes of the
So
black
black
colored
colored
stools?
stools can also be due to after consumption of iron containing tablets if the patient is taking iron supplements.
Like a patient having a peptic ulcer.
Yes.
Do you know any drug which is there which can cause a black colored stool?
So iron containing iron supplements can cause black colored stools.
No, you will not give the iron in the case of peptic ulcer. What drug was given before? Nowadays it is no more given, but still there is a drug which is there. which was used for the peptic ulcer, and that used to cause the real black colored stools.
Sir, I'm not aware of it.
That's the bismuth, you know. Bismuth was one of the treatments for the peptic ulcer, and bismuth gives the black colored stool. Now, why did you ask for neonatal history here? What is the age of the patient? 30 years. Why did you ask for
Sir,
that?
I wanted to rule out extrahepatic portal vein obstruction. It is a very, it's likely that it would present at this age, but still for the sake of completion, I asked because
What would have happened?
so during neonatal period, if there is umbilical vein catheterization or sepsis in the neonatal period, it can cause portal vein extrahepatic portal vein obstruction due to portal vein thrombosis.
Okay, as there is a umbilical inflammation, is the tonsillitis is there. Tell what are the other infective causes in the abdomen which can lead to the portal hypertension?
So causes like pyelonephritis, appendicitis, all these can also cause portal vein thrombosis.
How the pyelonephritis will cause portal obstruction, portal vein sepsis? The pyelonephritis you said, no? First the pyelonephritis.
So it can cause pyelophlebitis due to which septic emboli can be dislodged.
How it will cause the pyelophlebitis? Pyelonephritis causing the pyelophlebitis. How it will cause? You know, ultimately the inflammation is there, the inflammation is there. It has to drain in the portal system circulation there. So that is not your correct answer. The other causes which are there, which can where the blood is draining the portal system circulation.
Umbilical vein sepsis.
Already like a sepsis. Then the appendicitis can cause the portal hypertension. Diverticulitis can cause the portal hypertension because ultimately there is inflammation is there that is going to the portal circulation there, and that can lead to the portal hypertension. Why do you say this patient had a hematemesis? Why not a hemoptysis?
So the patient only gave complaints that there was blood present in the vomitus.
No, but how will you differentiate whether it is a hemoptysis or whether it is hematemesis? In both cases, the blood will be there.
So in case of hemoptysis, the blood is associated with frothing. It is dyed red in color usually. In case of hematemesis, it can be due to acid hematine formation and digestion by the acid in the stomach. It can have altered color.
What will be the preceding event there in a case of hemoptysis?
In case of hemoptysis, it is usually after a bout of cough. In case of hematemesis, it can be after retching or
Retching and nausea.
nausea.
Okay, the patient will have the retching and the nausea will be there.
Dr. Khanna, sir, should we move to the physical examination, please?
Yes, please. Please go on that.
Nikhil, please.
The patient was examined after taking due consent. He is conscious, cooperative, and well-oriented in time, place, and person. He is poorly nourished. The patient is afebrile. The pulse rate is 92 beats per minute, which is regular in rate and rhythm. A blood pressure is 110 by 70 millimeters of mercury. The patient has pallor. There is no evidence of excess clubbing or digging of the feet. There are no signs suggestive of chronic liver disease. Examination of the abdomen after giving verbal consent and exposing the patient from nipples to the thigh with the patient in supine position, legs at hip. On inspection, the abdomen is apfoid with present in the left hypogastric and epigastric region and left lumbar region. The umbilicus is displaced downwards in the left leg and is involved. There are no visible dilated veins, scars, peristalsis, or sinuses. The hernial sites and external genitalia are grossly normal. There is no fullness in the left supraclavicular fossa. On palpation, the findings of inspection are confirmed. There is no local warmth or tenderness over the area. A minor tenderness of 10 to 10 centimeter is present in the left hypochondrium, epigastric, and umbilical and left lumbar region. The sides are unmatched can be palpated at the anterior border. The upper margin of the lump is not palpable. It is firm in consistency and moves well with respiration. It is not possible to insinuate the fingers between the lump and the costal margin. and this lump is consistent with splenomegaly.
तुम बताओ अपना
The liver is not palpable. Corneal sites show no evidence of cuff impulse. External genitalia is unremarkable. There is no evidence of lymphedema with extraclavicular foci. On percussion, the lump is present all over the lung. The rest of the abdomen is tympanic. Top space is dull on percussion. The liver span is 13 centimeters and there is no evidence of shifting dullness. On auscultation, normal vowel sounds are heard all over the abdomen and there is no audible
और या
arterial,
तो
pili or
गोभी बन
venous
सकती
sound.
है, गोभी में सुनाई लगेगी।
On per
हाँ,
rectal
तुम बताओ कुछ
examination, there is
सुंदर
no
लगी।
inspection, there is no gross abnormality noted. On digital examination, melena is present and there is no evidence of
बैगन
growth or mass.
और कोई
On
है
post
तुम्हारे पास?
examination is within normal limits.
हमें फोन दी
The systemic examination is also within normal limits. To summarize, my patient is a 30-year-old gentleman who complains of lump in his left upper abdomen since 6 months and blood and vomited since 2 days. On examination, the patient had pallid, no signs of liver cell failure and splenomegaly.
So is Dr. Rajneesh Singh logged in, one of our fellow examiner from Lucknow?
Yeah, I'm. Yes,
नहीं ना
I'm
बेटा
right here.
Yeah, so can
नहीं
you
तो मुझे
ask?
फोन में
Am I
गई
audible? Yeah. Can you ask question based on the candidate's physical examination?
Let's start with the history first. Dr. Nikhil, you've done a very good job with the history. Unfortunately, when you're very young, you tend to club everything together in a large lump of a paragraph. And then the emphasis on various points tends to go away. You covered virtually everything. For example, in the history, you said that patient has had upper GI hemorrhage, which is very clear. And then obviously you have brought out points to say that the patient does not have liver failure. And you have brought out points to say patient does not have obvious history of suggestive of a petricalcer disease, history suggestive of preceding intake of any tablets or drugs which would cause erosive hemorrhage. Those points are all there. But you'll have to club them together so that in a very short time in the exam that you have, you bring out these points emphatically and with a lot of emphasis as to what you're really saying and conveying.
Dr. Rajneesh, I request you to ask some question on the physical examination. On his physical examination book, please ask some question for him to answer. Dr. Rajneesh is not audible. Can I request Dr. Nimesh to take over and ask some questions on physical examination? Dr. Nimesh Verma, you are mute. So, Dr. Khanna, can I request you to ask some questions?
Nikhil, please tell that, did you look for the veins in the abdominal wall or not?
Yes, sir.
Hello. In which position did you examine the veins in this patient?
Sir, I examined the veins in the supine position and also when the patient was standing erect.
Now, when the patient is standing position, where you will examine the veins in a case of suspected case of portal hypertension?
My name is
Where you will examine the veins
study in
suspected case of portal hypertension? Which part of the abdomen you will examine?
Around the umbilicus and in the flanks.
और मैं गाजर बनी
Which flank? Upper side, lower side, where? Above them like this, below them like this.
गाजर का हम गाजर का हलवा भी खाते हैं
Above the umbilicus.
बोल सकते हो
No, you will not observe above them like this.
गाजर
You
से
always observe it
का
below
हलवा भी
them
बन
like this.
सकता है
Why you have
और
observed below them like
हम
this?
इसका जूस पीते हैं है ना
Sir, umbilicus is the watershed area, so
से
below
आईसाइट
it,
आंखें
inferior
अच्छी
vena
रहती
cava
है ऐसे अच्छी रहती है
How do you differentiate between whether that is a IVC obstruction or whether it is a portal obstruction? How do you differentiate?
So for differentiating that, we will firstly in case of portal hypertension, the veins will be around the umbilicus, and in IVC obstruction, they will be located near the flanks. Then the direction of flow of the blood in the veins will be different. In case of portal vein obstruction, the direction will be away from the umbilicus in all directions. In case of inferior vena cava obstruction, the direction will be from below upwards.
Now, imagine now, if you examine above the umbilicus, both the direction will be the same. Means the portal obstruction as the IVC obstruction. It will be only below the umbilicus. If we do, then it will be the opposite direction. So it has to be always examined in the lower abdomen, not in the upper abdomen. What are the other differentiating feature between
बाबू सुबह से देखा है आपने और फिर क्लास भी करी है तो
or
कौन
whether
सा
it is the portal obstruction?
जहाँ पे वो पानी लेके
What other things you would like to see?
Sir, apart from this, on per rectal examination, I would like to see that.
No, I'm not talking the portal rectal examination. I'm talking about the veins on the abdominal wall.
Sir, in case of portal hypertension, in case of portal obstruction, can be an audible, there can be a venous hump which could be auscultated in the epigastric region, which is due to the increased amount of blood flowing through the splenic vein. In case of IVC,
You look at the back of the patient, okay? If you find there are dilated veins which are there, that is suggested IVC obstruction. These are two things in the anterior abdominal wall.
मंडे में मिलने की
Okay,
जगह
you see the direction of the flow, and on the posterior side you will see further dilated veins. That is suggestive of the IVC obstruction. Now tell about the
Dr. Khanna, can we request Dr. Rajneesh to take over and ask few questions so that we can
Sorry, I got cut off for internet connection. But this veins which Dr. Khanna is pointing out is very important, Dr. Nikhil. So can I ask you point blank, this patient, as your first diagnosis possibly would be a HPVO with a GI bleed. Why does he not have veins in the umbilicus? So why are their veins not present at the umbilicus?
Possibly they are under the stage of development, and the patient has already manifested with bleeding from the varices that might have decompressed the portal system.
That is a definite possibility, but that's very rare happening. Dr. Nikhil, what is the anatomy of the periumbilical veins? What is the anatomy of the umbilical vein? Where does it go?
Sir, in case of portal hypertension, dilated veins in the cancer, they are due to a patent connection between the paraumbilical vein, which is part of the portal circulation, and between the epigastric veins, which form the systemic circulation.
The other side of the paraumbilical vein, where does it go? You said other side, where does it go?
It drains into the
In a HPVO, where is the portal obstruction?
Sir, it would be in the portal vein, splenic vein or the portal vein.
So is this obstruction proximal to where this paraumbilical vein is joining, or distal to where it is joining?
Sir, if the obstruction is proximal to where the vein is joining, then the patient would present with patent paraumbilical vein.
Okay, I will stop here. Dr. Ajay, are you here? I know you have to leave. Can you ask few questions, one or two questions before you leave, Dr. Ajay? Okay. Hello. So Dr. Ajay Dr. Ajay, are you there?
Yeah, I am there.
Can you ask, for the benefit of candidate, ask at least two, three questions?
Why can't it be another lump? You have said that this lump is not crossing the midline. How do you justify whether this is spleen or something else?
Sir, to justify this spleen, to differentiate it from a renal lump, in case of a renal lump, I would be able to insinuate my hands between the costal margin and the lump. In case of a splenic lump, it would not be possible. The renal lump would be palatable or bimanually palpable. In this case, it was not so. For percussion, in case of a renal lump, the colonic resonance present it would be lost. In case of a splenic lump, it would be maintained. Trough space dullness would be present in a case of splenic lump, and it would be absent and the trough space would be resonant percussion if it's a renal lump.
Why you are interested in science?
Pardon, sir?
Science of hepatic failure.
Sir, I am interested to know about the series of chronic liver disease and hepatic failure because that would help me to categorize the prognosis of the patient. What the type of management depending on the status of the liver and how the poor function is. The patient has a good hepatic reserve.
Fine. That's fine. May I request Dr. Puneet to fire a few questions to the candidate? Dr. Nimesh Verma from Surat. Are you there, Dr. Nimesh? Okay. Is Dr.
Sorry, sir, I won't be able to join you because I'm busy with something else. I think the examiners will go ahead with the questions and other.
Okay, Nimesh, I was looking for Dr. Nimesh Verma from Surat. Okay. Is Dr. Arunima Verma there?
Yes, sir, I'm there.
So can you take the candidate on the investigation aspect? Now he has made a diagnosis, given history and physical examination. So
Yeah,
you ask
so
investigation.
yeah, so how would you manage this patient? How what is the investigation? You already mentioned that this patient has undergone an endoscopic procedure, right?
Yes.
Yeah, so what are the things that you look for in endoscopy?
Dr. Sunil, can we go to the diagnosis first before we go to the investigation? Yes, we have not heard the diagnosis here.
Okay, I'll leave that to Arunima. You just diagnosis Arunima and then you.
Yeah, go ahead. Please tell us what is your preferred diagnosis?
My diagnosis at the end of clinical examination is portal hypertension causing hematemesis due to variceal bleeding and stenosis with good liver function. The differential diagnosis would be non-cirrhotic portal fibrosis, extrahepatic portal vein obstruction, and less likely cirrhosis of liver.
So, why do you say that this patient has got non-cirrhotic portal fibrosis? That's your first diagnosis. What are the points in favor?
Ma'am, the patient did not have any signs of liver cell failure and has good liver function. And it presents with without any history which is suggestive of a hypercoagulable state or an uneventful neonatal history. So, my first diagnosis would be a non-cirrhotic portal fibrosis.
Okay, so you said he had hematemesis. So, when you do an endoscopy?
Ma'am, while doing an endoscopy, I started
उधर
from the
मार्केट
upper
में
GI
पहले
bladder.
कलर लेके आएंगे
In the
और
esophagus, I
वो
would
ले
look
आएंगे
for
एक कुर्ता पाजामा
phageal varices. Then
तो
coming
इसका
down, I would look at the fundus to check for fundic varices. Other varices present in the mucosa on the ectopic side of the gastric. Then
तुम धूप में बैठो
at the same time, I would also like to look for other causes of a upper GI bleed, such as a duodenal ulcer, a peptic ulcer, mallory-wise tear.
Yeah, so depending on your endoscopic finding, how does your management get affected? So you would grade the esophageal varices, look for stigmata of recent bleed, all that. So how does it affect your management?
Ma'am, in case that the patient has esophageal varices which are bleeding, or if there is a stigmata of recent bleed in the form of a platelet plug, varice on varus appearance, or a cherry red spot, then I would like to go ahead with a therapeutic procedure in the same setting in the form of esophageal band ligation, variceal band ligation, or sclerotherapy.
So, which is preferable, the sclerotherapy or the variceal banding?
Variceal band ligation is preferable to sclerotherapy. It shows a better outcome in fewer settings. Also, it is associated with fewer complications.
So,
Okay,
a patient.
After this question, can I request Dr. Khanna to please take over so that the candidate has the maximum benefit?
Yes, sir.
I'll come to you a little later. Yeah.
Yes,
I think still I am not very happy with the diagnosis. He has only given one diagnosis of portal hypertension. Whatever the rest he has differential diagnosis he has given, it is just the cause of the portal hypertension.
Yes, ask him, sir. Ask him. That is the whole idea.
He has to give the differential diagnosis of a patient who has got the splenomegaly plus bleed. Okay, these are the two things in this patient. That the patient has got the bleeding and the patient has got the splenomegaly. So he has to give the differential diagnosis for the splenomegaly plus bleeding. So, Nikhil, can you tell any other, what you have given is just one diagnosis, portal hypertension. Can you?
Sir, another differential I would like to consider would be hypersplenism, which can be causing thrombocytopenia and could be responsible for bleeding manifestations.
Okay, so one is, yes. What other differential diagnosis you want to give?
Sir, in case of neoplasms like myelofibrosis, the patient can again land up in thrombocytopenia with with splenomegaly.
Yes. So the tropical splenomegaly can cause to the bleeding. The myeloid leukemia can cause to the bleeding. So all these differential diagnosis has to come. Because what is the triad of the portal hypertension?
So the triad of portal hypertension is upper GI bleed, splenomegaly, and ascites.
So in this patient, ascites is missing here.
Yes,
okay, ascites is not there in this patient.
Clinically, the patient did not have ascites.
Yeah, so it is not there yet. Now, tell me now, this patient, when it comes to you, what are your principles of treatment in this patient?
Sir,
what are the things you are going to treat?
Sir, in an acute emergency setting, if the patient comes, I would first...
One is the bleeding, okay.
The first
one is the bleeding. What is
sir.
the second?
The second...
can happen the portal hypertension.
Sir,
what thing you are going to treat?
Sir, the second thing I would like to look at the liver function properly. So make sure that the patient doesn't land up in encephalopathy or other complications.
Yes, so second is the encephalopathy.
Yes, sir.
Third.
So the third thing would be shock.
Not in your patient, but that is the triad.
So ascites could be a sign of decompensated liver failure.
Right. Now tell what is intractable ascites?
Sir, intractable ascites is ascites which is refractory to medical management on the maximum dose of diuretics.
So what is that maximum dose of diuretic in adults?
Dr. Khanna, let Dr. Rajneesh ask you a question. Dr. Rajneesh, please.
Dr. Rajneesh, yeah.
Are you there, Dr. Rajneesh?
Dr. Rajneesh?
Yeah, I'm here. Sorry.
Please ask some questions.
Dr. Nikhil, am I audible to you?
Yes, sir.
Okay. See, when we talk about the triad of portal hypertension, you must understand it is reflecting liver disease. In run-of-the-mill usual BHPVO, which is your second diagnosis, or even NCPF, you will never have ascites, or very rarely have ascites. And yet that is portal hypertension. I think what Dr. Khanna was referring to was that you have essentially a patient of splenomegaly and upper GI hemorrhage. And from there onwards, you have to make differential diagnosis. One set of differential diagnosis you made, and that is relating the two. The other set of differential diagnosis relates to when the two are not related. The splenomegaly is not related to the upper GI hemorrhage. So splenomegaly is incidental or is related to tropical splenomegaly, and the GI bleed is related to something else. And then there's a third set of differential diagnosis which talks about non-splenomegaly and upper GI bleed, which could be, for example, very large GIST with upper GI hemorrhage. So you have to categorize these patients and then go forward. I wanted to know, why did you place NCPF as the first diagnosis instead of BHPVO, and cirrhosis, as you said, less likely? Why is that so?
So first, coming to the age group, the patient is already in his third decade of life. So the age group is more pointing towards a non-cirrhotic portal fibrosis. He did not have any history of a previous hypercoagulable state, or he had an uncomplicated neonatal history and no history of past history of chronic pancreatitis or abdominal malignancy or trauma, which could cause an extrahepatic portal vein obstruction. So that is why I placed non-cirrhotic portal fibrosis as the first.
Nikhil, you can unshare your slide so that we can see each
But you know, how big is the spleen?
So the patient has moderate splenomegaly.
How big is the spleen?
So it's till the umbilicus.
Yeah. So what is the difference in splenomegaly of NCPF, and what is the difference in splenomegaly of NCPF and EHPVO?
Sir, in case of EHPVO, the patient will usually have a massive splenomegaly.
Okay, now we have last 5 minutes left.
Other way around, NCPF usually has a massive splenomegaly.
Yeah. We have last 5 minutes to sum up. Can I request? I did not find Dr. Nitesh. He was logged in from Surat to ask few questions. If not there, Dr. Arunima, can you finally ask one concluding question from each examiner? So, Dr. Arunima, to start, last question.
So, what are the investigations you would do for this patient?
Ma'am, my investigations would be divided in a blood workup in which I would get an urgent hemogram run. At the same time, I would send it for blood grouping and cross matching and correct any anemia if present. I would also like to check for coagulation profile of the patient. Then I would like to check the liver function test to know the bilirubin level. If the patient has any features of liver
So
cell
that's
disease.
biochemistry. Okay, so
Yes,
after
ma'am.
blood investigation, what other investigation would you like to do?
Ma'am, after the patient is stabilized, I would like to get an ultrasound of the abdomen done.
What are the things you would look for in the ultrasound?
In ultrasound of the abdomen, I would like to know the liver echo texture. What is the state of the portal vein? If there is any thrombosis within, if there is any presence of collaterals. In the case of presence of collaterals, I would like to know the flow, whether it is hepatofetal or hepatofluval. I would like to know the status of the splenic vein, the portal vein, the condition of the spleen, if there is any the size of, as well as the presence of ascites.
So all this, how does it affect your management? What would be the management as a surgeon? How
Ma'am,
does all these findings affect your management?
Firstly, it would help me to find out how the liver function, how the liver is, if there is any cirrhosis in the presence of altered ecotexture of liver. Also, it would help me find out if the collaterals are there and how the splenic vein, portal vein, the renal vein, their dimensions are, in case I'm planning a shunt surgery for this patient later on.
Okay, Nikhil, we'll stop here. We'll stop here because I have just only 1 minute to sum up. Nikhil, you presented well. As the examiner pointed out, you could have dwelled on the differential diagnosis. The splenomegaly could be expanding. Someone is not muted. Please mute yourself. Splenomegaly in the endemic zone could be due to chronic malaria, kala azar. So you should have been a little open about it. Presuming that it's a portal hypertension with a GI bleed. So obviously you did discuss about investigation and management part. You need also to know this, what are the sometimes, so these days not the surgical option for a portal hypertension in terms of various shunt operations. At least you should name them, and also Sugyara procedures. I can see Dr. Puneet. I think we are finished, Dr. Puneet. We are giving you back on time.
Can I just make one comment?
Yes, sir.
Whenever you are giving, you say the portal hypertension cause whatever you want to say, extrahepatic or whether it is cirrhotic or whatever. The third thing is always telling in the diagnosis what is the child's grade of that, because that is going to decide your plan of treatment. So that should be coming as a diagnostic part. So just like in the cancer breast, you say the TNM staging. Similarly, in the portal hypertension, you will say that this patient child's grade is this one, because you are going to base your treatment on that. Thank you.
Yeah, point. That's a good point, sir. Okay, back to
Puneet,
Dr.
can I make a last point about?
Yes, Dr. Please do make.
I think I got cut off in between, but because of my connection, I guess. But Nikhil, I think you are a little confused about the paravenacle vein anatomy and why EHPVO does not have carpet medusae. If you wish, you can go back to the book, or you're free to call me or any of the senior examiners here. But clear that up because that is very important.
Okay, yeah. Time was the restraint with us, so
If you want to, Doctor, if you want to go ahead, you can, Dr. Rajneesh,
Tell
you can
them
go ahead.
Dr. Rajneesh, he answered that question for his benefit.
Nikhil, are you there?
Yes, sir.
Nikhil, the paravenacle vein joins the left branch of the portal vein, right? That part you know. Hello.
Yes, sir.
Yeah.
So if you have portal hypertension because of obstructing cause beyond that point, which means intrahepatic or post-hepatic cause, only then the paravenacle vein will dilate and produce caput medusae. If your obstruction is proximal to that point, which is in the portal vein, you cannot have caput medusae. Simple physics.
It's okay, sir. I thank all the moderator and the examiners for this session, and we can go ahead with the next session. The next session is distal radical gastrectomy. Unfortunately, Dr. Shabi is not available, as he is attending some urgent meeting there in his institute. So we'll go ahead with the next presentation, that is the case capsule at a lump abdomen, right iliac fossa. So for this, Dr. Sidesh is there. Dr. Sidesh, have you joined?
Yeah, I'm here.
Yeah, good morning.
But
Good afternoon, sir.
my other device, I want the laptop device, I want it to be enabled.
Okay, so you can enable your laptop device. In the meantime, we can have another examiner, that is Dr. Ashwini, Dr. Pradeep, Dr. Amit Srivastav, Dr. Vivek Srivastav, and Dr. Bhavesh. So I know that most of the examiners are there with us, and Dr. Pratik is there from our institute. Dr. Pratik, you are there? Pratik, are you there?
Yes, sir. Yes, sir.
So I request Dr. Sidesh to moderate the session.
Yeah, I can
You
do it on my mobile.
log in from the main webpage, otherwise the issue will.
मैंने 11 बजे करने का मन था वीडियो कॉल, फिर मैंने कहा ये सो ही रहा होगा ये। हाँ, दिन में पूरी कर लेता होगा नींद।
Hello. Request Dr. Sidesh to go ahead with the moderation.
Hello.
हाँ वही।
Yes.
हाँ, पहले तो सोच रहे थे कि आज शाम को आ जाए, मतलब ये हो रहा था, तभी कह रहे थे कल छोड़ दूं क्या, फिर मैंने कहा चलो कपड़े अपने पड़े हुए हैं उनको धुल दूं।
Good morning, everybody. Greetings from Mysore.
फिर आज शाम को भी कह रहे थे कि छोड़ दूं, फिर मैं वैसे तो मतलब समझ में नहीं आ रहा क्या करें।
Welcome the mic.
ये लग रहा है ठंड ना हो।
Other co-panelists on the session.
यहाँ भी है तो हाँ ना होगी।
I greet all the to Dr. Pratik.
यार बड़ी ठंड लगती है मेरे को।
Please go ahead.
Sir, am I audible? Are the slides visible?
अच्छा।
Yes.
ठीक है, देखते हैं, आते हैं, ये भी गए हुए हैं बाहर।
Hello.
अगर आते हैं तो फिर पूछती हूँ उनसे।
Yeah,
Hello,
Pratik,
Dr.
you can go ahead with the
आते हैं, वरना कल आ जाएंगे, आज शाम को देखते हैं जैसा वो बताते हैं। हाँ हाँ, कपड़े तो लानी, मैं कपड़े तो हाँ मेरे
Pratik, you go ahead with the presentation.
रख लूँगी, का लोअर रख लूँगी।
In today's PG Master Class, I am Dr. Pratik Jha, a third-year junior resident in Department
अबे बाहर गई उसको लेके अभी।
Sciences, BHU.
हाँ, वो अभी क्लास होगा उसकी।
Our patient was Mr. X, a 46-year gentleman from Siwan, Bihar, who was farmer by occupation, who presented in surgery OPD to achieve complaints of pain in the right lower abdomen for 2.5 months, and altered bowel habits for last 1 month. The pain in the abdomen, which was for last 2.5 months, was in the right lower
तो प्राइमरी में तो छोटे बच्चे आ गए ना, इनकी नर्सरी सब खुल जाएगा फिर।
and continuous in nature. There was no radiation.
चलो अच्छा है, खुल जाए लोगों तो
factors.
परेशानी करते हैं घर पे।
Taking oral medication to recover back. The patient also had complaints of altered bowel habits for last 1 month.
हाँ। of 3 to 4 है, मेरे तक है ना भी।
Intermittent passes of black color stool, which is melancholy and non-functional. There is no nighttime frequency.
अच्छा।
It was not associated with alternating bowel habits or fresh bleeding permission or early morning diarrhea or mucus discharge. There was no associated nausea, vomiting,
और दीदी है चली गई।
abdominal distension.
दीदी।
However, it was associated with easy fatigue.
कल चली गई थी।
But he
अच्छा।
was able to perform his personal daily activities.
जब कल आएंगे अगर आए तो।
There is history of loss of appetite, that is decreased intake from 4 chapatis in the initial period to 1 chapati exclusion, with unintestinal loss of weight, which was not observed. There is no history of fever.
शाम को दावत है। अच्छा, सही है। अच्छा। लल्ला सो रहा है।
Pratik, are you there?
ए हीरो।
Pratik, are you there?
बाल ऊपर काट दिए उसको, तेज लग रहा है।
Prateek, are you there?
अच्छा, हाँ बच्चों को काढ़ी देते हैं ऊपर को.
We disconnected due to some connection problem.
अच्छा, जय श्री कृष्णा, जय श्री कृष्णा. किस लिए बैठी थी? आऊंगी कल आऊंगी.
Dr. Prateek, can you hear us?
क्या छोटे कह रहा है क्या?
So give me 2 minutes. He is inside the department. Just give me 2 minutes. Unfortunately, he's not able to log in from his device. So device as such, he won't be presenting the history extempore. So I think he should go with the presentation.
अच्छा अच्छा, हाँ. और वो काम चल रहा है घर पे?
We can see. Dr. Prateek, please go ahead.
अच्छा.
Sorry for the inconvenience.
Cannot see his presentation.
Sir, I will present the presentation till the network issue rectifies. Yes. So, regarding the personal history,
तुमसे बात हुई थी ना कि छोटे रो रहा था, वैसे ही मैं इनको बता रही थी डॉक्टर साहब को, ठीक है. और अव्या बीच में लेटी मोबाइल देख रही थी, तो फिर मैं ऐसी बात बता के अपनी खत्म हुई, तो फिर बोलती है अव्या बिल्कुल नहीं थी, मतलब बात में बीच में से कहती है भेज दो उसको, ठीक रहेगा वो. और ये इतना हंसे, कह रहे तुम्हें क्या दुश्मनी है उससे, ये बताओ. छोटे से
in the right lower part of the abdomen for the last 2.5 years. Altered bowel habits with unintentional weight loss, which was not recorded, associated with anorexia. And
पता नहीं अब क्यों चिढ़ती है, कहती है वो मेरे को डांटता था. मैंने कहा क्या डांटता था, मजाक करता है वो तुमसे, तो कह रही है नहीं डांटता था, वो छोटे करके बोल देता था ना, हप हप वो चिढ़ जाती थी. तो वो मजाक में करता था, लेकिन ये समझती नहीं ना क्या. अब मुझे हंसी तो बात आई, मोबाइल देख रही है और हम दोनों आपस में बात कर रहे थे, तो बोलती है उसको तो भेज दो वहां से, अपने घर चला गया. अच्छा
no, sir, it is more than 60 years already. A patient in his late 40s with pain in the right lower abdomen, with significant weight loss, with anorexia. The working diagnosis.
ये पता है कुछ साल में ना बड़ा हो गया है थोड़ा सा, तो इस वजह से बातें आ गई है. लड़कों को होता ही थोड़ा बड़े हो जाते हैं तो. पहले छोटा था, बिल्कुल बोलता ना था.
Sorry sir.
What was the type of pain?
हाँ हाँ,
and it was mild in intensity, sir.
एक ये भी है, शुरू में शर्माते हैं, धीरे धीरे आदत खुल जाती है, झिझक.
So but in your case it is dull aching. And then you said patient had altered bowel habits. Once you said there is a altered bowel habits, then you said passage of blood in the stool was not associated with altered bowel habits. And then in the personal history you said there are.
हाँ सही है, खा लो जल्दी से रहता है. हमने भी बना लिया था आपने जल्दी. नाश्ते की जगह चाय वगैरह पी थी सुबह, फिर उसके बाद दाल चावल बनाते हैं.
These sir, there were no frequencies, increased frequencies. However, he had 2-3 episodes of blood mix with stool.
ओहो, हम भी आ रहे हैं.
Yes, Puneet. Sir, Ashwini is asking you.
पहले बताए होते अभी आ जाते हम तो.
The color of the blood.
What are you talking about? जय श्री कृष्णा.
Malina.
सही दावत खाई. हाँ जय श्री कृष्णा.
Hematochezia.
हाँ आ रही हूँ.
Right side colonic lesions.
Sir, no, sir. Generally, it will not present.
हाँ आ रही हूँ, दावत खानी आ रही हूँ.
Depends on the rate of bleed, isn't it?
Yes, sir.
Dr. Pradeep
पक्का
Saxena, sir,
बता
you are
देंगे।
here. You can ask any other question regarding the history wise.
अव्या गई है, पार्क में गई है।
He's not there. Dr.
पहले
Amit
बता दी तो
Srivastawa.
हम आ जाते यार दावत खाने।
Amit Srivastawa.
No, sir, it's fine.
तुमने बताया नहीं।
Why, sir? Ashwini sir.
तुम्हें भी नहीं पता थी?
No, now I want to ask him
हाँ।
one more thing. He shared points in favor of cure and points in favor of tuberculosis because they are two opposite diagnoses.
Yes, sir. So the points in favor of likely
क्या हाल चाल है?
tumor is or a malignant
जय श्री कृष्ण।
quality is
क्या हो रहा है?
the patient is 47-year-old. There is
खा लिया खाना?
dull aching pain for last 2.5 months, and it is associated with
अच्छा, जा रहे हो?
along
और
with anorexia.
कितनी माला करनी तुमने?
Yes, sir.
कितनी माला करनी?
Tuberculosis?
Sir, in tuberculosis,
अच्छा, अभी तुम 86 नहीं हो?
was that there was pain and there was weight loss. However, there was no history of fever.
अच्छा।
Rise of temperature with night sweats or
मन नहीं लग रहा आपका?
tubercular intake. Sir.
Why do you think it is tuberculosis? Because they are just a weight loss. They are not.
चलो नहीं, रेगुलेट ही रखना, ठीक है? ये नहीं कि एक दिन साथ छोड़ दो, बीच में छोड़ना नहीं, ठीक है? कोई दिन रेगुलर करते रहना।
Shall we go ahead, sir? History.
Yeah.
I have a question. What is the classical feature of a subacute obstruction?
ये दावत शाम तक चलेगी, ये बताओ।
Patients with this type of disease. Intestinal obstruction.
अन्नो हम लोग कल आएंगे, हमारे लिए रख लियो। हम लोग कल आएंगे, कल रख लियो फ्रिज में ढक के।
I think we are getting.
और किसी के सामने, मेहमान के सामने मत बोल दियो। बुआ आ रही है कल।
Can you hear me?
We cannot hear you.
I am unmuted.
मैं आके खाऊंगी कल। चल तू खाना खा ले, ठंडा हो जाएगा फिर, है ना?
Is not audible.
लल्ला जग जाए ना तो करेगी बात।
Is not audible. So just for the
Bye.
information of the postgraduate students, so you have a classical feature of subacute obstruction in patients with ileocecal tuberculosis. They will have colicky pain, abdomen, along with that is audible bowel sound and ball rolling movements. So these are classical pictures, though they may not be present in all the patients. So, but we need to positively look in for these points in the history. So, which obviously this patient doesn't have. He has a dull aching pain. So, which we need to take in point in the mind when we say this patient does not have features of obstruction as such at present. Okay. With your back, go ahead.
Go ahead.
So, Dr. Bhavesh Dave, sir,
Yes, sir.
Can you add on anything, sir, at history?
No, I don't want to ask. I just wanted to say Dr. Jha to relax and reveal result.
Yeah. Okay.
That is technological disaster likely to happen everywhere.
It will happen. We need to get adopted to it.
Yeah.
To compliment Dr. Puneet and his team, they have done a wonderful job.
Yes.
They have been 2013 onwards, they have been doing, I heard the inauguration, they told there used to be around 200 people in the audience. But today,
Yes,
500 people, that only shows we have learned so many things because of this pandemic.
Yes, sir.
Even in future, if we are able to get physical meetings organized, I think this virtual parallel or a hybrid part of meetings will continue, I think. So the benefit, I think we have learned quite a lot out of this pandemic. We are sure they can reach out many, and also what you can see in physical meetings, the number of faculty used to be limited because they had to travel all the time, the risk of traveling, the expense used to go up. Now today we can have any number of faculty. Say I have become faculty for so many, even without being a faculty, I am learning so much from these meetings. So that is a real advantage. Puneet, are you back? Sir Amit, you want to add?
Sir, I am there.
For the benefit of postgraduates.
Hello.
Yeah. Meanwhile, I just want to add on. See, left-sided colonic lesions, they present primarily with constipation, whereas right-sided colonic lesions, they present with altered bowel habits, sometimes alternating with constipation and diarrhea. So this has been described. So diarrhea part is because whenever there is a subacute obstruction which gets countered, suddenly there will be gush of fluid. So naturally they will present with relief of partial obstruction. They will present with increase. And also because of the irritation of the colon, the lesion, there will be a tendency for increased frequency. The reason is probably because of the bleeding which can be associated, the patient will continue to have more frequency. These are the reasons which are given. So, Amit, you want to add on anything?
Yeah, sir. Just the color of blood, he has specifically mentioned black colored stools.
Okay.
So unlikely to come from colon.
Yeah. That is one more point I just wanted to add. Depending on the site of the bleed and also rate of bleeding. So even very rarely distal small bowel and right side colonic lesions, if the bleeding rate of bleeding is very slow, they can have little altered blood, not classical melena. Black stools are not seen. Exactly, I agree with you. Okay. Can you have more information?
Shall I proceed with the examination, sir?
Yeah, you are there back. Please go ahead, Puneet.
Yes, sir.
Stay
Now,
calm as suggested. So
yes, sir.
calm, go ahead. Nothing left. Don't worry.
Now, proceeding with the examination, I informed our patient with informed consent in the daylight with adequate exposure in the presence of a male chaperone. The patient was lying comfortably on couch with a height of 170 centimeter, a weight of 63.5 kg with a BMI of 22 kg per meter square. Oral hygiene was poor with tobacco stains and caries tooth, and the kernel status was 70, that is ECO3. He was afebrile with a pulse of 108 per minute in the right brachial artery, BP of 120 by 64 mmHg, and a respiratory rate of 16 per minute. And the head-to-toe examination, pallor was present. However, no icterus spinalis, clubbing or general lymphadenopathy or pedal edema was noted. The hydration was adequate. Now, examination of the abdomen. On inspection, the abdomen was mildly distended with a vague fullness noted in the right lower abdomen. The umbilicus was centrally placed inverted. All quadrants were moving proportionately with respiration, and the overlying skin appeared normal. There was no visible pulsation, peristalsis, venous engorgement, or scar mark. The hernial sites appeared intact. There was no flexural deformity at the hip joint. On palpation, the temperature was not raised, there was no tenderness, and a lump of 6 into 4 centimeter was palpable in the right iliac extending to the right lumbar and umbilical region, which had irregular surface, irregular but well-defined margins, non-tender, firm to hard inconsistency, non-mobile, and on leg registers, a decrease in size. It was not bimanually palpable or palatable, and the liver was not palpable. There was no other lump or organ. Liver dullness was appreciated from fifth intercostal space with a liver span of 12 centimeter in the right midclavicular line. On percussion over the lump, it was dull. However, there was no evidence of fluid in the abdomen. On auscultation, the bowel sounds were normal in frequency and character. The bilateral testes were normal and the hernial orifices appeared intact. On digital rectal examination and proctoscopy, anal tag was present at 6 o'clock position. The anal tone was normal. No growth or pelvic deposits could be felt. Fecal staining of finger was present without any blood stain. Prostate was enlarged, which was grade 1 and formed. No spinal tenderness or deformity was noted. Renal angles were clear, non-tender, and tympanic compensation. There was no palpable left supraclavicular lymph node. The systemic examination was essentially within normal limits. So summarizing my case after a detailed history and examination, our patient was a 46 years gentleman presented with dull aching continuous pain in the right lower abdomen for last 2.5 months and associated with passes of loose stool with occasional passes of black colored stool for 1 month with associated loss of weight and appetite with no history of fever. On examination, there was tachycardia with pallor with an intra-abdominal lump of 8 to 6 centimeter which was non-tender, non-mobile, hard, palpable in right iliac fossa with no free fluid in the abdomen or hepatomegaly. The DRE and bronchoscopy examinations were assigned. On the basis of the history and physical examination, my working diagnosis would be carcinoma cecum with differentials being ileocecal tuberculosis and Crohn's disease.
Okay, thank you, Puneet. That was fairly good presentation, but I would like to say you have missed out one very important examination, that is examination of the scrotum. More so in a patient with a mass in the right iliac fossa. Why do you think so? Is it important?
Sir, it may be a primary testicular cancer which has metastasized.
No metastasis. No, you have done two mistakes now. I will let you, because the short of time, testicular malignancy does not spread to iliac nodes. It goes directly to the para-aortic. You should know the lymphatic drainage correctly. So the para-aortic nodes. So if at all you need to, so the reason is a malignancy in a undescended testis. Do you Puneet, agree that undescended testis is a site of increased malignancy?
Yes,
sir.
So in all patients of mass abdomen, your examination is incomplete without scrotal examination. More so in a patient with right iliac fossa mass. Would you agree that?
Yes, sir. I do agree.
Now, I would like request Dr. Pradeep Saxena sir, if he is there, to ask him about the palpation part of it, or examination part, sir. Any questions, sir?
You are mentioning
Dr. Pradeep Saxena sir?
Yes, I am there.
Yeah, please go ahead, sir.
Dr. Pratik, can you tell me more about the palpatory findings, the movement of the lump?
Sir, it was.
And the way you can discern it from pelvis and adjacent bone.
Sir, it was not.
Go ahead, Puneet, answer.
It was non-mobile, sir. The lump was not mobile, sir. Both in the upper longitudinal direction as well as the transverse direction, sir.
Okay, yeah. And you could feel the lump separate from the iliac crest.
Yes, sir. The lump.
The lower aspect of the lump was also.
Yes, it was fed. The lower half was also.
Pratik, if the lump is fixed mass, it is not mobile. What do you think is where is it fixed to in a patient with a lump in the right iliac fossa?
Sir, most likely it is originating from ascending colon, which is retroperitoneal in location. That is why it is not mobile.
No. I think colonic masses will have mobility which is restricted. It is not that they are not totally immobile. If it is a fixed mass, you have used the word fixed mass in the right iliac fossa.
Yes,
what is that fixity to? You expect it to be fixed to?
It may be fixed to the retroperitoneal tissue, sir.
Yeah. No, it should be, we have to expect it to be fixed to the bone, isn't it? What bone?
It could be to the iliac bone, sir.
So your diagnosis totally will go to something else.
Yes, sir.
You need to be a little careful when you say. I agree, sir. Pradeep, sir?
Yeah.
Yes,
it
sir.
might be a lump rising from the iliac bone itself.
Yes.
Okay.
Vivek Srivastava, sir, if you are here, you are not asked him any question, you can go ahead, sir. Vivek, sir?
I want to ask one question. Since we are talking about fixity, I want to know whether the mass is intraperitoneal or retroperitoneal on the basis of his examination finding.
Pratik, answer that.
Examination findings, sir, it is an intraabdominal lump. However, I could not be able to clearly specify whether it is a intraperitoneal or a retroperitoneal mass.
So you are saying it is intraperitoneal. And you are saying it is arising from the ascending colon. So they are totally opposite. So how will you differentiate clinically between intraperitoneal and retroperitoneal?
The retroperitoneal masses are fixed and they are not mobile, sir.
So our mass is also fixed and it is not mobile. And your diagnosis is carcinoma cecum. So they are actually opposite now.
Yeah, I think Pratik, the point is you were telling retroperitoneal masses are not mobile. That is not a right approach. You see, kidney is retroperitoneal or intraperitoneal?
Retroperitoneal.
Kidney masses will it not be mobile?
Yes, sir.
So that is not the answer. See, mobility is different from the plane of the swelling. Even retroperitoneal masses can move, but you need to know what state they are arising from, anatomical structure. Suppose the bony swelling from the iliac bone, it is not be obvious. Obviously, it is coming from a spine, it will not be mobile. So you should know about these things. So, shall we go ahead? Sir, Vivek sir doesn't have anything. You'll ask
Yes,
Dr.
sir, please.
Sir, I
We can
need
go
to
ahead.
say.
Yeah.
Yeah, Bhavesh.
Yes, sir. I need to definitely to tell this third year resident that whenever he proceed for an example, it should be within the protocol. When the palpation starts, he must mention about the examination of the whole and then immediately followed by whether it is intraperitoneal or extraperitoneal.
Okay.
He should not miss this particular point.
Okay, you should always make a point to mention is your okay.
Just one point I would like to add on what Dr. Siddesh had said regarding the testes. So it is important. He had mentioned this total examination, but just one point. If he would have mentioned that testes could be normally felt in the right scrotal sac.
Absolutely.
So it would have covered it. He mentioned
Absolutely.
hernial sites. He mentioned other things, but you should have also mentioned that testes was normally felt in the right scrotal sac.
Yes, I had mentioned that, sir, in the external genitalia examination.
Okay, so maybe I skipped that.
Okay, go ahead, sir. What about now with a working diagram? What is the most important point in this, which is pointing towards malignancy? Dr. Pratik, can you tell us? Other than the history of loss of appetite and loss of weight,
a hard lump.
Examination.
A hard lump.
Hard mass, hardness of the mass. One. Number two, general physical examination. Anything particular?
Pallor, sir.
Yeah, pallor. See, that is you need to keep. If the pallor is very significant, we need to keep a possibility of malignancy. Okay. Shall we go ahead, sir, for investigation? Anybody wants to ask something more?
Yeah, yes, I want to ask.
Yeah.
In differential diagnosis, he has kept two differentials: ileocecal tuberculosis and Crohn's disease. So, if you are suspecting tuberculosis, he should examine the chest also. There should be signs of tuberculosis. Then axillary lymph nodes. Sometimes you have axillary lymph nodes enlarged, and especially in our country, tuberculosis is very common. Again, about Crohn's disease, he has not explained the features of Crohn's disease.
Sir, in the
Why he thinks the Crohn is also a differential diagnosis? He should be able to support his diagnosis.
Absolutely. Pratik, you cannot just put one as one of the differential diagnoses as Crohn's unless you have one point at least in favor. What did you have?
Sir, the patient had a history of pain abdomen as well as intermittent pain abdomen as well as he has history of loose screws. So that is why distant differential.
What lesion of Crohn's can present with mass, hard mass? Can you just let us know? What lesion in the bowel can produce a mass in Crohn's disease?
Crohn's ileitis with which may transform into a malignancy can present as a hard mass.
No. Then the diagnosis will be malignancy. It's not, isn't it? So don't say that. What are the common complications which can present with mass? Can it perforate?
Yes, sir.
Yeah, stricture and perforation and fistula. So there can be an inflammatory mass. Small bowel, the omentum and lymph nodes. So together it can form an inflammatory mass. So that will be a different picture altogether. It's not this hard mass which is not very tender. It will be acutely tender as well, isn't it? Yes. So coming to ileocecal tuberculosis, what are the type of tuberculosis which can present with mass in the intestine?
A hyperplastic tuberculosis can present with a mass in even peritoneal tuberculosis can present with diffuse abdominal discharge.
I'm sure our co-examiners will be interested in asking the sign dance. Or I would like to ask emptiness in the right fossa. What do you feel about? What do you reason behind this?
Sir, because of this stricture, the cecum gets pulled up, and that is why the right fossa may be.
Suppose somebody says it could be a kidney mass. How will you say this is not a kidney mass?
Sir, the kidney mass will be
unascended.
Kidney mass will be bimanually palpable and palatable, sir.
No, that is an unascended kidney, no? So we need to percuss in the loin. If there is a loin dullness is present in the region of the, so the kidney is there in the normal position. So that will be an indirect evidence. So that is, these are the points you should know clinically. Yes. It's not a definite evidence, but though. So go ahead with the investigations, sir.
Yeah. Sir, I would like to raise one point that you should keep in mind chronic
recurrent intussusception or a chronic intussusception, but the patient would be much different presentation. They will have, okay, anyway, you need to keep as a differential diagnosis of right atrial fossa. You can go on enlisting lymph node mass, starting from that, unascended kidney, I mean, so many things you should know by that, but you cannot keep everything as a diagnosis. You have to stick to the findings and your history. Okay. So Pratik, you go ahead with the, how will you further evaluate in this patient? Keeping this as a working diagnosis? Go ahead.
Keeping this as a working diagnosis, my plan of investigation would be first to confirm the diagnosis. I would do ultrasound of abdomen as an extension of my physical examination. By doing ultrasound, I would be able to know the organ of origin of the lump. And in this case, it will also tell us if there is any associated ascites or any liver metastasis. Now, to confirm the same, I would plan for colonoscopy with biopsy. That would give me the histological diagnosis. If once the diagnosis is confirmed, now I would like to stage the disease. Now, in order to stage the disease, I would like to do a CCT of abdomen and pelvis along with a chest X-ray or HRCT thorax. That would help me to stage the disease. And for local
you are going little bit fast. This, don't you like to do a basic lab investigations? Would you not get try to get a hemoglobin investigation at least and a urea creatinine before doing a CT scan? Why is it important?
Because contrast enhanced CT may lead to contrast nephropathy, sir. Therefore, RFT renal profile is important before we go for contrast enhanced CT.
Okay. So your plan of action is to confirm the diagnosis, number one, and then number two, to if it is malignancy, then to depending upon that, you have to stage the disease. Third, most importantly, you should do also to look for the comorbidities and associated illnesses, and also to look for, you would like to do other investigations with respect to the condition of the patient. So Ashwini sir, you can take it forward from here regarding investigations.
You're right. He should do basic investigation first.
Yes.
Renal function is very important before ordering CT. Or before that, if he's suspecting carcinoma, he should do. He should not miss stool or gall blood. They are basic investigation. They should be part of the workup. Okay. Yes. After, once you have staged the disease, then what will you do?
Once the disease is once.
Sir, I would like him to tell us what are the findings you would like to look for in an ultrasound scan. What findings you get in bowel masses?
Yes.
This intussusception, what finding you will get? Is there
in intussusception, sir, we may see a target sign wherein the one intersusceptum may be into the intussusceptions. That may appear as a target sign with edema surrounding bowel, and decreased vascularity may be there, sir, if it is not.
Okay. What about in malignancy? What will you see? What would you like to look for in malignancy?
Sorry to intervene. Yes, we are talking about intersusception. We are talking adult intersusception. So you are not just focusing on diagnosis of intersusception. You are interested in looking for the cause also. So cause is very important on it.
Very good.
What can be the cause, Dr. Patti?
The cause can be, sir, it can
in
be
adults, especially adults. We are not talking about children.
Yes, sir. In the adults, sir, cause can be intraluminal growth. That may be.
So basically, you are looking for a lead point. Yes. That is very important because if you are ordering any investigation, you should know what to look for.
Yes.
Then only you will be able to see it.
Yes.
So ultrasound will show you interception. What else? What else ultrasound can tell you?
What else ultrasound?
In your patient.
In our patients, sir, it will say whether the pericolorectal tissues or the fat planes have been involved, along with whether there is ascites, whether there is any lesion in the liver, sir.
What about lymph nodes? You cannot look for the lymph nodes there?
Yes, sir. It will tell about the lymph nodes, but not more as sensitive or specific compared to
as CT. Okay, right. Okay, good. And also, ultrasound can tell us whether there is anyway. So let us go ahead with the further investigations. Laboratory investigation, more particular about liver function test, which you have not mentioned. Would you like to do a liver function test in this patient?
Yes, sir. Liver function test is important. In the past, liver function test with raised AST, OST, alkaline phosphatase have been implicated as a tool that may indicate liver metastasis. However, as per present guidelines, sir, it is
No, that's okay. That is one of non-specific, but it can be there. But more important, I would like to know about nutritional status. Anything part of it?
Yes, sir. In the nutritional status, the liver function test will also tell about the total protein as well as the albumin.
That is very important, isn't it?
Yes.
Fine. Now let us go ahead with your further investigations. So you have done is colonoscopy. Let us say, I don't think you have access to the findings. Colonoscopy, how would you, appearance-wise, diagnose a malignant lesion?
It depends on the right side, sir. Generally, the lesions
We are talking right side.
Yes, sir.
Pratik.
The lesions may be serrated, or there may be a proliferative growth, and in the endoscopic finding, mucus discharge or bleeding may be noted there.
So irregular,
Proliferative,
ulcerative lesion. It can be circumferential or it could be polypoidal. Depends upon the primary lesion which it has come from, isn't it? So we need to know that. And then whether it is obstructed or not obstructed, you'll know. And what is the major advantage of doing colonoscopy is you can take biopsy at the same time.
Yes.
Okay. Dr. Pradeep sir, you want to take it further? Any other thing you want to add on? Pradeep Saxena sir, you are not there. Amit?
No, sir.
Okay.
I would like to discuss CT scan. Why he is not having a CT scan before?
Yeah, he doesn't have it, I think, with him. Do you have an access to a CT scan? Can you put up pictures if you have?
No, sir. Sorry, sir.
It doesn't matter. You can tell us what you see in a CT scan. Doctor wants to know. Sir wants to know what is a CT scan.
In the CT scan, we would like to know the T stage of the disease.
Okay, very good.
Up to what level is it infiltrating? Would also like to see whether it is infiltrating the pericolorectal tissues, whether the fat planes are maintained, whether the adjacent structures have been inflamed, whether there is any omental or peritoneal metastasis. And along with that, if HRCT of thorax is done, that could also tell us about the any pulmonary.
No. Confine to abdomen first. There's only other points you need to look for. You're still talking about nodes.
Yes, sir. So it will tell us about the T stage. It will say about the locoregional lymphatic metastasis. It will also tell about whether the adjacent ureter and the retroperitoneal tissues have been infiltrated.
You should be specific. A lesion in the right side colon. What are the structures you expect it to infiltrate?
Sir, the right ureter and kidney as well as the retroperitoneal tissue are the ones that may be infiltrated.
Right kidney is higher. We are talking about right iliac fossa. You are talking ureter, right, fine, correct. Anything else? Gonadal vessels?
Gonadal vessels, yes, sir.
I am sure you would be interested, a surgeon who is going to operate would be interested in his proximity to the duodenum.
Duodenum, yes.
Duodenum. See, these are the three structures which can come across when you start mobilizing the colon. So you should know gonadal vessels, ureter, and the third part of the duodenum. Ascending colon, when it goes more proximally, you would expect the Gerontophagia and kidney. Okay. All right. Then go ahead. What else other than nodal status? Liver also.
Liver.
Important to know liver metastasis, CT scan. What all the points you would like to know in CT scan of liver, even if there is metastasis?
We'd like to see whether the liver metastasis is single or multiple, whether it is in a single lobe or bilobar, whether the single lobe is involved or both the lobe of the liver is involved, and what amount of the tissue of the liver is involved, whether it is resectable or not.
So in other words, you would like to know the number of the presence of secondaries. You would like to know whether it is single, multiple, or how many, and segments which are involved, size of the lesions as well, and proximity to major vessels. Reasons, the points would like to look for in CT. Okay, and then what else? Go ahead. Anybody wants to ask something more, sir? Ashwini, sir?
Yes, he has missed one very important basic.
Yeah, I have also got biochemical and other things.
No, before that, before CT scan, chest X-ray, which is very important nowadays. Chest X-ray, your diagnosis is tuberculosis and malignancy. And especially in COVID era, chest X-ray should be done before doing these major investigations. Yes.
Start.
Okay. Dr. Suresh, I request to wind up in 5 minutes time.
Yeah, within 5 minutes. Okay. See, Pratik, I would like to tell you, you have missed out one biochemical parameter with respect to the disease per se in long-term prognosis. Would you like to do before planning for treatment?
Yes, sir. The investigation before treatment intervention, that a baseline carcinoembryonic antigen level would be.
Yeah, you need to do it beforehand. Even after it confirms the diagnosis of biopsy, once it comes positive, you need to do a CEA pre-operatively. What do you need to do pre-operatively, Pratik? We'll go ahead with the treatment next.
Sir, because a baseline investigation would help us to monitor the patient later in the follow-up. A significant serial increment in the CA level after treatment would signify that.
Fine. First of all, we would like to know whether it is elevated. There are certain segment of patients where, subset of patients where even in the malignancy, they may not have gone up. Yes. So in those patients, it is a poor indicator for follow-up in the future. So that is one of the reasons. Okay, that's right. Let us cut short now. We have less time. Let us go straight to the treatment modality, except that this has been a malignancy proven. What type of malignancy you get, Pratik?
So these are generally
adenocarcinoma. Let us say this was a moderately differentiated adenocarcinoma, T3, N1 disease, no mets in the liver. What is your plan of action? I want Vivek to take it forward from there.
Yes, sir. I would optimize the patient and I would plan to explore with a plan of right hemicolectomy in mind and with intraoperative as well as nutritional assessment, whether to go for the anastomosis at the same time, sir. So once the patient is explored, I would again check for any ascites, any peritoneal or omental metastasis. And once the intraoperative findings are confirmed, then I would like to go for right hemicolectomy.
Vivek sir, is it okay? You want to ask him something?
Hello, Pratik?
Yes, sir.
What are the indications of inoperability of a carcinoma cecum or ascending colon? Can you enumerate few?
Sir, if the ureter or the duodenum has been infiltrated, if the retroperitoneal tissue is infiltrated, and if the other distant metastasis is present rather than isolated liver or pulmonary metastasis, along with peritoneal and peritoneal deposits or mental deposits or ascites, sir.
Okay.
It's not R0 resection what I'm talking. It is the inoperability means the duodenum, the ureter, the retroperitoneal muscles, if they are infiltrated, then it is inoperable. That is resectability what you are talking. R0 resection is possible or not. Okay, go ahead.
So Pratik, you need to know what is resectability and operability. These two are totally different. We need to know about the difference. Let us not waste time now. See, Pratik, I wanted to know, you have not added the term right radical hemicolectomy. Right hemicolectomy just per se doesn't convey the complete meaning what you are doing at in a T3 N1 lesion. when I asked for T3N1 lesion, the time nomenclature should have been right radical inclination. What is the difference? Let me know.
The radical would involve the surrounding tissue, the perirectal tissue that has been involved.
No, not perirectal. We are talking about right colon. So
the surrounding the pericolon.
Important than the pericolic tissues. What is most important?
Most important
radicality
is the lymph, the total mesocolic excision.
No. You have to, where do you ligate the vessels? Which are the vessels you ligate? That's where we are coming to.
Sir, in this we'll ligate the ileocolic artery, the middle colic artery, and the right branch of the middle colic artery and the right colic artery.
Yeah, where do you ligate them?
Sir, we ligate them close to their origin, sir.
Yeah, at their origin. You
Yes,
should. Why do you think that it has to be ligated there?
Sir, because the maximum number of lymph nodes could be, sir, resected out by this.
Now that is what is the radicality, isn't it?
Yes, sir.
What about the omental attachment to the right colon? What is the level of colon you need to resect? Transverse colon. These are the points. We'll decide whether it is a radical colectomy or not.
Sir, in the radical, we'll do the right 2/3, and we'll also involve the left branch of the middle colic artery.
You ligate left branch or right branch of the leg?
Right is to be, sir, ligate, right branch is to be ligated, sir. I mean, extended,
extended, we are talking about extended. No, we are talking about cecal lesion. Okay. Suppose that this patient has a ureteric involvement, what will be your line of action?
Suresh, I request you to please summarize.
Okay.
Finish it here so that we can have a session. Yeah.
Thank you. Puneet, you just answer that. Then we will go end this session.
Sir, if the ureter is involved, if a hemicolectomy is done, what we can do is we may go for reimplantation of the ureter with a body flap, or we may go for retro-ileostomy or retro.
Yeah. So today, if you have a good surgical assistant and a knowledge, you can go ahead with the radical surgery in spite of ureter. That is the message I wanted to give you. So anyway, thank you, Pratik. I think we had a good discussion. There are little technical hitches in the beginning. Thank you for my panelists who have contributed. I think Amit had to leave in the middle as it appears. So Puneet, it was nice that you gave us an opportunity to be part of it. And I think right iliac fossa mass is a very important topic which often comes as a long case in your exam. You need to be careful. History is very important. Try to dig into the history of the nature of the pain. What is, whether it is a, so that is very important. The type of bowel disturbances, and try to dig into the history. Don't forget to ask about the descent of the testis, even at the history level. And then urinary disturbances, hematuria, never forget to ask these. So they can be associated, urinary disturbances. So this may give a clue about your diagnosis. So history is very, very important, even in any case, and especially in a case with a mass in the right iliac fossa. And remember, this mass can just turn out to be a lymph node mass also as well. So we need to be careful in examining the generalized lymphadenopathy in these patients. So your clinical examination should be systematic as suggested by our colleagues here. You should not miss out, go systematically as been taught in your first year of your clinical posting in undergraduation. That will not change in mass abdominal examination. So be very careful, go systematically so that you will not miss. So I'm sure intraperitoneal and extraperitoneal, it is sometimes very difficult. It's not very important. Nowadays, examiners don't harp upon it, but some of the examiners may ask you, how will you differentiate between intraperitoneal? You need to know about the findings. Then of course, thank you. And your treatment options, today you need to be ready with telling about their liver resections in selected cases, what type of resection, and different modalities. It is segmental resection or isolated metastatectomy. So you should be ready to answer all that. And follow of action of all these patients, do colonic lesions like polyposis, what will you do in this, and familial screening, things like that. So you need to be ready to answer all these questions. Thank you again for this opportunity, Puneet, and the organizers, and thanks to my co-panelists. Thank you, sir.
I thanks Dr. Sudesh for moderating the session, and I thanks all the examiners and the panelists for this session. Now we have a next session that is on case capsule, lower abdomen. I think Dr. VK Bansal he has joined. Can I see Dr. VK Bansal?
Yeah, Puneet, I'm there.
Good afternoon, sir. So you are the moderator for this session, and we have other panelists and the examiners, Dr. Rachna Gupta, Dr. Ganesh Babu, Dr. Narasimha Swami, Dr. JP Sharma, and Dr. Rahul Khanna. So we have a panelist with us, and I request Dr. VK Bansal to please moderate this session. We have Dr. Jasmine Dahal from New Delhi. She will be presenting the case.
Thank you, Puneet, for giving me this opportunity to moderate this session. I would welcome all the examiners and the resident presenting the case. So I'll just request all the examiners. I think we'll go step by step in the sense that I think let her complete the history first. Then we can ask her some questions. We can have some discussion. Then let her complete the discussion. Then we can have some further discussion. Complete the examination. Then we can have some further discussion on that. So I think Jasmine, you can start.
Good afternoon, respected teachers. I'm Jasmine, and I'll be presenting a case on lower abdominal lump. So we have a patient, Mr. X, a 44-year-aged male. He's a resident of Faridabad in Haryana. He's a clerk by occupation, and he's educated up to the 12th standard. He presented to us with two chief complaints of lump in the lower abdomen for past 4 months and pain in the lower abdomen for past 2 months. Elaborating the history of presenting illness, he was apparently asymptomatic until 4 months back when he noticed a lump in the left lower abdomen. He could not define the size then. He described it as an ill-defined lump, which was initially gradually progressive in size, but showed a rapid increase for the last 2 months. This lump, he says, is also associated with pain over the lower abdomen and constipation and increased frequency of micturition for the past 2 months. However, there are no overlying skin changes on the lump. He gives a history of pain in the left lower abdomen for 2 months. It was insidious in onset. It was a constant, mild, dull aching pain with no significant aggravating factors. And he gives a history of it being relieved on oral analgesics. However, there is no history of any acute or severe pain episodes requiring hospitalization. He also gives a history of increased frequency in micturition for the past 2 months. There is no associated history of any reduction in the urine output. There was no dysuria or burning micturition or pain on micturition. There was no history of any passage of clots or blood in urine. There was no history suggestive of lower urinary tract symptoms like nocturia, hesitancy, or poor stream of urine. There was no incontinence, and there was no history of swelling of feet. He also gives a history of constipation for the last 2 months. He describes it as he used to pass stools almost twice daily, but now the frequency has reduced to once in 2 to 3 days with an increase in consistency of stools. He complains of passing hard stools, and there is no history of this constipation being alternating with diarrhea. There is no history of tenesmus, and there is no history of passage of blood or mucus in stool, and there is no history of passage of black tarry stools. There is no history of significant loss of weight or appetite. There is no history of fever, evening rise of temperature, or night sweats. There is no history of features of acute intestinal obstruction like pain, distension, vomiting, or obstipation. There is no history of lump elsewhere in the body, and there is no history of pain or swelling in the scrotum. There is no history suggestive of features of metastasis. He is not a known diabetic, hypertensive, or hypothyroid. Coming to the past history, there is no history of previous surgery. There is no history of tuberculosis or contact. There is no history of heart disease, no history of radiation exposure. There is no history of chronic medication intake, and no history of any drug allergies. Personal history, he's married. He consumes a mixed Indian diet. He gives a history of cigarette smoking, quite significant, of 25 pack years as of now. There is no history of tobacco intake. There is history of occasional alcohol intake. There is no history to suggest sexual dysfunction, and there is no history of high-risk behavior. Family history, he belongs to average socioeconomic status. There is no history of tuberculosis in family and no history of any malignancies or chronic illnesses in family. So summarizing my history, Mr. X is a 44-year-old.
Can you just hold on? Can you just hold on?
Yes, sir.
Can you go back to the previous slide? Okay.
Yes.
Okay. So I think she has told the history. So maybe I'll request all of you one by one to ask her what has she missed in the history and whatever you want to. Maybe Dr. Rahul can start. Dr. Rahul.
It was a good presentation, Dr. Jasmine. I would like to know whether there was history of spurious diarrhea.
No, sir. There was no history of any diarrhea.
No, spurious diarrhea.
No history of spurious diarrhea. No history to suggest mucus and stools or any diarrhea, loose stools, or increased frequency of stools. Yes.
And any history of crampy abdominal pain, festive of increased peristaltic activity?
No, sir. There was only a mild, constant, dull aching pain associated with the lump.
Associated with the lump?
Yes.
Okay. And no history of colicky pain?
No, sir.
Okay. And what about the, did the lump decrease after micturition?
No, sir. There was no change in the size of the lump associated with micturition.
There was no change. Okay. Thanks. You can proceed with your summary and all.
So, summarizing my history, Mr. X is a 44-year-old male with no comorbidities who presented with a rapidly progressive lump in the left lower abdomen for past 4 months, which is associated with a constant dull aching pain and with a recent history of constipation and increased frequency of micturition for the last 2 months, and there is no history to suggest metastasis. So based on my history, I would like to present the differential diagnosis, which include involvement of the possible involvement of the genitourinary tract or the left colon. So possibilities could be a tumor arising from the left colon, including the rectosigmoid and the descending colon, or it could be a tumor from the retroperitoneum, given the absence of any bowel symptoms, and also taking into consideration the symptoms, urinary tract symptoms like increased frequency of micturition. It could be a tumor arising from the bladder or prostate, or it could be a tumor which is involving the bladder and prostate and not primarily originating from there.
Would the examiners like to discuss the differential diagnosis, or you would like to look at the examination also and then come on to the differentials?
I think we can proceed to the examination because history-wise it is not pointing towards a specific system, whether it is genitourinary or gastrointestinal. So that is not being clear on the history. So I think we can proceed with the examination.
Yeah, I just wanted her to present the summary and the differential diagnosis at this stage, because in the exam, many of the examiners after the history, they would just ask the candidate to summarize the history and then ask the candidate that what do you think this could be? So that is why I just asked her to include this differential diagnosis and her thinking at this point of time, so that the students are not caught off guard, because it is sometimes the history is too large and the examiner may not be listening fully to it, and then at the end of the history, just to increase his knowledge, he says, okay, tell me the summary. So the candidate is caught off guard. So I think it is a good idea for all the postgraduates, whenever in the exam, to write a summary of the history. If it is asked, then you should tell it. If it is not asked, then you may not tell it. Do others agree with me?
I think it's all right, sir.
Okay.
Proceed for examination.
Sorry?
Proceed for examination, sir.
Yes, sir. Yes,
okay.
Proceeding to examination, after taking verbal consent from the patient in a well-lit room and while maintaining adequate privacy of the patient. First, general examination. Patient was comfortable and talkative. He was moderately built and moderately nourished. His BMI was 20.9 kg per meter square. His Anovsky performance scale scale index was good, about 80%. There was no pallor, icterus, clubbing, generalized lymphadenopathy, or pedal edema. The patient clavicular fullness, spine and weight were normal. Vitals of the patient were stable. His temperature recorded 98 degree Fahrenheit, pulse of 78 per minute, BP of 170 millimeters of mercury, and respiratory rate of 80 per minute. His systemic examination was essentially normal. Coming to examination of abdomen on inspection, which was done in supine position after exposing the patient from nipple to mid-thigh, abdomen was flat. Fullness was noted in the left iliac fossa, hypogastrium, and left lumbar region. All quadrants were noted moving equally with respiration. Umbilicus was central and inverted. There was no visible peristalsis. There were no scars or skin changes. There was no expensile cuff impulse at the umbilicus or hernial orifices, and the fullness which was noted in the left iliac fossa, hypogastrium, and left lumbar region appeared to be less prominent, performing the Carnet's palpation. The abdomen was soft and non-tender. A single large lump, as is shown in this diagram, was palpable in the hypogastrium and left lumbar region, measuring 15 by 12 centimeters, and it was less prominent in its legs and chest. This lump was non-tender, firm in consistency, and had well-defined superior and ventral borders. However, the inferior and medial borders were not palpable, giving the impression of pelvic origin of the lump. And this lump showed no mobility, and it had an irregular surface. Apart from this large lump, there were no other palpable lumps. There was no hepatosplenomegaly, there was no renal angle fullness or tenderness, no expensile cuff impulse at the hernial orifices. The external genitalia were normal, with bilateral testis normal in size and location. On submission, a tympanitic note was noted over entire abdomen except for dullness over the lump. Liver span was measured to be 13 centimeters, and there was no evidence of free fluid in the abdomen. On auscultation, normal bowel sounds were heard, and there was no systolic vascular bruit or venous harm. On parectal examination, the perineal area was normal, with normal tone of urethra. The rectum was found to be loaded with stools. At the level, there was no melena, palpitations, or bleeding, and there was no palpable. The prostate was not enlarged. On performing a proctoscopy after evacuation of the rectum, there were no hemorrhoids or growth which could be visualized. Summarizing my history of examination, we have a 44-year-aged male with no comorbidities presented with a rapidly increasing lump in left lower abdomen for past few months, associated with diarrheal pain over the lump, associated with recent onset, constipation, and increased frequency of micturition for past 2 months, which on examination of abdomen revealed a single large, firm, non-tender intra-abdominal immobile of 15 centimeters by 12 centimeters in the left iliac fossa, hypogastrium, and left lumbar region, likely pelvic in origin, with a normal rectum and test examination.
Okay, I think go back.
Questions on examination as well as the study of the case.
I think that you do a examination on the knee elbow position as well. Considering the location of the lump, of retrotectal origin, although it is not a very reliable test, it would be worth trying to do it on the knee elbow position. I have a little objection to saying that on palpation there is no adenomegaly. What you should actually say that the spleen is not palpable. Spleen can be up to 2.5 times without being palpable. So we can't say there is no splenomegaly. We should only say that spleen is not palpable. Same thing holds true for the liver. Okay?
Yes.
That's the second thing. And other thing you nicely mentioned that testes were normally palpable. That's important. Considering the flank location of the bilateral palpation and ballotment of Islam. So that also I found it that you can try to do. These are some of the points
भैया
not taken out bimanual palpation and block, no?
Lung is primarily located in the left iliac fossa and hypogastrium with just upward extension to the left lumbar region. It was not primarily located in the left lumbar region, so the possibility of lung was very rare.
अब मैं शर्म आ गई बुराई करके छोटी की
What is the plane of the swelling?
It appears the plane of the swelling. It is an intra-abdominal lump.
आप बताओ
Have you done bimanual? You have not done bimanual palpation.
और क्या हो रहा है
Such a big mass, can it compress ureter and cause hydronephrosis, all those things?
अच्छा
Yes, sir. Good cause.
You could have thought about
Lady
hydronephrosis
bata.
also, because such a big mass, no?
है उनसे कम नहीं होंगे
Another thing, Dr. Jasmine, considering the location of the lump, we should also try to feel the femoral pulsation on both sides. It could be offloading or compressing on the external iliac vessel.
अतुल भैया थोड़ा कर ले अतुल
Femoral and also
अतुल है बात कर ले
tensile pulsation like the dorsal pubis and popliteal tibia. They could be weakened on this side. Now do an ankle brachial pressure on both sides, because it is very likely that considering the size and location, that it could be pressing besides the ureter, as Dr. Staff already pointed out, on the vessels also, especially the external iliac vessel. That is another thing we should be looking for. The femoral pulsation listed to that. Okay.
Yes, sir.
I think in such large lumps, yes, it is very important to look at the femoral pulsations. And then I think you mentioned in your history, I think but in the examination
अब नीचे गई अब आएगी तो बात करा दियो
because it may cause concussion also and lead on to edema and other problems. So that is also very
हाँ रख लिए मैंने
even as a negative finding in a long case, you should always mention.
आएगी तो
Okay, anything else?
आएगी तो बता देंगे अच्छी लिए फोन अभ्या
No, what was the frequency?
अभी फोन ले लिया है अभ्या ने फोन ले लिया है इसने
What was the size when you noticed? Patient noticed the swelling?
Sir,
No, you said
he could not define the size, but he said there was a definite increase in the size.
किसी को बुला रहे थे
okay. What is in your mind? Is it malignancy or it is some benign condition?
Sir, considering that given his age and considering a retroperitoneal lump, most 80% of retroperitoneal lumps are considered malignant. So I would like to keep a malignant lump more likely than a benign lump. And given the history of a rapid increase in size for last 2 months,
What is the consistency?
and it is also sorry, sir.
What is the
Consistency was
consistency?
firm inconsistencies.
So, did you make out anything in when you're doing a digital rectal examination? Because it's a more of, you said, pelvic mass.
Yes, sir. It could not be palpable. There was no growth that was palpable.
Jasmine, if it was indentable, if you could pit on pressure, what would your diagnosis be? If this lump was pitable, you didn't mention this, whether you could indent it or not. Suppose, sir, what could it be then?
Generally, an indentable lump in left iliac fossa would mean a loaded colon with impacted fecal matter.
Exactly. So that sign also we should try to elicit the sign of indentation.
Yes.
So that is another likely diagnosis. Okay. Growth. Is the loaded colon proximal to the growth? Then it is indentable. Okay.
Yes.
Jasmine, somebody asking,
Sir?
Was the spine examined? Somebody is asking.
Yes, sir. Yes, sir. Yes, sir. The spine and gait were normal. This patient.
Yeah, okay. He's asked about the gait also. So why is it important to look at the spine as well as the gait?
So spine is important because it could be generally pelvic malignancies metastasized to the spine, and there could be in spine we could notice any collapsed vertebra on examination of the spine, and accordingly it would affect the gait, and such large mass could compress the nerves, so that could lead to weakness in the limbs, so that will affect the gait.
Okay. Anybody else, sir, please?
You asked frequency micturition. So how many?
During the he has to void almost 1 and 2
Yeah.
once in 2 hours, 2 3 hours. Yes, sir.
Do you suspect any bladder this thing in this case?
Yes, sir. It could be this large lump could be compressing upon the bladder. So either it could be originating from bladder. This could be another lump which comes in the bladder capacity.
Suppose it is a diverticulum of the bladder. What will be the history? A large diverticulum because it's such a big size. Okay. Sometimes they present with a double micturition. Okay, right.
What will be the other negative point for it being a large diverticulum of the bladder, Jasmine, apart from history in examination? A bladder diverticulum, large bladder diverticulum, as Dr. Narasimha is saying. So what will be there in the examination? What will not be there? You said it's a hard lump, no?
Yeah.
Bladder diverticulum will not be a hard lump.
Yes.
It will be soft.
It will be soft. No? At home, at the maximum, even if it is full. So it will not be hard.
Yes.
And then the location sometimes, yes, it can be a large bladder diverticulum. Okay. Anybody else?
And Dr.
JP Sharma?
Dr. Jasmine,
Yes,
you
sir.
said it's a retroperitoneal.
Yes, sir. Good afternoon. Peritoneum present very late when they grow to very large size. Next is it is not associated with like first I'm mentioning points in history, sir. First is a large lump which is not associated with like clear-cut bowel symptoms. There was only history of constipation, and apart from that there is an increased frequency of micturition. So this is a lump which is having pressure effect on both the bowel and the bladder. So it could be a retroperitoneal lump, and on examination it was an immobile lump, and so I'll keep, and given the location the lump.
As you said, there is no pressure symptoms or the veins or the vessels.
There was no
Have you
pressure.
seen it?
Yes, sir. Yes, sir.
There's a large retroperitoneal lump with this location. There may be pressure symptoms over the vessels.
Yes,
You
sir.
said no edema.
No, sir.
And you have not examined the femur. You have not examined the femoral artery.
Yes, sir. Femoral.
Why not? It's a ectopic and large kidney.
Sir, it could be a pelvic kidney or a horseshoe kidney which has grown malignant. It could be growing to this big size, but it is one of the remote possibilities.
Dr. Rachna?
Yes, sir.
Would you like to ask something?
Whatever she has given according to the case history and the case summary, we would like to know more about the retroperitoneal origins of the tumors coming out from the retroperitoneum area, and also some chronic non-inflammatory diseases also. So the history should cover up that part also, and also the congenital organs which can have their origin from there, like an unascended kidney. So the bimanual palpation part would have been much more described better. That was what I wanted to comment.
Regarding the unascended kidney, it could be a malignancy. It could also be a hydronephrotic unascended kidney. So that also we should keep in mind. Okay.
Yes, sir.
You can take history of Dieter's crisis. You know what is Dieter's crisis?
Yes, sir. The patient will have pain in the flank region, and then like in the setting of hydronephrosis, patient will have flank pain, and there will be a large lump which will be palpable because of the hydronephrotic kidney. But then the patient will pass a large volume of urine, following which there is a reduction in the size of lump.
Okay.
Okay, what is why this is not hydronephrotic kidney, Jasmine?
Sir, this is not a hydronephrotic kidney first because of the location of the lump. The lump was more of located in the pelvic region. The lump was pelvic in origin to begin with. Like it was the lower border of the lump was not palpable, and it was located in the hypogastric fossa and not in the left lumbar region. And apart from that, the patient did not have any like in a case of hydronephrosis, patients may have symptoms of urinary tract infections, or patient did not have any burning micturition apart from increased frequency of micturition. And
the characters of the lump, do they tell you something whether it is hydronephrotic kidney or not?
Yes, sir.
You said it is a hard, irregular surface swelling.
Yes, sir.
So the possibility of a hydronephrotic kidney is not very great. Bimanual palpation was not warranted in this patient.
Sir, there was
Majority
no
of
renal
the
angle fullness
pelvis.
or tenderness.
Sorry, say it again.
Sir, there was no renal angle fullness or
No,
tenderness.
that's
so
all right. But still, why a bimanual palpation was not warranted actually? See, the lower border and the medial border of this lump are not palpable.
Yes, sir.
So that is why a bimanual palpation may not be helpful, and in a large lump, generally the bimanual palpation and bloatability cannot be demonstrated.
Yes.
Right? Because it will be palpable otherwise also.
Besides what Professor Bansal rightly said, other thing is that the ileum bone will be behind that, considering the location of the lump. The ileum bone, the entire ileum, it's a large bone, okay, flat bone. So that is behind this lump. Okay.
Yes.
So when there's an ileum bone behind that, you can't do bimanual palpation, you can't do ballotment. So it's all right that you've not done it, but you have mentioned that we couldn't do this because it was low down in the pelvis. Okay.
So I think for the postgraduates, Dr. Khanna, I think they should always remember that if it's a large lump, they should say that since it's a large lump, they did not do a bimanual palpation and a bloatability. And since, as Dr. Khanna also rightly said, this lump was growing into the pelvis, coming from the pelvis, the lower border, the medial border is not palpable, and there is a large bone there. So how will you demonstrate a bimanual palpation and bloatability in this patient? So answer should be that.
Yes.
Okay.
Yes.
And then
so can you proceed, Jasmine? You can proceed to the what's your investigation plan?
Yes. What is your differential diagnosis first, I think?
Yes, sir. So based on my case summary, the first differential diagnosis that I would like to keep, given the large size of the lump, and so I would like to keep a diagnosis of retroperitoneal soft tissue tumor, predominantly malignant, because 80% of retroperitoneal tumors are malignant, and these are some of the common types of retroperitoneal tumors which are possible in this pelvic region. Most commonly the liposarcoma and leiomyosarcoma. Others could be a malignant peripheral nerve sheath tumor. Apart from this, retroperitoneal lymphoma, the possibility cannot be ruled out, even though the patient did not have generalized lymphadenopathy. Primarily, retroperitoneal lymphoma is still likely, although very rare. And next possibility, I would like to keep a malignancy of the left colon, of which it could be adenocarcinoma or gastrointestinal soft tissue tumor. Adenocarcinoma is generally does not grow to such large size, and this is a 15 by 12 centimeters lump. So however, it sometimes of the rectosigmoid, the tumor can grow to such large size, and other possibility is a mesenchymal tumor arising from the rectum or rectosigmoid. That is a gastrointestinal soft tissue tumor, which is known to grow to such large size. And the other rare, but it is very rare. I just kept it as a differential because of the symptom of increased frequency of which could be
Stromal tumor is correct word. Okay. Yes. Not soft tissue tumor.
Yes, sir.
So I would just like to say, Jasmine, that it is a good idea always to give your diagnosis, the organ of origin, and then the pathological diagnosis. So your organ of origin can be a retroperitoneal, or it can be the colon, or it can be the bladder in this area, or it can be rarely descended kidney. Okay, so then you come on to the pathological diagnosis.
Yes.
Would you like to consider any other rare diagnosis? Any other diagnosis? People have suggested few diagnoses on the chat box. Would you consider it as the
Sir,
extrahepatic hydrated?
Hydatid cyst is unlikely given the location of the tumor and the isolated. It was a single large lump and it was firm in consistency with irregular surface. Hydatid will have a smooth surface, and it will the location.
Okay. Okay. Anything else? Okay. The examiners, please.
Okay. What are the features? What is more likely in the malignancy of the left colon, adenocarcinoma or gastrointestinal stromal tumor?
Sir, like considering the possibility of malignancy, adenocarcinoma of the left colon is more likely than a gastrointestinal stromal tumor. However, fitting my case, that is a 15 by 12 centimeter lump, which is so I would like to keep gastrointestinal stromal tumor as more likely than an adenocarcinoma.
Right. You see, it is a malignant process without obstruction. It's a huge lump without a obstruction. So if there's a huge malignant lump of the colon without producing obstruction, it is not likely to be adenocarcinoma.
Yes.
It is more likely to be the second option, that is the gastrointestinal stromal tumor, because it is growing extraluminally outside. Okay.
Yes, sir.
So that can become very big without producing obstruction. So that is more realistic in this particular patient. Okay.
Yes, sir.
But if it is an adenocarcinoma, then it would have been the proximal loaded colon which would have been palpable, not the growth itself. Okay.
Yes, sir.
So that would have pitted on pressure. Plus, if it was loaded with fecal matter, then it would have produced spurious diarrhea.
Yes.
And spurious diarrhea, you specifically mentioned, it is not there.
Yes.
A loaded colon always produces spurious diarrhea.
Yes.
Plus, there is no sign evidence of large bowel obstruction as well.
Yes, sir.
So, if you consider malignancy of the left colon, then I think your first option should be GIST and the second should be adenocarcinoma in the order of priority here. Okay.
Okay, sir.
So just second possibility in colon. Okay. Anybody else? Okay, then we'll move ahead. You have more slides, or this is the last one?
So, plan of management.
Okay.
Keeping these differential diagnoses in mind, the first investigations I would like to do are to confirm my diagnosis. First, I would like to do an ultrasound abdomen with scrotum. This is as an extension of the clinical examination. And in ultrasound abdomen, I would like to look at thick or solid nature, and such large lump, it may not be possible to delineate the organ of origin using ultrasound. However, it may give us an idea about the kidney and bladder, like because we have bladder symptoms. So it will, pointed out, lead to a hydronephrosis to kidney and the bladder in the ultrasound abdomen. Apart from that, any features of metastasis or any free fluid in the abdomen can be made out with an ultrasound abdomen. And along with that, I've added an ultrasound scrotum because there could be a possibility of like testicular malignancy with lymph node mets. However, lymph node metastasis in CA testis is generally to the para-aortic lymph nodes, which are mostly in the epigastric region and do not present with a lump in this location. Next, I would like to do a CCT abdomen and pelvis or an MRI abdomen and pelvis. There are advantages to each investigation. So apart, and in CCT abdomen and pelvis, I would like to look at the organ of origin of the tumor, and if it is a retroperitoneal tumor or if it is arising from the colon or from the bladder. And I would like to like stage the disease based on the CT and the relationship of the tumor with the vascular with the vessels and the relationship of the tumor with any adjacent lymph nodes and any metastasis like peritoneal mets or liver mets, which could be made out, and local invasion into the adjacent structures. And MRI abdomen and pelvis can be done in case of these tumors, because they will better delineate the pelvic extent of the tumor than a CCT abdomen. However, MRI is more expensive and it is more time taking, although it has the advantages of no radiation exposure and no contrast allergies.
Okay. Okay. So colonoscopy, cystoscopy, and then the routine investigation. That's all right. So Dr. Khanna, Dr. Narasimhan, please.
Okay. So what was the finding on ultrasonogram in this patient?
Sir, and on ultrasonogram, 20 by 17 centimeters lump with areas of there were solid and cystic areas, predominantly solid, and the organ of origin could not be identified on the basis of ultrasound. However, it was seen to be indenting on the bladder, and there was no any metastasis. There was no signs of any liver mets or any free fluid in the abdomen.
So where does that leave us?
Sorry, sir.
Where do you, so what information do you get from this ultrasound? Is it any good or there's no benefit for this?
Sir, with this ultrasound, one advantage could be to do a preoperative coneal biopsy based on the solid and cystic areas that was made out in the ultrasound.
Then
To guide.
sometimes the negative findings of the ultrasound are equally important. Like you should have said that the left kidney was found to be normal. The left testis was normally visualized. Okay.
Yes, sir.
So the positive findings are important. Sometimes the negative findings also become equally important. Okay.
Yes, sir.
And then the ultrasound, if it is Doppler variety, it could see the vessels also. Vessels are involved or they're free, or encasement of the vessels. Then back pressure change is what we are looking for in the kidney, whether kidney is becoming hydronephrotic, like because of compression on the ureter. So these are the other findings. Even if they're negative, then you should say that there was no back pressure on the kidney and there was no encasement of the vessels. So these are findings which ultrasound can tell you. So did this patient undergo CT scan after that?
The status of the liver also on ultrasound is very important. The liver mets can be very nicely picked up by the ultrasound. Okay.
Liver mets and ascites also.
Liver mets and ascites both. Yes.
You have ultrasound report now? You have ultrasound report?
Sir, I have not attached here. Yes, sir.
Okay. You know how to read the films? You should learn that also. And what is the role of ultrasound of scrotum in this patient?
So as I said, it may not be recommended, but it was just done to rule out any malignancy of remote possibility of malignancy of testis metastasizing to the retroperitoneal lymph nodes. Although the location of the lump was not fitting to the primary location for metastasis.
Clinically, what is the status of the both testes?
Clinically, testes was normal. Clinically, testes were normal in size and location. Yes,
then Jasmine, in your plan of management, I want the presence of biochemical tumor markers as well, like beta HCG, alpha fetoprotein, carcinoma embryonic antigen, CA19-9, CA125. Are they good or there's no benefit with all these? Before we proceed for any invasive investigation, we can get these tumor markers done. Okay.
Okay.
So
especially
okay.
beta HCG.
So Jasmine, I think
extragonadal
just last
choriocarcinoma.
question. The organizers are getting restless. So just last question is ultrasound. Do you need to get a preoperative tissue diagnosis in retroperitoneal tumors?
Sir, this is controversial whether to get a preoperative conatal biopsy. However, in case of retroperitoneal tumors which are radiosensitive, we can go for a preoperative radiotherapy. These radiosensitive tumors are generally an alveolar rhabdomyosarcoma or a synovial sarcoma or a well-differentiated liposarcoma. And it could be used to downstage the tumor and make it more resectable, because often in the mainstay of treatment of retroperitoneal tumor is a curative resection of the tumor. en bloc resection of the tumor with those organs which are involved by the tumor. And so if we go for a preoperative radiotherapy, it can help to downstage the tumor and thereby reduce the morbidity of the surgery. So
Radiotherapy is very rarely useful, but yes, some tumors are chemosensitive.
yes, sir.
What are those tumors which are chemosensitive?
Sir, chemosensitive tumors, it has been classified as moderately chemosensitive tumors and chemoinsensitive tumors. Sir, moderately chemosensitive tumors include a well-differentiated and dedifferentiated liposarcoma, fibrosarcoma, a myxofibroma, and generally and a malignant peripheral nerve sheath tumor. These are moderately chemosensitive tumors, sir. And completely insensitive chemo-insensitive tumors will include a pleomorphic sarcoma or
So sometimes getting a preoperative ultrasound guided core needle biopsy is helpful in planning the complete management of these patients. It's a large tumor. You may end up doing adjacent organ resection also sometimes to reach a R0 resection. So if you have a preoperative diagnosis, sometimes these can be benign peripheral nerve sheath tumors also. Right. So then you can be less radical. So preoperative, I think core needle biopsy in the large tumor is also very important. Although surgical treatment is the treatment of choice, and you have to explore and see these patients. That's all right.
But suppose Jasmine, just to complete this, just in case it turns out to be lymphoma,
yes,
then
sir.
we don't need to do surgery. Then it is totally dependent on chemotherapy plus minus radiotherapy. Okay.
Yes, sir.
So we can avoid surgery totally.
Yes, sir.
The second thing is suppose you find that beta HCG is elevated, but testis is not enlarged. What would come to your mind? Testis is normal, but beta HCG is elevated.
Beta HCG elevation is generally seen in choriocarcinomas, which are the non-sematomatous germ cell tumors of the testis.
It could be extragonadal variety of germ cell tumor. Okay.
Yes, sir.
There's a class of germ cell tumor which is extragonadal. There's no focus in the testis at all.
Yes, sir.
That is another rare variety that you must keep in your mind. Okay.
Yes, sir.
So was the true conditional biopsy done in this patient?
Sir, true cut biopsy was not done for this patient. We proceeded with surgery.
Surgery.
Yes, sir.
So
No,
what
no,
was the
I
plan?
just want just a minute. CCT abdomen and what is the report is it in tell? Let us know from CCT abdomen and MRI abdomen. You are done?
Yes, sir. Yes, CCT abdomen was done, sir. CCT abdomen.
What is the organ of origin?
Sir, it was it was a retroperitoneal tumor, sir. And and it was indenting the superior surface of the bladder. It was displacing the tumor was displacing all the bowel loops to the opposite side, to the right side, and superiorly it was extending till the kidneys. And however, there was no involvement of the kidney, and the kidneys were also not enlarged in size. And so there were no lymph nodes, there was no lymphadenopathy, and there was no ascites, and no liver mets, no peritoneal mets.
I think we have already overshot our time. So thank you, Jasmine. Any last questions from the examiners? Otherwise, I think we will wind up.
So what was the laparoscopy and proceed? What did you see? Where was arising from this tumor?
Sir,
it was a large retroperitoneal tumor which turned out to be a malignant peripheral nerve sheath tumor actually on final
Okay, sir.
histology.
Thank you very much.
Okay, I think thank you so much, Jasmine. You did a good presentation, but some things you missed, as rightly pointed out by the examiners, and the differential diagnosis and other things are all right. But good presentation. Thank you the examiners for a nice discussion. Thank you so much. We just overshot the 5 minutes, I think.
Thank you, Professor.
Yes, sir. Thank you, sir. Thank you, Bansal,
Thank you very
sir.
much, sir. Thank you.
Thank you. I thank Virender Bansal, sir, and all the examiners for this session. And now, as we are running short of time, we'll be quickly moving to the next session, which is a ward round and on fecal fistula. And presentation has to be done by Dr. Purvi Priyadarshini from Kolkata. And moderator for this session is Dr. Ramanuj Mukherjee from Kolkata itself. So over to Ramanuj Mukherjee, sir.
Is my video hello?
Yes, sir. You are visible and audible both.
Okay. Just a second, sir. Right.
Dr.
Sir,
Purvi,
am
can
I
you please start?
right?
It
Hi.
turned out to be something new. It was a new nursery cleaner.
Before Dr. Purvi
Without permission
takes
from
over with the screen for the presentation. Hello.
Yes, sir. Yes, sir.
Right.
Actually, what
Okay.
I wanted to
Before
say
Dr.
was
Purvi,
rectally
there is a background sound, please. Can you kindly
that was
request
one
that
type of
lady to
bimanual
stop?
pattern. So
Anilji, please see to it.
Okay, right. Okay, a very good afternoon, ladies and gentlemen. Before Dr. Purvi takes over with the screen, I will request the examiners for the session, Dr. Arshad Ahmed from Lucknow, Dr. Rajiv Shahai from New Delhi, Dr. Probal Nyogi from Prayagraj, Dr. UC Singh from Gorakhpur, and Dr. Manoj Kumar from Patna. I hope that all of them are present and ready. Okay, Dr. Arshad, do you have you on the line, sir? Hello?
Yeah, I'm there.
Okay,
Thank you so
hi,
much.
sir.
Good afternoon.
Hi, good afternoon, sir. Sir, you have already texted in the box, so Dr. Sahai is there. Dr. Probal Niyogi, sir. Hello.
He'll be joining shortly, sir.
Okay. Dr. Singh from Gorakhpur, sir.
He has stuck in some emergency, so probably he'll not be available.
Okay, and Dr. Manoj Kumar.
He will probably be joining.
Oh,
Yeah.
hi, sir. Sir, a very good afternoon, sir.
Yeah,
Very good afternoon.
good afternoon. Good afternoon.
Okay. Can I have the candidate, Dr. Purabi? Are you ready to present?
Yes.
Okay. So please, onto your screen.
Okay, sir. Just a minute, sir.
Yeah, no issues. Ladies and gentlemen, the discussion is a ward round scenario with an intercutaneous or a fecal fistula, as is commonly called as, which is a common scenario in a general surgical or a gastrointestinal surgical ward. All surgeons have faced at one point in their life with a patient having a fecal fistula. So the ward round scenario is a common presentation with an ileal injury which later led to a fistula, as Dr. Purubi will be elaborating.
Okay.
So by that time, okay. So Dr. Purubi, do you have the presentation?
Finding some difficulties.
Okay.
Share your screen button, green button on the bottom of your screen. Share screen.
I'm trying, sir, but I'm not finding the PowerPoint presentation.
Keep your PowerPoint presentation on your laptop, on your desktop, whichever you're using.
Dr. Purabi, you can present your screen. Hello.
Okay.
You can present your screen, and if you have the screen and the PowerPoint ready, then it will be projected in that.
Oh, no, it is some other window.
Okay, right. I think yes.
One second. Let me check.
Okay, right. So can you go to the right? Can you go to the right? Okay, good one. So can you go to the slideshow, please? Yeah, please present your case.
Extremely sorry for the delay, sir. I'm Dr. Purvi Pirachini, third year PG trainee from Arjika Medical College, Kolkata. I'm presenting fecal fistula, as you know. Our case is a male of 20-year-old, male with a history of blunt trauma abdomen. Presented at our trauma center up to 48 hours with diffuse peritonitis and shock. The patient was resuscitated. An emergency.
Dr. Purabi, can you advance the slide, please? It is not visible. The slide. Okay,
Sorry. It was referred to our institute after 48 hours. And then patient was resuscitated and emergency laparotomy was done. Intraoperative finding was transverse mesenteric tear with devitalized ileal segment. Resection and anastomosis was done. First 4 postoperative day was uneventful and patient gradually developed abdominal distension. Discharged on the POD 5 onwards. He was febrile with tachycardia, tachypnea. after liquid on the day of them. Patient was kept NPO and out 21 patient is stable with stable vitals and soft abdomen, and fistula output decreased from 600 ml to 200 ml. He was allowed oral fluid, and TPN was still continued. There was a weight loss 6 kgs. Initial became to 52 kgs. So we have done some investigations on the routine basis, but here I recorded POD 5, POD 10, POD 15, and 20. I monitored hemoglobin, total leukocyte count, albumin, and electrolyte
In
on
between,
regular
we have
basis.
to wait till she finishes her talk, Dr. Ramanuj.
Yeah, I think that we will let her present the case, and then after she has finished, and then we.
Okay, thank you, sir. There was radiological injection in the abdomen, and that was done on POD 10. And a CCT abdomen was done after the stabilization of the patient on POD 14. It was with the IV and oral contrast. There was no localized collection, and contrast seen coming through the wound. And the management procedure, the up to third week, first week, second week, third week basis, we have managed the patient, and the patient's vital monitoring, blood reports, and nutritional assessment, sepsis control, and wound management separately. Then in the first week, we monitored the vitals daily and electrolyte daily, and the blood investigation are done on the alternate days to check for the derangement of the LFT and urea-creatinine, etc. And antibiotic will continue with the cefuroxime and metronidazole for anaerobic coverages. And nutrition assessment with body weight and basic anthropometric measurement was done. And TPN was started from the POD 7. Albumin level was checked constantly for the nutritional assessment. Wound was managed with local dressing and wound manager bag. Fistula output was monitored. Wound swab was sent on the first week after we have seen the discharge coming out. And in the second week, we focused on the sepsis control plus nutritional improvement of patient along with the resuscitation. But in the second week, patient was more stable and TPN was continued. Wound management continued with the daily fistula output monitoring and wound manager bag. And in the third week, patient was very stable than before. So monitoring was done of the vitals daily, and the electrolyte and blood reports were done almost 2 days interval. And the routine bloods, hemoglobin, albumin, LFT done every 3 days. Antibiotic was sorry, I have forgotten. Antibiotic was changed from cefuroxime to piperacillin plus tazobactam. As the count was total count was increased, it was not decreasing, rather than it was increased 17,000 for in the second week. So in the third week, we continued with the piperacillin tazobactam. The count was gradually becoming less. Body weight was at time 52 kgs. Daily fistula output monitoring was done, which was decreasing. The present status in the POD 21 can see there is a, I think, video. Patient is stable with wound manager bag in situ and is TPN for that. As you can see, patient is quite oriented, and there is feculent matter in the wound manager bag. It is almost liquid, but the discharge is decreased. Going for next slide. Present day, patient is allowed on the day 21 with sips of water, but TPN is continued. Fistula output decreased from 600 ml to 200 ml. Vitals are stable and abdomen is soft. Uh, Total count is decreased to the acceptable level 12,000, and albumin is also increased greater than 3.2. And patient has a weight loss of 6 kgs. Sorry, I have not mentioned. 52 kgs actually. There is a editing error. And present day patient is with treatment, antibiotic has stopped, and daily dressing with fistula outward management is being carried out, and patient is on conservative management with stable vitals. We have taken a consent from the patient for this videography and photography, and this is the end of my presentation.
Okay, can you go to the first slide, please? I will request Dr. Prabal Negi to start the questions for this case, and then we move to you, Dr. Akhtar.
Right. Purubi.
Yes,
So you have a basic. I'm sorry, I'm in the OT. I'm using my mobile for this, so there might be a bit of disturbance. Purubi, this is a case of basically a fecal fistula on day 21, right? If suppose you were the consultant in charge of this case, could you have done something different from the very beginning?
So we should have done a stoma instead of dissection, anastomosis in the primary basis, as the patient led that.
Yes. So when you first saw that there was a feculent discharge, what is the difference between a fecal discharge and a feculent discharge? You said something like feculent discharge.
The order was feculent, but these were liquid feces were coming.
So that is a fecal discharge, isn't it? It is not a feculent. Feculent discharge is something that is like feces, smells like feces.
Yes,
it's feculent. Well, this is a fecal discharge. So initially you had a feculent, and then it became fecal.
No, initially it was purulent.
Say, I think day 6. Right, isn't it?
Pardon, sir?
Yeah. So could you have done something different at that time? Because considering it's a distal ileal perforation.
Distal ileal perforation. The time when the feculent discharge were coming. Not getting.
No,
What could you have done? Would you have done a ileostomy?
Right. So
that I have said, sir. That initially we should have done ileostomy in the first procedure, but during the no signs of peritonitis. The rest of the abdomen was soft and bowel sound was there. So patient was in the not in exactly the sepsis and peritonitis. So we didn't go for that.
Right. So in a patient of a blunt injury abdomen, and what are the causes that can lead to such an event where you have repaired the wound and still it has leaked?
They can have a bowel ischemia and tight suturing.
How?
Or
In a trauma, I'm asking you trauma, bowel ischemia. How do you get bowel ischemia in trauma?
During the, as I have said, there was a mesenteric injury, transverse mesenteric injury. The bowel margin which we have taken, so that may get ischemic after that due to the poor vascularity of the poor bowel perfusion.
So what is the bucket handle tear?
Bucket handle tear. Sorry, sir. I can.
Is it a longitudinal or a transverse? So just think of a bucket handle, Dr. Purabi. So will it be a longitudinal or will it be a transverse?
It's a transverse.
Okay.
It's a transverse injury.
Okay. And
it will be affecting the collaterals of the.
No. It looks. See, imagine a bucket, right? The mesentery. This is long bowel is there, and you have a mesentery which is like a curtain. So if you get a tear along the bowel in the longitudinal segment, so that the bowel is separated from the mesentery, the bowel becomes a handle, and the rest of the mesentery is the bucket. So that is a bucket handle tear. It often happens in blunt injury abdomen. That is why I'm asking you. What are the two essential things of an anastomosis, viability of an anastomosis?
The margin should be there should be good blood supply with a healthy margin, and approximation should be accurate, not way too tight, not too loose, and tension free. It should be tension free.
Tension free. Right, Ramanujit, can you take over?
I think that, okay, now Dr. Arshad, please. Dr. Arshad, your question.
Devascularization, there was some bowel segment that was devascularized. So apart from that, what other factors can lead to this disaster? I mean, intraoperatively, if you have those factors present, and you can still you do anastomosis instead of diverting. So what are those factors which increase the risk of anastomotic dehiscence?
Patient was in trauma and in shock. So there is a there may be the highest possibility patient had a hypoxia and hypovolemia at that time. that leads to poor perfusion of the bowel, and the patient's general condition after that, after a laparotomy, generally worsens.
Okay, Dr. Burabi, I will like to, okay, as Dr. Arshad has asked you, see, as an emergency surgeon, you need to take a decision when will you like to do a stoma or when will you like to do an anastomosis. What are the situations in this patient that an ileostomy would have been a better choice rather than doing an anastomosis?
So it was a decision by the emergency team.
Okay.
But if there is a diffuse fecal peritonitis, swelling of the bowel, we'll straightforward go for the abdominal toileting and will not risk the patient for the 4 to 5 hours of laparotomy and etc. We'll do a stoma and cut short the procedure. But if there is no soiling of the bowel and it seems the margin seems healthy at that time and patient general condition is good, so we can go for anastomosis.
Okay,
That can be a wrong
means,
decision, but
okay, but
that
wait,
time it looked
right.
margin looked
So
healthy.
right. So that means that for a summary for all the students who are listening, in an emergency, when will you like to do a stoma? When will you like to do an operation? Number one, when there is a gross fecal peritonitis, preferably to think about a stoma. When there is a delay of more than 24 hours, associated hypovolemia, hypoxia, then it is preferable to do for stoma. Dr. Arshad, sir, in this regard, sir, any other points to add in this point? When will you consider a stoma when not an anastomosis?
Well, factors related to bowel, there are factors related to peritoneal cavity, and then factors related to general condition of patient. As we have already discussed, that factors related to bowel could be the pathology, because in trauma cases, bowel is otherwise healthy. But pneumonia could be one factor if you find that a large segment is ischemic and we suspect that this ischemia can, spread out. Then that is one very important factor that can intraoperative hypotension comes in patient factor. Apart from that, patient is very grossly anemic, patient is very malnourished, patient is then you have, as you said, patient presented after 3 days. There can be gross peritonitis and along with a lot of edema. So definitely these factors are there which can increase the risk of post-operative anastomotic rate.
Okay.
In presence of these factors, especially if we are dealing with the distal bowel, if we are dealing with proximal bowel like duodenum or jejunum, then definitely we have to try to be more conservative in taking out stoma rather. So continuity should be restored. But in distal bowel, this is a very safe option because patient's nutrition can be maintained even with a stoma, and safety will not be compromised.
Right. Okay. On this regard, as we have, sir, a dearth of time and many things to discuss. So the patient underwent a blowout of the anastomosis on which post-operative day, Dr. Purabi?
I think it's postoperative 5.
Okay.
We have noticed that postoperative 5 after the removal of the stitches, there
Right.
was constant
So now,
discharge coming out.
and then you have summarized your management in the first week. So I request Dr. Sahai. Dr. Sahai, please, the management, particularly in the first and the second week of the fistula formation.
Right, Purvi. It's a case of fecal fistula which you notice on 5th day. So the most important thing is the nutrition, right? You want to build up the patient before you can do anything else. So you started TPN, right? Now suppose the patient is gaining more than 1 kg of weight per week. Do you think this is good or bad?
So patient may be having a fluid overload and there may be edema in the bowels.
Right. So you're giving
we are
more
over
fluid.
resuscitating the patient.
Right. Now, suppose you have to correct the protein, the energy, and the electrolytes. So how much energy and how much protein do you expect to give to this patient so that his nutrition improves?
Actually, in this patient with hypercatabolic state, one calorie requirement is 1.5 to 2 times more than the normal person.
That would be how much?
That could be around 25 kilocalorie per kg, 100 to 150 kilocalorie per kg.
About 30
And
to 35
the
kilocalorie per
protein
kg
is
body weight.
2.5.
And what about protein?
2.5 2.5, I think 2 to 2.5.
How much is the normal protein requirement per day in a normal person?
The is I think 2 gram per kg per.
It is 1 gram, right? So give about 2.5. What about electrolytes? Suppose his potassium was, this is a high fistula, they generally lose potassium and sodium. Suppose his potassium came down to 2 milliequivalents. How much potassium would you give order for that day?
So it is actually 1 milliequivalent per kg per day is the supplementation dose.
That is the daily requirement, but he's losing. So how much will you give and how will you give that potassium?
We'll
Do you know how
give
to
the
calculate the discrepancy?
Actually, we calculate the loss by measuring the electrolyte in the fecal, the discharge coming in the.
You can't do that. You can't.
No,
I mean, you
that is
can't
impossible.
get potassium levels done in your fecal and matter.
Serum potassium is measured as supplementation is so 60 milliequivalent per day in divided doses. Actually,
No.
42 sections.
Look, it is 1 milliequivalent per kg body weight. So about 60 milliequivalents is the daily requirement if 60 kgs, right? So what you do is that suppose the normal potassium is 5 milliequivalents and when you test it is 3 milliequivalents. So deficiency is 2 milliequivalents. So 2 milliequivalents into body weight into 0.5 in females and 0.6 in males. That is the deficiency, right? So it's suppose 2 into 50 is 100 into 0.5, right? And you add 1 milliequivalents per kg body weight and you give half of it in first 8 hours.
Okay.
Now, what is the loss, Purabi? What do you expect this fecal distal ileum? What electrolyte loss would be there maximum?
The bicarbonate will be lost and sodium will be lost.
So the enteric secretions have a high content of sodium, isn't it?
Yes, sir.
So you have to replace the sodium. And how do you replace the sodium?
Sodium replacement is by the normal crystalloid form, either normal saline.
What solution would you like to give? And how much? So what is the maintenance fluid that you give in one day for a normal person? How much sodium? How much potassium?
Normal sodium as the body requirement, we'll give the normal sodium, but the fluid rate will be 100 ml per kg per hour for the first 10 kgs as we.
How much is required per day? What is the normal requirement of, as the Dr. Rajiv said, potassium is right? So how much is the sodium requirement per day?
Sorry, sir. I can't.
How do you calculate that? Like if you have calculated happening, suppose it is from the small bowel, then there's a high content of sodium loss. If it is a large bowel, it's a diarrhea, then there's potassium loss is there. So the chances you have to supplement with potassium also, the extra, whatever loss is there.
But in the TPN, we are giving the sodium and potassium in the solution.
How much is there in a TPN? In one bag of 1 liter of, how many liters does it contain, a TPN?
We are having 2 liter bag.
Okay.
Bags are usually there. You can have 2 liter bags also. So what is the content of sodium, potassium in that? Have you checked ever?
Yes, sir. Yes, sir. Potassium is around 32 millimole and sodium is around 42 millimole.
Exactly. So it's about 35 millimole. So that is grossly deficient, isn't it? So you have to give more of sodium and potassium apart from the TPN that you are giving. Right. Okay, Ramanuj.
Now, I will now ask Dr. Manoj. Okay. So now, Dr. Purabi, what is the first important idea after you have identified that there has been an intercutaneous fistula that is in the way of formation? What is your priority of treatment in the first week of the treatment?
So in the first week, we'll try for resuscitation and the sepsis control. Try for the resuscitation primarily with crystalloid and electrolyte supplementation should be given.
That means, to summarize, the main issue is that management of sepsis, either with use of local wound exploration, letting out the pus and any collections, and use of systemic antibiotics. Okay, now, sir, I will request Dr. Manoj Kumar, sir, questions, because the patient is in the state of management of sepsis, TPN has been initiated. Sir, questions now,
if this is your patient and patient after putting your bag, the wound manager bag, his count is about 20,000. He's intermittent fever. So how you investigate further to find out what is going inside? And because he's sick, you cannot go, you cannot operate this patient. So what are the investigation you will do?
So we have done the blood investigation. We have sent for the blood culture sensitivity, wound culture sensitivity, basic blood investigation, total leukocyte count were checked. USG was done to see any residual collection.
That count is raised. You already said. So you do need any other radiological investigation? Is ultrasound is a good investigation in a
the patient is like ultrasound is the cheapest. Pardon?
It is not very specific.
Because
any other
is
better
also
localizing investigation than an ultrasound?
So CT scan.
Something that you have done?
CT scan can be done.
Okay.
Yes, CT scan. CT scan will tell you about any hidden collection, any collection which can be drained percutaneously. So CT scan is a must. And later on, when the patient is more stable, then you can do a CT fistulogram to
delineate the
more anatomical localization of this patient, of this fistula state.
Okay, right. In this regard, there is a question about what is a simple fistula and what is a complex intercutaneous fistula.
So a simple fistula is just a linear tract where draining the line by granulation tissue, draining the intestinal content to the cutaneous surface. But in the complex fistula, there is a peri-anastomotic abscess. There is an abscess along with the drainage of the tract to the outside.
Okay. So now, as you are now in the third week, what are the main priorities or what are the main principles of management of an intercutaneous fistula? Please understand the question. Yeah.
Can I just add one thing? Please. What is in the first week? In the first week, what is the role of octreotide?
Okay, very good question, sir. Very important question.
Do you give it, use it, or you don't?
Right. Okay.
The octreotide seems to have a role in decrease in fistula output. Definitely, it is having a role in a decreasing fistula output in the pancreatic fistula. In the bowel and intercutaneous fistula, it's controversial.
How does this octreotide work? Number one, for a bowel fistula, we're talking. Let us restrict ourselves to bowel fistula.
Okay, sir, it is a somatostatin analog. It decreases the bowel secretions. And
number one. Number two.
The motility is also decreased.
Yes, the transit time is increased. So it basically absorption is more of the secretion.
Absorption is more.
Right.
Secretion.
Right. Why don't you? By the way, why don't you use somatostatin? Why do you use octreotide?
So, somatostatin not
why not?
available.
You said somatostatin analog, right? So why don't you use the somatostatin?
It is found in octreotide form. So
no, everybody knows. But why do I'm asking you why? Because it's got a very short half-life. Exactly. Somatostatin has a very short half-life. So it's about 1 to 3 minutes. So anyway, right. So when do you decide that this octreotide is working, and when do you say that yes, it has worked, or it is not working?
So we'll give it for 3 to 5 days. We'll see the output monitoring. It's decreasing, or it is having an impact. We can see that, and then we can stop that.
Well, there are no good studies right now, but what the general thought is if the fecal fistula amount decreases drastically in the first 48 hours, then that means the octreotide is working. If it does not, then you don't need to continue octreotide. 48 hours is a trial period, right? Okay, go ahead.
Can I just ask something?
Yeah, please.
Can I just intervene? Purvi, what are the other drugs which you give to decrease the output?
There's TNF alpha influx.
No, Purvi, let us start with the simple one. I have asked you a very simple question. So rather than talk about biologicals, talk about pharmacologicals, like opioids. Anything of opioids that can be helping to decrease the
Codeine.
fistula output.
Codeine can be used, which decreases the motility and increase the transit time. So that causes the increased absorption and decreased output.
More commonly used drugs. More commonly used drugs.
Particularly patients with a chronic diarrhea, they are
Codeine,
gastroenterologist.
loperamide,
Can be used.
Even PPI can be used.
PPI
Right.
can be used.
Okay. Now, anything to be given orally that had a role, people used it very frequently in the past.
The bulk
Anything
forming
that,
agents and charcoals can be used. They are used by some of the surgeons.
okay, all right.
The thought is that bulk forming agent will absorb the water content and make the feces more
flax seeds,
make the
psyllium.
the soiling will be less and wound will be healed better and output will be decreased.
Okay. So now we come back again to the old question, Puravi. What are the principles of management of intercutaneous fistula?
So, in the third week, there may be 4 hours of management of resuscitation, rest to bowel, radiology, and the plan of management and re-establishment of the continuity. There is a Chapman principle, which includes fluid and electrolyte resuscitation, sepsis control, nutritional improvement, wound care, and anatomical delineation by radiology.
Okay, so go slow. So that means the principles of management will basically include fluid resuscitation, number one, as we have had a discussion, replacement of sodium and potassium losses. Number two, management of sepsis. Number three is nutrition. Number four is wound care. Thereafter, it will come restoration of continuity and radiology. Okay. Now, Puravi, one question: how does TPN give or is beneficial in a patient with an intercutaneous fistula?
The TPN mainly provides the calorie and helps in the caloric requirement of the patient. Patient is in a severe catabolic crisis at the present, losing proteins and aggravating sepsis, constant fistula leakage causes malnutrition in the patient. So TPN will mainly provide the caloric requirement of the patient and will cause weight gain.
Okay, so you have used an important word, that is something called rest to the bowel.
Yes.
That is provided by TPN while providing proteins and calories, as Dr. Shah has very appropriately said about the proteins and the calorie requirement. Right. Now, what is the management of the wound that you have planned? Because we saw a picture of an wound manager being applied. So, what is the management of the wound that has been planned?
So wound management basically includes the care of this overlying skin and the effluent management. The effluent wound manager bag is such a bag which covers the skin in the margin, and there is a outlet tab for the liquid matter coming through the
Okay, right
fistula.
now. So time is short, so we have understood this principle. Now, when will you consider, or what is the prognostic outcome of a intercutaneous fistula? In how many percentage of patients does a fistula with your treatment that you have advised that heals?
About 90% fistula heals by 1 month if the adequate nutritional support, sepsis control, and
Etc. Very right. Let us stop at this point. What are the causes in which fistula, what are the reasons of non-healing of an intercutaneous fistula? Time is short, so
there are various causes. I will summarize that. There may be the foreign body, and there may be the radiation.
French pneumonic, you can say.
French pneumonic, the epithelialization of the tract,
so time is
infection
short,
and
so just give
increased
us
bowel
5
output,
minutes. Right.
neoplasm and nutritional deficiency, distal obstruction.
How long you wait for any fistula to heal before you plan for going in for surgery again?
Right.
We'll wait for um, usually the fistula heals by 4 to 8 weeks, but we can wait the definitive surgery up to 4 to 6 months. For the healing of the abdominal what to say, prepare the abdomen for the next operation, improvement of the nutrition of the patient, and delineation of the anatomy. So in the cases, we can do early surgery less than 6 weeks if peritonitis is present, and if the wound is not healing, fistula is not healing, output is persisting, greater than 6 weeks, we'll go for operation.
Okay, so right. I think the time is short, and here Dr. Puneet will be finishing that. Sir, just finishing comments from Dr. Sahai. Sir, anything to comment on the management of intercutaneous fistula because time is short?
Right. I would just like to tell you that fistula characteristics on examination, if the fistula length is more than 2 centimeters and the opening is more than 1 centimeter, then it will not close. And if there are multiple fistless openings, then you will have to deal with them in a different way.
Yes.
Sir, Dr. Praval Negi, sir, closing comments.
Closing comments, it is all obvious. Obviously, the prevention is better than cure. I think in this patient, an ileostomy would have saved the day. But if a fistula has formed, then there are, as you rightly see, we have discussed, there are 4 things that have to be taken care of: nutrition, electrolyte imbalance, sepsis, and skin care. Right? Later on, later hernia form, and then you should also learn about skin closure techniques. We could not discuss that in part of time.
Right.
That also.
Right. Okay, Dr. Manoj Kumar, sir.
Very important thing, you have to manage the skin part very good because you have to apply the appropriate colostomy bag, ileostomy bag, or wound manager because this is the most troublesome thing to the patient. If there is a fistula, the skin will macerate and the patient will be socially neglected. So this part has to be taken care.
Right, sir. Thank you. Okay, Dr. Arshad, sir, closing comments before I just
sometimes very challenging for the treating doctor as well as it is very frustrating for the patient as well as for the attendant. So I think it's very important to counsel the patient, to counsel the attendant, to motivate.
Very appropriately said. An important point.
Long time to feed and maybe very expensive sometimes, TPN and all. I think that resource group has very carefully tackled, and you must tell the patient that it might take time and resources may be consumed. So I think motivation and counseling is also a very important part of overall management apart from the basic sepsis control and nutrition and just ensuring the distal patency and all those things. I think that part should also be taken care of.
Right, good point, sir. Just, to close on this one, Dr. Sahai, sir. Okay.
You must also know about the surgical management other than closure of the thing like bypasses.
I request Dr. Mukherjee to please find
yes, sir. So just 1 minute.
the time, yeah.
Right.
You can summarize, yeah.
Right. So to summarize this, ladies and gentlemen, the intercutaneous fistula, the basic principles are 5: fluid and electrolyte management, sepsis control, total parenteral nutrition to give rest to the bowel till it becomes a low output and stabilized, so that you can start an enteral diet, because there has been a new concept of starting enteral nutrition. Wound management by applying appropriate devices, and particularly with an upcoming rule of negative pressure wound therapy. And finally, restoration of continuity of the bowel when the patient's catabolic phase is over and the patient can tolerate another surgery with an appropriate team and with an appropriate experience. With this, I think I would like to thank all my co-examiners and particularly Dr. Purabi for the nice presentation. Thank you, Dr. Purabi, and definitely Dr. Puneet and the whole team of IMS BHU for allowing us to present the case of intercutaneous fistula in front of us. So thank you, Dr. Puneet. Thank you.
I congratulate Dr. Amanoj for the wonderful show and a very good moderation for this session. I thank all the examiners for this last one round. I go ahead with the next presentation, that is the radiology, in which we will be dealing about the X-ray, CT scan, barium studies, and the X-ray chest. And Dr. Shivi Jain, she is assistant professor in the Department of Radiodiagnosis in IMS BHU. She will be covering this topic, and the moderator for this session is Dr. R.N. Meena and Dr. S.P. Mishra. I think both of them have joined.
Yes, sir. Thank you, sir.
Yeah.
So, Dr. Pavi is actually an associate professor. Dr. Sheikh, you can please share now.
Okay. Am I audible? Is my screen visible?
Yeah, fairly visible. Please make it full screen.
Okay, so good afternoon, everyone. Myself, Shivi Jain from Department of Radio Diagnosis, and I would like to thank Professor Puneet Sir, Head of Department of General Surgery, and the organizer team for giving me this opportunity. I hope I would be able to do justice to the topic and the residents would be benefited. So coming to a normal chest X-ray. Now this is a chest X-ray. First we identifying any pathology, we have to see whether good or not. So adequate centering, the medial ends of the clavicles equidistant from the sternum, check. Now the adequate inspiration, the first 6 ribs anterior end should be above the diaphragm. So this is a good inspiratory film. So this is checked. And the penetration should be adequate, means the vertebra should be just visible from the through the heart shadow. So this is good centering, good inspiratory film, and good penetration. So yes, we can now see the pathologies, whether it is normal or abnormal. And one more important thing, that we have to see that normally that left hemidiaphragm is below the right. Why? Because the heart presses the left hemidiaphragm. It is not the other way that liver pushes it upwards, but rather heart pressing down. And the left hilum is above the right hilum because the pulmonary artery goes above the main bronchus, while here it is anterior. So this is a normal chest X-ray. And if we see the pathologies, if we see the normal anatomical structure, we would see that these are the hila, this is the heart shadow, these are the lateral costophrenic angle, these are the cost, and these are the cardiophrenic angles. Now, what is the difference actually between PA and AP? I am telling you this because actually that determines the pathology, whether it is normal or abnormal. On PA means the rays are coming from posterior to anterior, and AP means the rays are coming from anterior to posterior, and we do this type of X-rays to find in position, like the patients who cannot go to upright position in ICU setting, etc. Here the clavicles, if you will appreciate, they are more cranially oriented compared to PA view. The scapula, they are overlying the lung fields. Here the scapula, they are displaced, but here they are overlying the lung field. And the heart shadow and the hilum are more prominent. So this is the AP view. Now the most important thing what we want to see on a chest X-ray is presence of a free air under the diaphragm. So here it is always, we know that it is better to appreciate on right side, because on left we confuse it with the fundic gas. Theoretically it is said that one measure what you can apply is that it is diaphragmatic thickness is around 2 to 3 mm. So, if it is a fundic gas, the distance from the lucency to the diaphragm, it is around 5 to 6 mm, because 2 to 3 mm is also the wall of the stomach. So, if you will see in the lucency, the distance between the lucency and the diaphragm 2 to 3 mm, it is free air. And if it is 5 to 6 mm, probably it is a fundic gas. But of course, it comes with a practice. And then some important mimics are very important. Like this is the Chilaiditi syndrome, that is the hepatic flexure coming between the liver and the diaphragm, or this is a plate atelectasis, the linear atelectasis. This is the normal lung, and we can misdiagnose it as pseudo-pneumoperitoneum or air in the diaphragm. Actually, there is no pneumoperitoneum, but it is an atelectasis. How we say, whenever you have an associated lung pathology like this is a hyperinflated lung, then the chances of a plate atelectasis is suspecting of obstruction or perforation. Now here you can appreciate an abdominal X-ray. The air is outlining the psoas muscle. So whenever you see a psoas muscle outlining the psoas muscle, near the adrenal gland, suspect that air has gone into the intraperitoneum. Now another thing, see the important entities. One is phrenic nerve palsy. Another is the infiltration of diaphragm, and third is the diaphragmatic hernia. Now, there is very important concept among all these three, that phrenic nerve palsy, we know that is paralysis. Eventration, there is inadequate muscularization of the diaphragm. And in diaphragmatic hernia, there is defect of the diaphragm. Contiguity of the diaphragm is lost. So, in eventration and diaphragmatic hernia, what we usually get on chest X-ray is the mediastinal shift is always there. In phrenic nerve palsy, we don't get mediastinal shift. Mediastinal shift we get in diaphragmatic hernia or eventration. Now, how to differentiate between the two? Now, here we can see that trachea is deviated towards the contralateral shadow. Heart shadow is little bit contradeviated. So there is medial sternal shift. So many a times, if you are here, we can appreciate the diaphragmatic continuity, but many a times we are not able to differentiate, and it is a very diagnostic dilemma. Then we have to take help of CT scan. Now, another thing what we can appreciate on this X-ray, we can see a right pericardic shadow, and what is more important, the presence of the lucency. This is the bowel gas. So this is another hernia which is called the active hernia. At times, the lucency is not there, then it becomes little difficult to differentiate whether it is simply a diaphragmatic hump or it can be even a cardiophrenic fat bag. Now, another case, this is a very important case. This patient presented with some persistent cough and breathlessness. Some radiopacity was there in the basal lung feed, which was consistent with pneumonia. What else? The interesting thing, the incidental finding, what we noted was the presence of this air fluid level against the cardiac shadow. So this was a very good catch. And when we did the lateral X-ray, we noted that yes, there was a hiatal hernia. So at times this is very diagnostic. Whenever you see air fluid level against the cardiac shadow, it determines the hiatal hernia. So coming to the abdominal X-ray, what important, the basic things I want to highlight. Whenever you see an abdominal X-ray, you have to appreciate the gas pattern, whether it is normal or abnormal, the air, whether it is extraluminal or intraluminal, calcifications, abnormal or normal, and any presence of soft tissue mass. So this is a normal abdominal X-ray, and this is a supine and the prone position. First of all, how you differentiate between supine and prone? If you appreciate the iliac blades, so iliac blades are like open like a book. So this is a supine view, and when it becomes little vertical, half open, so this is a prone view. So this is supine and prone view. Now this is the shadow of the psoas muscle. In supine view, you almost always have the gas in the stomach. And this sigmoid region. At times, you may have air also in the non-dilated small bowel loops. And what happens in the prone position? This ascending colon, descending colon, and the rectum, they are posterior structures. While when they are prone, they occupy the highest position and air fills the rectum. So in prone position, you always have the air in the colon. At times, you may have air in the small bowel also. This is S-shaped rectosigmoid, and the whole colon is diffusely showing presence of air. Now the upright or the erect. Whenever you have the erect position, normally in erect abdomen or upright abdomen, you don't see air in the colon. Or very few times you see, but usually you don't see air in the colon in the upright position. We have to see for two things. One is presence of a free air, another is the air fluid level. So this is a normal gastric fundus air. We have to appreciate that whether it is free or not. And then we have to check for the air fluid levels. Classically, traditionally speaking, we know that maximum 5 air fluid levels less than 2.5 centimeters. So whenever we have more than 5 or more than 2.5 centimeter air fluid level, it is abnormal. So here the length is less than 2.5 centimeters. So this is a non-dilated small bowel showing a normal air. Now, important differentiation when we see the X-ray, we have to see whether this is a large bowel obstruction or small bowel obstruction. We know small bowel it is centrally placed, large bowel is peripheric placed. Small bowel will have valvular conniventus, large will have ostrations. So the classical difference between valvular and ostrations is valvular, they are complete, they are thinner, and they are more closely placed. Ostrations, incomplete, thicker, and relatively widely placed. So this is the difference when we can, this can help us. So this is a case if you see, they are ostrations, incomplete, thick, and these are the valvular conniventus. They are thin, they are almost complete. So small bowel obstruction, large bowel obstruction. What else we can see? We can appreciate, yes, we can appreciate the wall of the bowel. That is, air is lying on both sides. So this is a massive pneumoperitoneum, regular sign what we call. And here if we appreciate, you can see the ovoid air density. That is called the football sign. So they are very fascinating terms. But what is more important, we have to appreciate whether it is free air or not, whether the obstruction is large bowel or small bowel, and whether there is massive pneumoperitoneum. Another, usually falciform ligament is not visible because on both sides there is soft tissue, but in presence of pneumoperitoneum, you can appreciate that. So now we know that this obstruction can be mechanical, it can be functional. Functional, it can be localized or it can be generalized adynamic ileus. And with obstruction, it can be partial obstruction, complete obstruction, large bowel, small bowel obstruction. So if you see that, see, this is a persistent single loop dilated bowel. So this is a localized ileus. And traditionally what we say, whenever you see, for residents, I want to highlight, whenever you see a single dilated loop in the, we say, this is the right upper quadrant, left upper quadrant, appendicitis, right lower quadrant, appendicitis, left lower quadrant, diverticulitis. So we know this is sign resulting from appendicitis. Another important thing is,
नहीं एक्सरसाइज नहीं क्या
actually I cannot see my
गंदे मत कर, नीचे मत बिछाना।
नहीं टेंशन फ्री नहीं, जो हमारी अंदर की कुछ बीमारियां होती हैं।
It is a mechanical bowel obstruction. Mechanical
Are my
bowel
headings visible? Slide heading?
Yes.
Okay, fine. So now this is the another case. If you see, they were having the, this is a valvular conventus, small bowel obstruction. But we can also appreciate large bowel. So this is a partial obstruction, not a complete obstruction. Some air is also going into the large bowel, but the small bowel is disproportionate connected to large bowel, indicating small bowel obstruction.
हाँ जूस पीते हैं उसके सामने समझ लो।
We can see, and this is a small bowel.
धोती भी है, तौलिया अपने लिए ले आया हूँ।
Not a closed loop. Ileocecal valve is incompetent and colon is able to decompress itself into the small bowel. So large bowel obstruction, but with incompetent ileocecal valve. Classical appearance of a sigmoid volvulus and a cecal volvulus, if you see, we know that the apex towards the right upper quadrant, coffee bean sign, is a sigmoid volvulus. Apex towards the left upper quadrant. On CT you can appreciate
ना ऐसे ही रखते थे।
when you have the
मैंने कहा चलो आज पुराने जमाने के लिए आता हूँ।
right lower quadrant in cecal volvulus and left lower quadrant in sigmoid volvulus. And what is more, you can appreciate again, and there is associated small bowel obstruction, means again the ileocecal valve is incompetent. Now the abnormal calcifications, what I want to highlight, whenever in presence of a small bowel obstruction, you see a gallstone-like thing or a stone-like thing, you know that what we are talking about is a regular striate of the gallstone ileus. This is the pneumobilia. For residents, pneumobilia or what is it, the gas in the portal vein, and the portal venous gas is peripherally located. So this makes a regular striate. Now these are the abnormal calcifications, mesenteric lymph node calcification found in abdominal. And these are the typical pancreatic calcifications, a spotter for all of us, or chronic calcific pancreatitis. Another, to differentiate whether it's a porcelain gallbladder or a gallstone. This is the porcelain gallbladder. The wall is calcified. The lumen is wall is calcified, and here we can we can appreciate the laminated appearance of a gallstone. So now another case, if you see, to appreciate the soft tissue shadow. On X-ray, you can identify there is some soft tissue shadow present. And when some GI series and CT scan was done, it was nothing but only the fluid-filled bowel loops. These are the fluid-filled bowel loops. So this is a pseudotumor sign. So on X-ray, sometimes it may be suggestive of a soft tissue mass like Wilms or nephroblast Wilms tumor. At times, it may even mimic a fluid-filled gas. So coming to the various series. Classically, upper GI series, lower GI series, we have the swallow, meal, follow through, and anema. Swallow, it is of esophagus. Meal means stomach and duodenum. Meal follow through means till the ileum junction, we appreciate. Enteroclysis is a small bowel enema, means a nasojejunal tube on the bilbao.
Black वाला यही
is placed just
वो लगा दो,
DJ flexure.
उसमें लगा दो,
Most important, what is good thing,
चार्ज कर रहा है ना,
adequate distension of the small bowel, especially proximal jejunum, ileum, and good thing is yes, for small bowel pathology, but disadvantage, it has relatively more radiation exposure in small bowel enterocolitis than compared to BMFT. And then we have the anemia. Overall, we know that important point to remember is that whenever you suspect a perforation, it should not be done. Barium, if goes into the peritoneal cavity, it will not be good. It may cause hypovolemic shock and other things. So when we suspect perforation, we don't do barium series. But in complete obstruction, it may be done depending upon the risk-benefit ratio. So coming to the barium swallow, these are the normal barium.
Dr. Shivi, sorry to interrupt you.
Yes,
Dr. Shivi, sorry to interrupt you. We'll have to finish the session in 5 minutes, so please try to be fast.
Okay, boy.
Thank you.
So this is a normal barium swallow. I'm not going in detail. I just want to highlight one thing on barium. That what is it is a benign one, and whenever you see this irregularity, so this is the malignant one. So this is how the most important thing you differentiate whether it is a primary achalasia or the secondary achalasia. This is irregularity and this is smooth. Now the hiatal hernia, we know the concept, more than 3 centimeter, this is the gastroesophageal ring, these are the gastric folds. So classical saying more than 3 centimeter hiatus, presence of 3 gastric mucosal folds across the hiatus, G junction more than 2 centimeter, this is the standing hiatus. This is the classical spotter when you have the
6 बजे ये खत्म हो जाए तो
syndrome. So barium means stomach and duodenum, benign and malignant ulcer. In benign, we have projection outside the gastric contour, and whether when we have it is within the gastric contour, irregularity, it is a malignant one. Typical mottled appearance of the gastric reservoir and finding in pancreatic abnormalities. BMFT transit time normal 30 to 120 minutes. We have the typical classical appearance inverted umbrella sign. This is the ileocecal junction.
और वो ना फैब्रिक की मान है उसके बाद वो एक्सपायर हो जाएंगे
and here ileum is dilated and the obtuse angle of the ileocecal junction, so giving the gooseneck deformity of a
तुम लोग ना कम से कम अभी कब से खा रहे हो 2 हफ्ते 3 हफ्ते खा रहे हो फरवरी खा रहे हो
string sign of Crohn's disease and the mottled appearing lead pipe appearance of ulcerative colitis, the claw sign classical of interception and the apple board deformity of a carcinoma colon. Important thing is when we want to distinguish between diverticulum and polyp. Diverticular, they are outpouchings outside the lumen. Polyp, they are within the lumen. So this is the polyp means when it is towards the lumen, it is polyp. When it is pointing outside, it is the diverticulum.
चलो कोई बात नहीं वो तो कम हो जाएगा पहले अपना हेल्थ से कर दो पहले हेल्दी होना ज़्यादा जरूरी है ना
check whether there is
वॉक कर लिया कर
there is extraluminal air or not.
और बाकी गर्म पानी पिया कर जब खाना खाने के बाद पानी मत पिया कर
So this is
हाँ
the
खाना
sign
खाना
and
खाने
we
के
can
खाना खाया ठीक है खाना खाने के बाद पानी पियो सुबह सुबह और जो जितना चाय की तरह पीते हैं ना फूक फूक के
pneumatosis, the air in the wall
सुन रही है
as well as
फूक फूक
air
के
in
पानी
the
जो पीते
mesenteric
हैं गरम
veins. So this indicates
वैसे पिया कर दिन भर में हाँ वो जो शरीर में फैट होता है ना वो जलाता है
also taken place.
ठीक है
So this is very good for detecting that.
और बाकी
Appendicitis, we know that appendix, we know it more than 6 mm.
ठीक है
Higher
चल
sensitivity
सकते
than
हो
ultrasound.
लंबे लंबे चल
Very
लो
good investigation for detecting
और
appendicitis.
उठक बैठक लाएगी
So in short,
उठक
yes,
बैठक
and
रहने दे
clear
तो
within 5 minutes. So plain radiographs, very useful in acute setting.
वो वहाँ से बढ़ रहा होगा
Barium studies, we know still in the era of cross-sectional imaging, they still remain the
उसके लिए ना
mainstay.
वो आते हैं स्क्वैट्स वगैरह बोलते हैं स्क्वैट्स इसका बड़ा टफ होता है कठिन होता है करना नहीं दिखता है
That we don't make use of it in
हाँ वो
perforation.
होते हैं
That we have to go for
वही
gastroenterology studies. And CT scan is a cross-sectional imaging having its disadvantages
ना ना
of
वो तो
radiation
मशीन के द्वारा
exposure.
होगा वो तो
So we have to
अपने आप ही
adequately
करते हैं
use optimization of
एक
imaging and judiciously we have to use it. To use, see the extraluminal air, bowel ischemia
पता नहीं
necrosis,
समझ
and
नहीं आ रहा
presence of
कौन
any
सा करिए
extraluminal disease, and staging if malignancy is responsible.
अच्छा समझ गई जो उठ के उस पे छूना होता है
all the organizers for
अच्छा
giving me
वो
the opportunity.
हाँ वो भी होते हैं वो एप्स के होते हैं और एक
Time.
होता है कि
And
जंप
actually we
करना
are
होता है
running
जैसे
short
कि
of time.
जीना है हमारा जीना है ना आगे वाला
I request all those who have got questions, so please post your questions in the chat box, and I request Dr.
उसी पे
Shivi
ही
to remain
ऊपर नीचे
connected
करना
with
होता
us
है.
for the some time so
तुम्हें
that
याद
she
है
may
मैंने
answer
एक
the
बार
questions in the chat box.
वहां
Your
करे थे
closing comments, Professor and Meena sir.
हाँ.
The
तुम
CV,
3 सेट अभी 5
thank you
करियो,
for presenting
5 से शुरू करियो, ठीक
nice
है.
presentations
जैसे
of
कि
the basic investigation
5
which
एक
is
सेट, फिर
required
2
in
सेट 5, फिर तीसरा 5,
emergency
3 सेट 5
setting,
5 के
especially
लगते
the
हैं, एकदम
X-ray,
ज्यादा हैवी नहीं करना,
chest X-ray,
है
and
ना. 5 ऐसे
X-ray of
करना.
the
मेरा
abdomen.
हीमोग्लोबिन
So
आयरन
it is
चाहिए.
very beneficial for the student. My
क्यों?
small
ये
is
3
in
महीने
the
थोड़ी होता
COVID
है, 3
time. You
महीने
can just
3 महीने के
mention
लिए होते हैं आयरन.
what are the finding
हाँ, आयरन बंद नहीं कर
in
अभी.
the chest X-ray in the CT scan, so that ki sometimes
अच्छा.
the
और
surgeons
विटामिन में
or the non-radiologists may be able to
कैल्शियम की
detect.
दूध ले लिए और
In
और क्या
COVID
बता
times,
रही
sir,
थी?
actually, what is more important, we have
विटामिन
to
डी, हाँ
be,
विटामिन डी ले ली क्योंकि
this
मुझे
is
पता है.
basically
और फिर ना
peri-high
थोड़े
prominence
दिन बाद
is what we
15
get.
दिन करीब ले
And
लिए.
we have to see where, this is very important that we should be able to
पता नहीं क्या है,
differentiate whether
मैं
it is
देख लूंगी
normal
गूगल पे.
hilum or peri-high
वही है.
prominence. So in
अच्छा,
COVID
मैं
we
गूगल
get
पे
the
सर्च कर
peri-high
लूंगी
prominence. At
ये है.
times we can
और
also
दूसरा
get
ब्यूटेडिन में
the
बैठी
possibility
नहीं
to get the
बैठी.
blood test. And more so we always know
अब
that
नहीं
CT
बैठी
is
ना,
a
लेकिन
better
ब्यूटेडिन से तो आराम
investigation
हुआ था ना.
than X-ray. So there are
अब आगे हो रही है.
definite protocols. How do we classify whether it is a particular patient is at high
हाँ.
risk or high suspicion
अच्छा.
for?
पेशाब में जलन तो नहीं है?
Thank you, Dr. Shivi. So as we are running
तुम
short of
बीटेडिन
time,
में
so
बैठना.
we'll be closing this session now.
Shall
And
I stop?
yeah, please, Dr. Shivi. And the next session, I wish to invite the Professor MC Mishra
एक
sir
काम कर.
to moderate the
बीटेडिन
next
में बैठना
session.
फिर से शुरू. मैं टब लेती हूँ
Session
फिर
on
आओ
intravenous
तो.
portal swelling. Over to Professor Mishra sir.
तब भी कहीं खाली ना मिलता हो कभी.
Good afternoon, Dr. Puneet. Thank you, Dr. Shashi. Department of Surgery.
मैं बाथरूम में जब जाती हूँ तब मुझे वही ख्याल आता है कि यार तब जाता.
Lead faculty for this session.
Sir, you are the moderator for this session.
वैसे तो रखा रहता है, यहाँ कुछ काम नहीं है, बस अव्यय नहाती है हफ्ते में. हाँ वही बस अव्यय नहाती है हफ्ते में एक बार तो यूज में आता है, वरना वो भी रखा रहता है यहाँ पे.
Dr. Ratna Chopra from New Delhi, Dr. Satyendra Kumar from Varanasi, and Dr. Mrityunjay from Bhagalpur.
अभी तो हफ्ते
I
में
hope that everyone is there except for Dr. Mrityunjay. I can see all of them. They have joined, sir. So you can
थोड़ा ना गर्म पानी में बैठना तुमको तो देख ना जैसे 7 दिन लगातार बैठी या 10 दिन लगातार बैठी ना तो कुछ भी वहाँ पे होगा तो ठीक हो जाएगा. है ना क्योंकि और
Okay, Dr. Shaurya, are you ready?
Yes, sir. Just I am opening.
दूसरी कहाँ हुई तुझे?
Okay, Dr. Shaurya, please go ahead.
जहाँ से लेटरिन से जाते हैं वहाँ होती है.
Dr. Shashi, Dr. Puneet.
और
40 minutes we have it for this session.
Okay.
And we'll be discussing in the same manner. We'll be first starting.
मतलब थोड़ी ऊपर कमर के नीचे और लेटरिन रास्ते के बीच में.
I could see Dr. Jignesh, but I have not seen others.
अरे तो तुझे टांकों में होगी
Dr. Ratna Chopra, both of them are there, sir.
Okay.
टांकों में नहीं, sorry.
Shaurya, please go ahead.
The slides are visible. Can I start?
Yes, we can see your slide.
Good afternoon, sir. Sir, I am Dr. Shaurya Katia.
अच्छा, जो हमारी स्किन है उस पे हो रही है जहाँ बाल रहते हैं.
I'll be presenting on inguinal scrotum swelling.
और कौन
I'm presenting case of Mr. X, 42-year male, who is a farmer and resident of Manipur, Jhansi. He came with deep complaint of swelling in right groin since 1 year. History of present illness. Patient was apparently
अच्छा तो नहीं पता बाल तो साफ नहीं है
when he noticed a swelling in his right groin region.
और जब बाल
It
आते हैं
was
तो
insidious
इसमें
in
से
onset.
दिक्कत होती
It was
है.
initially small and confined to groin, but has gradually progressed to
स्ट्राई
deep
मार्क्स में नहीं है, स्ट्राई मार्क्स में.
It appears on
स्ट्राई
walking,
ऊपर
coughing,
जाते हैं.
and straining, while it disappears spontaneously on
हाँ नहीं है.
There is no history of chronic breathlessness, constipation, or straining on defecation.
अच्छा
No
वहाँ
history of
होती है.
dysuria,
तो गीला भी नहीं छोड़ेगी अपना.
micturition,
ड्राई
bleeding
करके
of
दिए ना.
urinary stream, nocturia. There is no history of
बदल
intermittent
देती
nausea,
मतलब तू
vomiting,
ड्राई तौलिया से
colicky, abdominal pain,
साफ
or
तौलिया से
abdominal
साफ
discomfort.
सूखी तौलिया से
Past history,
जब
there is
टॉयलेट
no
गए या
history
फिर
of
पानी में
tuberculosis,
बैठ के
bronchial
धो दे
asthma,
उसके बाद
diabetes, or
साफ वो
hypertension.
ड्राई
There is
नहीं
no history
करती
of any
खाती नहीं है.
surgery. Family history, no history of
Discharge
swelling
बोले
in
तो
any
white
of his
discharge
family
है
members.
पीरियड वो वाला पीरियड वाला
Personal history, he is
तो
vegetarian,
white discharge इतना ज़्यादा
blood
नहीं
and
होता हो कि
urine habits
लगातार
are
हो रहा है
normal,
ये है कि
normal
कभी
sleep
कभार हो रहा है
pattern, history of tobacco chewing since last 4 years, no history of smoking or alcohol consumption. Summary: a 32-year-old man presented with right-sided inguinal scrotal swelling since 1 year, which appears gradually on walking and exertion and disappears spontaneously on lying down.
और white discharge है तो एक काम करते रहो.
Should I proceed, sir?
Dr. Jignesh, would you like to ask anything at this point of time?
Yeah. Yes, Shaurya, welcome to this session. Shaurya, can you go back to your history? Can you go back to your history? So you mentioned to us about some urinary symptoms in the patient. The next slide. So is there a particular pattern? Is there a particular pattern in which you notice urinary symptoms, or you just randomly ask about everything, whatever is possible?
So, considering the age of the patient, as he's a young 32-year-old male, I suspected him of a urinary stricture that may develop in his age. So I tried to rule out that.
Fine. And suppose if it was an elderly patient around 60, was there any particular pattern in which you will ask the questions?
Yes, sir. Sir, for that I'll ask the bladder outlet obstruction symptoms, most probably due to benign prostatic hyperplasia that may result, sir.
Do you directly have obstructive symptoms, or there are some other symptoms which come first?
So first there are lower urinary tract symptoms like increase in frequency of urination, nocturia, then outlet obstruction symptoms appear.
So there are irritative symptoms which come up first, and then you have obstructive symptoms. So there is a pattern in which you are supposed to ask rather than asking randomly. Why have you asked history of chronic cough?
So chronic cough and breathlessness, sir, these features are not only are both precipitating factors as well as are causing for increased intra-abdominal pressure, which might result in hernia, sir.
Brand name candidate.
Okay, and why history of chronic constipation?
So chronic constipation and straining on defecation, so both of these are causes for increased intra-abdominal pressure, sir.
Okay, fine. Thank you.
Shaurya, do you call them cause or something else?
Sir, these are the precipitating factors, sir.
Predisposing
factors.
Not necessarily that everybody who has chronic cough will develop hernia, but the likely that some of the patients may have history of chronic cough or stress means how does it happen actually? What happens in chronic cough? What happens in chronic constipation? What happens in dysuria or prostatic enlargement? What happens?
Sir, all these symptoms, sir, they lead to increased intra-abdominal pressure.
That's fine. That's fine. Go ahead. Move ahead.
So Shaurya, you also asked about history of surgery, some surgery. And the second thing you asked about is any family history. Can you elaborate on these 2 points? What surgery were you looking at? And
yes, sir. Sir, history of surgery, any lower abdominal incisions around abdominal incisions, for example, on right side appendicectomy or any ureterolithiasis incision, and if left-sided ureterolithiasis incision is given, these when a muscle cutting incision is given, this leads to damage of the inguinal nerve and iliohypogastric, which in turn leads to weakness of the muscle in that region, the oblique muscles. So which in turn leads to direct inguinal hernia.
Direct.
Okay, and the history of similar swelling, direct or indirect?
So direct inguinal. So defect. So this leads to direct inguinal.
How do you know that? have you seen any study where it showed only the direct will come, not the indirect one? Only anyway, go ahead.
And one more thing, Shaurya was no history of similar swelling in the family member.
Can
you elaborate on that?
Sir, yes, sir. Collagen deficiency diseases are, sir, they are the causes of weakness of lower abdominal muscles, sir, like Ehlers-Danlos syndrome, sir, Marfan syndrome, osteogenesis imperfecta.
Which type of Ehlers-Danlos syndrome?
The type 4, sir.
There are different types.
Yes.
Type 4 or type 5?
Type 4.
Not sure. Type 4.
4.
Okay, fine. Continue.
So, on
Just continue with your examination.
Yes, sir. So, patient was examined in a well-lit room in both standing and supine position after taking proper consent. Patient was well-oriented, nice and person. Performance status ECOG score 1, temperature afebrile, pulse 78 beats per minute.
What is this ECOG score?
European Cancer Society scores. It is done for performance.
No, it is a European Cancer Society.
Nice.
Yes, sure. What is it? Because you have said something, now you're committed to it. So this is what, we don't, as an examiner, if you have written something in the exam, you have to know the full form and everything about it. Even I don't know. But
You
you
have
have to
to
elaborate and
enlighten
tell
us.
us. Yes.
You must have read about it. So enlighten everyone. What is the ECOG score, or you don't remember now?
Sir, I had
Forgot?
It is the European Cooperative Oncology Group.
So, Shaurya, the big lesson here is do not use abbreviations if you are not sure that you would remember them. Use full terminologies, and in bracket you can write the abbreviation. So avoid using abbreviation because everybody is not. I am not aware of this. So it may be important, but I'm not aware of it. Go ahead.
So before she goes,
yes, Ratna.
Yeah, before she goes to examination, is hernia the only possibility that comes to your mind when you think of reducible swelling? Based on the history, you said swelling is reducible when the patient lies down. Can you tell us some more swellings that reduce on lying down and appear on standing up in the groin?
Sir, ma'am, differential for this type of swelling can be a varicocele, another all groin hernias, varicocele, a saphenous varix, or a lymph varix.
नहीं रहा इसमें.
Yeah, you're okay. Go on.
शेयर करना होता है.
Okay, beta. Go ahead, doctor.
Please carry on.
Yes, ma'am. Ma'am, pulse 78 beats per minute, regular, normovolumic, without any residual or radio.
Blood pressure is okay. And any other significant positive finding?
No, sir.
Absent. Go ahead. So I will save some time. Okay.
Sir, local
All right.
examination. The standing position, a pear-shaped swelling seen in right inguinal region extending up to the root of scrotum. Surface was smooth with rounded margins. Skin over the swelling was normal.
Okay, just stop here. Dr. KN. Dr. KN Shrivastava can you hear me?
Yes, sir. Sir, can you?
Yeah, now I can hear you.
Yeah, Dr. KN, would you like to ask anything at this point of time?
In fact, I just got disconnected for 2-3 minutes. One thing
this inspection, can you see her slide? She has just narrated this inspection findings. A pear-shaped swelling seen in right groin region, extending up to the root of scrotum. Surface was smooth and round margins. Skin over swelling normal.
She is contradicting herself by saying pear-shaped, and then she is telling that it is going right up to the scrotum.
Root of the scrotum means it's not going into the scrotum. Root, what do you mean by root?
The root of the scrotum just above the testis is not reaching.
Yes, I think it's not root. It's not going into the scrotum. That's what you mean?
Yes, sir. So not entering the scrotum.
Yeah,
exactly.
It is not entering the scrotum. That's what it should mean actually. So it's not a complete hernia. That's what you want to say?
Yes, sir. It is an incomplete hernia, sir.
Yes, Dr. Kian, please.
Dr. Mishra, in fact, I was lost for 2-3 minutes during her
Okay,
history.
Shaurya, go ahead,
So,
describe other
I just wanted to tell one point to Shaurya. It's
Yes,
a very
sir.
small English language problem. Whenever you state the duration of the illness, always mention for if you are using 1 year or 2 year or so on. You should use since only when you say it is since year 2020 or since July 2020. It's a very minor issue, but you must always remember if you are using the duration 1 year, always use swelling for 1 year. Okay, one. And second thing, I just wanted to know in the history you were telling that there is no history of surgery. Are you very specifically asking for some surgery which may be of any use in this particular case?
He mentioned, Dr. Kian, appendectomy on right side.
Sure. I'm sorry.
Open urethral lithotomy on right or left side.
Okay, I was lost during that.
That's what she meant.
Sure.
Shaurya, go ahead.
Go on.
Yes, sir. Sir, expansile cuff impulse present. Swelling disappears when patient lies down. No visible peristalsis over the swelling. Penis is not deviated to any side, sir.
Dr. Satyendra Kumar, is he there? Dr. Satyendra,
yes,
you are.
Hello. Am I visible?
Do you want to ask something at this point of time?
Shaurya?
Yes, sir.
Can you think when you suspect patient is having a could be inguinal swelling or the femoral swelling on inspection? Can you suspect?
Sir,
Even on inspections?
Sir, on inspection, sir, an inguinal hernia swelling lies above the inguinal ligament, while femoral lies below the inguinal ligament. And with respect to pubic tubercle, it lies medial and above the pubic tubercle inguinal, while the femoral lies lateral and below the pubic tubercle.
Yeah. Right. Okay, sir.
Okay, go ahead, Shaurya.
Yes, sir. Sir, on palpation, temperature normal, tenderness absent, not possible to get above the swelling. A pear-shaped swelling of size 6 into 4 centimeter present in right inguinoscrotal region from deep inguinal ring to the upper pole of testis. Sir. Surface is a smooth, consistency granular and doughy. It lies medial and above to the pubic tubercle. Expansile cuff impulse present. Swelling is reducible manually and contents easy to reduce initially as compared to the last part. Deep occlusion test swelling does not appear on cupping. That is, deep occlusion test is positive. Siemens test impulse felt at the pulp of the right index finger. Bilateral testes are palpable. Bilateral inguinal lymph nodes are not palpable.
Dr. Mrityunjay, has he joined?
Yeah, I have joined.
Yes, Dr. Mrityunjay, would you like to come in at this point and ask her some questions?
Yeah, I can. Shaurya, tell me whether intra-abdominal pressure is a significant thing in the etiology or it is not related to the hernia formation. Increase intra-abdominal pressure.
Dr. Mrityunjay, we got over this point very early on. I think
the point was not discussed, sir.
So you can convey your point and let's move forward. Because
yes, increase intra-abdominal pressure is seen in the Olympian weightlifters, and there is no incidence of rise in hernia in as compared with the general population. So it is not the thing. It is only the structures entering or coming out of the abdominal cavity is more important, and because testis comes out through the inguinal canal in the intrauterine life, and that weakens the Hasselbalch strand, that weakens the Cruchot's myopectineal orifice, and that is the cause of hernia. There is no relation of the rise in the intra-abdominal pressure caused by the cough or the constipation or the bladder outlet obstruction. It is not.
Dr. Mrityunjay conveys that there is no significant risk, increased risk of development of hernia, even if there is raised intra-abdominal pressure,
as seen in
and
the Olympian
that has
weightlifting.
been brought about by athletes who participated in Olympic Games. But naturally, all these traditional, or I would say orthodox teaching is going on for decades, and maybe that is based on some patients who might have developed in elderly age group when there was a weakness, and because most of the times is chronic cough, chronic constipation, and obstructing urinary symptoms develop in elderly population.
Yes,
and these Olympic athletes are young. They have good musculature, so in them it may not have worked, but it is just that in some patients that may be predisposing. I think that is what she said, and which has been the standard traditional teaching all these years to all the students, but the evidence is contrary to that, at least in young population.
Yes, that I want. Another point, sir, about the operations, that is appendicectomy or ureterolithotomy. The hernia which is caused is always direct. It is never indirect, because
that's what she said. That's what she said. That's
no,
what
some
she said.
controversy was there, sir.
No controversy. We were just probing her.
Yes.
There was no controversy.
Another point, sir, those incisions should be laterally placed towards the anterior ileus.
Basically, when they involve the nerves, they can damage the nerves, and that is the reason. On the this examination on this slide, do you have anything to ask or add?
No, sir. No. About the type of hernia which is mentioning, according to the distance of the descent, that is, what is bubonoceal or what is funicular? Can she tell us?
Yes, sir.
Shaurya, can you respond to?
The bubonoceal, the content enter through the deep inguinal ring into the inguinal canal, but do not cross the superficial inguinal ring. So while in funicular, they enter the deep inguinal ring, they cross the superficial inguinal ring, reach up to the upper pole of testis, but do not reach the base of the scrotum. That is, testes are palpable separately from the swelling, sir.
Then type of hernia yours is, in this case,
incomplete.
It is funicular. Better to tell funicular. Yeah.
Dr. Shaurya, what he's asking, what type of hernia it is, direct or indirect?
Sir, indirect hernia, sir.
So you are saying incomplete indirect hernia, and you are saying it is funicular.
Funicular.
Yeah. That's okay. So on percussion, a dull note was present on percussion over the swelling. Vowel
What
sounds
does that mean? Dull note. What does that mean? Dull note.
Sir, if we comment on the contents of the hernia swelling,
so what does it mean? What does it mean?
Sir, most probably it is omentum, sir.
So it may not be bowel. It may only say that. Okay. Auscultation, bowel sounds absent. So there no bowel. Left side, inguinal scrotal region is normal. On inspection and palpation, external genital are normal. Okay, go ahead. Anal tone normal, prostate not enlarged, no other growth. What is his age? You said?
So 32 years.
30 young. Okay. Go ahead.
So systemic examination.
Anything significant on systemic examination?
No, sir. On per abdomen.
Okay, go ahead. Skip these slides.
Yes, sir. So summary.
Summarize.
So a 32-year-old man presented with right-sided inguinal swelling for 1 year, which appears gradually on walking and exertion and disappears spontaneously on lying down. On examination, the swelling was reducible with positive cuff impulse and deep ring occlusion test. In Siemens test, impulse felt on the pulp of right index finger.
How reliable is this pulp business? How reliable is this pulp business? Pulp or the tip?
Depending on if this hernia is not.
I'll request Dr. Jignesh to intervene at this point.
Shaurya, how reliable are all these tests? Are there any tests which can definitely tell you about direct or indirect, or how do you make out?
And is it important in modern 21st century?
Yeah.
So there are fallacies of all these tests that both these tests. There are some.
So which is the best way to know whether it is direct or indirect?
Sir is asking whether it is important in this era to differentiate between direct and indirect hernia.
That is number one. And number two question is, which is the best test?
Yeah.
Sir, it is important if the patient, when we have to tell the patient for further the possibility.
No, it is not important. The
How
treatment is same. Treatment is same. So it is not.
Can you elaborate, Shaurya? You are saying
Dr.
that
Mrityunjay, I think let Dr. Jignesh interact here. I think your turn will come.
Yeah. Shaurya, can you
Yes,
tell us
sir,
how it will change the management?
Sir, I just wanted to say that a small direct inguinal hernia in an elderly patient with comorbidities can be left for wait and watch policy, and rest need to be dealt surgically. And the best way is on table while doing surgery to know whether it is a direct.
Will we follow wait and watch policy in this patient, 30 years old male?
No, sir. We tell him to get over surgery.
I think, Shaurya, I'll probably agree with your second part that the best way is to know intraoperatively. But your first part that you should leave it alone is a very subjective term, because a lot of times patient would be having bladder as a content in a direct hernia. So it depends on case-to-case basis. But obviously, there are fallacies of the test.
Is she saying direct hernia you leave alone?
Yeah, she's saying direct hernia you should leave alone. So that's a very...
in which group of patient you would not like to intervene? That's it.
An elderly patient with comorbidities, sir.
Who do you consider elderly? Am I elderly? If I have a hernia,
Shaurya, I can also do the hernia under local anesthesia. So for me, probably there is no contraindication. Then what will you do?
What would be the relative contraindication or not contraindication you would not like to operate? That's a relative thing. In which group of patient you would not like to operate? Give me one sentence answer.
Sir,
if the risk of performing surgery is higher than the risk of hernia. Okay, and those patients would be, like Dr. Jignesh said, he can do it under local, and we have done under local anesthesia.
Yes.
So that's not the point. Point is, if somebody has excessive risk, that risk would be related to cardiac status. That risk would be related to patient can't lie down on the table to get it done. Patient has bleeding diaphysis, which is anyway contraindication for any surgery at any age. Okay. So age per se is not a contraindication for any surgery if the patient carries acceptable risk. And defined for most diseases, surgical diseases at most ages. So I think that is something. My father had a hernia, and I regret not having operated upon him. And he was quite uncomfortable until he died.
लखनऊ में भी गया था प्रेजेंट करने के लिए, उसको एम्स का है ना, हाँ, और उसको उन्होंने प्राइज भी दिया था, मैक्सिला का वो फ्रैक्चर कुछ बताया था,
patient and family has to take.
हाँ.
Okay.
Yes, sir.
Okay. Go ahead.
The provisional diagnosis: right-sided, uncomplicated, reducible, indirect inguinal hernia with.
Professor Srivastava, would you like to come in at this point of time?
Yeah, I think one Dr. Jignesh asked you,
Yes,
what
sir.
is the one test which you like to
इन सालों को भी आराम मिल गया होगा अपने कोरोना में.
The answer is
है ना?
or solution.
Hey.
You have come
मैं कुछ
immediately
कह रही हूँ,
forward.
लगा के बैठ जाते
That
काम.
is the one
एक
test
काम
which
में
will
आवाज नहीं आ रही.
immediately tell you whether it is direct hernia or indirect hernia.
नहीं
So that
बताओ क्या
answer
करेंगे.
was
मैं कह रही हूँ लोगों का भी
supposed to be
नॉलेज
given
का
by you.
उन्हें भी आराम मिल गया होगा कोरोना में.
Question I like to ask you,
है ना?
which surgery would you advise in this particular and why?
The hernia surgery basically is a tailored.
32-year-old male, young male, indirect inguinal hernia as per your description, which is reducible, possibly has omentum, which is reducible. Question is very
ये नहीं
simple.
खाएगी
What would you advise this patient and when?
एक्चुअली बीच में ब्रेक ले लिया ना तो दिमाग काम करने लगा अब ये थोड़ा समझ में आ रहा है
Prone to get complicated, and he is a farmer by occupation. This hernia, hinders with his normal daily activities. And I'll tell him both about open surgeries as well as the laparoscopic surgeries. Then, depending for which one he opts, or the surgeon who is doing it with the surgery which he is more comfortable. He will be advised to.
Patient says you decide. I am ready for anything.
और डॉक्टर साहब आपका जो ठीक आप समझे वो कर दीजिए. इंडियन पेशेंट तो यही कहता है आखिर में आप जितना मर्जी एक्सप्लेन कर दो उसको वो कहेगा डॉक्टर साहब आप जो ठीक समझे वो कर दीजिए. तो आप क्या करेंगे?
What will be your choice? And why?
I'll go with Lichtenstein mesh hernioplasty. Sir.
Why not laparoscopic repair?
Sir, basically, sir, laparoscopic repair is still indicated in bilateral surgeries, bilateral hernias and recurrent hernias.
As per NICE guideline, it is now recommended in unilateral as well.
Yes.
Shaurya, I think you need to give a better answer to that. As Dr. Mrityunjay has said that now unilateral hernia is also laparoscopic repair is recommended. So give a better answer. We want a better answer from you.
Sir, I'll explain him about the.
No, you have explained. You have already explained. वो तो कह रहा है ना डॉक्टर साहब हमने आपको आपके ऊपर छोड़ दिया. आप जो ठीक समझे वो कर दीजिए. फिर और क्या फैक्टर्स आएंगे कि आप डिसाइड करेंगे कौन सा प्रोसीजर करना चाहिए या नहीं करना चाहिए. आप सर्जन हैं.
And you are competent in both routine as well as laparoscopic repair.
नहीं अगर कॉम्पिटेंट दोनों में होगी फिर तो ये लेप्रोस्कोपी कर दी होती इसने अब तक. वो है नहीं ना इसलिए वो कह रही है मैं तो लाइकेंस्टाइन में हूँ. मैं तो लाइकेंस्टाइन उसका जवाब ठीक है वो.
करेक्ट
है ना.
ठीक है.
वो लड़की कर रही है प्रेजेंट तो बोलता है मतलब वो बोलती है कि ओल्ड एज में डायरेक्ट hernia को हम छोड़ भी सकते हैं. तो ये better. Whom you consider old? Am I old?
Early recovery to work, early return to work.
Okay,
Shaurya, you were mentioning that since it's an indirect hernia, that's the reason I would like to operate. So that means if it was a direct hernia, you would have not operated it? Because you made that comment very clearly. Sir, because it's an indirect hernia and he's a farmer, I would like to operate it. So suppose if he is a doctor and he's got a direct hernia, then?
Yes, sir, indirect hernias are comparatively more prone to complications, sir. That I'll explain him more about the complications.
So if this patient had a direct hernia, then you will not operate it?
No, sir, as sir mentioned that now only all hernias should be operated, and even if it is a direct hernia, it should be operated.
This is I like this student because she is taking the information from one of the examiner, so that you take one examiner on your side, you can score well.
Okay, Dr. Ratna, please come in at this point of time.
Dr. Shaurya, you've written European Hernia Society classification PL2. What do you mean by 2?
So 2 means the finger breadth defect. So ma'am, if it is one finger breadth defect, that is less than 1.5 centimeter. From 1.5 centimeter to 3 centimeter defect, it is 2 finger breadth defect. And if it is more than 3 centimeter,
that's fine. In your clinical examination, when you defined it, you mentioned about the size of defect. So you never made a mention of the size of the defect then. but you're making a clinical diagnosis of PL2. So we have to be a bit cautious about that. Another comment I wanted to make was you never talked about the urethral meatus and palpation of urethra in a young patient. And the third thing I wanted to talk about was that when you described your examination, you started directly with the hernia on the right side, right? You should give a panoramic view first. There is asymmetry on the two sides. And then you just talked about, both the testes are palpable and then thereafter the left inguinal scrotal area is fine. So that was a bit haphazard. We can follow a very structured pattern to describe. And then whenever you are asked how would you manage a case, it may be a good idea to say that I will discuss the options with the patient and tell them the incidence of recurrence in both the types of surgeries, that they are almost similar, and that we are doing as many surgeries at our center, and then I would prefer to do this. If the patient does not want, say, Lichtenstein's and wants a laparoscopy, you can give him an option of going to another center with a laparoscopic surgery. Dr. Mishra, sir.
Okay, Dr. Satinder.
So, Sonia, can you, at this point of a diagnosis, can you say what is the type of hernia in the reference of Wilbert classifications? You said 2 centimeter defect.
Yes, sir. Type 2, sir. Medium indirect hernia, sir.
Yeah, type 2 is less than 2 centimeter defect, and more than 2 centimeter is type 3. Another point is that in the direct hernia, why you advise for the conservative approach, not surgery? I think the study said that if you operate delayed operation perform with these patients, the complication rates are similar. Okay.
Okay.
Next. Okay, go ahead.
Sorry, can you tell us whether TEP or TAPC? If choice is there.
Yes,
Chile,
there are two options available in laparoscopy. So total extraperitoneal repair or transabdominal preperitoneal repair. Sir, the advantages with TAPP, sir, first of all, wider view of preperitoneal space is available. Secondly, can be done in a patient who have undergone prior pelvic surgeries. Thirdly, it is easy to learn, and the learning curve is easy and easy to teach as well. And sir, it is better in females also, sir.
आज का होमवर्क करा दिया होमवर्क करा दो इसको
Okay. And you can
one more thing is that
put the next slide. Can you put the next slide? What is the next slide? Then we can ask Dr.
One more advantage of this TAPP is you can also diagnose the occult hernia, contralateral occult hernia.
Bilateral
yeah.
is upfront. Dr. Mrityunjay.
What is occult hernia? Can you tell me?
The patient complains of pain in groin, but there is no clinically palpable swelling in groin.
How you diagnose it?
By investigations or ultrasonography.
No, without investigation. You can rely upon the history. If the patient tells that the swelling appears and disappears, you can make your diagnosis on that history only. Second thing is to re-examine the patient at a different date, says after 3 months, or when the swelling appears. Then the investigation. What investigation will you go for?
So first, sir, in this patient, sir, first we'll do routine blood investigations.
No, to diagnose a case of occult hernia.
Sir, ultrasonography, sir, higher resolution sonography will be done, sir.
After if it is not there, then?
Sir, then we go to
next investigation.
So, CT scan can be done, sir.
No. Do you know about herniography?
Herniography, sir. Herniography, sir.
What you find there?
The contrast is injected in the peritoneal cavity, and on taking and patient is light supine, and on taking image, a sac is seen that is herniated through a defect.
Sac is seen or some asymmetry is seen on the both sides.
Both sides.
Asymmetry.
Dr. Mrityunjay. Dr. Mrityunjay, can we take opinion from other examiners on herniography?
herniography nowadays absolute one. But nowadays most of the time this all hernia died with the
That is true.
ultrasound.
That is
Yeah.
true.
So,
But as a
so Shaurya,
postgraduate, she has to know. She has to
yeah.
answer.
So, Shaurya, we would not do, yeah. So we would not do a herniography nowadays,
Yeah.
Shaurya.
That's
But you mentioned
that's
about
true.
CT. What's specific in the CT? Can you elaborate on that? What CT? So you have to do a Valsalva enhanced CT scan. Okay. So you have to do a plain CT scan of the abdomen and then do a Valsalva enhanced. So when you do a Valsalva enhanced CT scan, you can appreciate that bulge, and this is the way you can pick up occult hernias. Okay. So it is not only CT scan, Valsalva enhanced CT scan. Okay.
Is there any role
Sim-
of diagnostic laparoscopy?
so similarly, the Valsalva maneuver can be done while performing ultrasound of that thing only.
Yes, agreed. Yes.
Okay.
And
Any role
why
of
I
do you
think
want
let
to?
us.
diagnostic
The time
laparoscopy?
we are left with only 3-4 minutes. So can you go on next? What slides you are left with?
Sir, this is the last slide, sir.
Okay. So Doctor K. Srivastav.
I think she has said things about the investigations, and she has been told about the further investigations which are required. I would definitely like to know about the main steps of licensing. I think that should be that is one she should be knowing it. So I think what is exactly done in licensing? What exactly you do?
Sorry to interrupt you, sir. We have a full
Open
session
mesh
there
repair.
on the open hernia mesh repair. So we'll be discussing the all steps which are required there. So I think, sir, we are not
Okay.
overshooting the
I
time.
think then we are. No, we are not overshooting, Dr. Puneet. We started
Yeah, so we can.
4:15, and now it is not 4:58.
सुनो
So we are very
मंदिर में
close to
पैर
the.
मत छुआ करो
Shaurya, one question to you in elderly
सुना नहीं है
patients. There is
क्योंकि
a
मंदिर में तो
repair
सबसे बड़े
which is
भगवान
known
है
as Kunz repair. I will answer the question for you.
यही होगा
Can
इसका
you tell
कारण
me what is the Kunz
मेरे
repair
दिमाग ने
which
अभी
is
कहा
done in some patients who have got large, indirect, incomplete sac? KOONZ, Kunz repair.
Kunz repair, sir, where orchidectomy along with the removal of cord is cord and testis is done with posterior wall repair.
Why it is done? Why it is done? Why don't you do it in all the patients? So your answer is correct. So probably you would probably get marks on that.
Sir,
But when you have dense adhesions in a very chronic sac, and there is an atropic testis at that particular age, so there is a repair which is described, which is known as a Kunz repair. So one should know that this should be, but that the patient has to be well concentrated at that particular age,
informed
and that's the
consent.
reason. Yeah. Now in this particular case, Shaurya, just a very quick answer for you, yes or no. Would you like to operate his both the sides, or you would like to operate only the right side?
Sir, only
And
right.
if yes, why? If no, why? Yeah, why not the opposite side? If you're doing a laparoscopic repair and if you find the opposite side, then what will you do?
लेप्रोस्कोपी में तो लगाना चाहिए
Sir, if we are doing laparoscopic repair, then it will right hernia on quadrilateral side, we will repair that side.
But then you have not taken the consent.
Sharing is right, Emily.
Yeah, consent is not taken. So that's where your answer of ultrasound comes into the picture. That ultrasonography will let you know what is happening onto the opposite side. So you consult the patient well in advance that if I find a hernia onto the opposite side, I would like to do it at the same time. Yeah. Okay. So this is where your investigation.
Or you can counsel the patient. I look at the other side, and if I find hernia, do you allow me to operate that side? I think that can be done. So I thank my examiners, Dr. Jignesh, Dr. K. Srivastav, Dr. Ratna, Dr. Satyendra Kumar, Dr. Mrityunjay, and thank you so much, Shaurya. You presented very well and wonderful. I must give all credit to you for your presentation. You were well prepared. Hope that you do this kind of a history taking and examination routinely, not only for such presentations. I think that is the bottom line, and that is what all the residents need to learn. Thank you, Dr. Puneet. Thank you, Dr. Shashi, for giving us this opportunity. Back to you.
Thank you, Mr. Sir. Thank you, Shaurya.
Yeah, thank you, sir. Thanks,
Thank you, Puneet sir.
Pulisha, for moderating the session, and I thanks
Thank you,
all the
sir.
Dr. Patel, and Dr. Mrityunjay, acting as an examiner for the last session. Now I request Dr. Paninder Lal, he has joined. Yeah, I can see him. I request him to act as a moderator for the next session, and that is a case capsule on incisional hernia. So over to Dr. Paninder Lal, and we have our examiners in this session, Dr. Rajiv Sinha, Dr. Richa Jamin, Dr. F.P. Singh, Dr. G.N. Rathod, and Dr. A.K. Atri. I think most of the examiners, they have joined.
ज्यादातर लड़कियों नहीं प्रेजेंट करें यार।
Dr. Sachdeva.
एक ही लड़का आया था शुरुआत में, कृष्णा, उसके बाद लड़की भरी पड़ी।
Over to Dr. Paninder Lal.
Thank you, Dr. Puneet. Everybody. Yeah, thank you, Dr. Puneet, and welcome everyone. Please, some mic is on, so if you could mute. I'll unmute myself again. Yeah, thank you. So I welcome my panelists, and the way we will go is that we'll request Shelza to present in the first 6 to 8 minutes, and we will take a break at the end of history, and all the 5 examiners will ask a question each in 1 minute, and then we will move on to examination. And again, I request all my examiner colleagues to be ready with the question in 15 seconds or so, and giving about 45 to 50 seconds to the candidate to answer. And then we'll move on to investigations and then to the management. So we'll have 4 rounds with each of my colleague examiners. Just in case an unprepared question has been asked, please be ready to come up with another question so that we don't have a repeat. So over to Shelza Sachdeva. Please start your presentation. It's 2 minutes past 5 o'clock.
Shelza, you can
please start. Shelza,
you are not audible as such.
Unmute yourself. You're on mute.
Hello.
yeah, we can hear you now. Yeah.
Good evening, respected all. I am presenting a case of 15-year-old male, resident Anu, who was admitted in the surgery ward and presented with 3 complaints of swelling in lower abdomen from 4 months. History of present illness. The patient was apparently asymptomatic 4 months back. 4 months back, when he noticed a swelling in lower abdomen. The swelling was painless, insidious in onset, gradually progressing in size, initially with a size of 5 into 5 centimeter approximately, and gradually progressing in size to attain the present size of approximately 15 into 15 centimeter. The swelling increase in size or becomes prominent on standing, walking, straining, coughing, and decreases in size on lying down. The swelling is reducible. The patient also complains of pain and swelling since 1 month, which is mild, dragging, non-radiating, remains throughout the day, more towards the end of the day, or just after the meal, and relieves on taking rest or after defecation. And the patient complains that he had episodes of dry cough a few months back. There are no complaints of chronic constipation, difficulty in micturition, of redness or skin changes on the swelling, of swelling anywhere else in the abdomen, of recurrent colicky abdominal pain with vomiting or constipation, no history of lifting heavy weight, no history of acute irreducibility associated with pain, vomiting, or distension, no difficulty in walking, no history of back pain, no history of breathing difficulty. Past history. As per file records, there is history of exploratory laparoscopy done by a midline incision with suprapubic cystotomy done intraoperatively 7 months back. There is history of COVID-19 infection with mild symptoms, cough, sore throat, and fever, for which he was managed in COVID isolation ward. There is no history of tuberculosis, diabetes mellitus, asthma, or any other chronic illness in the past. Personal history. The patient is a vegetarian. The patient passes urine via suprapubic Foley's catheter. Uses since 7 months with regular catheter care. No history of normal bowel habits. No history of any substance use in the past. Summary. A 15-year-old male with complaints of swelling in lower abdomen
from 4 months,
हम्म,
which is insidious in onset, gradually progressing to attain
आराम
the
से
present
आराम
size
से
of
ठीक
approximately
है
15 into 18 centimeter,
मुझे लग
painless
रहा है खत्म हो
initially,
जाएगी
becomes prominent on
तो
standing, walking, straining, cuffing,
गुड
and
मैनर्स के साथ
decreases in
खाओ
size on lying down, associated with the history of
हम्म?
exploratory laparotomy by a midline incision 7
आराम से
months
खाओ
back. The swelling is associated with dragging pain, mild, dilating,
इसके बाद तो
non-radiating, remaining throughout the day, more towards the end of the day. Just after a meal, relieves on
इनका
tickiness
एक
or
फायदा ये
pain
मिल रहा है,
indication from 1 month. There is
ये पढ़
history
पढ़
of
के बोल दे
direct
रही हैं।
infection with COVID-19.
तुम्हारा
जिस
इधर
समय
हो रहा है
जिस समय वहां होता था तब पढ़ने को नहीं मिलता था,
Wait, just go back to that
तो ऐसे
summary,
प्रेजेंट करना होता था।
Shelza. And I request Dr. Rajiv Sinha to come up with the first question on history.
Yes.
Sir, you are muted. You are muted, sir.
So, what kind of midline incision was it? Was it lower midline incision, infra or supra?
So it was a complete midline incision, supra also, infra also.
Basically,
Extending 3 centimeters.
history has not yet been asked, so it's, I mean, examination has not yet been done, so it's on history only.
What I wanted to know was whether the whole part of the incision was protruding out, or it was only just on the basis of history, or was it only a localized part just protruding out?
So localized parts, so lower infra part of the infra umbilical part of the incision, there was a swelling in the lower abdomen. In the upper part, there was no swelling.
Was the patient on catheter still?
Yes, sir. Actually he was a patient of polytrauma with bilateral pubic canal fracture, and he had a urethral injury when he came to the emergency. So he has developed a urethral stricture now. So an SPC was done intraoperative.
So now tell me, all this part of history. I mean, I thought I would come later on, but I'll ask Dr. Richa Jaiman to come in now. Dr. Richa, please unmute yourself. She's not here.
No.
Yeah, Dr. Richa, we can hear you now.
As you said, there is a history of explorative laparotomy 7 months back because of some trauma.
Yes,
and now the patient is with SPC, and he has noticed this swelling since 4 months. So before 4 months, there was no swelling, and the swelling is only confined to the lower abdomen.
Yes.
The patient, the swelling is actually with the suprapubic cystectomy as well.
No, ma'am.
SPC is also presenting with the swelling.
No, ma'am.
The part of where the SPC is there is no bulge.
No,
the
ma'am.
bulge is only confined to infraumbilical and just above the suprapubic catheter.
Yes, ma'am. Yes, ma'am.
You mentioned that
So ma'am,
bulge is confined to this.
Ma'am, not in the history, in the examination. Tell that the SPC
should actually mention what I am seeing in your slides that you have mentioned too many words in single slide. It is very difficult to summarize everything. Anyway,
I hope the message has gone to you that you need to be very crisp in your the way you describe. So, Dr. SP Singh, are you there, Dr. SP Singh?
Yes, thank you, sir.
Question for the history, sir, from Shelza.
So, what are the important points in the post-operative course of the previous surgery? We want to know in this case.
No. She got disconnected, I think. We'll just wait for her to get back. I think she got disconnected.
Yes, Dr. Pondala.
Yeah, just come up with the presentation again. You are muted. Please share your presentation. Yeah, please share your slide again and answer the question which Dr. SP Singh has asked you.
Sorry, sir, I was disconnected for 5 seconds.
Tell them what do you want to know during the post-operative course of the previous surgery, which is important for this patient.
So, in the post-operative period, I would like to know that what was the nutritional status of the patient post-surgery, and for how many days he was kept nil per oral Was there any history of blood transfusions? Was there any history of infections, localized wound infections, and any and for how many days also he was kept immobilized for the same, and mainly wound infection and nutritional status, sir. And any history of straining while passing the
Yeah.
urine, history of any chronic cough post surgery.
All right. We'll move to
Dr.
Dr.
Jadhav.
Gulwant Rathod, please, from Ahmedabad.
Yes, thank you, Dr. Pawandranath. Shelva, I want to ask you two things. One thing you mentioned about that he has urethral stricture. How do you know from history that he has urethral stricture?
So in the see there is a SPC in situ, and in the past history records of the patient, sir, I saw the blood procedure was done before. He's not passing urine per urethra. The urine is being passed through the SPC, through the Foley's in situ. Yes, sir.
Okay. Dr.
And
Atri,
Okay.
please. Dr. Ashok Atri, if you are there.
Unmute yourself, sir.
Sorry.
Yes. Good evening, Dr. Ashok. Please welcome.
Good evening, Dr. Pavinder. I think, Shelva, you have written a very interesting point in the history in summary that the patient developed pain and then it used to get relieved after defecation. How did you decipher it?
so there's a big swelling protruding out. There's a swelling protruding out from the abdominal wall. So when he takes food, there is the pain increases, and when he empties the bowel after defecation, so there is a sense of relief after defecation. That is how.
But what actually is the interpretation of this? Can you infer something from this particular history, which looks to be an interesting part of history?
The interbowel region.
That will how that will lead to relief in pain after defecation. That will produce more of subacute intestinal obstruction.
So there are
Can you on this point? Can you think about the contents of this particular hernia?
Yes, a bowel.
Which part of the bowel?
Large.
Large bowel. Which part of the large bowel?
Colon. Sigmoid.
Sigmoid colon. So sometime what happens, sigmoid colon may become part of the hernial sac. So it may lead to stasis. And you have said in the continuity that the pain will appear towards the end of the day, and then on the rest it will subside and after defecation. So probably once this loaded colon is evacuated by the patient, the pain may be relieved by that mechanism. Okay, Dr. Lal, you can continue.
Yeah, okay. So thank you all. My quick point to you, Shelza, is that a very important point of trauma and the whole thing that caused this whole sequence was missed out in your history completely. And we were all trying to struggle what is happening and why this incision. So somewhere in the history, in past history, it had to be recorded. Such a huge thing happened. This patient had a trauma, the patient had a pelvic fracture, patient had a cystostomy, patient was your history should have actually been able to tell whether there was urethral injury or not. What history would be present to say after a trauma to the lower abdomen that there is a urethral injury?
Sir, hematuria.
They don't have hematuria. They're not able to micturate. There is something else that is seen.
So blood at the tip of the penis can be seen.
Correct.
And
So that component of history was completely missing, and all six of us, we were at a loss to see why a young child of 15 years should have a suprapubic in place. So that point should have been mentioned. I think that is the only deficiency that I would like to point out. And once that is there, then we are all able to explain the incision as well as the reason that the catheter is there. The other point, if you go back to your history of micturition, just go back to the slide where you showed micturition. He has no urinary problem, you said. Go back.
Yes.
Where is that?
No, sir. There's chronic constipation and difficulty in vigilation.
Difficulty in victuration. How can that be? How can the person be having no difficulty in victuration if he has got a suprapubic in place and he can't provide his normal passage? So it's a misleading history, and that is how all 6 of our examiners got doled out by your history. So we'll quickly now go to the examination now. You can start with the general physical.
General physical examination.
Can I ask one thing in the history?
Yes, sir. Yes, sir. Please come in. Last question.
Yes, she asked about history of postoperative wound infection. So can you elaborate, Selja, on postoperative wound infection?
Yes, sir. Suppose, sir, any history of discharge from the stitch line post-operatively, any history of dehiscence of skin sutures, or any history of burst abdomen, any history of gape in the suture, that would be the localized wound infection. That is significant.
So have you asked
What
in
is the
detail?
importance? I think the examiner is trying to ask you the importance of this history. Is that right, Dr. Gunwan?
Yes, sir. Yes, sir. I want to ask what questions you have asked to gather the information about post-operative recovery and post-operative wound infection. Was there any burst, minor or major, even small one? And what was the kind of discharge? For how many days patient was kept there? What kind of dressings were done? Like that. Huh? That is how you gather the information that patient was having some kind of postoperative wound issue, which led to some amount of dehiscence in the sit, and later on which might have led to the incisional hernia. So that is very important while you are taking the history of operation, especially in case of incisional hernia in such a young boy.
Okay, we'll go on. Just stick to anything positive you have in general physical examination.
Sir, no, sir, the general physical examination is within normal.
Remarkable. So
Yes,
we'll go to the local abdominal examination because we'll concentrate on them, on the abdomen.
Yes.
Local examination per abdomen. I've done the examination in a well-lit room with proper consent. Exposure exposed him from nipple to mid-thigh. I have examined the patient in standing and supine position. On inspection, there is a hypertrophied, hyperpigmented vertical scar mark in the midline, extending approximately 4 centimeter below Ziffy sternum to 3 centimeter above the pubic symphysis, traversing the center of the swelling. Length and width of the scar is 25 centimeter into 3 centimeter approximately. There is an obvious swelling present in lower abdomen, which is approximately 18 into 15 centimeter, which becomes less prominent on supine position, becomes prominent on raising head or raising both legs. There is visible cuff impulse present. There is visible peristalsis present over the swelling. There is no ulceration or thinning of skin over the swelling except of the midline scar mark that is traversing the center of the swelling. There is a visible SPC in situ separate from the midline scar mark with a distance of 1 centimeter between the main scar mark and the SPC. There are 2 scar marks, one each on bilateral spino-umbilical line. There are no other lumps seen over the abdomen. Other hernia sites appear normal. Palpation. Abdomen is soft, non-tender with normal temperature. A soft, non-tender parietal.
Can I come in?
Do you have an image of the patient, Selja?
Yes. Can you share the photograph or video if you have?
Yes.
All right. It would have been better to put it alongside the same place so that while you are saying we can also visualize this, but it's fine. We'll go back to your palpation.
Yes. Abdomen is soft, non-tender with normal temperature. A soft, non-tender parietal swelling in lower abdomen and umbilical and hypogastrian region of about 20 into 19 centimeter with well-defined margins is felt. The swelling is reducible with skin over the swelling free. On lifting both the legs with both knees extended and with both arms folded over chest, the swelling becomes prominent. A defect of 15 centimeter into 12 centimeter is felt in the abdominal wall. In the midline scar measures 25 centimeter into 3 centimeter, extending from 4 centimeter below xiphisternum to 3 centimeter above the pubic symphysis. There is no swelling or cuff impulse felt in other hernial sites. There is no apparent organomegaly. External genitalia are normal except a thickening present at the bulb of penis. Per rectal examination is normal. Local examination. Percussion. Abdomen is resonant in all quadrants. The swelling is resonant on percussion. On auscultation, bowel sounds are present and bowel sounds are heard over the swelling. Systemic examination, CNS well oriented to time, place, and person. In cardiovascular, S1, S2 heard no added murmur. Respiratory system, bilateral chest clear, no added sounds. Summary. A 15-year-old male with complaints of swelling in lower abdomen from 4 months, which is painless, insidious in onset, gradually progressing in size to attain the present size of 16 into 19 centimeter approximately. Reducible, becomes prominent on standing, straining, cuffing, and less prominent on lying supine with history of exploratory laparotomy by a midline incision. On examination, a parietal swelling of size 16 into 19 centimeter, present in umbilical and hypogastrin region, which is soft, non-tender, reducible, with well-defined margins, with a present cuff impulse, with a well-defined defect felt of size 15 into 12 centimeter, with a vertical midline hypertrophied and hyperpigmented scar of 25 centimeter to 3 centimeter. The swelling becomes prominent on raising both legs with both knee extended. The swelling has a tympanic note on percussion with bowel sounds heard over the swelling.
Come back with your diagnosis. Yeah.
Diagnosis: 15-year-old male child with reducible incisional hernia. According to European Hernia Society classification, it is M345W3R8.
Okay, Dr. Rajiv Sinha sir, first please shoot your first question on the examination component to Shailja.
Any particular reason you mentioned the gait in the spine position in your examination?
Yes, sir. So with a large abdominal wall swelling, there can be lumbar lordosis and cause that can cause
देखना
cuffing, and
ये
that is why I
डायग्नोसिस है रिड्यूसिबल इंसिजन हर्निया EHS क्लासिफिकेशन M345W3RO ये क्या होता है
क्लासिफिकेशन हो गया ना ये M1 M2 M3 स्टेजेस हैं ये 4 5 M कहीं M3 M4 M5 वो है क्लासिफिकेशन में उसके अंदर लिखा हुआ होगा
without a bone fracture, yes,
ऐसे तो क्लासिफिकेशन
lordosis also and gait abnormalities also.
उसने बस पॉइंट कर दिया पूरा मेंशन नहीं करा M3 के आगे क्या लिखा है M4 के आगे क्या लिखा है
Shailja, am I audible?
Yes, ma'am, you are. And now you are muted. You got muted yourself, ma'am. Please unmute yourself.
Audible?
Yes, you are audible now. Again, you got muted. You got muted, madam. Yeah, you're okay now. Please ask.
Shailja, as you said in history that your swelling is below the umbilicus. Okay? Am I audible? And now in your presentation you said the swelling is occupying the umbilical area and below umbilicus. One thing, which is another thing, there is a hypertrophic scar.
इसके बाद आएगा सीन
But
इसके बाद आएगा सीन
what I can see
अबे हर जगह
hyperpigmentation. Is there any hypertrophic scar?
Please put your image of the. Just leave the patient. Yeah, leave the patient.
Seems to be hyperpigmented.
ये बेटा खाता सुन रही है
Above the umbilicus it seems to be hypertrophic, but below it seems to be hyperpigmented. But anyways, you just tell me, as you said,
सुन लो
on leg and there is
क्या
prominent. The side of the swelling gets prominent. What do you mean by this?
That means this swelling is parietal when due to the external oblique muscles of the abdominal muscles, when the patient raises his legs, the swelling will become more prominent. That means it's not intra-abdominal, it is parietal.
Swelling is not intra-abdominal.
It's parietal.
You are not. There is some defect in connectivity. Can you again repeat it?
Ma'am, during straight leg raising test, the abdominal muscles will become taut. And if the swelling increases or becomes prominent in size, it means that the swelling is parietal, but not intra-abdominal. If it decreases in size, that means the swelling is intra-abdominal.
So does that work out for a hernia, Shelza? That's the catch. Because you are trying to say it's a parietal swelling, it is coming from the abdominal wall. It is not coming from inside. But your findings are saying that there is a tympanic note over it and the bowel sounds are heard over it. So I think that is what Dr. Richa is trying to say. That
coming from inside the abdomen.
Okay, Dr. SP Singh, please.
Hello. So what are the other systems which can be involved by the long-standing incision hernia?
So respiratory system can be involved. So respiratory system can be involved because a large hernia is protruding, so that can cause, because of loss of domain, it can cause decrease. It can alter the pulmonary function because of lower blood. So because of loss of domain, there will be reduced pressure in the nostrils that can alter the pulmonary. Breathing movements will be.
So you have to mention the type of the respiration during the examination, whether it is abdominal thoracic or thoracoabdominal.
Yeah.
Good point. Dr. Ashok, please.
Yeah, Shalja, you showed the picture. What can you infer from this type of scar which has been formed?
Yeah, very important point which needs to be discussed. Please answer this question to Dr. Atri.
What is your inference after looking at such a scar?
सूचर जो हैं इसके खुल गए थे, ये बस्ट एब्डोमेन हुआ था, ऐसा लग रहा है.
It is the, you only said 24 centimeters from the ZC to the pubic symphysis, isn't it? It's the whole abdomen cut open. Please think about it and then give your answer to Dr. Atri.
So that means it's a long scar. So it could have because of
that is visible. That is a long scar. Even Professor Lal is also telling the same. You can get a lot of information from this scar. If Dr. Rathore was also asking some question related to such a situation. What has happened in this patient? Why this ultimately incisional hernia has developed?
बस क्या समझ लीजिए.
So there was no history of gaping in the gaping of the wound, but there must have been potential
gaping or not gaping history wise.
So if there is history of
Okay, complete your answer. Come on.
So if there is history of any discharge from the wound, or if there any discharge, either serous or seropurulent, history of long dressings.
Dr. Shalja, please, as Professor Lal very rightly pointed out right in the beginning, I must say once again that it's a very poorly taken history, not in a systematic order. There is no information available to examiners in such a situation to infer what has actually happened in this patient. But on examination, you can give a lot of information while interpreting the findings from inspection as well from the palpation. So I think Professor Lal can continue because we are running short of time.
That's right. So we'll just quickly go to Dr. Gunwant, please, to continue from where we finished. Yes.
Yes, I want to point out one thing. In palpation, Shelja mentioned about apparent organomegaly. Your palpation findings should not be any adjectives. It should be concrete one. And second thing is your diagnosis. You mentioned that it is only reducible incisional hernia. Are there any complications which have occurred in this hernia? what are the common complications?
So there could be interbowel adhesions. There could be adhesion of the hernial sac with the defect. There
So
could be
adhesions will lead to what?
And can I come, Dr. Anand Bashir?
Yeah, sure. Please come
Even
in.
even in the photograph, she has not bothered to bring down the trouser of the patient to the mid-thigh level, and the catheter is not being seen properly from where it is actually coming out, whether it is coming through the, So and it is the scar is short of 3-4 centimeter from the pubic symphysis. That's what she said in the examination. But I think it is up to the DC sternum, and suprapubic catheter must be coming. So this is also, there are so many things which in a time of 40 minutes cannot be pointed out. And incisional hernia is very catchy case. Students they take it as a very simple type of case, but with a little bit
Yeah, so to point this out, yes, Dr. Gulwant, you were completing it.
Yes, here they have a liberty of PowerPoint. They can show anything, but we can't see the lower margin of the lower end of the incision. Anyways, what are the common complications? You said addition. So how addition we identify on clinical examination?
So we could not be able to feel the margins of the defect. There could be irreducibility of the lump also.
Yes, irreducibility event. Second thing is
irreducibility of the tenderness could be present, and
कितना खून पिया इसने मेरे देखो मोटा हो रखा
the defect
कान पे बैठा था हाथ में आ गया
we could not feel.
असो छोड़ोगे
छोड़ देता हूँ बाहर
हाँ छोड़ दे
most important is
मैं हाथ सुनेंगे तो मुझसे ज्यादा देगा
or obstructive features if it is possible obstruction. That is very important. So how do you identify kind of obstructive symptoms in this patient?
There could be irreducibility of the swelling. Irreducibility of the swelling. There will be distension of the abdomen. Bowel sounds will be increased, and in history the patient can also tell about the vomiting and pain.
I think yes, we covered those points. So I think we'll just move on to the next part. We have finished history and examination, Sarja. My quick couple of observations from this and keeping in summarizing this whole examination would be, when I see this patient in my OPD with a goofy to pubic symphysis thing, I am not going to be convinced that this person had only a urethral injury. This man had an exploratory laparotomy, and that surgeon was looking for something. It could have had a splenectomy, they could have had a liver injury. So I would be very careful in asking the history as to whether this person came in shock, whether the patient had blood transfusion, whether the patient had removal of a major organ or part of a major organ. So this is something that should be alerted. And number two, very rightly pointed out by Dr. Rathod and Dr. Atri, that the width of the scar when you see, this does not show that this scar has healed by primary intention. Primary intention healing is by a linear scar. All of you know it's a clear one line, like linea nigra, you see just one single line. Here it is a width, as if there has been a wound infection, post-operative morbidity has taken place, there have been dressings, and therefore these should alert you about the risk factors that are involved with the occurrence of a situation like a hernia. And third important is, look at the width of the defect which you have shown in the hernia. You see 19 centimeters on one side and 16 centimeters on the other. You see it's a huge defect that has taken place. So go to your last slide and we'll quickly come. Last slide. What do you understand by M345W3R0? Just explain this.
So M denotes the area in the classification where the swelling is situated. It is divided into M1.
Yeah, so 3, 4, 5 is what is M?
So M is the area where the swelling is situated.
What is M standing for?
Have to be precise.
So midline.
M for midline, L for lateral. Right.
Yes, sir.
Okay, right. And what is 3, 4, 5?
So Sir, 3 is the umbilical, 3 centimeter above or 3 centimeter below the umbilical.
Yes.
4 is infraumbilical, that is
Yes.
3 centimeter beyond 3 centimeter below the
Correct.
umbilicus.
Correct.
And 5 is sir, 5 is supra pubic, that is 3
Excellent.
centimeter.
Excellent. So we have done that. We have understood. Any other slide after this you have?
Just one question. What is the extension of the midline? M stands for? What's the extension of the midline?
Extension of the?
You say M, so M would be extends from where to where?
M1, where is M1?
M1 will be below the Zippy sternum, 3 centimeter below.
Just a minute. M and L. So where does M stop and where does L start?
So L starts at the lateral border of the rectus abdominis muscle. It extends up to anterior axillary line laterally.
All right, we'll quickly move on. Go to your slide on investigation, Selja. And you have written this workup. We'll quickly come to Dr. Rajiv Sinha and tell us let Dr. Sinha ask you about the investigations that you will do.
One thing, you've seen this extensive scar, the spread out scar, which indicates that there must have been infection in this patient, biliary secondary infection, and the swelling is reducible. So then how do you decide whether there are intraabdominal adhesions or not? Because that forms a very important part of the operation in any patient, the pre-operative build of this patient. How would you decide the patient has a lot of adhesion, doesn't have adhesion?
Sir, with the help of ultrasound abdomen and CCT whole abdomen, basically in interbowel adhesions that we can come to know with the help of ultrasound abdomen.
Okay, I'll tell you what adhesion. I doubt that.
Sir, you give us the answer. Give her the answer.
It has to be a dynamic ultrasound. The ultrasound has to retain high resolution, and then the ultrasound has to be where you can get an idea as to the
Yeah, okay, Shelza, we've got 8 minutes remaining. Tell us you've given your workup here. You've given urology workup and you've given abdominal blood investigations aside. He's a young person, so everything would be fine. Tell us your plan, and then I will ask Dr. Richa to come in with her next question on management. What is your plan with this patient?
First of all, we will like to go for the urology workup and manage the stricture urethra, because if that is not managed, that will and we operate him we manage him for the incisional hernia, that can again reoccur because of that. So first of all, the management of stricture urethra has been done, and once that has been done, then we will plan for the management of the incisional hernia.
Okay, Dr. Richa, please come in. Yes, you are audible, ma'am. You are okay.
Okay. Why you are going for CCT whole abdomen? What is the use of CCT whole abdomen in a 15-year-old male presenting with such huge hernia? What do you want to see?
Ma'am, we want to because since it is a large hernia, we want to confirm the size of the lump in the size of the swelling, vertical and horizontal diameters, the size of the defect we want to confirm, vertical and horizontal. We want to know the status of the muscles, abdominal muscles, any atrophy or any diastasis. We also want to know how will we manage this patient for the management of the patient through the CT. We want to know the loss of domain. If we want to know the ratio of the loss of domain, volume of loss of
Is
domain.
there any other information what recently was asked that with such a huge seeing such a large incision, and we are talking about some major surgery. Can we go for CCT and another information regarding this laparoscopy? Can we get?
Any other injuries were present. For the if laparotomy was done, if any other injuries were present at that time, if solid organ injuries.
Yeah, so I think what ma'am is asking you is you will come to know if there is a missing spleen, if there is a missing kidney, you don't even know that. It could have had a nephrectomy, there could be a splenectomy, there could be a partial hepatectomy. You don't even know what's all happened because the scar, is very scary. That is what we are trying to tell you. And of course, Bawal, you very rightly said about the parietal bone, which you want to study. So I'll ask Dr. S.P. Singh to come in now for the questions on investigation and management.
You have mentioned about the urology workup of the patient. What will be the satisfactory endpoint when you will like to do this incisional hernia surgery? After how many days, or any investigation you like to do before going for this incisional hernia surgery after the urology?
So we would like to do a uroflowmetry, and when the patient stops without straining, the patient is able to pass urine. And after a normal uroflowmetry study, then only we will proceed for the incisional hernia workup.
Dr. Rathod.
Yes, sir. Selja has pointed out investigations well. Now it remains to be seen. After you have given what actually you are planning to do with this incisional hernia, which is so big, it's not total loss of domain, but there is quite a large swelling there. So, what is your general plan of management? Whether you will do open surgery or you are planning some laparoscopy or something like that, whether you will put mesh or not, and how will you do?
So, so I was planning an open surgery with component separation with a recto-rectus mesh placement, sir.
Are you happy with Dr. Rathod? Do you accept that component separation for this patient? Disconnected. So we'll quickly ask Dr. Atri.
Shailja ji, you said that this is a hernia which is occupying supraumbilical area also. So you said you will go only for open surgery in this patient. Why you want to do only open surgery? Why you are not considering the laparoscopic also?
So because of the larger defect size, so it is more than 10 centimeter.
I think Professor Lal, he is such an expert person in laparoscopy. He is doing much bigger hernias than this. What is the contraindication of doing laparoscopic in this patient?
So there could be loss of domain also.
No. What is the contraindication in this patient of going for, or relative contraindication, I will say?
So placement of ports.
Placement of ports, how they are? It will be difficult or it will be easy in this patient?
Difficult.
It's infraumbilical ports.
So just think about the anatomical location. The hernial defect is going right up to the pubic symphysis. Now think about the question which Professor Atri has asked.
So the ports will be placed above. So we have to also go till the space of radius and fix the mesh with the bone. So that will be difficult laparoscopically.
First only port placement. That is very important. If you are contemplating laparoscopic surgery, the first that you should be able to place ports safely. Will it be possible in this patient or not possible? Or how it can be made easy?
So, supraumbilical port placement. So it will be difficult to put ports.
Supraumbilical is again a hernial sac there. You can see, you have already said, even in your European classification, you have said there is an extension of hernia in supraumbilical. So how can you put port directly there?
So yeah, so I think we are just close to finishing. So I think I'll just kind of summarize. You don't have any other slide, no, Sharja? This was your last slide. Okay, so I think what you have said is acceptable to all the examiners. The fact that you would like to correct the stricture urethra first, that's a correct management. You did not jump onto the abdominal hernia first. Number
Right.
two, your management about the abdomen, that you would like to study the abdomen with the CCT is very well taken. Also, that you would like to do an open hernia is well taken, because it will correct the scar. It will be able to remove that wide scar, and it would be, in a young person, it may be possible to achieve primary closure. If not, you are ready to do a component separation. I am sure you will take an expert surgeon with you who is aware about component separation surgery. It's not very easily done and understood by everyone. So your answer would be that I would like to refer this person to a surgeon who is dealing with a large hernia, and I think that way your answers were okay. But I think the only deficiency or things to improve would be on a very comprehensive history. When you were presenting, and the points that were pointed out in the examination, and otherwise it's been a very well presented case. Well done. And I would like to thank all my colleagues, Dr. Sinha, Dr. Richa, Dr. Gunwant Rathore, Dr. Atri, and Dr. SP Singh for being there. And thank you, Dr. Puneet. We have finished in 45 minutes as was allotted to us. So well done, Shelja Sachdeva from Sci-Fi.
Thank you, Shalja. Thank you for interacting with us. Thank you.
Thank you very much, sir, for a wonderful moderation. And we have a next session, and I thanks all the examiners for that session also. The next session is operative, that is open inguinal hernia mesh repair. That is by Dr. A.K. Khanna from Institute of Medical Sciences, Banaras University. And the moderator for this session is Dr. Rakesh Sharma from Kota and Dr. Salesh from Patna.
Shabby?
Can I see Dr. Ajay Khanna is there? Yeah, he is there. And moderator Dr. Rakesh Sharma.
Yes, I'm here. Good evening, everybody.
Yeah, good evening. You can take over the show. Yeah.
Okay. First of all, thank you very much, Dr. Puneet, Dr. Ramnivas, and the organizers team for arranging such a nice event. I welcome Dr. Ajay Khanna, and I also welcome Dr. Sailesh.
Thank you, sir.
I request Dr. Khanna to start presentation because we are late by many minutes. Dr. Khanna is there?
I'm there, yeah, I'm there.
Sir. So you please start your presentation.
Thank you, Chairperson. My dear colleagues and my dear residents, I think open inguinal hernia mesh repair is probably one of the commonest operations which all the surgeons, the general surgeons, they face in their lifetime. And one has to be really meticulous to carry out this surgery, otherwise there may be many complications and the adverse effect of this operation. If we look at the magnitude of the problem which is there, it's a huge number which is there. Almost more than 20 million patients, they undergo groin hernia repair annually. So it's a huge number where this operation is carried out. Now, most surgeons now prefer to perform a tension-free mesh repair. There was a time of hours like that we used to carry out the tissue repair, but now you carry out the mesh repair that should be tension-free, whether you carry out the open surgery or whether you carry out the laparoscopic surgery. That depends on the certain situations which are there. But let me tell you that till date, even in the Western countries, including all European, Asian, Indian, still the open hernia repair is much more common than carrying out the laparoscopic repair. Basically there are three types of surgery. You can carry out the herniotomy, which is done for the pediatric age group. We used to go for the herniorrhaphy. That can be carried out, but majority of the time, as I told you, it's the hernioplasty or the mesh repair. So what are the various types of operations that are carried out? It can be basically divided into two types. It can be tissue repair or it can be mesh repair. In the tissue repair, you should know about the Basni's repair. You should remember about the Shouldice repair. And now there is Dr. D. Sharda technique, which is there. I think you should also know a little about that. Dr. D. Sharda is an Indian surgeon from Pune, and he takes the external oblique aponeurosis, which is there, as a patch and put it on the inguinal canal. And in fact, he says that he is very famous even in the Canadian and the US. Now, the mesh repair which are there, the most common mesh repair which is there is called the Liechtenstein mesh repair. You know, there are various pronunciation for the Liechtenstein. Some people call it a Liechtenstein repair, some people call it a Liechtenstein repair, but the correct pronunciation which is there is the Liechtenstein tension-free repair. And then you can have the proline hernia system, the plug technique, the stopa technique, and you have the laparoscopic repair, which can be the tap or the tap. Now, out of all these procedures, now there is a definite evidence-based medicine says that Liechtenstein open tension-free mesh hernioplasty is almost a gold standard. It can be carried out for all adults, irrespective of the age of the patient, the weight, except in the children, as I told you in the pediatric, you do not use the mesh. Up to the age of 14 to 16 years, it is accepted that one should not use the mesh, but beyond 16 years, one should always use the mesh for inguinal hernia. This operation can be performed very well under the local anesthesia, and it is in fact very easy to understand. You know, if you look for the other operations which are there, it is difficult to carry out this operation, but the learning curve for this operation is only 5 cases. And all the surgical residents who are carrying out this technique after a adequate exposure, they can do this hernia repair with a good outcome. The procedure is the time tested, it's a safe procedure, it is economical and does not involve a long operating time with a low complication rate, and that is why it has almost become the gold standard technique for the inguinal anesthesia. Now we'll come to the steps which are there of the Liechtenstein repair. You have to basically make a incision, then divide the external oblique. You have to mobilize and tape the spermatic cord. You have to identify the hernia sac. Then according to the direct or indirect hernia, you have to tackle that. You know, in the case presentation of the inguinal hernia, the panel was asking whether is it really important to know whether it's a direct hernia or an indirect hernia. I think when you're doing the opener, it may be good for the tap repair that you can see on the both sides that whether the patient has got the direct or indirect. But if you're doing the open repair, I think you should know preoperatively that this patient has got a direct hernia, because what you will do when you're lifting the spermatic cord, and if it is a direct hernia, you will never able to reach to the deeper part. The sac has to remain on the posterior side, and that is why it is important. Then one should know that whether it is a direct hernia or indirect hernia. And once you tackle the hernia sac, you tailor the mesh which has to be placed, and you fix the mesh by the various ways which are there to carry out the Liechtenstein repair. Now this is the exact technique. Now look at the first picture here. Now this is, in this one, you make a incision which is 1 centimeter above the inguinal ligament. Some people, they put the oblique incision, but if you look at the crease here, abdominal, lower abdominal crease which is there, it runs like this. And that will definitely give you a better scar. Now, important thing is, if you are suspecting it's a big hernia, or it is a like obstructed or a strangulated hernia is there, it is always better to go for the oblique hernia, because you have to extend this line here on this side. So it has to go over the scrotum. But if it is an uncomplicated hernia is there, then in that case, I think the better incision which will be that you put a lower abdominal crease. This operation is done majority of the time under local anesthesia. There are various ways to give the local anesthesia, but now the standard technique which is there, which the Liechtenstein Institute carries out, is it is not required to give the anesthesia at 5 or 7 places. Initially, there was that you put incision, the anesthesia at the pubic tubercle, you put anesthesia at the level of the anterior spine, you put the anesthesia at the level of the deep ring and surrounding area. So there were 7 points for there where the anesthesia put. But nowadays, you can start with a infiltration of the skin itself. And as you go down, you go on infiltrating. And I will tell you that what is the way. So once you are given the local anesthesia in this line here, you should go at least up to the pubic tubercle. That you must remember that you have to go because your mesh will go beyond the pubic tubercle. If you do not put your mesh at least 2 centimeters beyond the pubic tubercle, that is a site where there will be recurrence. Liechtenstein Institute, when it started carrying out, initially they had a recurrence of 5% because they were putting it up to the pubic tubercle, the mesh used to shrink, and there was a recurrence at the medial side. And then they modified that technique and they at least went 2 centimeters beyond in this area. So you have to dissect at least 2 centimeters beyond the pubic tubercle on the medial side to avoid the medial recurrence. Now the second step of giving the local anesthesia is as soon as you have reached up to the external oblique after cutting the camper and the scarpa fascia, and you have to take care at this point that you are taking, there are 3 known blood vessels will be coming there, all the 3 superficial branches which are there, they'll be coming and to take care of that. You can burn them. Many people, they just ligate that. So you have to take care because that is one of the reasons for formation of the hematoma formation in the postoperative period. So once you expose this external oblique here, now you can see the shining external oblique. Now at this point towards this is the anterior spine here. Okay, this is the pubic tubercle side here. So you infiltrate this local anesthesia in this closed anatomy. This is at this time a closed one. So you put the local anesthesia at this point. So it is going to take care of the ilioinguinal nerve, the iliohypogastric nerve, and the genital branches, genitofemoral nerve, which are the 3 branches which are there, which are coming in the way when you are operating for this. Then you cut the okay. Then as soon as you cut here, now you can see this is the superficial ring here from which this spermatic cord is coming out. So you cut it completely here. You do not leave any fibers here. If you leave any fiber, there will be really difficulty in carrying out the operation here. So you have to cut it at this point. And at this point, you have to be very careful that this is a site where the ilioinguinal nerve is likely to damage. So you have to be very careful when you're cutting at this point that you take care of this ilioinguinal nerve which is there. If you are not careful, you can damage the ilioinguinal nerve, and this patient is likely to have the inguinal hernia. Nowadays the surgery for the inguinal hernia is balanced against the quality of the life. Some people say that it is not necessary mandatory that you should carry out the surgery for every case of inguinal hernia. Initially, it was thought that all hernias has to be operated, but when this concept of the quality, again, it was discussed in the inguinal hernia presentation when the case capsule was going on. But there are real cases where you have to balance the quality of the life. And the quality of life in these patients is because of 2 reasons. One is definitely the recurrence which is there. And the second, which has come much more, is not the inguinodynia. You have to avoid the inguinodynia in all circumstances. Recurrence may be less than 1%, but inguinodynia goes up to 6 to 10%. And it has been shown, and there have been a lot of the medico-legal cases because of this inguinodynia, and the people, they have lost their job because of this inguinodynia. So one has to be very careful when you are carrying out the surgery for the inguinal hernia to take care of this one. Okay, then once you have, this is the cord here. Now this is the external oblique aponeurosis, and you have to go up right up to the reflected part of the inguinal ligament here. This is the reflected part of the inguinal ligament. So you go right up to this area because this is the place where you are going to fix your mesh. So this has to be very clearly taken. And when you go on this medial side, now here is somewhere is the pubic tubercle, but dissection has been done right up to 2 to 3 centimeters beyond the pubic tubercle. So this has to be taken care. And then this is the superior flap which is there. And this has to be undermined as much as possible because the mesh which is there is of 7.5 to 15 centimeters in size. So it has to accommodate that 7.5 centimeters. So this is the width of that it has to accommodate. And that is why you have to do a good dissection here. But when you're doing this dissection at this point here comes the iliohypogastric nerve. So you saw the ilioinguinal nerve coming right over the spermatic cord which is there. And here you will be encountering the iliohypogastric nerve. And this is important when you're fixing the mesh at this point, you have to be sure that you are not taking bite from the iliohypogastric nerve. The next is this lifting of the cord. Now, this is very important. You know, the common thing which has been taught to us that you put your finger and the thumb and you lift it near the superficial ring here at this point here. But this technique is not good technique. This will lead to the ischemia of the cord. And that is why you have to dissect the cremaster muscles here and you go deep to the cremaster muscle and you will find a very good plane on the posterior side. So it has to be rather a sharp dissection rather than the dissection that you are lifting the cord like this. That is not acceptable to carry out. You have to make a dissection here right at this point and then you lift the cord. Now this is the cremaster muscle here. You can cut the cremaster muscle. Some people they sacrifice. It is a controversy whether you should sacrifice the cremaster muscle or we should not sacrifice the cremaster muscle. And then you dissect. This is the lipoma of the cord in this patient. This is a hernia sac, and this is, you can see here the pampiniform plexus. So that's the spermatic cord. So you separate the spermatic cord from the hernia sac. And then if it's a big hernia sac is there, like here, it is not necessary that you twist the sac. It is not required. It is not necessary that you completely remove the sac. That is also not necessary. You can just open it here and then you can close it. Because if you twist the sac or if you try to remove whole of the sac, if the big sac is there, you are probably creating more the ischemia. There's a more injury to the cord structures are there, and that will lead to the even the testicular atrophy can occur because of that. So this distal part which is there, you must leave it open. It should not be closed, but make sure that this margin doesn't bleed. So that is the very important thing. So proximally, you can just cut it like that, and then you close this. It is not necessary again to do a very high ligation. So you have to be comfortable at that point because ultimately this part which will be there, it will go inside. And then you are putting the mesh. Now this mesh is the mesh which is taking the 7.5 to 15 centimeter size, but that becomes a little bigger one. So what you usually use is the 7.5 centimeter in this transverse axis, and this is around 12 centimeter. So you discard around 2.5 centimeter because your main aim is the length of the inguinal canal is around 4.5 centimeters. So you have to go 5 centimeter on this side, 5 centimeter on this side. So that becomes about 12 to 13 centimeter size here. So you discard around 2 centimeter of that, or it is not necessary that you should always discard that. You can just, if you have made a good place, you can put that mesh in that area. And then the fixation of the mesh. Now fixation of the mesh, the first suture which should be here, it should be the most medial one here. So you are taking the bite at least 2 centimeter from the pubic tubercle. Never take a bite from the bone. You have to take the bite only just superficial to the bone and never through the bone. So that is one. and then you suture this to the reflected part of the inguinal ligament here. And this continuous suture, usually only about 3 to 4 bites are required, and that goes just beyond the deep ring which is there. So that is the lower fixation. As far as the upper fixation is there are only 3 sutures which are required. One is at this point here, on this upper side here, that's toward the posterior rectus sheath. Then one is at this point here, where you have to be careful about the iliohypogastric nerve when you're taking that bite. And the third is at this point, making a new deep canal. So you are making the new deep ring which is there. And for taking this suture which is there, when you divide this mesh to take the cord coming in between, this will be the 2/3 and this will be the 1/3 here. So 2/3 upper flap is there, 1/3 lower flap is there, and then you suture the lower end of this to the lower end of this, and then to the reflected portion of the inguinal ligament. So that is the way this third suture is taken. So in the upper flap, only 3 sutures which are required to take care of this mesh. People now use the glues for that. Some people say that if it is a 3-dimensional mesh is there, you may not require to put any sutures, but I think it is better that you should put at least 1 or 2 sutures. Okay, so this is the mesh which has been put here. This is the cord which is coming in, and when you're sutured it, you must make sure that you pull this cord inside the scrotum. Okay, so with the gentle action, you must bring down everything toward the scrotum here, and then you start suturing. And the suturing should be always done from the lateral side, not from the medial side, because medial side you have to leave a gap here, small gap. Otherwise, there will be ischemia will be there. So you started from the lateral side with the help of the 2030 vehicle which is there, and you slightly leave a gap here in this so that it accommodates without any ischemia to the cord. Okay, so this is the mesh which has been fixed. Now this external oblique has been closed, and then you can close the fascia which is there, or you can directly close the suture with the help of the clips or the subcuticular sutures or the normal sutures which are there. I will just show you the video that how it is done. So this, you can see, this is the mark of the pubic tubercle here. So you are infiltrating only in the skin and the subcutaneous tissue for the local anesthesia. Okay, and this is, you can use 0.5%, you can use 1%. It doesn't make a difference. The type of the anesthesia is almost the same, whether it is 0.5% or 1% or 2%. So you are cutting the okay, so after giving this local infiltration here, cut the skin, the fascia, and before cutting that, so you can see this is the lateral side here. Okay, this is the lateral side here. We are infiltrating the local anesthesia at this point here, so that there's a closed space, and this is the opening of the external oblique. You can see the nerve here, and now you will raise the flap. See, this flap is being raised. You can see a very whitish thing which at this point here.
We are running short of time, sir.
Sorry?
Sir, we are running short of time.
Okay, I will just finish in 2 minutes, 3 minutes.
Yeah, yes.
Okay.
Okay, sir.
Okay, so this is the superior flap which is raised. Now this was a patient who had in fact, a sliding hernia. Okay, there was a sliding hernia was there which we have taken care. Lipoma was there with exercise, and now the mesh which is there, how to prepare the mesh. This is very important. Mesh is prepared like your foot which is there. So it has got the greater toe, it has got the lesser side here. So this portion which is there, this will be fitting toward the pubic tubercle side, and this little toe side will go toward the upper side. And I have already told that how to fix this mesh. On the lower side, it is beyond the pubic tubercle. and this should be a continuous suture. The suture which is used is usually the 2,0 polypropylene. Now you can see the mesh here, okay? So this is the mesh. Now this is the way to put the mesh so that it goes. So you take out the bite from this, and this another end which is there, you bring it out through the mesh here. So that what happens, this portion which is there, this corner portion which is there, it is not infolded, because it has been shown that if there's an infolding of this mesh at this point is there, that can be tender point. So that has to be avoided, so that this suture which goes on the there is no curling of the mesh is there. And then you take this continuous suture here.
Sir, I request you to please.
Yeah, I'm just. Okay, I think it is. Right, so this I am taking, this is from the. So that's the last suture on the lower side. And when you're taking this upper suture there, you have to take care that you do not damage the iliohypogastric nerve. And see here, now this is the way I was telling, this is the lower portion, this is the lower portion, and then it will fix to the inguinal ligament here. Right? And you check this one, okay, that this should not, this deep ring, artificial ring which you have made is not very tight. So that almost finishes, and now we are closing the external oblique from the medial side. There are the various complications, everyone knows about that, but I think the inguinal should be taken into a strong consideration for the treatment of the inguinal hernia. Thank you very much.
Thank you, Dr. Khanna. Thank you. And I think we are running short of time, but Dr. Khanna has put everything very meticulously, very fine-tuned procedure has been explained. If the residents are watching the videos, I should say that they must have benefited by this. Only thing I would like to put forward is that choice of the mesh is also important, because when we use the mesh with the very tight pores and 100% polypropylene, the post-operative fibrosis may be another reason of inguinodynia or the pain around the operation site. So now there are various views regarding choice of the mesh. It may be a composite mesh.
शनिवार और मंगल के दिन चला था चमेली का है ना.
We can use glues to minimize the neuralgias post-operatively. We may use loose sutures rather than tight sutures while fixing the mesh. So there are so many variations of the Lichtenstein repair. I request Dr. Seles to put some comments, then we can wind up the session.
Yes, sir. Thank you, sir. Thank you very much for
allow for the deliberation about the mesh. No, otherwise it itself is a big topic.
Yes.
Yes, sir. Sir, thank you very much, sir, for your wonderful presentation, sir. One small remark. That is a very small thing, but very play important role in the management of this Lichtenstein repair. That is before when you put take up the mesh, you must ensure that that is very, very important in mesh repair. And second, sir, one small comment from you. That is when you open the cord for dissection of the sac, do you routinely close the sac, sir, after removing the sac?
No, he's asking about the cord.
कल भी ऐसे ही है यार.
Open the cord to remove the sac. After removing the sac, do you routinely close the spermatic cord?
चलेगी तो 6 बजे तक.
I could not understand what is the closure of the spermatic cord.
The inside the spermatic.
अभी आधे घंटे की और बची.
He mean that the sac is to be closed probably.
आधे घंटे की बची है.
No sac. The different layer after opening the spermatic cord, you remove the sac. After that,
because there is a cremastic fascia over that.
Yeah.
So you can remove the cremastic fascia, or you can leave it as such. But as such, separately, you are not going to do anything with the spermatic cord.
Okay.
I thanks everyone
Thank
for
you.
a elaborative session, and I thanks Dr. A.K. Khanna for a wonderful presentation on open inguinal hernia mesh repair. I thanks Dr. Rakesh and Dr. Salesh too for moderating this session. And I request.
Thank you very much.
Thank you.
Thanks a lot.
Now I request Dr. Shabi Ahmed to present a distal radical gastrectomy. It is an operative session. In which I request Dr. Atiya, she is there, to act as a moderator for this session.
चेंज कर दिया हमने.
I'm very much there, sir.
Yeah, go ahead with it.
Good evening to all of you.
वो क्यों नहीं आया जो होना था?
Hello.
Yeah, Dr. Shabi, we can hear you, and can you share your slides, please?
Screen, yes.
I can see 49 slides are there. I think you have to sum up in 12 minutes time.
I'm going to not show everything.
It's okay. You can make a full screen. Yeah.
Okay. Now it's visible.
Thank you. Yeah, you can go ahead with it.
So I think I'll get going. And thank you, Dr. Puneet, for once again giving me this honor of presenting this lecture series and your wonderful PG Master Classes. PG students, what are the various types of gastric resections? We have wedge resections, wherein various situations you do a wedge resection. Gastrectomy, basically, this is also a question. An antrectomy or a hemigastrectomy consists of about 40% of the stomach, which is removed. Partial gastrectomy involves about 65%. Subtotal is involving about 80%. And the near total, where only the fundus cap is left. About 90%. The radical gastrectomy, which can be a distal radical gastrectomy or a total radical gastrectomy with a D2 lymph nodal resection. Now, before any gastric resection, we presume that the patient is basically having a malignancy of the stomach. But the basic preoperative evaluation requires an endoscopy, which is to evaluate the growth and proper biopsy, because you cannot proceed for surgical intervention without a histopathological evaluation. Imaging basically is various imaging to stage the disease and know the resectability, which includes an endoscopic ultrasonography, especially in very early, or what you call it, the early stomach cancer.
चलो फिर बुक्स निकालो, जल्दी से होमवर्क करा देती हूँ, ले लो।
Preoperative prophylaxis and deoperative prophylaxis is as usual. Now, just evaluation of these indications where a subtotal gastrectomy is quite feasible and indicated, such as in carcinoma pylorus, carcinoma of the antrum, in a primary gastric lymphoma limited to the was about 80% of the stomach. Neototal gastrectomy usually done in a stasis syndrome for gastroparesis or carcinoma involving the body of the stomach in a lymphoma, and it involves removal of about total more than 90% of the stomach. Just a quick review of the lymph nodal status. What I would suggest, it's easy to remember it. If you imagine the stomach, and can you see my pointer? My pointer? Dr. Atiya, my pointer?
Yeah, it's very much visible.
Okay. Now, you take the stomach, the lesser curvature and the greater curvature, and you start counting. You start from the lesser curvature on the G junction. This is 1, first opposite is 2. Then the lesser curve is 3. 3 and 3B, it is divided. The greater curvature is basically 4. Again, these lymph nodal stations, you can see up to 4D. Then you come up 5, is suprapyloric and 6 is infrapyloric. So that finishes 1 to 6, which basically is for the D1 gastric. Now come to the 7 is the left gastric, 7. Then you have 8, which is the common hepatic. And the 9 is celiac trunk, and you have the 10 at the splenic hilum. So if you go in this fashion, 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10, and then 11 is behind along the splenic artery. 12 is the proper hepatic artery vessels. So this way you will remember at least the most important basic lymph nodal station up to 12 without forgetting them. Now there are other terms also. The D0 basically lymphadenectomy less than D1 is given the name by the Japanese cancer treatment guidelines as D0. D1 involves the station. Again, D1 and D2 also refer to the according to the situation of the malignancy. Now there is one new term like D1 plus. So what they have done is D1, which is removing stations from 1 to 6 basically and 7, and added 8A and 9B, 9. And D2 is D1 plus involving the lymph nodes from 8A to 12A. Now there is another term given by the Japanese, which is D3. So basically, if D2 plus the stations from 12 to 14 are removed, it becomes a D3 lymph nodal dissection. Now, this was what I was talking about. Depending on the position or situation, the site of the cancer, the lymph nodes are removed. In a D2 for a distal gastrectomy, the station 2 and 4 SA especially, that is near the splenic vessels, are basically omitted, as well as the stations 10, that is the tail of the pancreas, station 10, and the 11D. These lymph nodes are basically omitted if we are doing a D2 distal gastrectomy. So likewise, this nomenclature has been slightly modified. Now, indications basically D1 or a D1 plus, depending on the protocol of the surgeon or the center. For all T1 lesions, D1 lymph nodal resection can be done, or a D1 plus lymph nodal resection. In a D1 lymphadenectomy, basically T1A tumors that do not meet the criteria for endoscopic mucosal resection or endoscopic submucosal resection, and for tumors like T1B and 0 tumors that are histologically of differentiated type and 1.5 centimeter or smaller diameter tumors, they can be managed like this. For a D2, it is basically tumors which are node positive disease. T2 to T4 tumors, they can be dealt with by a D2 lymphadenectomy. There was a randomized controlled trial which did not show much survival advantage with a D3 lymphadenectomy. That's why a D3 lymphadenectomy is not in a proper use. So let's come to the operating technique. So basically we can divide it into 6 or 7 broad steps, starting from the cauterization of the duodenum, the mobilization of the greater curvature with bursectomy. I'll be showing the figures and then you'll understand. Omentectomy and division of the left gastroepiploic artery. Then the second step is the infrapyloric mobilization with ligation of the right gastroepiploic artery and vein as it enters the gastrocolitra. Then is the superior mobilization, the suprapyloric mobilization with ligation of the right gastric artery. Then follows the duodenal transection. After duodenal transection, the stomach can be reflected upwards and to the left side. And lymphadenectomy can be proceeded with by dissection of the porta hepatis, the common hepatic artery, left gastric artery, celiac axis, and splenic artery vessels with ligation of the left gastric artery. Now, a point of caution, whenever a left gastric artery is to be ligated, you should make sure that the apparent left hepatic artery is not arising from there, which can be sometimes present arising from the left gastric artery, and that can jeopardize the vascularity of the liver. Therefore, this thing has to be taken in point. And in that situation, if it happens to, if you see a vessel which is going towards the liver, then the division is above the origin of that vessel. Then follows the gastric transection, and followed by lastly the reconstruction, which can be various ways which we'll discuss later on. Now, this diagram basically shows the steps. Number one, this, you can see my pointer. This step, we start from this part. Of course, I have presumed, I've not talked about the after the staging procedure. Every carcinoma stomach patients, they have to undergo a diagnostic laparoscopy or a laparoscopy and proceed, because many a times you will see peritoneal mets and then that procedure is abandoned. Second, after opening the abdomen, again a reassessment for metastasis. So the first step in radical gastrectomy is division of the peritoneal fold and cauterization. So lift up, basically right up to the IVC, and you can have the head of the pancreas in your hand, and you can see the aortocaval lymph nodes and the posterior pancreatic lymph nodes clearly, because that will be removed, the posterior growth. Then followed by the Pochett's maneuver. Basically, this is division of the omentum from the transverse colon through the avascular plane, which is there along the transverse colon and the transverse mesocolon. And this step, now you can see the intraoperative images, that this is the transverse colon and the omentum has been bared and lifted upwards, almost taking the anterior sheath of the transverse mesocolon. This is what constitutes the bursectomy. So basically, it is nothing but a lesser sac bursectomy followed by a lymph nodal dissection. Here you can see the mesocolic, the transverse mesocolon vessels, the middle colic vessels, the right and the left branch, is almost exposed over here, and here would be the trunk of Henle. Let's see the other image. Now, after this, you can very well see the transverse colon vessels. Now, this is, as you know, is going into the artery and the veins. Hello? Hello? Somebody is speaking in between. Okay. So, you can see the pancreatic tail, the pancreas body being exposed. And up to here, the careful dissection of the uh, vasectomy is carried out. Now, after doing that, the gastrocolic trunk basically is exposed. Here you can see the superior mesenteric vein, the bluish structure which is peeping out. And this is the gastrocolic trunk, which is also known as the trunk of Henle. Normally, it has got three branches. That means one would be going into the stomach as the right gastroepiploic vein. The other goes into the along the pancreas, the anterior superior pancreaticoduodenal vein, and the third will be continuing into the right colic vein. It can be sometimes separate. It can be a single trunk giving origin to all three. Therefore, this has to be carefully looked up, and then the proper division has to be taken. Where I'm moving my the and Dr. Shabi, I request you to please bind me. Okay. How many minutes are here, Dr. Puneet? Sir, already we have. No, I'll tailor it according to that. Already 2-3 more minutes to complete, sir. Okay. So I'll just take the deal. So is division of the right gastroepiploic vein, and then exposure division along the suprapyloric area, and there the right gastric artery is taken down, and then the duodenum is transected, as you can see in the image. And usually nowadays we use the stapler to transect the duodenum. After that, the lymphadenectomy dissection is carried out. Basically, the station which we just discussed, that means the 7, 8, the 12 from the hepatoduodenal ligament. After dissection, you can very well see the structures which are laid bare. Here you can see the splenic artery. This is the area of the same lymph node 8A. The common hepatic is bared, and the gastroduodenal going down over the neck of the pancreas can be seen. This is dissection of the 12A nodes, and the common hepatic vessel is looped up so that the lymph nodes dissection is proceeded up into um, uh, the hepatoduodenal ligament. Normally, we do it from below up. And after that, the hepatoduodenal dissection, the lymphadenectomy along the splenic artery has been done, and the division of the left gastric artery is taken usually near the origin, taking the lymph nodes along it. As I said earlier, before division of left gastric, always look for the replaced left hepatic artery. Sometimes it can be present, and therefore avoid damage to that. In case of total gastrectomy, where we are doing for the body of the stomach, the GE junction is taken out. As you know, that the abdominal aorta about 4 centimeters. So the lymph nodes at the cardia and the hiatus is seen. As you can see here, the diaphragmatic crus is exposed and the fibrofatty tissue is removed. That's the complete picture after doing a total gastrectomy. So you have seen the images and the principles. So basically, we are doing a D2 lymphadenectomy. Some centers still advocate a D1, and the number of lymph node harvested also is very important, as only after a total proper dissection will we be able to stage the disease and obtain a local regional control and have some survival benefit. So let's not go into this detail about the Japanese and the Western concept. Coming to the overall survival, it is about 60% in the East, and the West is less than that. Now let's come to the reconstruction techniques. As you know, the Billroth 1 reconstruction, the Billroth 2 reconstruction. Billroth 2 is usually adopted. These are the various variations of the Billroth 1 reconstruction. Billroth 2, most of the time we are doing that, and because it prevents an undetention and the anastomosis, and we can either do a hand strain or a stapled. It can be anticholic or retrocolic. That's not going to affect the survival, only the function of the remnant stomach. One important thing is the length of the afferent limb, because if you leave a too long afferent limb, it can result in afferent limb syndrome, which can be really debilitating and require surgery. These are the various modifications. Billroth 2 gave this modification. Then there is the Conlin.
Dr. Shafi, I request you to please wind up, because
yeah, this is the last.
We have a faculties waiting there for the next session.
Okay. So I end up with this slide, the complications. And thank you, Dr. Puneet, for allowing me to speak.
And I request Dr. Athiya to please interact with any issues and any questions there in the box.
Can I speak just a small comment? Can I make a small comment?
Yeah, of course.
The first is regarding case selection. As a matter of fact, distal gastrectomies can be done both for the distal part of the stomach, that is the distal most third, as well as for the middle part, including middle third. Regarding the distal 1/3 is concerned, we can go ahead with a D2 gastrectomy. Always as a radical gastrectomy, both D1 as well as D2. Regarding the middle third tumors, one can only have a scope for a D1 gastrectomy and not a proper D2 resection, because whenever we think of a D2 resection in middle third tumors, then we have to remove the entire stomach, because we have to take the lymph nodes at the station 11 as well. So that is why that might not be feasible. The other thing is that whenever we are going ahead with a gastric tumor, there are certain indications, there are certain guidelines as per NCCN, that is in T2 tumors which are node negative. There's a controversy whether one should go in with neoadjuvant therapy or should go in for surgery upfront. It has been nowadays recommended that
even for T2N0 tumors, it is better to go ahead with a neoadjuvant therapy of ECF, 3 cycles, and then go ahead with surgery and 3 cycles of ECF later on. Or one can go ahead with an adjuvant therapy. They have been found to improve the survival status. Regarding even T1 tumors which are N1 positive, again, neoadjuvant chemotherapy is the recommendation. Because this paucity of time, that is all I could say hurriedly. I think
Yeah, very
that
correct, Dr. Athiya. Actually, this was just only the operative steps. So you're not discussing the new adjuvant, that's only
So
limited.
indications also.
Yeah.
Indications also, it is important that the proximal margin should be around.
Dr. Subodh,
Previously, it was recommended that it should be 5 centimeters. Sir, may I say? Yes, sir, please. So the proximal margin should be was previously recommended that it should be at least 5 centimeter away from the gross tumor, but now it has been found that even at 5 centimeter there may be an R1 resection. So to have an R0 resection, it is always better to have a margin of 6 centimeter. That is the current recommendation. As far as the distal part of the tumor is concerned, because it might extend into the duodenum. So if you are able to get a safe margin 1 to 2 centimeters beyond the palpable distal tumor, you can still go ahead with the distal gastrectomy. That is all I think I could say hurriedly.
Okay, thank you, Dr. Athiya, for a wonderful moderation. I thank you, Dr. Shabi Ahmed, for a wonderful presentation. And we can go ahead with the next session, that is on blunt trauma abdomen. It is a ward round, will be presented by Pranay from AIMS New Delhi, and Dr. Subodh Kumar. He will be moderating the session. Along with that, we have other examiners, Dr. Amit, Dr. Dinesh, and Dr. S.K. Bharti. I think we have all examiners with us, and Dr. Subodh to take care, means to take over. Thank you.
Very good evening. Am I audible?
Yeah, you are very much audible.
Yeah, first of all, I would like to thank Professor Puneet for organizing this virtual PG Master Class in surgery, and I'm sure it will immensely benefit the postgraduates who are pursuing surgery in their exit exam. And I congratulate you once again for this. And I want to thank you for keeping a session on trauma in this PG Master Class. Thank you, Dr. Puneet. Thank you once again. We are exactly 1 hour late, and we being the trauma surgeon, we can understand the importance of 1 hour that is known as the golden hour in trauma. And we can actually lose a lot of lives if we late by the 1 hour in the trauma management. So without wasting much time, I'll invite the eminent panelist for this session, Professor Amit Gupta. Can I have the video, please, Professor Amit Gupta? Yeah, Professor Amit Gupta, he's a professor of trauma surgery and critical care at Trauma Center, All India Institute of Medical Sciences at New Delhi. We have Professor S.K. Bhartia. Dr. Bhartia is there? I think I can't see Dr. Bhartia.
Hello. I think he's there.
He's there? Can Dr. Bhartia is there? Dr. Dinesh Bagaria. He's an assistant professor of trauma surgery and critical care at AIMS Trauma Center, New Delhi. Dr. Dinesh is there?
Yes, sir. Good evening, sir.
Okay, good evening, Dinesh. Dr. Bhartia is there?
Dr. Bharti, are you there? I can see you.
Okay. So
I think you have some issues with the audio.
No problem. So you want us to wait, or we go ahead?
I think you should proceed.
Okay. So Dr. Pranay Kaviraj, who is a senior resident, he is pursuing MCH in trauma surgery and critical care at Trauma Center AIMS New Delhi. We'll be discussing a case of blunt injury abdomen. See, trauma is different from other general surgery cases in very important reason for that. In general surgery cases, what we take a history, we do examination, and then we manage the patient. But trauma is a different ballgame altogether. What we are doing in trauma, we start with the management of the patient. The importance of the history and the investigation upfront. So you start with the management. And that is why it is different, because time is of essence in trauma. So without wasting much time, I will request Kaviraj to present the
पहन लिया
case,
करो
share
और
his
नहीं
screen,
पहनो
and I'll
ना
request all
पहन
the
दो
panelists
तो नहीं पहनी सब
to just discuss the case along with Dr. Kabiraj, and we will have the questions answers at the end. Please, I request all the attendees to write their questions in the chat box.
Dr. Subodh, I just had one question.
Yes.
When would be presenting
कल ही
the
पहन
case, is it possible or is it
ज्यादा
possible
कपड़ों के
for
ऊपर नहीं आएगा ये
us
अंदर एक
to
इनर पहन के
sort
फिर
of
पहन लेना
interact with him?
I think I would, yeah, I think I would suggest that whenever you want to interrupt or you want to ask any further detail from the Kabiraj, it's better to interrupt him and ask him first, rather than waiting till the end. Because otherwise we will lose the track of the case.
Absolutely.
Because as you know, the trauma management is a dynamic process.
Yeah.
So we have to do it in a dynamic process, dynamic way.
Hello, good evening, everyone. Should I start, sir?
Yes, you can. You can share your.
Sir, is my screen visible? I have already shared
Yeah,
my screen.
yeah, it's visible.
Yes, yes.
Okay, sir. Thank you. A very good evening to all the respected panelists and all the delegates. I'll be presenting a ward round case of management of a blunt trauma abdomen. So we had a patient. We had a patient with 31 year. He was a 31-year-old male with an alleged history of motor vehicle crash on 14th of January at 2000 hours. And the mode of injury was he was sitting in an auto rickshaw and he was hit by a two-wheeler. The patient was taken to a district hospital and then referred to trauma center after 2 hours and 40 minutes of injury.
Dr. Pranay,
Yes, sir.
I just had one question on mode of injury because mechanism of injury, you know, is very, very important, and that's what probably we all miss. So this was an auto rickshaw passenger hit by a two-wheeler in the sense that what do you want to suggest? Is it a dangerous mechanism of injury? What do you mean by this particular sort of injury where two-wheeler is hitting an auto
Yes, the patient was sitting, which he was sitting. So definitely, sir, it was a dangerous mechanism of injury.
So did you elicit? Okay, did you also elicit which side the passenger got hit?
So the passenger was sitting on the left side of the driver, and the auto rickshaw fell on the left side, on its left side, and thereby injuring the patient. I will describe the injuries in the later part of the slide. So from that we can correlate that.
Also like to make that.
Yes, sir.
At the same time, is it prudent to comment upon the injuries the co-passenger also had?
Yes, yes, sir.
And what would be the importance for that?
Sir, actually, when we should always ask about the co-passengers of the vehicle, because a co-passenger death even automatically upgrades the level of injury as a dangerous mechanism of injury. So it is important to ask about the co-passengers in the vehicle. So we can have an idea that there was a significant amount of energy transfer, and we should be very cautious about that. He might be having a very significant amount of injuries. Therefore, it is necessary to ask about the passengers and about the mechanism of injury in details.
Okay.
Hello.
Okay, go ahead.
Please go ahead.
So the patient was triage red, and on examination, his airway was rapid examination. His airway was patent, and we put a hard cervical collar, and he was breathing spontaneously with a respiratory rate of 18 per minute and a SpO2 of oxygen saturation of 99% on 10-liter high flow oxygen mask. Air entry was bilateral equal. Chest compression test was negative, and a pneumoscan was negative. On circulation, his pulse was 124 per minute on arrival, and his BP was 85 by 40 millimeter of mercury. His pelvic compression test was positive. So we put a pelvic binder, and the fast examination was positive in all the quadrants. Also, he had a amputated left leg, for which we applied a tourniquet on the left thigh, and 1 liter of ringalactate infusion and 2 units of PRBC, 2 units of FFT, and 2 units of platelet transfusion in 1:1:1 ratio. The pulse decreased to 98 per minute, and BP increased to 112 per minute, 112 by 70 millimeter of mercury. His GCS was full score, and bilateral pupils were reacting normally to light. And hypothermia was prevented by covering the patient.
Dr. Pranay, just
Yes.
wait on this slide because this slide is very sort of populated, and I want to ask you three pointed questions. One, what is the status of pneumoscan in terms of primary survey? Number one. What do you understand by pneumoscan for the benefit of the residents? The second question is that the patient was applied a tourniquet in the hospital or outside the hospital, because tourniquets are generally applied outside the hospital. And if it was applied within the emergency room, what was the reason for that? And third question for you is hypothermia prevented. What is the importance of that? So let's begin with the pneumoscan. What do you have to say about the pneumoscan and its role in primary survey?
By pneumoscan is a part of extended fast examination in which we see if the lung is sliding against the pleura. If it is not sliding, then we can have an idea that the patient might have a pneumothorax. So that is the importance of pneumoscan. So in case the patient has a pneumothorax, it has a higher sensitivity than the chest X-ray. So in case the patient is having a hypotension with a pneumothorax, with a pneumoscan positive on the right side or the left side, we can have an idea that it is an obstructive shock. So that is the reason
I
for
just
doing.
wanted to, yeah. So this the other question was that do you have radiologists doing that, or is it a clinician-based scan? So just for the benefit of the residents, do you do your pneumoscans and your fast examination, e-fast examination, or a radiologist comes for your help?
Sir, it is a point of care ultrasound. It is done by the surgeon only while assessing the patient in the ED. It is a part of the primary survey. So it has to be done by the primary physician. It is a point of care ultrasound.
Okay. Okay. Fine. The second question was about you infused 1:1:1, sort of first 1 liter of finger lactate, and a tourniquet was applied. Why did you do all these maneuvers?
Sir, the patient had a traumatic amputation of the left leg. I will be sharing the photos in the later part, and it was bleeding. So, in the circulation part, what we try to do is to prevent the bleeding, prevent the sources of bleeding. So, a rapid control of a extremity trauma, we can put a tourniquet. It was applied in the hospital only. So that the patient does not, since we can see that he came with a BP of 85/40. So to prevent further bleeding, we applied the tourniquet in the ED only. He had a traumatic amputated leg, so it can be used only in extremity traumas only.
Okay. And what do you mean by hypothermia prevented? How do you prevent hypothermia?
Sir, we prevent while examining the patient in the ED. First, we have to remove all the clothing. So this will increase. This might contribute to the lethal triad of death, which is in which hypothermia is a part of that. So we cover them with a warm blanket, the air, in which there is a air circulating, warm air circulating blanket, and by that we can prevent hypothermia, and we can give warm IV infusions. The RL which we give has to be warm, and we have to cover the patient so that he does not so he does not get into the lethal triads.
So whatever crystalloids you give to the patient, are they pre-warmed?
Yes, sir, they are pre-warmed in our ED.
Okay. You may
Dr.
process.
Amit, there
Yeah.
are two, three very pertinent questions. I think this is the time to take the question because it's related to the primary survey only. The attendees have asked that one, that should we use the RL only in the initial resuscitation? Because he has mentioned, so it's RL or normal saline, which is better. This is one. And second question is, what is PCT in primary survey? So I would like Dr. Amit, you to respond for this.
Okay, thank you, Dr. Subodh. So, very quickly, PCT means the pelvic compression test. So basically, there are there are five major sites of bleeding. One externally, which Dr. Pranay said that he was bleeding from the lower limb, so he tried to control it, but it was not controlled, so he applied the tourniquet. Apart from the external hemorrhage, one on the floor and four more. Four more are chest, abdomen, pelvis, and retroperitoneum, and the long bones. That means the femur, bilateral thighs. So these are the major sites of bleeding. And when you want to control these, obviously external you can control easily. For internal, at least you have to find out from where he is bleeding so that you can control it after giving the initial fluid resuscitation or fluid plus blood resuscitation, which is nowadays called balanced resuscitation. So PCT is a way of finding whether or not, clinically finding whether or not CCT and PCT. CCT is chest compression test. If it is positive, that means it is just indicative that probably he might also be having a blunt trauma to the chest and he might be bleeding into the chest. Obviously, to know more about whether or not he's bleeding, we would require adjuncts to primary survey, something like chest X-ray or extended fast or E-fast. PCT again is a clinical examination to see whether or not pelvis is unstable, stable or unstable. So you actually apply pressure to the anterior superior iliac spine, keeping in mind that it is just done once, and posteriorly, if it is not mobile, then anteriorly, inside, inverting. So if it is unstable, obviously that means that the posterior component and the anterior component of the pelvis both are fractured or are unstable, and therefore it can give rise to a lot of space within the pelvis, which can give rise, which can bleed into the retroperitoneum. So PCT is pelvic compression test, number one. Similarly, you have to give as the initial bolus 1 liter of crystalloid. Obviously, the Ringer's lactate is preferred over any other fluid, but if you do not have Ringer's lactate, which is a more balanced solution, you can obviously give normal saline. But nowadays, we always say balanced resuscitation. That means within a time span of 1 to 2 liters of crystalloids, the blood or blood products should be available. That means your blood bank should be ready, or your emergency room should at least have a fridge in which the shock pack or at least 2 units of PRBC, FFP, and platelets are stored there of O negative so that you can immediately give that. So that's my take on it.
Yeah. Thank you very much. Yeah, Pranay, you can go on. We have to keep in mind the time also. So already we have 10 minutes passed. We are left with 20 minutes. Go ahead.
So after completion of the primary survey, we had the adjuncts to the primary survey, which was the chest X-ray was normal. In the pelvic X-ray, he had a left acetabular fracture with posterior dislocation of the femur. And extended fast was positive in all the quadrants in the abdomen. You can see the chest X-ray, which is normal, and the pelvic X-ray, in which the acetabulum is fractured with posteriorly dislocated femur. On secondary survey, the patient had a traumatic amputation of the left leg with a bleeding stump, in which we applied two Foley's catheters as tourniquets. And on Foley's Foley catheterization, the patient had hematuria. The ample history was normal in this patient. So,
what is the ample history, Pranay?
So the ample history is a part of the secondary survey which we use in trauma, in which it is a acronym in which stands for allergies, M for any medications, P for any past medical history, L for last meal, and E for events. So the events of the environment. So the ample history was no, he did not have any past medical history or allergy to any medical allergies to any drugs, and his last meal was 8 hours ago. So this was the ample history. There was nothing suggestive of any previous medical condition.
Okay. Please carry on.
So after resuscitation and after stabilization of the patient, we sent the patient for imaging. We did a NCCT, non-contrast CT of the head with C spine, cervical spine, and CECT, as a contrast and a CT scan of the torso. The imaging revealed The head and C-spine was normal, and the imaging revealed that the patient had a grade 4 renal injury with no active contrast extravasation and a small PCS involvement, pelvic calyceal system involvement of the lower calyx with contained collection. There was no pneumoperitoneum, and the patient had mild hemoperitoneum, and there was a retroperitoneal hematoma adjacent to the kidney. And this is a 3D recon image 3D recon image showing the left-sided acetabular fracture with roof fracture also.
Very quick question, Pranay. Very quick question. Would a NCCT of the chest and abdomen be equally effective? Would you have done a NCCT? Why give contrast unnecessarily?
Sir, because unless we give a contrast and take a delayed phase, we can miss solid organ injuries. We can miss active contrast extravasations, which are suggestive of vascular involvement. Like if the spleen is bleeding actively, we will miss it in a non-contrast CT, and we cannot evaluate the kidneys as well as the ureters in case we don't give contrast.
So you used
So,
the word
is it?
thoughtful. Yeah. Please, Dr. Subodh. Sorry.
Yeah. So there is one question from the attendees. So is it really safe to do the contrast enhanced CT scan without doing blood urea and serum creatinine?
Hello.
Yes, go ahead.
Sir, in this case, the incidence of contrast-induced nephropathy is less than 1%, and the chances of we missing an injury without giving a contrast is very high. So the risk in the risk-benefit ratio, there is much more risk. There is much more benefit than risk. So yes, it is safe, and it is a standard protocol which is used in all the trauma centers, all the big trauma centers in worldwide.
That there is no role of non-contrast CT scan in blunt abdominal trauma. Okay, that's the message you want to do. Okay, go ahead.
So the plan of after completion of the CT scan and secondary survey, the plan of management was non-operative management for the blunt trauma abdomen, that is the renal injury, and left-sided formal above knee amputation, and a TBL pin traction for the left acetabular fracture, for which definitive surgery was planned afterward. This was the plan of management after CT scan. So after the first surgery, that is the amputation, on first post-operative day, the patient had persistent tachycardia and he developed soft diffuse tenderness was present on the abdomen, and his bowel sounds were absent. With a TLC count of only 3,380. After 24 hours on post-operative day 2, the patient still had persistent tachycardia and he developed rebound tenderness of the abdomen with cardboard rigidity. He did not pass any flatus and the bowel sound was absent. The TLC further dipped to 2,900 only. So after development of the cardboard rigidity, we revisited the radiology to see if we missed any finding in the initial scan. So the initial radiology scan did not suggest anything else, any missed injuries, but still due to the clinical finding of a cardboard rigidity and a rebound tenderness, we took the patient for a laparotomy. So this is the finding. Yes, sir.
Pranay, can you go back on the slide? So this was the clinical information which you had gained from examining the patient, both locally, that was abdomen, as well as obviously he had a pelvic fracture also, so the abdominal examination might have been slightly, sort of.
15-20 मिनट बहुत वहीं पे चले ना.
Because whenever you have pelvic fractures or lower rib fractures, the abdominal examination can be that rigidity or what other indications did you get that the patient was not well? You marked certain things with red, but can you just elaborate what all you actually observed? Because this is put the patient on a non-operative management or a conservative management.
To call it as a non-operative management, which is serial clinical examination with the option of abandoning it. So with the option of abandoning it at the first sign of deterioration. It is a non-operative management, not a conservative management. It does not have any surgery. The conservative management means we will not operate the patient at any. We will not operate the patient at. It means that we don't operate the patient in conservative management. There is no option for surgery. But in non-operative management, we have a heightened clinical. We clinically examine the patient, serially clinically examine the patient, and at the first sign of deterioration, we intervene. So that is the difference between a conservative management and a non-operative management.
It's a very active sort of management, not conservative. You don't sleep over it. So it's a very, very active. So did you put this patient in the ICU?
Yes, sir. We put the patient in ICU for serial monitoring.
Yeah. Okay.
I request Dr. Dinesh Bagari and Dr. Bhartia to interact and take part in the discussion with the Dr. Kaviraj. He can put the question to the Dr. Kaviraj, Dr. Bhartia and Dr. Dinesh.
Sir, good evening, sir. So, Pranay, one question that as you said that we put the patient in the ICU for monitoring.
अभी इसमें जो इसका लिया गया
we
है
do and
दिनेश बगारिया, इससे भी मिला था मैं एम्स में.
Sir, we have a blunt trauma abdomen and BTH charting.
क्वेश्चन पूछने वाला भी एम्स का और आंसर देने वाला भी एम्स का.
In which we examine the patient initially for first 24 hours. We examine the patient every hour, and after 24 to 48 hours, we examine the patient for every 2 hours, and then after 48 hours, we examine the patient 6 hours. Sir, ABG, I would like to add a ABG in this arterial blood gas analysis.
तो आप एक बार देख लो कैसे बनता है, ए कैसे बनता है, बी एक बार रीडिंग करा लो ना, रिवीजन देख लो एक बार चैप्टर.
Gurushan Thappa has a very good question for you, and he says that I have added question to that how TBL pin traction if amputation plan for the acetabulum and pelvis, and my question is, do us admit the pelvic fractures or the orthopedicians admit the pelvic fracture?
Sir, pelvic fracture is always admitted under in our institution. It is always admitted under trauma surgery because there is a chance of deterioration at any time, and after stabilization and a significant amount of time, after passage of significant amount of time, after the physiology is restored, we take help from the ortho department and get the pelvic fracture fixed. So it is till the time the patient is physiologically unstable, the patient is admitted with trauma surgery only, sir.
And the second, I think, important point in the pelvic fracture. One is that yes, he may deteriorate because of the ongoing bleeding. Second is that he can miss injuries, associated injuries. That is also an important aspect. That once we are sure that we are not missing any injury associated with the pelvic fracture and patient is hemorrhagically stable, then we can go to the orthopedic for a definitive management of orthopedic injuries, if at all required. I think go ahead and very pertinent questions, and I think why this PT ANA deranged on day 2 in this patient. There is a question in this from the attendees.
Okay, sir. So I would like to answer the first question. How do we apply a pin traction if we have gone for a above knee amputation? We apply the pin just proximal to the level of amputation, so that the acetabulum is pulled down. It does not go up, because at the later stage of rehabilitation, when we put the patient on a prosthesis, the acetabulum has to be in place. So if we delay the placement of a pin and we delay the traction, so the acetabulum will move up, and it will be difficult part to reduce the acetabulum, and it will take time to rehabilitate the patient. So we think about the rehabilitation during the resuscitation. While we are resuscitating, we are planning for rehabilitation. The second question that has been asked is that about the coagulopathy which is developed on day 2. So it is developing because of the sepsis. It is a sign of the sepsis. Amit sir asked me what were the parameters which showed us that the patient is not doing well. The tachycardia, the patient had a persistent tachycardia. You can see that in the first post-operative day, it was 105 pulse per. He had a and he had a diffuse abdominal tenderness. His bowel sounds were absent, and his TLC count was less than 4,000. On post-operative day 2, his tachycardia increased, his respiratory rate increased, and he developed rebound tenderness. His TLC dipped further, and he developed a coagulopathy. So these were the signs which suggested that there was some kind of abdominal injury which we missed during the which we were not addressing during the primary management of the patient.
Dr. Amit, we are left with 10 minutes. If we can quickly move on with the case and give the take-home message.
Okay, so after the development of cardboard rigidity, we took the patient for laparotomy in spite of no signs in the CT scan in the review. So this was the clinical finding. The patient had a completely transacted jejunum 40 centimeter from the DJ flexor with 2 liters of bile in the peritoneal vein. So we gave an extensive lavage and a side-to-side jejunal anastomosis was done and a feeding jejunostomy was done. Distal to the anastomosis with skin only closure, and the patient was shifted back. The patient was shifted back to ICU for further resuscitation and management. The patient, after shifting to the ICU, was hemodynamically stable, but his TLC counts were constantly on rise. The bowel sound returned on third post-operative day from the second surgery, and the patient developed a left-sided pleural effusion, for which we put a ICD and 500 ml of serous collection.
I'm sorry. You used two things. Just go back on the slide. You said two things. One, side-to-side jejunal anastomosis. I want to know the reason. Number one, why did you do a side-to-side anastomosis? And then skin-only closure. What do you mean by skin-only closure?
We did a side-to-side anastomosis in this case to avoid any post-anastomotic stricture because end-to-end anastomosis might result in a post-anastomotic stricture, and therefore we did a side-to-side. And skin-only closure means we do not close the sheath. We only close the abdomen on continuous by its continuous sutures, non-absorbable continuous sutures, to save time first of all, so that we can take back the patient to ICU for further resuscitation and have a laparotomy. So that is the reason for a temporary abdominal closure. It is kind of a damage control surgery.
Are there any other ways in which you can do temporary abdominal closure apart if the skin is also not coming together?
Yes, sir. Yes, sir. We have a mesh laparostoma. We put a Bogota bag is known techniques. There are multiple temporary abdominal closure techniques, but Bogota bag is very cheap and effective technique. And here at our institute, we do a mesh laparostomy. The mesh is a bit costly, but it is a rapid way of closing, temporarily closing the abdomen.
Then I have one question from my side also. Okay. If the same finding you would have found in the first time when the patient presented first time,
yes, sir.
Are you going to do the same surgery or it would have changed the way you operated now?
Yes, sir. It would have changed. I would have temporarily closed both the abdominal loops with 2 stapler fires. I would have closed the loops, not tried to anastomose the patient. And we have closed the abdomen temporarily, shifted the patient to ICU after bleeding control and contamination of control of the contamination, that is this bowel content. And we would have shifted the patient to ICU with temporary closure of the abdomen, resuscitated the patient back, and then again would have taken the patient back for definitive surgery. That is for the restoration of bowel continuity.
That is the complete paradigm of a damage control resuscitation, basically.
Yes, sir.
So it's a very good question actually. And one question from the participant, and I think Dr. Dinesh can answer to the panelists, that what's the reason for there is no pneumoperitoneum at the first CT scan? What is the possible explanation for that?
I also see that there should not be any reason of not having pneumoperitoneum on CT scan. But the only thing which we can explain that probably that time when we did the CT, actually the patient presented very early. At that time, probably there was no complete transaction or the bowel was quite maintaining the continuity. And when the injury set up, that time bowel gave away and developed the perforation and
Yeah, and what we have observed, unless it's a perforation either in the stomach or distal in the bowel,
Probably
colon or distal. So the pneumoperitoneum, the chances of pneumoperitoneum are high. If it is an injury proximal to the DJ, because it's filled with the fluid and you may miss actually pneumoperitoneum, it is a proximal injury. Dr. Amit, your comment on this?
I just wanted to say yes, there are about 5% chances, and literature says that there are about 5% sort of negative results even on a CT scan in acute, and especially if it is done within 6 hours of arrival of the patient, whether it is pathological perforation like enteric perforation or it is traumatic perforation, it can yield a negative result. That is the reason why we always say as trauma surgeons, serial physical examination and in a critical care unit, and the surgeon should know the critical care part of their patients. Until and unless the surgeons are involved in critical care in the ICU, the physicians can or anesthetists can never look at patients in the same way, knowing their injuries in the same way, and that is the reason why trauma surgery is also always associated with critical care. Like Dr. Pranay said, he gave certain examples of heart rate and the coagulopathies and things like that. That is always, you have to be a physiological surgeon rather than an anatomical surgeon. I always say that as a trauma surgeon, you are a physiological surgeon. You know the physiology also, and you do the surgery also. Thank you.
Okay, so go ahead. Go ahead.
So after shifting the patient on post-operative day 3 of the second surgery, that is the laparotomy, the bowel sounds returned and the patient passed flatus, but the patient developed a raised TLC count and left-sided pleural effusion, for which we put a left-sided ICD, intercostal drain, and 500 ml of serosanguinous fluid came out from that drain. On post-operative day 4, that is from the second surgery, the patient had a high-grade fever with pus coming out from the midline wound. So we again took the patient for relook laparotomy, the patient on the same day. On exploration, the approximately 250 ml of pus was found under the left hemidome of the diaphragm, and the jejunal anastomosis which we did, the side-to-side anastomosis, was intact. The pus was sent for culture sensitivity, and this time due to bowel edema, it was difficult to close the abdomen, so we did a mesh laparostoma, including the bowel edema. After the third surgery, oral feed was the patient had the bowel sound was present. Oral feed was started on post-operative day 2 from the third surgery, and the patient improved clinically. The pus culture which we sent came out positive for pseudomonas, which was sensitive to cholesterol, and culture by antibiotic was started. Now at present the patient is doing fine and is planned for split thickness grafting over the mesh laparostoma.
At this point of time, there is one question from the attendee that you put in a tube when there was a pleural effusion in the chest. Why did you put the chest tube?
So the patient had a rising TLC count. That is that the leukocyte count was increasing. It was raised to 17,000. So we wanted to find the source of sepsis. Hidden source of sepsis could be because we operated the patient. It could be chest, abdomen, the blood, the lines. So during the fever work, it is a part of the fever workup for which we put the ICD. We send the fluid for culture. And also 500 ml of pleural effusion is a significant amount of effusion to cause problems in breathing. So for these two reasons, we put the tube, ICD tube, for taking the fluid for culture and for improving the breathing.
Okay. Any point, Dr. Dinesh or Dr. Bhartia, you want to add in this?
So what antibiotic is started before? In the beginning, what antibiotic is on, and after that is antibiotic.
Sir, we started a broad spectrum antibiotic as per our hospital protocol. We started a third generation cephalosporin with metronidazole anaerobic cover.
The other question which was which I'm seeing on the chat is about why not a diagnostic tab. So as surgeons and critical care surgeons, we never use diagnostic tab, should not be used. See, ultimately 500 ml of any fluid into the thorax, and you can imagine what kind of lung you would have. Number two, if you keep that fluid for a longer period of time, it is very natural for it to get infected otherwise also and create an empyema like situation. As surgeons, we want to drain any extra, sort of physiological collection which is happening. Now, so the chances of getting it into an empyema are very high. Even if it is reactive when you are giving antibiotics, after day two, if it does not recur, if the fluid draining comes down, remove the chest tube. So one-time aspirations, I would not say, because it is not a continuous drainage. You introduce an infection, there will be more chances of that getting into a empyema. In trauma, we always say if there is a collection above 500 ml, you drain it by a chest tube. Dr. Subodh, you can answer.
Absolutely right. Absolutely right. There is no question. Any effusion which you can diagnose either on chest X-ray, on ultrasound, which is compromising the physiology of the lung, you must drain it. Go ahead with Dr.
So the lessons which we learned in this case were like every trauma patient has to be managed as per the latest 10th edition ATLS protocol. That is the primary survey in which we have to manage according to airway, breathing, circulation, disability and exposure, followed by a secondary survey only after completion of the primary survey, and that has to be backed by a good tertiary survey. Injuries can be distracting both for the patient as well as the doctor treating. Like in this case, the overwhelming injury in the extremity affected us from the blunt trauma abdomen that the patient was hiding a bowel injury with it. Non-operative management for splenic and liver injury differs from non-operative management for renal injury. In case a patient is fast positive with a blunt renal injury, we should put a scope to avoid any bowel injuries associated with renal injury, because most of the renal injuries don't become fast positive. Importance of serial clinical examination in blunt trauma abdomen cannot
पूछिए
be
छोटी सी
overstated. Because of serial clinical examinations only, we could detect the deterioration of this patient, and no radiological investigation suggested any injury. So bowel injuries can happen without pneumoperitoneum only, pneumoperitoneum also, because pneumoperitoneum is not a prerequisite for a bowel injury. It can happen without without pneumoperitoneum, and the radiology has to be revisited in case the patient does not have corroborative clinical finding, and it is also a part of tertiary survey. Every previous scan has to be revisited within 24 hours, probably by a new member of the team who is not the part of primary and secondary survey. If the patient is going into sepsis in a case of blunt trauma abdomen and you are suspecting any purulent collection, we cannot finding, it is prudent to watch under the diaphragm, because it is an old saying that pass somewhere, pass nowhere, pass below the diaphragm. The importance of mesh laparoscoma. Open abdomen is much better than a closely tight abdomen, causing abdominal compartment syndrome. It is not a failure of surgery, but it is a it is a defense mechanism by which we can still save the patient with a increased bowel injury rather than tightly closing the abdomen. Diagnostic lab is an investigation. It is in blunt trauma abdomen. It is a investigation, just like a CT scan or a USG. It is a valid investigation which gives us very good results when radiology does not show us when there is a clinically non-corroborating finding with the radiology. Then diagnostic investigation is a very good bridging investigation. And the third is, there still after a good primary, secondary and tertiary survey, still there are missed injuries, which is approximately as per the literature available online, 8 to 9% there are still missed injuries, which which even after a good primary and tertiary and secondary survey, there are still we can miss 8 to 9% of injuries, most of which are musculoskeletal.
So thank you, Dr. Pranay. Thank you very much. And I think time is up. We have the quick comment from Dr. Bhartia. Dr. Bhartia, quick comment about the management of a patient with the blunt trauma abdomen for the benefit of the post-graduate, for the residents. A quick comment from Dr. Bhartia.
In the blunt trauma abdomen, most important thing is always if they're doing the repeatedly the survey, primary survey, secondary survey, tertiary survey. In spite of that, there is a chances of the missed injury. Yes, we of course seen that there are so many injuries are revealed even on the day 7, day 5, and initially there is no findings, but there the features of the unclear abdomen persist on day 3, day 4. And then there the scene arises to investigate. Diagnostic laparoscopy is no doubt is the adjunct in the diagnosing the missed injury apart from the CT. Whatever the missed in the CT that should be visualized by the diagnostic laparoscopy, and on the basis of the diagnostic laparoscopy we can do the definitive pairs. And from the Pranay, how much about this? You are doing the mesh laparoscoma here in this case. So
Yes.
what is the ideal time to repair the plant ventral hernia?
Sir, we first of all we try to close the abdomen within 6 to 7 days. If we are not able to close the abdomen in that setting, then we try to do we plan a ventral hernia, which is we put a split thickness skin graft after the mesh laparoscoma is granulated, and after 3 months of trauma, we usually schedule the patient for a ventral hernia repair.
राइट साइड में मुड़ते हैं, सागर रत्ना के लिए लेफ्ट साइड में मुड़ोगे.
After the skin matures and separates from the viscera underneath, we plan hernia surgery for that patient.
Okay.
So what is the ideal time? 3 months, 6 months?
Yeah, I think Dr. Bhartia, that's actually depends from surgeon to surgeon. So there is no consensus in the literature about the after the laparoscoma and after the split skin grafting. What should be the timeline? It depends from surgeon to surgeon. But generally, what is our policy at AIIMS Trauma Center?
This is again the matter of debate. Yes,
it's a matter of debate. But generally, we do not close the ventral hernia before 6 months of injury. A quick comment from Dinesh, Dr. Dinesh. Dr. Dinesh, are you there? I think we have lost him. Final comment from Professor Amit Gupta. For the benefit of residents, the word of wisdom about the management of patient with the blunt trauma abdomen.
Thank you so much, Dr. Subodh. I'll take very little time just to say 2 or 3 points. One, whenever any injury comes, do not take it as only blunt trauma abdomen or blunt trauma chest or limb injury. Please see the patient from head to toe. All general surgeons should be trained in taking care of a total trauma patient and not blunt trauma abdomen only, although that might be of the interest to general, so-called quote-unquote general surgeons. But I'm sorry, you have to take care of the chest, you have to take care of vascular injuries, you have to take care of extremity injuries also. Taking care that you do not miss a vital injury which is hidden in the chest or abdomen because of what is visible as it was in this particular case, a distracting injury of the extremity took your focus initially in the primary survey probably, or maybe it was because the injury itself was not posing a problem in the initial goal. Number one, this is first sort of lesson for the postgraduates. Number two, you have to manage a trauma patient in the right way. That means primary survey physiology first. After that, after you stabilize the physiology, only then you move to the anatomical injuries, see the secondary survey, and then if the patient is stable, get more investigations like CT scan done. Thirdly, non-operative management is a standard of care It is not a failure of you doing surgery. So ultimately, at many points of time, you will understand that non-operative management is much more intense and intensive than probably operating that particular person and doing away with it. Therefore, it has to be done in an ICU, well equipped ICU, with you as surgeons taking care of the patient, seeing the criticality of the patient. This is lesson number 3. Lesson number 4, always serially reevaluate. Reevaluate is the mantra. Keep on reevaluating. These patients are very dynamic. Anything can happen within the span of first 1 week, and therefore, whatever you are doing within the first 3 or 4 days, keep on reevaluating the patient. Maybe in the ICU, maybe in the HDU, maybe in your wards. That's very, very important. So these are the 4 messages I would like to give through this particular case.
Yeah,
Thank you, Dr.
I think very pertinent take home message. And what we say, if somebody has a polytrauma, his abdomen is he has a head injury or and a lower limb injury, that it is very unlikely that his